Hi. Good morning.
Good morning.
Hi. So, Dr. Reardon, right? Okay.
Good morning. Yes.
So you're not in the morning, but what time is it?
Evening here, morning there.
Okay. So thank you for attending the meeting.
那个
魏教授，
好，王教授，好，你好。
我这样，我大概5、6分钟以后再上来。现在有个比较急的事情，我先处理一下啊。
好，那我能不能先让您知道一下，我们待会这个题目要不要最后2个题目你来主持，可以吗？
那行，最后2个题目了。
这2个题目的时间您看看哈，有一个15分钟，有一个25分钟，所以我待会会先讲一下这个。
你先讲一下，我大概9点左右上来。
好，那9点。
我前面上来，反正我就听好了，没事儿。好，
那么9点半那个跟9点45的。
那我懂，
就麻烦你。
但是我可能当中上来我就听好了，没事儿。
OK， 好，就麻烦你介绍一下，是好，谢谢，好，再见。
魏教授你好。
哎，好，是这个好。
赶上了。
是对，黄医师，对，是 ，OK。叶教授 ，OK，Dr. 叶。
魏教授你好，赶上了，我快赶。
Yeah. How about? Dear colleagues, thank you for attending the second day's meeting of the 2022 Taipei Valve Summit. In the era of TAVR, the first need is to save the patient's life. However, the standard tissue valve will degenerate when the time passes, but the patients still want to live. Therefore, a second transcatheter valve is necessary. In addition, due to the promising results of a TAVR, the age of implantation has been lowered. Reimplantation is inevitable. We understand that the tissue valve can't last forever. The planning of the various treatment modalities and the uses of types of tissue valves is essential. Therefore, we need the lifetime management for the patients suffering from heart valve diseases. Today's lecture not only focused on the lifetime management, but also we have several interesting life cases for demonstration. Dr. Ye, would you like to say some words to our audience?
Oh, thank you. Good morning. I think good morning, Taiwan, Professor Wei and Ying and Chung. Also, good morning and afternoon, and everyone. Maybe good evening, everyone from all over the world. So, yeah, as Dr. Professor Wei said, today is the second day of the 2020 Taipei Valve Summit, and thanks for you participating in the summit. I believe you enjoyed yesterday's great lectures, the rich discussions, and the live cases. And I think today will be another busy and exciting day. And as Dr. Professor Wei mentioned, today's will covering lots of important and probably also controversial topics on the surgical and the transcatheter intervention for all 3 valves, including aortic valve, mitral valve, tricuspid valve. So I think look at the program. We also have 5 live cases scheduled. So it will be a very busy, exciting days. On behalf of the conference, organizing committee and Professor Wei, I really wish you a great and enjoyable day. And thanks and welcome.
Thank you. Let's proceed to the first session. The session is so-called lifetime management, and the moderators will be Dr. Ye Jian and I. Dr. Wang Jiannan will be he will come to the room later. I think the panelists on the list. We have will have 6 panelists. Dr. Wu Yongjian, Dr. Huang Zhihong, Dr. Wei Lai, Dr. Li Guozhen, Dr. Li Maoxun, Dr. Okay, Dr. Jung-Cheng. So the speakers, please leave 5 minutes for discussion. Okay, so please control the time since we have different durations of your lectures. So the first topic will be given by Dr. Ye Jian. The topic will be the lifetime management overview. Dr. Ye, please.
I share my, I'm trying to limit in 20 minutes, within 20 minutes. Can you see my slide?
Yes, yeah. So the lecture will take 25 minutes. Please leave 5 minutes for discussion. Should I introduce you again? Since I think I haven't introduced you before, right?
It's okay.
Is that okay?
Yeah.
So Dr. Ye is the co-director of this program. So I thank Dr. Ye for the long-term help in organizing and also in preparing this meeting. And Dr. Ye is the let me find your program. Well, never mind. So, well, I think most of us already know you very well. Okay, so thank you for everything. You helped. You know, I got it. Yeah. So Dr. Ye is the clinical professor and research director of the Division of Cardiothoracic Surgery, Faculty of Medicine, University of British Columbia, Vancouver, Canada. He's the, as we all know that he's the pioneer in several fields, especially in the field of TAVR, especially also the valve-in-valve implantation through the Apex. We learned the technique from you. Our hospital learned this technique from you. So you have been proctoring many procedures at various hospitals. So thank for your help especially in the technical side for our hospital. So please, Dr. Ye.
Oh, thank you very much for your kind introduction, Professor Wei. So today my topic is life management of aortic stenosis. I think I just focus on the aortic stenosis because of mitral valve and tricuspid valve will be different. So this is my disclosure. So I think that the lifetime management of aortic stenosis in the past is pretty simple. I don't think this is a really major issue. I think we never really discussed the lifetime management of aortic stenosis in the past because it's really choices of surgical aortic valve replacement or medical management. But in the healthy young patient, it's really not an issue. Is surgical aortic valve replacement is the choice for aortic stenosis. The key decision is very simple: either mechanical valve or tissue valve in young healthy patient. And the redo is also simple: either surgery or the medical management. However, now that the things becomes more complicated because more options available, and some option we still not know. Many things we still undetermined. So that's why it makes things a little complicated. And the lifetime management now have been talking about this, frequently. So the choices for initial intervention, I think the initial intervention probably is one we have to make a decision in young healthy patient. The surgery or TAVI, I think is critical. And of course, the following intervention, either surgery or valve or medical treatment. And the key decision now is not just the intervention is very mechanical valve, tissue valve. That's used to be the key decision point. But now is whether surgical versus TAVI or versus valve or type of the THV, because the THV has many types of tissue valve compared to the surgical type of surgical valve. So that's why it makes things a little complicated. And I just listed these three cases. For example, this is 65 years old. And the first one is very healthy, no comorbidity, and has severe symptom, of course, in the class 1 indication for surgery, and the normal EF with no pulmonary hypertension and the normal chronic. For the second case, as a patient have some comorbidity and had a mild coronary artery disease, but doesn't need intervention. Third one, I just listed that as a patient the same age, but have quite a significant comorbidity, moderate chronic immunodeficiency, and the EF is low, and the pulmonary hypertension, and also mild coronary artery disease. So for these three patients, what's the initial intervention for aortic stenosis? I think that's the main decision making in same age with different comorbidity, and what kind of the treatment that we should choose, particularly initial intervention. So I'm going to give us some discussion in the last and the last slides. I will give you my opinion for this three patients. So I think that for the life time management, I think the key factors affecting decision making, I think the patient's life expectancy is very important. Second, of course, invasiveness, and the third one is a potential complication of intervention, and also durability of biprosthesis valve, and the risk of re-intervention. I think is very critical in the young patient, because the majority of patients probably will need a requirement, will need a subsequent intervention. And what's the feasibility for future coronary artery access, and also per patient preference. I think when you talk about patient preference, I think it's for truly informed consent process is very, very important in the young healthy patient in nowadays. So in terms of young patient, I think that's a definition probably need to be careful. Here the US 2020 guideline, they say that less than 65 you use a surgical valve, but 65 to 80 is more like a surgical, either TAVI is a class 1 indication. But I want to make people be cautioned, because the life expectancy in different regions is really different. This is the guidelines more for the Americans. So the life expectancy, average probably is 80s. But if you move to the China or region or this area, the average, the life expectancy is only like a 75. And if you go to the Africa is a 65 already, is actually above the life expectancy. So that's why when we talk about a young patient or the 60 years old, I think I need to be very careful to look at the patient as I think from which region or the nationality, or I think this needed to be considered. So in terms of invasiveness, I think I listed the current available option. I think for the aortic disease, there's quite a few options. One is the Ross procedure. Ross procedure used to be, quite initially was for the popular everybody trying to do the Ross, but now over the past several years, and more people are trying to do the Ross procedure nowadays compared to 5 years ago. And the other things, of course, the standard sternotomy and the partial thoracotomy and the partial sternotomy and the TAVI. I think invasiveness, of course, I think I listed here as a relative. So from a more invasive to less invasive, if you just consider invasiveness, of course, the TAVI will be the best for compared to any other interventions. And how about complications? I think the complications surgical versus TAVI, I just put something here. I think mortality in the young healthy patient is very similar. I think for the surgical intervention, mortality less than probably 0.5% in the young patient. So I think mortality, I don't think TAVI will be low. I think it's very similar. And the coronary obstruction, of course, surgery, I don't think it will cause coronary obstruction. And the stroke are very similar. AKI may be high in the surgical part, but there's a mild perivalve leak definitely in the TAVI patient as a more compared to surgical valve, and the thrombosis probably slightly high in the TAVI patient. And the other things, the pacemaker, then of course depend on the valve type, and atrial fibrillation, blood transfusion, of course, much higher in the surgical group. So that's just summaries general complication related to the procedure nowadays in the young patient. And in terms of long-term durability, I I think it's very important to look at the long-term durability, at least beyond the 7 to 8 years, because you see a list here is not a comparison. I just want to list here to show this tissue valve. They usually don't fail within the first 7 or 8 years. Very few patients that really need a redo or the valve was failed, either in the surgical valve or the TAVI THV. But after really to show the differences is after 7 or 8 years, that because the tissue valve deteriorates very quickly, particularly in a young patient. So that as a TAVI, as you see here, as the same, almost after 6 or 7 years, they started deteriorating. But this age is almost 80 years average. But if you look at the surgical valve, there's lots of data available. You can see the young patient is after 7 or 6 years, they deteriorate very quickly. From 10 to 15 years, they can drop from 80 to 20%. So that's why I think it's really important when we talk about long-term durability, not extrapolate from an elderly patient. We have to look at the young patient, whether this after 6, 7, or 8 years, whether they deteriorate quickly. I think that's very critical in terms of long-term durability when we discuss it. So I think at this moment, as a sutureless valve and TAVI, I don't think there's much available beyond the 7 to 8 years, particularly in the younger patient. So I think we need to be a little bit cautious when we move all the intervention to the very young, healthy patient. So other things that can factors you have to think about in young patient is a coronary access. I think a coronary obstruction, that's very, very critical, because in young patient, they will, some patient, quite a percentage of patient will develop a coronary disease. In the health, like elder patient, 80s or late 70s, you don't really think too much, because the patient is self-selected. If they don't have a coronary disease, they unlikely will develop a severe coronary disease, in during the rest of their life. So that's why we are not paid to attention. But in the young patient, I think it's really, really important to pay this attention in terms of what is the feasibility for coronary access and reintervention. So generally speaking, is a low skirt, like a basically a high skirt, a high probability of coronary access problem. That's a general rule. So you can see that the different type of valve is really the heights are different, the leaflets and the standard heights are different. So in the young patient, I think critical, not just based on the your preference or you choose this valve, I think this is better or this not better. I think it's very important to think about which valve is best for the patient. That's the most critical part when we choose which type of valve. So I think a J valve, because it's the lowest stent and the lowest leaflets, that's why, and then of course there's a clasping device that's to protect the left main is probably the best valve in terms of to protect the coronary artery obstruction and the best for the future like coronary reaccess. But of course this valve is need more data in terms of durability, long-term durability. So I think that's also needed to be carefully assessed for the next few years. So I will not play this because it's a really, really good protection. There's no issue for coronary obstructions. So other things I want to mention is about the difficulty for the reintervention. I think that's one thing I always trying to emphasize it, because we don't have a lot of experience for the re-explantation of this kind of valve, particularly after 5-10 years, whether this was simple or not simple. And for the first years after implantation, you want to do the redo. Of course, it's easy because it's not much scarring. You just can easily to take it out, but that doesn't represent there's a long a surgery after the many years. As you see here, even these are including some early failure or need to require redo. You see the mortality, hospital mortality is 12%, and aortic surgery, concomitant aortic surgery need 35%, almost third of patient that need aortic combined aortic surgery. That's not the situation in the surgical valve redo patient. We don't need a root surgery for most surgical intervention for failed surgical valve. That's why I think people need to pay attention on that, particularly in the young patient. And And this is a different data, the STS data. You can see the mortality 30 days is still that, even the not later days, it's still the 12, 13%. The European experience also the 15%. But I just want to say this patient is not like all the patient after 5, 10 years. They are just early failure and some like 2 or 3 years. So you already have a 15% mortality and also combined aortic surgery. How about after 10 years? This will be similar. I think generally speaking, probably will more difficulty. So this is another one is the STS data. You can see the low. This is interesting. In the young patient, low-risk patient, expected mortality for redo is 2.6, but the true mortality 14.3. That's in the low-risk patient. So I think it'd be very caution about we choose the TAVI as a first, and we do the surgery. We always people say, oh, you failed, you can do a surgery. But you look at it, there's a 14.3% mortality in young patient. You really want to put a patient in this high risk. I think we really need to be carefully, consider. And this is another one is a register. So that's of course it's a voluntary register, but you also can tell right now it still have a 13.4% root replacement. Okay, this is for the redo first redo aortic valve surgery, and the mortality is 13%, and the stroke is 8.6%. These number I don't think is acceptable. If you operate a young patient, I think this is not acceptable to me. And how about the valve? Of course, people will say just don't do the redo valve surgery, but just do valve because valve was a very minimal invasive, quick recovery, simple procedure, good early come. I totally agree. I always present my data as I always say this is a nice, easy to do. But however, there's some concerns. There's coronary obstruction, high residual stenosis, high rate of pacemaker implantation and thrombosis, and also the compressed coronary access. So I think there's a few things still not really, this I have shown before, all the data, you can see the average mean gradient is all in 2 digit, and even large biprosthesis is still 14.8 digit. So as a gradient is not low compared to surgical valve redo. And you can see this is a valve. You also can see the gradient is still high. And the new pacemaker surprisingly 11.1%. That's and the early was 9.6, also pretty high. And another paper, this paper published, there's almost 26% patient they are not eligible for TAVI because of multiple factors. So that means quite a number of patients you really cannot do the valve. You force you to do a surgery, and to do a surgery is a high risk. So we really have been think about it. Of course, the high gradient is also related to the early failure and other things. So I think that definitely is a high gradient is not a good idea for the young patient. And this is a paper published as a propensity match, as you see here. Valve versus surgical valve, after the 2 or 3 years, the lines are crossed. Seems like these lines continue separating. So we really, like to see this longer, this follow-up, whether this lines continue separating or they back to the together. So we really don't know yet. This is seems like after 2 to 3 years, these lines are separated in terms of all the cause mortality, cardiac mortality, and the pacemaker, of course, is high. And so another thing is coronary reintervention after TAVI, in the TAVI, with this is a CT assessment. You can see if you choose a different valve, especially as a high mounted valve, if you use the first the high mounted valve, second the high mounted valve, you almost, you can see how much you cannot do the coronary access. Majority of patients, you cannot do coronary intervention. That's really the concern for the young patient, because if you put into 60 years old and 15 years later, if they develop coronary disease, then force you to do surgery rather than coronary intervention. So I think that's a critical in terms of type of valve you choose for the first time and the type of valve you choose for the valve. I think that's critical, not just focus on the early outcome, early hemodynamics. We are talking about young patients, so we are more focused on the long-term situation, not early first years or 30 years outcome. I think when you talk about 30 or 1 year outcome in the 80s, that's totally appropriate. But in the young patient, I don't think that's sufficient to determine they are same or not the same. So I think that my opinion is that TAVI and the valve is still not ready for prime time in young healthy patient. I put a healthy patient, not just the young patient, because they can have a comorbidity. So a healthy patient probably is not. So many factors you have to think about when you do make a decision in the young healthy patient. I think as a critical one's anatomical related factor, I think it's very important to look at all these factors and to make a decision. Second is as device-related factor. I think it's also important, of course, durability and whether there's other issues related to the TAVI. And also that you need to think about a redo, whether it's easy to do or not easy to do. And other factors, local expertise or these kind of things, you need to think about everything when you make a decision in the young patient. So back to the first slides. So that's my opinion. For the 65 years old, it's a little too young. It's not too young and not too old. So I think for this patient, the life expectancy, if in the North America, probably will be 20 years for life expectancy. So I think in this kind of patient, I think it should be a surgical intervention. And whether the mechanical valve is appropriate, that's needed to discuss with the patient and also the patient preference, and not as a physician decision choose a mechanical tissue valve for the patient. I think it should be patient should be informed, and they need to make a decision what type of valve they really wanted, because I think it's important. For the second patient, I think 65 years old, but they have some comorbidities, and also comorbidity, and also have mitochondrial artery disease. So this kind of patient, probably life expectancy not the same as the first one, probably reduced by the comorbidity. So in that situation, what type of surgery should be, initial surgery intervention should be considered? I think a surgical valve could be considered, I think, this patient. And the TAVI also could be considered. But I think that for the TAVI, should choose the patient to have a favorable anatomy for subsequent valve and the corner access. If a patient have a good corner access down the road and also favor for the valve, I think that kind of patient, but probably TAVI is reasonable. And when you choose the TAVI, type of TAVI, I think you should have considered, it's very important to see which the valve have a less problem for the coronary reintervention for coronary obstruction, not just after first TAVI and after the second TAVI in TAVI, whether this will be a problem. So I think you should think about it more ahead. And for the third one, this patient, you can see clearly this life expectancy will be significantly decreased due to this significant comorbidity. In that patient, I would say the TAVI, even the 65, but I think the TAVI is more appropriate because of this patient, the longevity probably won't be as good as as second patient. So the TAVI, I think THV, that's a very reasonable. But that's my opinion for the life management, particularly first time. So this is probably my last slide. So I think the people that listed all the different type of intervention, but I think for me, for the young patient, the 55 to 65, I think the mechanical, don't forget the mechanical valve, I think it's still the option. And I don't think it should be TAVI considered in the young patient first. I really against this because you need to think about the valve future, redo surgery. That's all factors should be. I don't think it should be TAVI first because make the reduce difficulty, make a more problem for the coronary accesses. I think it should be surgery first for the young health patient. And it's not a recent publication in JAMA, and this they say the benefit for the young patient with TAVI first, and then compared to surgery. I'm not sure this is really the right way to do in the young healthy patient, the TAVI first rather than surgical post phase. I put a big question mark there. So I think this is my last. So I think a heart team is very important in the young patient to make a decision. And also I think at least the interventional cardiologist and cardiosurgeon should see the patient and do involved in the consent process. Thanks.
Thank you, Dr. Ye. Well, I think that your point of view is very good, and it helped a lot for us to make a decision for the patient. Since almost every patient asks our opinion to to see what kind of procedure should we done or what kind of valve should we choose for them. So, so this topic was open for discussion. Are there any question or comments from our speakers and the panelists? Yes,
Dr.
please.
Yeah, I'm Dr. Lee from NTUH. Thank you for your excellent lecture. I learned a lot from you. Talking about the TAVR explant, because I'm quite amazed that the data you show that 13% of the patient need to do the root replacement. Is there any difference in this issue between the self-expanding or balloon expandable THV? Because you know that the self-expanding is relatively high friend, and the low friend is a balloon expandable valve. So is there any difference in their root replacement?
This is an excellent question, Dr. Lee. I don't have too much experience in expanding on these patients because most patients is elderly. They don't live that long. But of course, early after the implantation, I think there's not much different because you basically you can take it out. There's not major issue, but I will expect it because the longer stent, the longer time the stent will be in the aortic wall. So you're wasting more time as the aortic wall, probably more involved. So I think you still can do it, but I probably will be a more chance to have a concomitant aortic procedure. That's because the stent is high, and you can cut it, you cannot cut a stent. You have to cut it above that. So if you want to take it out, it's quite a high away from the annulus. So I'm pretty sure after the 10 years, it probably will be a very difficult. And the concomitant aortic surgery will be more. So I think the low stent, probably generally speaking, my impression will be easier for like a long term after the initial valve implantation. But of course, your annulus still will be difficult, regardless is it self-expanded or the balloon expand, because there will be a lot of scarring down there.
Well, I've done 29 of these, and there's really not a lot of difference between them. The biggest problem in that study was the average number of explants done by the surgeon was 1. And there are very few surgeons that had much experience. And out of 29, I've only replaced 2 roots, and one was a ruptured annulus with a fistula to the left ventricle, which just needed the root replaced anyway. So there are some tips and tricks, and we've published on this, on how to get both these out. Even the self-expanding, you can cut below the end of the valve and then bring it out through the open aortotomy. The biggest problem is that a lot of the surgeons out there have never put in a TAVR valve. They don't know what they're taking out, and they're doing their very first one. And that makes it difficult. But it is more difficult than doing an aortic valve. So you do have to counsel your patients that it's not like doing a virginal aortic valve when they come back.
Thank you.
Well, yeah, please, Dr. Ye. So, I would like to make a comment on this because, up to now, I don't have much experience in explantation of the TAVI valve, but what I'm thinking is that if I do the second operation, the open surgery for the failed TAVI valve, well, I want to remove the whole valve. I will leave I will cut the wire, the excessive part of the wire. I will cut it with the wire cutter and leave the TAVI valve and the metallic the metallic portion of the valve at the annulus portion, and I will insert another transcatheter valve. If it I won't remove all the things, and I won't do this surgical aortic valve replacement in the conventional way. We can insert another transcatheter valve on the table, during the open surgery. I don't know if my suggestion will work very well. I don't know, but at least you can remove the excessive tissue from the previous TAVI valve, and to see if we can do that better to have a higher successful rate instead of to remove the whole thing of the TAVI valve to do the conventional surgical, the suture method for the open aortic valve replacement. This is my suggestion. I just, curious about this. Yeah, thank you.
I think that's a great suggestion, because for the difficult part, I agree. Take the leaflets out and then put another stent valve will probably have no problem for the coronary reaccess, because if you just wiring valve, you do seal all the stents and then make a difference. But if you cut the valve out and put another valve in, I think there will be less problem for the coronary access. I think that's a great point if difficult to take it out. And I think and thanks for your clarification, and you have more experience. But I just compared the surgical valve, probably will be a relatively difficult surgery.
Yeah, the real key is you're starting with a big annulus. If you have a little annulus to start with, you're going to be putting in a little transcatheter valve. And 1/3 of these that I've taken out have got an annular enlargement, so we can put in an adequate size surgical valve. And if you start Russian dolling these things, I saw some people putting in size 20 sapien valves. The 20 sapien valve has an EOA of 1.22. You haven't done your patient any good. So you have to make sure you get an adequate valve in when you do this.
Yeah, okay. Thank you so much. And the second topic will be given by Dr. Michael Reardon. Dr. Michael Reardon graduated from the Baylor College of Medicine, and has been working at the Texas Heart Institute as a residency and the fellows. And now his position is the Allison Family Distinguished Chair of Cardiovascular Research Center in the Department of Cardiovascular Surgery, and is Professor of Cardiovascular Surgery Academic Institute, the 4th member Research Institute, and also the Houston Methodist Cornell Medical College. I think it's Dr. Reardon will give the lecture on the topic of so-called TAVR valve degeneration. Thank you, Dr. Reardon.
Great. Can you see my slides?
Yes.
Good. So we're going to talk about lifetime management, TAVR valve degeneration, but we're also going to spend a little bit of time talking about surgical valve degeneration, because you have to understand both as you go through lifetime management. Let's see, why is it not advancing? So these are my conflicts of interest for TAVR. I've had the opportunity to run a lot of the TAVR trials in the United States as a surgical principal investigator, but I'm also a surgeon. So I do both of these. I've been doing valve surgery for almost 40 years now. So if you look at our surgical definitions of structural valve degeneration, this is from Kerry Akins from the Brigham from back in the 2000s. And what Kerry Akins said was that structural valve degeneration, which is something that includes dysfunction or deterioration of the operated valve, exclusive of infection or thrombosis, as determined by reoperation, autopsy, or clinical investigation. So most of what surgeons have done are people that either died or got their valve replaced. In fact, if you remember the previous talk, when you saw those Edwards slides for degeneration for the CE valve, those were all severe degeneration. Dan Blackman's paper from the UK, that line that was falling down red was moderate. What you didn't see was a little blue line at the top, which was severe, which is what would have matched up against the Kerry Akins definitions. Now, we have a lot of data in surgery, but some of it's not all this great. If you look at this from freedom from explant or prosthetic replacement or reoperation, which is how this is generally defined, we often see for 10 years, we'll look at the one on the fourth one over, there's one patient left at 10 years. And the mean follow-up is often less than 6 years. So it's really not particularly good data. Once you get to 20% of your initial cohort, you need to cut your study off and you can't claim tenure. Here we see the same thing for 15 years. One study had 0 patients at 15 years, and it's put out as a 15-year survival. Again, freedom from explant. Again, the mean follow-up is often less than 5 or 6 years and a 15-year follow-up, and the same thing we see for 20-year. So surgeons have really not done a very good job of really classifying our structural valve deterioration. Now we've gone to try to be a little more selective in this. This is David Capodanno's work, and these are the European guidelines. And what David did was take bioprosthetic valve dysfunction and divide it into 4 distinct categories. Structural valve deterioration, something that's intrinsic to the valve itself and permanently changes it. Non-structural valve deterioration, which is an abnormality not intrinsic to the valve, like paravalvular leak, malposition, patient prosthetic mismatch, thrombosis, and endocarditis. What we're, of course, interested in here today is structural valve deterioration. And what David did and the Europeans did was, instead of just having an on-off switch of either the valve's okay or it needs to be replaced, they said this is a gradient. So we're going to define moderate hemodynamic structural valve deterioration as an increase in your mean gradient from your discharge or 30-day echo to your current echo of 10 millimeters of mercury or more, but less than 20, and a final mean gradient of 20 to 40. Or you could have an increase in your intraprosthetic AR. They're going to define severe hemodynamic structural valve deterioration as a final mean gradient of 40 or more with an increase of 20 or more from the baseline, or now severe intraprosthetic. And then morphologically, if they see any abnormalities of the leaflets. So we're now starting to parse this a little more carefully. What they also did was they separate out valve dysfunction from bioprosthetic valve failure, which is what surgeons have usually looked at, and said if you got severe structural valve deterioration or you had cardiac-related events, that was a bioprosthetic valve failure. If you had a repeat intervention, that was a bioprosthetic valve failure. If you have a valve-related death or severe dysfunction at autopsy, like related death, that was bioprosthetic valve failure. Otherwise, then we could claim clinical success. These are the VARC-3 Valve Academic Research Consortium guidelines. I was on the writing committee of this, and when we started defining biostatic valve dysfunction, we did the same thing as David and the Europeans did, and defined it as structural, non-structural thrombosis, and endocarditis. And then we asked for each one of these, were there hemodynamic changes, and divided those into 3 stages, and then defined failure as death, need for reoperation, or evidence of severe dysfunction and symptoms, much like somebody needing an original. And stage 1 was morphologic valve deterioration, where there's evidence of deterioration on echo, but there's really no significant hemodynamic changes. Stage 2 was moderate, and just like the Capodanno, it's an increase of the mean gradient of 10 or more from your final echo to your current echo, with a final mean gradient of 20 or more. But here we also said you needed a decrease in your effective orifice area of 0.3 centimeters or greater, or 25%, or a decrease in your Doppler velocity index of 0.1 or more, or 20% at your last echo, or new AR. And then stage 3 was just upping to, now you have a high mean gradient, you're up above 30, you've gone up over 20, your EOA has gone down even more, greater than 0.6 or 50%, your Doppler velocity has gone down more, greater than 0.2 or 40%. So really the echo criteria for severe aortic stenosis. Now, there's a lot of evidence of early structural valve deterioration in surgical valves. This was an early one on the trifecta valve that came out of Hartzell Shaft in the Mayo Clinic. This was Jennifer Lawton in the Medtronic Mosaic valve. This is early for the MitraFlow valve. We published in 2017 our experience of early failure of the trifecta valve. So when we start talking about both surgical and TAVR valves, we have to remember these are not all the same. Every surgical valve behaves differently as far as its structural integrity, and every TAVR valve is going to end up behaving differently as far as its structural integrity. So we have to be careful as we make our lifetime decisions. We also know several other things. This is Fallon's work from the STS, looking at the database of almost 60,000 patients that were 65 or older, having an isolated aortic valve replacement in the US over a 10-year period. Very similar to what we're talking about here in the lifetime management. And what Fallon showed was that any degree of patient prosthetic mismatch significantly decreased the long-term survival and significantly increased your readmission both for heart failure and aortic valve replacement. So we need to think about this as we're deciding which valve to use. So what TAVR data do we have? Well, this is the NOTION trial, the Nordic trial, which was the Finland, Norway, Sweden, and Belgium. And this was a very early trial starting in 2009, designed as superiority, all comers over 70 for TAVI or SAVI. So it's an all-comers population. And they had a primary endpoint of all-cause mortality, stroke, or myocardial infarction. And what Lars Sondergaard showed us at 8 years was that the hemodynamics for TAVR, which was statistically superior to surgery at every time point, was persistent all the way out to 8 years, as was surgery. So we see no real hemodynamic changes of this. We also saw that the all-cause mortality didn't differ over 8 years in this all-comer low-risk population. The combined endpoint of all-cause mortality, stroke, or MI was the same over all 8 years. But then what Lars did was he then used the European definition to look at moderate structural valve deterioration. And what he found was at 8 years, there was twice the moderate structural valve deterioration in surgery than there was in TAVR, and this was statistically significant. If you use the definition of severe, which is what surgeons have typically used, the numbers were very similar, 10.6 for surgery, 7.3 for TAVR. Again, this is now not statistically significant. But the early signal of moderate is a little worrisome. Now, we do have some TAVR durability from the randomized trials. In the US, is TAVR 1B, 1A randomized against surgery, no change at 5 years. Core valve extreme, good. Core valve high risk, randomized against surgery, no change in hemodynamics. Partner 2A, intermediate risk, no change in hemodynamics. And TAVI, which we just presented, no change over 5 years. So in the early going here, it looks pretty good. So what do we know from the randomized trials? Well, this is the Partner 2A, 5-year structural valve deterioration. This was presented and published by Philip Peeberow. And what they did is they looked at the randomized group between the SAPIEN XT and surgery and looked for structural valve deterioration. And then they looked at the surgery compared to the non-randomized continued access arm of the SAPIEN S3 and propensity matched them. And what they found is, looking at a definition of moderate structural valve deterioration using the VARC3 definition, the 5-year rate for XT was 9.5% and for surgery 3.5%. This was statistically in favor of surgery over the XT. If you look at the non-randomized S3, 3.9 for S3, 3.5 for surgery, this is not statistically significant. And if we look at the severe bioprosthetic valve failure, it's statistically in favor of surgery over the XT, but not over the S3. And again, if you look at all-cause bioprosthetic valve failure, again, statistically better for surgery than S3. For SAPIEN S3, it's 2.6. For surgery, it's half of that, 1.3. But this did not reach statistical significance, but it is starting to trend towards surgery. So we did a study that using the high-risk randomized trial for core valve, as well as the TAVI intermediate risk trial, knowing this data, because there really was limited data on the factors associated with and outcomes from large-scale multi-centered randomized trials. We had previously shown that with the suprannular core valve evolute, there was significantly lower 5-year rates of hemodynamic valve deterioration, and this was associated with clinical outcomes. Remember that VARC3 and the European definitions have never been associated with clinical outcomes. So we presented this as a late breaker at the American College of Cardiology this year. The way we did this trial was we took the randomized group from the high-risk and TAVI and used these randomized patients, over 2,000, to compare the rates of structural valve deterioration. We then added in the non-randomized cohorts of both of these, now over 4,700 patients, and used this just to look for association with clinical outcomes and the predictors. We use our definition of moderate hemodynamic valve deterioration as an increase of 10 millimeters or more from your discharge 30-day echo to your last echo, and a mean gradient of 20 millimeters of mercury or more, or new onset or increase of intraprosthetic AR to moderate or greater. All the randomized group where we looked at the difference were assessed by the Mayo Clinic Core Lab JO, and I looked over every one of these myself, along with Steve Yakubov and Kendra Grubb. So this is what we found for the structural valve deterioration using death as a competing risk, that at 5 years for surgery it was 4.38%, and for TAVR it's 2.57%. This is statistically in favor of TAVR. So outside the NOTION trial, this is the first time that TAVR has been shown to have less structural valve deterioration than surgery. This is the moderate level. Then we looked at small annulus. Annulus as 23 millimeters or less on CT scan. Again, statistically in favor of TAVR, and even widens out. And we looked at the larger annulus, and what we found was that it's still numerically in favor of TAVR. It's trending, but doesn't reach statistical significance. So does this make a difference? Well, yes, it does. What we found is, for the pooled data of over 4,700 patients, whether you had surgery or TAVR, if you develop moderate or greater structural valve deterioration, your hazard risk of death, all-cause cardiovascular mortality or rehospitalization was 2, and all statistically significant. For just the surgical cohort, the mortality risk was even higher. It's almost 2.5. And the only line that crosses unity was rehospitalization, and that's only because of small numbers. If you look at the overall TAVR group, again, a hazard risk of 2. So in either group, TAVR or surgery, if you develop moderate or greater structural valve deterioration, you doubled your risk of dying and you doubled your risk of rehospitalization. What we found is, if you're older, male, or had prior PCI or AFib, you had less risk of structural valve deterioration. Remember, the converse of this is younger, healthier females with the small annulus are going to have more likely to get it and more likely to have a problem with survival. And if you're obese, you had a greater chance of developing structural valve deterioration. So some of our patient prosthetic mismatch that we're building an obesity factor probably shouldn't be done. So the conclusions from our study was that patients with severe stenosis, intermediate or high surgical risk, the 5-year rate of structural valve deterioration was statistically higher in surgery than in TAVR with core valve evolute. And the difference was more profound in the small annulus and statistically significant, but still trending in the large annulus. And that our use of Doppler-derived structural valve deterioration imparted a near 2-fold risk of all-cause mortality or rehospitalization. And again, our multivariate predictor found a higher risk in patients with a higher body surface area, a lower risk in patients that are older, men, or prior PCI or atrial fibrillation. The clinical implications of this are that our patients do come in and they want to know how long their valve is going to last, whether they get a surgical valve or a TAVR valve. And this is the first time we've shown superior early to midterm for a TAVR valve over surgery. They also want to know if they get structural valve deterioration and their valve starts to fail, does that mean something? And the answer is yes. It increases your risk of death by 2-fold and your risk of hospitalization by 2-fold. And long-term data will be obtained from both the intermediate and the low risk, which we need longer-term data. But certainly the evolute core valve is the only valve that's been shown in randomized trials to have superior hemodynamics at every time point tested, and now superior survival in this short to mid-term. Now, we all know as surgeons that the older you are, the longer these valves last. These are surgical definitions really of reintervention or reoperation. But the younger you are, the more likely, the more quickly they're going to fail. We know from Doug Johnson's work at the Cleveland Clinic, the higher your initial gradient, the more rapidly you develop structural valve deterioration. This rises exponentially when it goes above 20. We've already talked about this work from Fallon. We know patient prosthetic mismatch matters. We know that from Fleming's work that patient prosthetic mismatch is a marker for both structural valve deterioration and for early death. We know from the low-risk trial that if you're assigned to surgery at 1 year, your risk of having moderate structural valve deterioration was 5 times higher for surgery than TAVR. We know that the risk of moderate to structural valve deterioration was much lower for evolute than it was for partner, because partner has hemodynamics that aren't as good as a supraannular valve. Remember Becky Hahn's paper in circuit intervention, the Doppler velocity index average for a SAPIEN S3 is 0.42. The Doppler velocity index average for evolute is 0.61. About 30% better. So in conclusion, all bioprosthetics valves will fail given enough time. Failure is related to the age of the implant. Failure is related to the valve type. Failure is related to smaller effective orifice area or higher initial gradients. Failure is a progressive process. And midterm suggests TAVR durability is at least comparable to surgical durability. Thank you very much.
Thank you, Dr. Reardon. Is there any questions from our panelists and those speakers? Well, I quite agree with your, opinion that I think the long-term durability is quite related to the pressure gradient, since actually when we do the surgery as the open heart surgery, as an open method, that we need to make these stitches, and especially if you are using the intra method, right? So instead of on top, the type of the sutures making the intra method, then sometimes the size of the surgical valve will be smaller. So nowadays I'm using the continuous suture to make the surgical valve bigger. Besides, but still, the transcatheter valve still can be, have a lower pressure gradient. I think this is makes sense for the long-term durability, and also especially for the patient with the high body weight, I think, right? So any other comments or questions from
well, I think for the surgeons in the crowd, you really need to make sure that you're sending out adequate size valves. If you're sending out 19 and 21 valves, your cardiologist might as well be sending these people to TAVR.
Yes.
And in my operating room, the rule is females never leave with less than a 23 and males never leave with less than 25. And I've started this since Bo Yang introduced the Y annuloplasty. If you're not familiar with Bo Yang from University of Michigan's Y annuloplasty, you should look it up. You can go 3 sizes bigger with this. It's very simple to do. You don't cut into the mitral valve itself. And my fellows are doing these on a routine basis now. And so I think as surgeons, if we really want to compete, we need to make sure that we're bringing in adequate size valves, to begin with.
Okay. Any other? Okay.
I have one question for Dr. Redden. Yes, the current recommendation for the post-regimen for antithrombotic regimen is the single antiplatelet or anticoagulation alone in those patients who indicated. So the valve thrombosis is maybe the risk factors for the valve deterioration. So in your opinion, do you think the early stage of the more aggressive anticoagulation is beneficial to the long-term durability?
We don't know, but it's a very good question. As you know, in both the low-risk trials, and I ran the Evolut low-risk trials, they both had 40 CT sub-studies. Both of those were looked at by the imaging group in Vancouver. And what we found is that in the Evolut, there was actually more halt of 50% or more in surgery than in the core valve Evolut. In SAPIEN, there was more halt or thickening in the SAPIEN valve than in surgery. And it's probably related to the fact that our surgical valves, unless you're using a porcine valve, are all bovine pericardium, as is SAPIEN, whereas the Evolut is porcine pericardium, which is thinner. Now, whether or not anticoagulating these makes a difference, I don't know. But if you look at the risk factors for structural valve deterioration, you notice that having a prior PCI and prior atrial fibrillation, both were protective from structural valve deterioration. So both these are markers for coronary disease or for heart disease. It may mean you're dying quicker, and so that's a competing risk, or they're all in anticoagulation. And it may be that the anticoagulation is what's protecting them. I don't have the data. That's something that we need to look into. So I'm looking for young investigators who want to write a new paper, and we'll write that from that data.
Thank you for your answer. Thank you.
May I ask a question for Dr. Redden? What's your comment about the operation of Rose operation or Ozaki operation for the, in Asian, we have lots of young, small annulus patients. So I know some experts emphasize the advantage of Rose procedure or Rocky procedure for such patients. So what's your comment in your hospital? Yeah, thank you.
I think for people that are less than 50, if you have a Ross surgeon and really knows how to do the operation, it's a great operation. The Ross operation outside of a valve-sparing route is the only aortic valve operation that returns you to a normal lifespan. Stented valves do not do that. TAVR valves do not do that. The Ross will do it, and a valve-sparing route, when you maintain your valve, will do it. The biggest problem we have is there aren't many really good Ross surgeons out there. There's surgeons that do 1 or 2 of them and then claim to be a Ross surgeon, and they really aren't. But if the people that are really good Ross surgeons, my children are 41 and 45, if they need an aortic valve, I would find a really good Ross surgeon. I've done a number of Ross procedures in my life. I don't have many younger patients. I don't consider myself a Ross patient. I would send them to somebody I consider a Ross. It's a wonderful operation in the right hands.
I totally agree with Dr. Reardon, the comments. I think a Ross procedure nowadays, there's too many people want to do it, and then they do annually probably a few cases. I think that's need to be a caution. Maybe the worst outcome will come out in the next few years if everybody doing the Ross procedure. I totally agree with you. Thanks.
Well, if we could have good surgeons like Anson everywhere, we would do good, like in Vancouver. The one thing that we haven't talked about in lifetime management, having run both one low-risk trial, is that my problem is that cardiologists see these trials.
Thank you, Dr. Redden. So we have to proceed to the next topic. With that will be chaired by Dr. Ye.
Oh, thank you. So next speaker is Dr. Papma, and he's available on board.
Okay.
Oh, can you hear me?
Yes, I can. Can you hear me?
So please,
good.
Dr. Palmer or
Dr. Palmer? Go ahead.
Yes.
Dr. Ye, we can't hear you, Dr. Ye.
Oh, you cannot hear?
How about your, yeah.
Sorry, I already unmuted. So you maybe you
we can hear you,
Dr. Ye.
Yeah,
but we can hear you.
Oh, okay.
The panelists can, but maybe the main stage cannot.
Okay, I don't know.
Probably, yeah. Okay, but take Dr. Ye, take your time, and I would. How about your?
So you doing?
No, it's okay. Yeah, we can hear you.
Sorry. Okay, I just give a sorry. I don't know why. So I just say next speaker is Dr. Palmer. He is a world-renowned interventional cardiologist, and he's a director for interventional care and interventional, and also the angiograph care laboratory at the Beth Israel Medical Center in Boston. So he has been like a PI and principal investigator for many TAVI trials. So he's really well known and interventional cardiologist, particularly in the TAVI. He's a pioneer for the TAVI. So his lecture will be an expert discussion on life expectancy and reintervention after aortic valve replacement. Dr. Palmer, please.
Dr. Yi, Chairman, can you hear me okay? Is my volume all right? Perfect.
Yeah,
all right, great. I am very humbled by this group. We have a lot of input from cardiac surgeons. I have to say, in listening to the strategic approach that you use for your patients, they're very similar to those that we use in our patients in the United States. And I think that one of the things that really comes up as a repeated challenge is that we've always known that lower gradients at the time of the procedure likely had a beneficial effect on late-term valve durability, but we didn't know it. And really, we focused over the last year on a series of data analyses and of publications that have demonstrated that there is a correlation with gradients immediately after the procedure and long-term valve durability, which is really the focus of this discussion. We've done that by finite element analysis, looking at S3 versus Evolut with a 40% lower stress on the leaflets with Evolut than Sapien. We've looked at reintervention, surgery versus TAVR. Dr. Reardon has shown you the data from the NOTION trial. We had similar changes, reductions in hemodynamic valve deterioration in our data sets. And the meta-analyses that have come forth suggest, particularly from EuroPCR, that there is in fact a benefit of supraannular valves compared to annular balloon expandable valves and annular surgical valves. So the focus now is all on durability. And you've heard and you will hear with Dr. Pirelli some very, very intriguing data about which goes first. This is a editorial from Dr. Wackman's group. Do you do the SAVR first, followed by TAVR? Do you do the TAVR first, followed by SAVR, and then TAVR? Or is this really something for the patients where we have to come up with solutions for TAVR and TAVR and TAVR? Well, I'm going to challenge this hypothesis just a little bit and say, what are the chances that the patient's really going to get to the third TAVR, even if they're relatively young, in patients who we think are appropriate for transcatheter aortic valve replacement? We have two sets of guidelines. One set of guidelines is from the American College of Cardiology working group. And in their pivotal paper, they discuss the fact that patients who are under 65, all things being equal, should undergo surgical aortic valve replacement. Patients over 80, TAVR, and there's a gray zone in between 65 and 80, where there is a heart team discussion. The European guidelines, just published last year, suggested that age threshold should be higher. It should be 75 years old to recommend under 75 recommending surgical aortic valve replacement. And that was primarily driven by the surgeons in Europe concern that we did not have enough long-term valve durability with our TAVR valves, and that really the state of the art at that point was really surgery. Now, this discussion came up earlier. It's a very important discussion. It's a heart team decision, balancing the risks of SAVR with the risks of TAVR, with many patients in the middle who could go either way, and the patients then choose what their outcome, what their treatment therapy will be based on their preferences. So it's always a balance. And certainly if we expect to have patients live over 20 years, SAVR is a good first step. If we think the life expectancy is under 10 years, TAVR is a good step. But what about those patients in between? Those patients between 10 and 20 years life expectancy? Well, this is the heart team discussion. This is what happens in the US. I'm sure it happens in Taipei, that the surgeons and the interventionalists get together and they say, let's balance long-term durability and potentially lower rates of leaflet thrombosis, as was brought up earlier, with other things that we have to be concerned about in this patient's lifetime. Pacemakers, coronary access, ease of use, TAV and TAV. This conference will address many of these issues, particularly the TAV and TAV side. Dr. Reardon has focused on durability. We've heard a very provocative question based on the recent JACC cardiovascular interventions paper suggesting that HALT is associated with late SVD. We believe that, and so does Renu Vermani. So it's a heart team discussion balancing risks and benefits. So the purpose of this short talk is a critical discussion that we really need to understand better what we're discussing with our patients about durability after surgical aortic valve replacement. How long do the patients live? What's the rate of structural valve deterioration? As Dr. Reardon has pointed out, it's usually explant in the surgical literature. What factors affect structural valve deterioration? We need to understand these factors as we balance the choice of choosing a transcatheter valve with the data that Dr. Reardon just shared with that of surgical data. Now, Dr. Reardon had a slide about Dr. Johnson and Dr. Blackstone's pivotal analysis of nearly 13,000 patients who were treated with primarily Edwards valves, and then followed, as many of them were live, out to 20 years. And Dr. Blackstone has been a leading statistician who's allowed us to understand the risk of death and how we have to factor that into our analysis of structural valve deterioration. Dr. Johnstone's series showed what we just feel, and you know that from the explant registry. Early structural valve deterioration is often due to endocarditis, but late structural valve deterioration is in fact due to degeneration, calcification, and pannus formation of the valves themselves, and that increases over time. Now, on the right side of the screen, you'll see a very important number, and that is using the criteria for surgical explantation for structural valve deterioration. We see that the problem of SVD is not a problem in 80-year-olds. It's somewhat of a problem in 65-year-old, 80-year-olds, but it's really a problem in patients who are 60-year-olds or less, with nearly half of the patients developing structural valve deterioration over the next 20 years. Now, this was referred to by Dr. Reardon. These are the numbers. I think they're incredibly provocative from the surgical literature. We believe they also apply to the TAVR literature. And that is that your risk for structural valve deterioration relates to your residual gradient, and that increases over time. But take a look at that graph on the right. The residual gradient is not so important in an 80-year-old. That makes sense. A little bit more important in a 70, 80-year-old. But in younger patients, the residual gradient is very important in determining the rate of late structural valve deterioration. These are the same principles that we have in TAVR. So the bottom line is that if we're just going to treat 80-year-olds, structural valve deterioration may or may not be much of a factor. But as we move down into 75-year-olds and 65-year-olds, then the residual gradient that's within the valve after the procedure is incredibly important. It's important in the surgical literature. Now, what happens when we treat a patient with surgical aortic valve replacement? Do the patients return to their age-match adjusted mortality rates? And Dr. Blackstone will call this the age paradox. And that's really an important factor, and it was alluded to earlier. And it really basically says that if you present with your aortic stenosis at a younger age, even though you have successful surgical aortic valve replacement, you never get back up to the curve again. If you're in that intermediate range of age, 70 to 80, Dr. Blackstone would suggest that you get back up closer to your age-matched control. And if you're 80, then you seem to have some longevity with respect to durability and a good life expectancy, and I'll show you the data for this. Now, this was a very thoughtful study from the Netherlands, and it used microsimulation monitoring to determine what the rates of structural valve deterioration would be by age with the competing risk of death. And it's pretty interesting because whether you're 75 years old or 80 years old in this microsimulation study, you pretty much got back up to your age-matched survival rate as a general population. And I'll go over what those numbers are in just a second. So in this microsimulation study, things look pretty good in this 75 to 80-year-old time frame. And that's where Dr. Blackstone would say that that you get back up to your age-matched control. And the numbers, if you're 75 years of age, the rate of SVD is 7%, it's 3% if you're 80 years old. All that makes sense because the rate of structural valve deterioration goes down because of the competing risk of death as you become older. But let's look at this data. Let's look at this data. Another large series of patients after successful surgical aortic valve replacement, and understanding that the age life expectancy is going to vary by the surgical risk of the patient. High-risk patients had a 6-year median survival. Intermediate risk patients had a 78-year survival. And low-risk patients between 10 and 12 years, not 20 years, between 10 and 12 years. Let's drill down into this data just a little bit further and say, let's just look at low-risk patients. What's the survival in successful surgical aortic valve replacement in low-risk patients? Well, if you're 70, your median survival is 12 to 13 years. Again, Dr. Blackstone would say, don't get back up to the age-matched control. If you're 75, that seems about right, median survival of 10 years. And if you're 80 years old in this series, you got another 8 to 10 years, which sounds great. That's the paradox. So as we're talking in our heart team discussions about how long the patient will be alive after their valves, that number, whatever the age, is going to be somewhere between 8 and 15 years. Just about what we think the longevity of a surgical aortic valve is, which makes the information that Dr. Reardon provided so much more provocative, because if most patients survive without a reintervention after surgical aortic valve replacement, if we have a valve that halves that rate of structural valve deterioration, more patients will get across the finish line of life with a single valve rather than multiple valves. And that's why the durability data is so important. Again, this is additional data from Dr. Mikhailovich, now the CEO at the Cleveland Clinic with Dr. Blackstone, demonstrating again that in that intermediate range, it's about a 50% 10-year survival rate. So what do? We're in our heart team discussions now, and we say, well, what are the median survivals? Well, if you're young, you do get pretty good years out of it, 15, 16 years or so. From the papers that have been published over 70, it's somewhere between 12 and 13 years, 75, 10 years, median survival 80 years old, because of the age paradox, a little bit longer. So we want to match what we're going to do with our first valve in order to provide the best outcome in patients who are undergoing aortic valve replacement. So as we talk about that balance, we believe that we want to put the most durable valve in first, whether that be if one's looking at surgical valves or whether that's looking at transcatheter valves, the most durable valve first, given what we know about the data that Dr. Reardon presented, should give us more durability over the long term and lessen the need for the patient to have a second valve. But just to finish up, I just want to go over a couple of other points about what we have to balance that with. What do we have to balance that with? We have to balance that with the patient living a longer period of time. We have to think about the implication of pacemakers, coronary access, the ease of use, and TAV and TAVR will be extensively discussed in the next section with Dr. Pirelli. I'm not going to cover that much. But let's just talk about how we're going to mitigate these risks. And I'll show you some data that was just really presented over the last 3 weeks. First of all, Dr. Kendra Grubb presented the Optimize Pro study, which is a prospective study using the cusp overlap technique with Evolut in order to understand if we could achieve lower pacemaker rates than the 17.4% pacemaker rate that we saw in our low-risk trial. Everybody followed the protocol of cusp overlap. You know what that is, and everybody's been trained on that. It's incredibly important. But mostly what the cusp overlap does is unforeshorten the left ventricular outflow tract, so that when we're placing our valve, we have a much better idea of exactly where it's landing. Very, very important. So what we found in that study of 400 patients presented by Dr. Grubb was the average pacemaker rate was 9.8%. Not as low as we'd like it to be, but certainly better than the 17.4% that we saw in the low risk. But here's where we're really looking at the provocative data. This slide demonstrates whether or not the cusp overlap technique was followed or not followed in the course of the study. And there's 2 events I want you to look at. Firstly, if we follow the cusp overlap technique with good visualization, with the Lunderquist wire, with the slow deployment, knowing exactly where we are, there were no cases of valve embolization. It was only when we didn't follow the technique that we had that rate of 1.3%, which is what we see in our registry studies. On the right side of the screen, just picking 3 and 6 compliance, there was a lower compliance rate when you follow the cusp overlap technique than when it wasn't followed, down to 8.1%. Dr. Gada has just submitted to TCT a further analysis of this, which will support this even further, that the cusp overlap technique has in fact made a difference and has gotten pacemaker rates lower. Now, most importantly, from the cusp overlap technique, look at this slide. Most importantly, we have always had the Achilles heel of paravalvular regurgitation. With appropriate implantation techniques using cusp overlap, 78% of patients had none or trace paravalvular regurgitation. No patients had moderate or severe, 22% had mild, but it's an incredible rate of none or trace paravalvular regurgitation, which is in fact our goal. Now, at the most recent TVT meeting, which was last week, Dr. Harvey presented our registry data, similar to what your registry data you're collecting, in 54,000 patients in the TVT registry, 54,000 patients. And what you'll see from this graphic is that we have gotten better over time with our pacemaker implantation rates. These are impossible pacemaker rates down to 7.6% with this analysis, most recent quarter down to 7.5%. So we're getting better with our cusp overlap of accurately placing the valve and reducing pacemaker rates. That's step number 1. We have to get that down closer to surgery and closer to where they are with balloon expandables. Now, that meant that the median length of stay in the TVT registry, median length of stay is 1 day. Patients go home the next day in the majority of cases. That's pretty incredible over time. Now, I just want to touch on where we're going next with our technology, because we do believe that having cusp overlap to allow a more accurate implantation is important. We also think that ease of use is important. And finally, we have buttressed ourselves on making sure that we have commissural alignment, because with commissural alignment, we think we have better coronary access. And this is a recent study from Giuseppe Tarantini comparing Evolut Accurate Neo and Sapien with respect to commissural alignment or no commissural alignment, and the frequency of not being able to get angiography of both the right and the left coronary artery with Evolut, with annular aligned Evolutes, was 3%. 97% of the time we got pictures as long as there's commissural alignment. This was very provocative data for us, very important data, because we believe, as Dr. Reardon has shown you, the durability relates to the superannularity of the valve, the strong inflow, and maintaining the radial strength is a very important part of our portfolio. But we now think that we can actually come with a better catheter. We're going to start the commercial use of that in the United States. We got to get it to you guys as fast as possible. The FX has a nose cone redesign, a more flexible capsule, a single spine shaft, stability during deployment, and inflow markers, which will be very important for us for commissural alignment. Now, as all of you know, when you place an Evolut Pro Plus, it's a very useful and recapturable valve. But with deployment, the valve actually moves into the ventricle. The operator pulls back to make sure it doesn't go too far in the ventricle, and that cants the valve. The new FX design is made such that when the nitinol capsule is retracted, there's symmetric deployment on both valves. Symmetric deployment on both valves. And we believe that's very important to make sure that there's not canting at the time that the valve goes in. So ease of use should be markedly enhanced with this valve. More importantly, this valve has 3 markers that are placed at the commissures. And the 3 markers of the commissures will then allow in cusp overlap to place 2 of the markers on the left side of the screen and 1 marker on the right side of the screen. And in cusp overlap then, the neo commissures are lined up to the native commissures, and we believe that will enhance our ability to access the coronaries. Now, what happens once we get commissure alignment? Well, then we can move into our next generation FX Plus that will have large cells in front of the Evolutes to maintain to allow coronary access. And after that, I'm going to try to go back here to this one, see if I get this to play. After that, we're going to go to FX 360, which means that in the ascending aorta, we can line up the markers by rotating a dial and get to coronary alignment, not just commissure alignment, which is going to be very important. So I think others will cover the TAV and TAV coming up here. I think that we really need to figure out in a very clear way what the advantage of a more durable valve is. Right now, we can compare that to surgery. And with that, we think that in appropriate patients who have a life expectancy between 10 and 15 years, it's most patients over 70, putting the most durable valve in first will lessen the rate of the need for reintervention later. And then subsequently to this, you're going to hear the discussions about how we do that if the valve does fail. But more importantly, Medtronic is very, very committed to commissure alignment, to ease of use, and to coming up with TAV and TAV solutions. I want to thank the organizers for their attention, and I'll stop here and see if there's any questions.
Thank you, Dr. Palmer. Well, the topic will be open for discussion from other speakers and also panelists. Well, I think
Maybe I can ask Dr. Go ahead.
Yeah, please, yeah.
So Dr. Reardon, you've been dealing with our surgeons. We have a lot of surgeons on the line. Maybe you could discuss how surgeons view this durability data with respect to valve selection in the appropriate TAVR patient in the US.
I think, Jeff, surgeons have known for a long time that the bigger EOA and the lower gradient you start with, the more durable your valve is going to be. We also know from Becky Hahn's work that if you look at a balloon expandable valve, you get a Doppler velocity index of 0.42. That means your EOA is 42% of your LVOT, whereas the Evolut, it's 0.61, 61% of your LVOT. And for most of surgical valves, it averages at about 0.5. And so, you know, would you rather start with an EOA that's 41%, 50%, or 61% of your LVOT? Well, the larger you start, the more time you have before that's likely to get small again. And most of these pericardial valves fail because of eventual calcification and stenosis. And so I think that this is again really provocative data for the durability. Now it's kind of midterm data, and we need longer term data. But my feeling is that structural valve deterioration is a progressive phenomenon, and these curves that have separated will only separate more and more rapidly. So I'm looking forward to the 10-year data. And I think, unfortunately, surgery is going to have a harder time keeping up with a supraannular valve with these types of hemodynamics.
And just for the audience here with the surgeons, I know we've got 3 surgeons on the line and Dr. Pirelli's on the line too, is that we're working with Dr. Blackstone and Dr. Johnston at the Cleveland Clinic to try to come up with similar models for structural valve deterioration with annular valves and supraannular valves, as well as surgical valves. And that's going to really be able to determine better what the risk is going to be for us over the next several years. As long as we treat 80-year-old patients, I just don't think the structural valve deterioration is going to be a clinical issue for most of them. But when we start to get down into younger age groups of patients, and I say younger, 65 is young, then I think that's where we're really going to have to start thinking about this more.
But I would like to point out again that like surgical valves, transcatheter valves are all going to behave differently because of their valve design.
Yeah.
And you can't look upon these as a monolithic group. Patients come in my office all the time and say, well, my cardiologist told me this valve will last X number of years. And I have to tell them it depends on how old you are, your overall state of health, and which valve I put in.
Yeah.
Dr. Palmer, can
Yes.
I have one question?
Of course.
I'm looking forward to the new generation of self-suspending valve in Taiwan. And could you explain more detail about the 3 marker about the alignment to the coronary axis? And how about it in case of bicuspid valve? Bicuspid is how to rotate the 3 stop. Thank you.
Excellent question, and that's why we have the portfolio of valves that will move forward to a full rotation and be able to do that. For the surgeons on the line, as cardiologists, we always thought that the coronary arteries came off right in the middle of the commissure, right in the middle. But the surgeons have taught us that, in fact, they don't always, that the right coronary artery is a little bit posteriorly oriented. And at least my surgeons, after I've given them a beer or two, do say that although they line up the neocommissures to the native commissures on occasion, if the coronary artery is not in the right place, they'll rotate the valve a little bit in order to make sure that the commissural post is between the left and the right coronary. With this technology that we will have, with the markers on the commissures, we'll be able to take the CT scan and rather than doing a cusp overlap view, do a coronary overlap view. And that coronary in general is a little bit more REO and a little bit more caudal, and we have to figure out what that means because sometimes it's already a little bit much. But once we get to a coronary overlap view, not a cusp overlap view, but a coronary overlap view, then my mark and being able to put 2 markers on the left side of the screen in cusp overlap. The 1 marker on the right with the commissure deemed deployed will go right between the right and the left. But we have to have precision with being able to rotate the catheter. So our 2-year goal is not commissure alignment. Our 2-year goal is coronary alignment. Because first, identifying the angiographic projection for which we'll implant, and secondly, be able to precisely rotate the catheter so the commissural post can be between right and the left coronary. Does that make sense?
Yes, sure. Coronary alignment is more important. Yeah.
Coronary alignment is more important. That's where we're headed with our group. And we're learning from surgeons every day.
Yeah.
And so we're learning all these things. And coronary alignment is really what we need to do. And that's going to really facilitate coronary access.
Appreciate it. Thank you.
So may I ask a question for Dr. Palmer? In bicuspid valve, is there any study to compare with the? We know in tridiphilic patient, the TAVR, the performance is superior to surgical valve. So how about is any study to compare with the in bicuspid aortic valve TAVR? Is the long-term or short-term hemodynamic performance is better than surgical valve?
So we're going to learn from you. I mean, I'll be honest with you, is that in our low-risk study, which was 150 patients, and the European Bivolute study by Nicholas van Meegen and with Didier Cheche, another 150 patients. The totality we have is 300 patients that we've studied. The Bivolute was not low risk. The US was low risk. Most of them, 90% of them, were Sievers 1. So you will have all the data, much more than we will, for the Sievers zeros. And one of the comments that I would like to, and I think that the question was, raised earlier, is that it's not so important if it's 2 or 3 cusps, as long as we know where the coronary overlap view is, then we can put our next generations with the commissural post between the coronaries. Good predilatation, open up the valve, and then put it between the two. Between now and then, we want to work with your teams as much as possible. We think that the valve that we have, the superanular valve, provides more of a concentric coaptation, 13 millimeters above the inflow with a bicuspid, than a balloon expandable will. We think that it's going to be better for that, more symmetric, better gradients all. Our preliminary data from low risk, published now with bicuspids, looks good. But to be honest with you, Medtronic is very much interested in working with physicians in the Asia Pacific who have bicuspid disease in up to 40% of cases. That's really where we're going to learn, and we're going to learn from you for these new techniques. So I hope we can work together on that. We need more data.
Other comments?
May I ask another question?
Okay, keep on going.
Okay. May I ask a question for Dr. Redden about what's your opinion about the rapid deploy or some socialist valve? I mean the placebo device, because we take off all calcium and put a stainless valve for our patients. So physiologically, it's be better than the stent valve or the TAVI valve. So what's your opinion about the placebo valve in human?
I've done about 100 of the personal valves.
Yes.
And what I liked about it wasn't the rapid deployment, was the hemodynamics, because it had hemodynamics that looked like an Evolut valve. It wasn't that it was that much faster. It just had better hemodynamics. I will tell you that I use it less now because the pacemaker rate is a little higher. We still don't know how it's going to do long term. And quite frankly, when we came out with the Y annuloplasty from Bo-Yang, as opposed to a Nix or Manugian, where you often got one size bigger, and I can always get 3 sizes bigger, I'm more likely to do a valus pericardial valve now and just give them a good valve rather than do a rapid deployment valve. I don't have anything against them. I did about 100 of them. I don't use very many of them anymore. That's just a personal choice.
Okay, thank you.
Okay, thank you. So it's about the time to move to the next 2 topics. The 2 topics will be chaired by Dr. Wang Jian. Wang Jian is the vice superintendent of the second affiliate hospital, the Zhejiang University School of Medicine. So he's quite famous in the field of TAVR in China. So please, Dr. Wang Jian, can you chair the next 2 topics?
Okay, thank you, Professor Wei. Next speaker will be Dr. Pirelli. Dr. Pirelli is an associate professor of cardiothoracic surgery at Knox Hill Hospital at Northwell Health, New York. The title of his presentation is Aortic Stenosis and Systolic Heart Failure, WRF and AVR. While involved, the time is coming. I welcome you, Professor Pirelli.
Okay, can you see my screen?
Yes, it is very clear. Thank you.
Okay, perfect. So thank you very much for the invitation. I think we'll keep talking about basically lifetime management of aortic valve disease. These are my disclosures. So we know, as it was pointed out earlier, that the aortic valve disease is a pretty prevalent and common disease that appears and starts to be even more common in the mid-50s now. And life expectancies in the world all over, especially in industrialized countries, is increasing. So our vision is that we'll probably implant more TAVRs in younger patients than we ever did before. And if we think about placing a transcatheter or even any tissue valve in a younger patient, we need to think about the need of repeated procedures and further interventions. And as Dr. Popna pointed out, and Dr. Reardon also, we know that now we start to have good midterm to long-term data about transcatheter aortic valve. And especially if we go look at the Notion trial for self-expandable valve, we know that these valves work well. And there were actually no significant differences in the risk of all-cause mortality, stroke, and myocardial infarction, as well as the risk of bioprosthetic valve failure after 8 years of follow-up. So basically, when we have to deal with a young patient, we know that we have options. And I think it's not that easy to understand which is the best option for the patient, because nobody has the crystal ball. Nobody knows the real life expectancy of the patient, and nobody knows how actually long the valve will look like and will last for. But we have to predict that a young patient from the age of 55 to 70 might have and will probably have at least 2 procedures down the road. And I think the goal of us as physicians is to try to offer the patients a minimally invasive option and try to avoid as much as we can open heart surgery, especially if the patient is older and has more comorbidities. So it's always better and easier to operate and do an AVR on a young and healthy individual instead of in somebody that is older and sicker. And we all know as surgeons that explanting a transcatheter aortic valve is not always easy. It's actually a pretty challenging procedure, especially if the valve is well endothelialized and has been in for a long time or relatively long time. And sometimes in about 14% of the patients, we will need to do a more challenging and more radical procedure that implies a root replacement with implantation of the coronary. So it's not just removing the frame of the valve, it's replacing the whole root. Not in all patients, because sometimes we can find the right plane to just do an AVR, but in some patients that becomes a little difficult. And we know that if that's the case, an explantation of the transcatheter valve in a root replacement or even an aortic valve replacement in this category of patients has not the greatest outcome. Let's say that. It's not like a regular AVR in which we can give and provide good survival and outcomes to the patient. The patients are usually sicker, and usually their survival long-term is not as good. So honestly, I think the issue here is to try to understand the feasibility of a future procedure and try to predict what valve and what prosthesis, what size prosthesis, and based on the anatomy, we can put in order to avoid a surgical explant in the future and being able to do instead a TAV in TAV. And we'll see these more and more because now indications for TAVR have expanded, as we know, to younger and healthier patients. And these patients sooner or later will come back with a valve degeneration. We just need to make sure that we actually did the right choice in the first place, and now they're feasible for a valve-in-valve. And I think the role of imaging and CT scan, especially in every single patient with aortic valve disease, is now crucial and needs to be taken into consideration to better plan a lifetime management of aortic valve disease. And we know from even the VIVID registry and the valve in the TAV in SAV registries that one of the most important risks of a valve-in-valve in general is coronary obstruction and sinus sequestration. So basically what we do when we put a valve inside of a TAVR or another surgical valve, we'll create a cylinder. We'll create a cylinder, and sometimes if the STJ is narrow or is not that tall, we make the leaflets of the first TAVR valve to be completely pushed to the outside and opened and sealed to the STJ, so that there is basically no flow in the coronary ostia. And this is a dramatic and catastrophic complication if it happens in the operating room or in the hybrid room. And I think the best therapy for it is the prevention. So we need to know which patients are more at risk or more prone to have sinus sequestration and coronary obstruction, because probably those patients, actually not probably, but those patients will not be candidate for a valve-in-valve. So the combination of a low STJ and high TAVR valve commissure would definitely increase the risk of coronary obstruction. And there are several studies that are actually taking into consideration the baseline CT scan of patients with aortic valve disease to predict how many TAVRs procedures the patients could undergo in their lifetime. And for example, in this study that was published in Eurointervention not a long time ago, the aim and the goal of the authors was to simulate not one, but two TAVI procedures and to predict the risk of coronary obstruction. And actually, we can see that the results show that only 1/4 of the patient have favorable root anatomy for TAV in TAV. Almost a third require leaflet modification regardless of the first type of TAVR. And only 50% or less are feasible for redo TAVR if the first valve is a balloon expandable valve. So I would say that, again, more studies whose topic is the valve-in-valve are basically based on the measurement or CT measurement in order to predict the feasibility of the second procedure. And in this study, the post-TAVR CT of patients who underwent TAVR with balloon expandable and self-expandable valve were basically recorded, and the redo TAVR was defined as at higher risk for coronary obstruction due to sinus sequestration for two reasons. The first TAVR commissure level was above the STJ, and or if the distance between the TAVR valve and the STJ was less than 2%. And we can see that in both self-expandable and balloon expandable, but probably a little more for self-expandable valves, the patients were at risk for sinus sequestration, because at the end, the advantage of having a supraannular design for the Evolut platform that will most likely give longer durability to prosthesis has the counter effect of having higher commissures that can fall above the coronary ostia. Not only that, but also if the commissural alignment technique is not utilized during implantation of valves, even the basilica technique or any kind of leaflet modification or leaflet laceration technique that would allow coronary flow would be absolutely useless, because if the commissure of the TAVR valve will fall right in front of the coronary ostia, there is no point of lacerating the leaflet to allow coronary flow. So another issue, or another study actually looked at the easiness of infeasibility of coronary angiography right after transcatheter valve replacement, and for evaluation of the feasibility of a TAV-in-TAV procedure. And this was studied in 3 different prostheses. They were the Sapien, so intraannular balloon expandable design, Evolutar, and Accurate Neo. And what came out from this study was that the coronary angiography after TAV-in-TAV was defined unfeasible in almost a third of the patients. This situation appeared to be a little bit more common in patients with Evolut and Accurate Neo. On the contrary, the TAV-in-TAV was found more feasible in patients with an intraannular transcatheter aortic valve in place. And in almost 30% of the patient, the TAV-in-TAV was theoretically feasible, meaning that the VTA was greater than 2 millimeter, and that the coronary axis was or could be achieved from below the risk plane. Another study from Landes looked at, basically it was a registry of patients who underwent redo TAVR. They studied over 200 patients that had stage procedures because of basically valve degeneration, some valve failure. And what they showed was that the redo TAVR was for sure associated with symptomatic improvement at 30 days, and the symptomatologic benefit was persisting at 1 year. The aortic valve area and the gradients improved at follow-up, and actually the residual mean gradient after TAV-in-TAV was lower than the one that was found in the VIVID registry for TAV-in-SAV. And the differences in the residual gradient were significant when tested based on the baseline TAVR size, so smaller or bigger than 23 millimeters, but it was not different according to the valve type. So it didn't matter if it was a balloon expandable or self-expandable. And the median follow-up was almost 500 days, and the survival rate was pretty good, was 86% at 1 year. The only, I think, significant bias of this study was that all the patients who underwent redo TAVR were already selected of having low risk, of being a low risk for sinus sequestration based on pre-op CT scan. What can you do if you have high risk of coronary obstruction? You can use basilica technique. This is a again, an off-label procedure that is not that easy to perform, and it's also unclear if can be used to all kind of prostheses. And again, if there is misalignment between the commissures and the coronary osseous, the basilica will not make a difference. So we came up with a technique that we named surplus, so surgical resection of prosthetic valve leaflet under direct vision. There is a hybrid procedure, and I'll show you this case of a 70-year-old lady with systolic heart failure who underwent many years before a alternative access TAVR with a core valve 29 millimeter, and came back with degeneration of her prosthetic valve. And as you see, I think the echo will play in a second. Thicken by prosthetic valve immobile leaflets with some AI on Doppler. You can see the coronary height that is about 13 millimeters on both sides, and the wrist plane that if you see, it's above the ostium, the ostia of both the left main and the right coronary artery. So if you put a TAVR valve inside, you will create a cylinder that would seal at the STJ, excluding circulation to the coronaries. So this lady didn't have many options to go. We decided to approach the problem in a hybrid way. So we decided to resect the leaflets only of the core valve, leaving the frame in place, and implanting a sapien valve under direct vision inside of the core valve with alignment of the commissures of the two prostheses. And as you can see, the surgical picture shows the alignment of the S3 commissures with the native commissures and with the core valve commissures, and the inflows of the two transcatheter valves aligned perfectly, as you can see in panel E. On TEE intraop, you could see also flow in the left main coronary artery. So this was a successful procedure done in a different way, still with surgery, with sternotomy, on cardiopulmonary bypass. But again, it spared an aortic root replacement, and it made the procedure, the valve, the TAVI TAV much faster with a very short clamp time. And this is the post-cardiopulmonary bypass echo. So in conclusion, the TAVI TAV will become more common as an option for degenerated transcatheter heart valves. Imaging, meaning especially CTA, has a crucial role in the selection of patients. In good candidates in which we know the risk of sinus sequestration is low, TAVI TAV is safe, reproducible, has good hemodynamics result and acceptable short-term results and outcome. And more data is, of course, needed, and long-term results are still unknown. And I thank you very much for, again, the opportunity to talk today. And I'm open to questions.
Okay, thank you, Dr. Parelli, for your excellent lecture, which is very informative, educational, especially focusing on how to do a proper valve-in-valve procedure, how to select the proper device, and how to have a good thinking about preventing the obstruction of coronary artery. Thank you so much for your wonderful presentation. So any more questions from our audience?
Dr. Pirari, may I ask the technical question about your the final case? I mean, when you take off the pericardium tissue of the core valve first, and then you deploy the ADAPT sapien valve within the core valve. So did you add an additional fixed stitch when you deploy the ADAPT S3 valve, or just let it open by usual manner? Thank you.
So we basically approached the problem like it was a regular surgical AVR. So once you open the aorta, you have your core valve in your face. Instead of explanting the whole frame, I decided to just resect the leaflets with a Metzenbaum scissors. Once that is done, basically you're ready to put a wire that can be a confida or even a regular J wire, because you don't need much support, into the left ventricle. And then with the commander delivery system, you advance under direct vision your sapien 3. You will still need fluoroscopy because it will be very hard. The angulation will be not so great to figure out what depth the inflows have to be deployed. So I think the direct vision helps you in aligning the commissures, but the fluoroscopy will help you in aligning the inflows of your valves. And once you go in there, you advance your valve, you find the right position and right depth, you deploy, and you're done with the case. You close the aorta and you come off bypass. So instead of, again, doing a root replacement or even trying to find a plane to explant the TAVR valve, you just resect like you were doing for an AVR, and you just deploy. The clamp time should not be longer than 20 minutes.
Well,
Okay,
I totally
see.
agree with yes. Yes, I think that since this kind of a technique will reduce your pump time and reduce the risk of the open surgery. Yeah, totally agree with you.
And we are actually, we started a registry, and I'll be happy to share all the informations with all of you that are interested. And we're trying to collect data and actually show that this technique might give better outcomes compared to the root replacement, the TAVR explant and root replacement. I think this will definitely shorten the pump time, and that from the explant TAVR registry is one of the main predictors of a poor outcome.
Yeah,
Hi,
it's
Professor.
really a clever way to redo the TAVR in TAVR in such a case. How about your opinion if we treat the TAVR in TAVR? How about the cerebral protection device you routinely use in this kind of patients?
So that's a good question. So we are still unsure what cases the Sentinel device or the cerebral protection device should be used into, but we believe that in cases of valve-in-valve, as well as in cases of bicuspid valve, in which we are aware that the risk of stroke is higher than regular elective TAVR in native valves, probably the cerebral protection device should be used. So I would say TAV in TAV or TAV in SAV and bicuspid valves are the cases in which we routinely use cerebral protection devices.
Thank you.
In regular TAVRs, probably depends also on the amount and location of the calcifications, but we're not very keen in spreading the use of the cerebral protection device that much. But in those two categories of patients, valve-in-valve and bicuspid valve, we feel that the risk of stroke is higher, and we can decrease it with the appropriate tools.
Thank you.
Hi, Dr. Pirelli. I have a short question. As you know, we, especially for self-expanding device, we emphasize a lot about the commercial alignment to prevent the obstruction of coronary artery. So how can we do further? We can step up from the commercial alignment to the coronary alignment. So just now in your presentation, you emphasized a lot. Would you give us some summarization how to do? Maybe someday we can realize the coronary alignment.
I think the most difficult but most significant part is, I think, planning the procedure with a pre-TAVR CT scan. And you don't need to go to the operating room and trying to figure out how to position the valve. If you have a good, again, plan beforehand. So we play a lot with the CT scan pre-op. We will go to the operating room that we know already the angles of deployment. And I think, if you are able to interpret and to read the CT scan in a more efficient way, and you know where the coronary ostia are, you know already your angles, I think then it becomes pretty easy to not to obstruct. And I think the commissural alignment should be coupled also with a virtual valve implantation that will also predict and tell you what kind of procedure you will be able to do in the future. And I think it also depends on several measurements that you need to be aware of, the size and the diameter of the sinotubular junction, or how the coronaries, what's the height of the coronaries. If the coronaries origin in the natural and regular place, or they are displaced, again, how large are the sinuses. All those components, I think, will help you in planning and deploying actually the valve when you are in the operating room. So it's a combination of maneuvers, but I think the most important thing is planning the procedure, knowing what the anatomy is.
So what do you think about the future of computer simulator? You know, until now, we don't have the computer simulator good enough for predicting, especially for guiding a procedure case by case. So what do you think the future of computer simulator?
I think we as interventionalists or surgeon have to be dependent now on good imaging and good prototypes. Surgeons can have the luxury to see what they do and maybe correct their action based on surprises that they find in the operating room. This is not a luxury that the structural physician has. So everything is dependent on what we see and what we plan beforehand. And I think there are several prototypes that actually are pretty good at the moment for predicting and assessing the root anatomy. And also something else that we sometimes use in challenging cases is the 3D printing. 3D printing can give you the option of bench simulating procedures and try to see if things work as you plan before. But I think overall the concept is even the prototypes and the software will improve and will be better and better, and we will be more dependent on the imaging than before, for sure.
Thank you, Dr. Pirelli. Because of time limitation, Professor Wei, maybe we need to move to the next session. Thank you so much for your excellent presentation and wonderful answers. Thank you so much.
Sorry. Yes. Since it's already 10 o'clock and the second session should be started, then well, I'm so sorry to Dr. Pirelli that probably your last topic cannot be conducted. So well, maybe next time when I would like to invite you again for for you to talk on the last topic. So I'm so sorry that we have to stop the session, and the next session should be open. Okay, so we will move to the next session. Dr. Tsai Chien-Sung. Okay. Thank you, everybody. For this,
bye. See you next time.
See you next time. Thank you.
Good morning, everyone.
Hi, Vinny. Good to see you.
Good to see you.
Good to see you, Kentaro. Good to see you.
Good.
Hi, Dr. Park.
Good to see you.
Good morning, Dr. Hayashida. Good morning. Hi.
Good
Dr.
morning.
Bapat. Good morning. Hey.
Nice to see everybody.
Thank you.
So can I have a request? I'm in India for an in-person meeting, and I have a talk there in another half an hour time. So I have to chair a session. So if possible, if I can just switch the order and go second or something like that, let me know. Thank you.
It is absolutely okay.
And Dr. Professor
Professor Tsao, you can be in charge first because my screen has some problem. I cannot show my photos. Okay.
Okay.
Sorry.
So good morning, everyone, and welcome to the Taipei VAF. The next session is TAVI Mitral. We have moderators, Dr. Tsai Chien-Sung, Professor Tsai, and myself, and Dr. Duk-Woo Park from Hsien Medical University, and Dr. Kentaro Hayashida. And we also have a panelist, Dr. Vinayak Bapat, and Dr. Xiangbin from China, and Dr. Tsao also from China, and Dr. Jung-Cheng, Dr. Zhang from Taiwan. So I would like to introduce the first speaker, Dr. Kentaro Hayashida. Dr. Hayashida is from Keio University and Keio Department of Cardiology. I think he is a very well-renowned TAVR expert. Today, his topic is TAVI in small annulus. Dr. Hayashida, please. Thank you.
Thank you very much for your kind introduction. And can you see my slide?
Yeah, we can see your slides. I can hear you very well.
Yeah, thank you so much. And today I'd like to talk about the TAVI in small annulus. And this is my disclosure. And what are the challenges in TAVI in small annulus? Because of the risk of prosthesis patient mismatch. And indeed, severe prosthesis patient mismatch is associated with increased mortality. And we also have the many patients with small annulus in our country. So therefore, this issue is quite important to us, especially in Asia. And what is prosthesis patient mismatch? And the definition is defective orifice area of the implanted prosthesis is too small in relation to the patient body size and resulting in abnormally high postoperative gradients. If the patient have index EOA smaller than 0.85, they are classified as moderate PPM. If the patient have the indexed effective orifice area lower than 0.65, they're classified as severe prosthesis patient mismatch. And if you look at the literature from the experience of surgery, and the total incidence of PPM 44%, and moderate PPM was noted in 34%, and severe PPM is noted in 10%. And the incidence of PPM ranged from 10 to 80%, depending on the literature. And the patient undergoing surgical ABR in between 1981 to 2008 are included in this study. And the question is, does PPM affect survival after surgical ABR? If the patient have severe PPM, even though the ejection fraction is good, it might impact the mortality. And if the patient have the low ejection fraction, not only severe, but also moderate PPM might impact prognosis of the patient. Therefore, we also need to be careful to take into account the severe PPM, moderate PPM, and the ejection fraction. And let's look at the literature for the in the TAVI field. And the left study demonstrated the severe the PPM in the small annulus. And TAVI demonstrated the lower incidence of severe PPM in the patient with small annulus lower than 20 millimeter. And the right study demonstrated very huge cohort of the TVT registry and in American patient. And the severe prosthesis patient mismatch is noted in 12%. Therefore, even with TAVI procedure, we still have the substantial amount of severe PPM in this cohort. And this choice extended registry demonstrated the difference in terms of the incidence of severe PPM between SAPIEN 3 and Evolut R and Puro. And Evolut 3s had a lower incidence of the PPM compared to SAPIEN 3 due to the super annular nature of the biprosthesis. And this study is quite important study conducted by my friend, Dr. D.W. Park. And they compared non-Asian and Asian patient. And they clearly demonstrated that the incidence of PPM is lower compared to the Western people. And maybe because of the body surface area, maybe we can ask Dr. D.W. Park later. And we also conducted the similar study using our Ocean TAVI registry. And moderate PPM is noted in 9%. And notably, severe prosthesis patient mismatch is noted in only 0.7%. That is much lower than that of the TVT registry. And we presume that the reason should be derived from the lower body surface area and the less obese patient in Japanese patient compared to United States. So sorry for the American people, but we don't have that many patients with obese patient. And this is the data from our Ocean TAVI registry. And if you look at the breakdown of the bioprosthesis size, and the 20 millimeter SAPIEN 3 device is used in 8% in a cohort, and 23 millimeter SAPIEN 3 device is not used in more than half of the patient. And if you look at the breakdown for the Evolut R, 23 millimeter device is used in 10%, and 26 millimeter device is used in almost half of the patient. That is quite smaller than that of the Western country. And this is the hemodynamic data. And if you look at the data of the 20 millimeter SAPIEN 3, and it represent a mean pressure gradient of 15 or 17 during the 1 year follow-up, that means that it doesn't provide that high pressure gradient in our Japanese patient. And this is a comparison between Evolut and SAPIEN 3. And Evolut had a higher effective orifice area as well as the lower mean pressure gradient compared to the SAPIEN 3 device. And we also compared the clinical outcome, and the device success rate is similar, and the new pacemaker was surprisingly similar, and there was a trend towards a higher incidence of moderate PPM in SAPIEN 3 group. However, there was no significant difference in severe PPM between two groups. Therefore, even with the very small SAPIEN 3 device, as far as the patient body size is not that big, it doesn't reach to the severe PPM. And this is the mortality. There was no significant difference between two devices. And maybe some of the Chinese friends can read these Chinese letters. And we have 23 members in our Ocean SSD family, not only TAVI, but also including the mitral and appendage closure. I would like to propose some case example. And this is a case 192 years old female, and she has a really small annular size, like 270 millimeter square. And the LVOT size is much smaller, and the sinus of Sava is also very small. And we chose 23 millimeter Evolut R device, and the implantation was successful, and the peak flow velocity was decreased from 6.6 to 2.6, and with mild PVL and no AV block. And this is a case 288 years old female, and she also had very low stature, like 145 centimeter with body surface area of 1.2. And she also developed very severe aortic stenosis with mean pressure gradient 87 millimeter mercury. And STS score is quite high. And if you look at the CT data, and the annular size is quite small, 252, and the LVOT size is much smaller, and the SOB is like 25 millimeter, and we chose the Hsien-Li device, the 20 millimeter. And this is our old experience, and we implanted the devices very low. And we also conducted the post-dilatation like this. And in this case, the peak flow velocity decreased from 5.9 to 2.2, and the mean pressure gradient was also decreased to 11. And effective orifice, index effective orifice area is achieved like 0.97. In no V blocked until discharge at day 4. Therefore, and if we think about the body size of the patient and the both supraannular device and balloon expandable device can be used in the small annulus. And this is quite interesting study about the balloon versus self-expanding valve system for failed surgical aortic valve process. The name is Lighting Trial, conducted by Dr. Joseph Raducabo. And I was lucky to make some editorial comment. And if you look at the difference between catheter measurement and echo measurement in terms of the gradient, and there was no significant, not a big difference in Evolut. And however, there was a really big difference in 7.3. And this is called the discordance caused by the Bernoulli equation. And therefore, maybe we need to establish some criteria to evaluate the prosthesis patient mismatch, not using echo, but also using the simultaneous measurement. And we also need to take into account the coronary access, and only one valve is okay, but if we put the two tall valves, it might impact the future coronary access. And in conclusion, ladies and gentlemen, a severe prosthesis patient mismatch should be avoided for patients with small native annulus. Not only annulus, but also the body size and coronary access and other factors should be taken into account for optimal device selection. And thank you so much for your attention.
So thank you, Dr. Hayashida, for your excellent talk. And is there any question or comment from our panel?
So I wanted to ask Kentaro, is how common it is in your practice to see Evolut R23 and Sapien 20 in percentage?
Thank you so much. Actually, we use the Sapien 320 millimeter in the 10% of the Sapien use. and 15% or something with the 23 millimeter absolute R. And I presume that that is much higher than that of the experience in Western countries.
Thank you.
Thanks, Vinny.
So can I ask one more question then? Because
sure.
Everybody's quiet. I'm always curious because I think sometimes the gap between 20 sapien and 23 is quite wide. And maybe we will benefit if it was a 21 size. Yes. And I saw the case you presented, you put some extra volume in it. And we have learned a lot from both Asan Medical and Japan experience about, slightly underinflated or overinflated with CT calcium, etc. So do you think we need a valve which is like 21 maybe, so that we have less issues with the balloon expandable valve?
Yeah, I totally agree with you that the we need 21 instead of 20 because the decrease rate from 23 to 20 is, as you mentioned, too big. And compared to from 26 to 23. So maybe, Vinny, you can talk with editors to make 20 for us.
Thank you.
Thank you.
Dr. Park, would you like to comment on the ppm difference in Asian and Western people in your trial?
Yes, so in our registry, it's a TAVR registry, including Asan Medical Center, also Stanford and Northwestern in the Western country. In the overall, the severe and moderate form PPM proportion was much lower in Asian population. So, although the clinical impact of a PPM, we don't know, I think we require more long-term and the big size data.
Okay, thank you. So because the time limited, so I would like to move on the second talk. So the next speaker would be Dr. Vinayak Bapat. Dr. Bapat is a surgical director, mitral and tricuspid therapeutics at the New York Presbyterian and Columbia University Medical Center. And today his talk is TAVI Explanation. Dr. Bapat, please. Thank you.
Thank you very much, Dr. Tsao, for introduction. I've recently moved to Minneapolis, but Columbia New York Presbyterian is still close to my heart and close friends. Thank you very much. I think, sorry to jump the order of the talk, but what Kentaro said was really important in the talk, that it's going to happen that if we implant a TAVR, there's a possibility that these valves are going to degenerate, and then some valves we can't do TAVR in TAVR because of coronary access, issue of PPM also, because if it's a small valve to start with, you can't put a small valve inside that. So I'm just going to give you a quick summary of what's actually happening. So the best case scenario, we may say that a patient will have TAVI for 10 years. In United States and EU, the average age we are implanting, or the age we are implanting TAVI is 65 plus now. But the life expectancy is going to be high in these patients. So these patients are going to come back with failure. We also need to understand that, one valve is different than another valve. And especially in US now, we've got 3 valves or 4. In Europe, there are already 9 TAVI devices. And in Asia, there are more than that. So these designs are going to interact very different with each anatomy as well. This is just one of our cases, which just shows what happens. This is a 75-year-old patient, really no issue, straightforward TAVI candidate. The analysis shows here that the size was great. We did a SAPIEN 3, no issues at all, and the patient was doing very well. Then in 2019, we found that after many years, of course, that the patient had gradients and some leak as well, and patient became symptomatic. Now, this was most likely because of structural valve deterioration. We also contemplated whether patient had HALT before, which had not got noticed. But essentially, what do we do? So we gave her some anticoagulation, but it didn't improve the gradients. Patient was very symptomatic. So now we have only two options. Is one, can we do a TAVR in this patient, or we should explant a TAVR and implant a surgical valve? Rightly so, we need to understand a lot about in which patients you can do TAVR. There are many things you have to consider, including height of the device, ST junction interaction, neoskirt height, coronary access, coronary flow, etc. But it can also happen that this patient was not suitable because we felt it will lead to sinus sequestration. Now, there are some important considerations when you are explanting these valves. If they are small valves, so I simply divide them into valves which are shorter in height and valves which are taller in height. The shorter height, which are mainly balloon expandable, to be honest, one thing happens is, although it's balloon expandable and short, we when we expand it. So the interaction with the annulus is, so it can cause annular damage, mitral leaflet damage, and conduction tissue damage when you are trying to explant the device. I think if you do that not carefully, it can lead to a full-blown root replacement. This is just a case, one of the techniques. This is a video sent by a friend in Italy. You can see that although the advantage is it's a short profile valve, it doesn't come out very easily as people think, because people think SAPIEN is a small valve, so I can just pull it out. It's really embedded. So here what they're doing is they're slowly and carefully separating the device from the native leaflets. You can see he's holding with the forceps native leaflets, which are pushed outside. And then he's developing a plane slowly and at times cutting the struts so as to just try and compress it and make it easy to collapse it in the center. And this is exactly what he's doing now. He's slowly and meticulously doing this, taking his own time. There is no need to rush these procedures because it maximum takes 5 minutes to take it out. And you can see now they've developed a nice plane. And then once you develop the plane, you just go circumferentially around and then collapse the valve inside the lumen and not push outside that much, because you can, now he's in the AV node area. And then for the sake of time, I'm just going to push this a bit forward. And you can see now he's cutting the pannus, which grows in the LVOT, and then remove all the leaflets as well. So this is one technique of doing the explant. The other technique is, I call it crocodile roll. This is a very interesting technique. Is what you do is, you essentially open the aorta, identify the SAPIEN stent, and if it is embedded sometimes in the wall, what you do is you cut the SAPIEN frame right in the middle. You just go from top to bottom, and once you cut it, you hold one edge of the SAPIEN, as you can see here, and then simply roll the forceps. So it kind of twists the valve on the forceps and then take it out. So this is again one of the good techniques to keep in hand. Again, I'm just going to show you at the end of it, he has managed to compress the valve and then gently take it out. You have to be very careful because you can easily damage the mitral leaflet or the annulus and also the conduction tissue. I mean, I have seen perforations in the membranous septum because of this maneuver. And as you can see here, the valve was taken out very nicely. Once the valve is out, you can do a regular aortic valve replacement. This is an acute case where I was called because of some issue. What I like to do is I like to just collapse the valve inside. As you can see here, you just collapse it like a pyramid and then keep collapsing it, and then you can just take it out. Some of you may know that direct flow was a valve which was implanted in Europe quite a lot. This was a valve which is forgotten now. Not many people remember it. But now we are seeing these patients coming back. And this is very interesting valve because it has a different frame design. And then at the end of it, there was a polymer injected in those two rings. The one ring in the LVOT and the other ring in the aorta. So when these valves come out, they look very scary. So I'm just going to show you, this is one of the cases which was sent from Munich by Professor Lange's group to me. And you can see how embedded this valve is. And I'm pretty sure there are some lotus valves which are going to come back now, and they are going to be very difficult to explant surgically as well. And this, they had to really cut it piecemeal to take it out. So all I'm saying is that meticulousness is really important when we are removing these valves. What about tall valves like Evolutar, Accurate, Venus, etc.? These valves not only interact with the annulus, but also interact with the ascending aorta. And I think that is very important that we understand the differences between the two. We did a live case last year at TCT to demonstrate the technique of removing these valves without causing any damage. And I think we have been successful at present after nearly 5 years of explanting valves not to lead to any root replacement. This is one of my cases. This is the Evolutar. This was luckily after 2 years, but we have removed Evolutar up to now 6 years. This is one of my residents, actually, chief residents taking the valve out. First thing we do is we look at where the coronaries are. We also open the leaflets and look at the LVOT. So we know how deep the valve is implanted, because it's very important that we don't damage the mitral valve and conduction tissue. And once we see that, what we do is we start developing a plane between the top of the valve and the aorta. And you can see here, this is just after 2 years. So imagine after 5 years, there's a false membrane which embeds the valve into the aorta. And if I rush into this, I'm going to cause a hole in the aorta. So what I do is I always, this is where I'm telling my resident not to use the forceps, is use a spatula to create a nice plane. And you will see that in a minute, that what he's using is a coronary endarterectomy spatula, and then gently remove the top of this valve from the aorta. There is always a pseudoendothelium. And then we are pushing the valve inside. This is a nitinol frame, so it's beautifully pushable inside. You can bend it inside, there's no problem. We sometimes use cold slush, but I have not found it very useful in these cases. So once we separate it from the top, and this is very important technique to be patient, and we are teaching these techniques to a lot of surgeons now, because I think TAVR explant is something they need to learn as well. So once you separate it out, the top structure, then we assess the bottom part. We are just putting some cold slush here. And now we will separate the valve from the native aortic leaflets. You can see how this valve is pushed in. And the good thing is about nitinol valves is, as again the Sapien, you saw how difficult it was to bend inside. This is actually a very easy step now, because all you have to do is keep separating and keep pushing the valve inside. And once you do that, like he is doing here, once the entire valve is separated, you just gently pull it out. And I just want to show you how the valve is pulled out. In this case, we could pull it out straight away. But in some cases, like the one I showed at TCT, what we do is we put 4 sutures at the top and just snare it inside a tube to make it easy to explant. So you can see that the explant is possible. I'm just showing here how the panus is grown inside and outside the stent frame. Gilbert Tang here, a close friend, has led these registries, TAVR Explant International Registries. And this registry has, many patients now. And, we have learned a lot. Like TAVR explant is not easy, but it's not difficult either. And I think we just need to make sure our technique is good. And then we can offer this to many, many patients and do only aortic valve replacement and not do a big operation like a root replacement, which will increase the mortality. Thank you very much.
Thank you, Dr. Papa, for your excellent talk. I think valve explantation would be more frequent in the future. But I think it's not a very simple procedure. It could be very complicated. Yeah. Any question from our panel or any comments? Dr. Tsai Chien-Sung, you are a very good surgeon. Do you have any comments?
Thank you, Dr. Baba. Very excellent talk. Actually, in our hospital, well, now we don't have any experience or experimentation of TAVR valve. So, but my question is, what's the tip when you take out the processes of ADAPT valve? What's the tips? You don't injure the ADAPT wall or don't injure the annulus. What's the tips from your experience?
Yeah, it's a very good question. And in the early stage, I used to rush to take it out, and that's what used to cause injury. Now I slowly. So for the expandable valve, I bend. For a self-expandable valve, you tend to see thrombus in the left atrium, and then once you remove the peel, it's very easy to take it out, and you don't damage the aorta. If you have to replace the ascending aorta, it's not a big deal, but root replacement is a big problem.
Okay, thank you.
May I ask a question?
Yes, please.
Okay, thank you very much, Vinny, for your fantastic presentation always. And I want to ask a question. And some patients require root replacement to explant the total valve, and some patient doesn't require root replacements. Which type of patient do you think you need root replacement for the TAVR explant?
So the patients actually where we have done root replacement is the one with endocarditis, because the endocarditis has spread into the annulus. And the second ones which has happened is when there is sinus sequestration already so much that the valve is embedded in a very bad way. So technically, if it's an inexperienced surgeon doing it, and I don't mean inexperienced as inexperienced surgeon, but somebody who doesn't know the TAVR explant yet, you can damage the sinus or you can make a hole in the mitral. And I think we just need to share our techniques with a larger group so that it becomes easier for us to do these procedures.
Thank you so much.
Thank you.
Dr. Xu, please.
Yes. In the previous session, Dr. Jeffrey Pama have shown us the case that he excisioned the leaflet or pericardium of the core valve and then do the hybrid procedure to implant the SAPIEN 3 inside the stem frame of the core valve. So how about your opinion in such kind of the procedure?
I will only do that if the patient is so sick that I have to do the procedure very quickly. Because to be honest, if I'm opening the chest and putting the patient on bypass, and I might as well take the valve out and do it. But you are really spot on, because if it's a good size core valve to start with, you can remove the leaflets and put a SAPIEN valve inside. We have done that for the mitral as well. 2 PCTs ago, I showed a case where we did a mitral valve and there was a LVOT obstruction issue, a very sick patient. So I didn't want to spend long time on bypass to remove the mitral and then implant a new one. She had a big size mitral valve. Now what we did was we just cut the leaflets and we cut the frame to surgically fracture the valve and then put a 29S3 inside. And it's been 1.5 years now. We are following up the patient. So that's a great suggestion. I think it's very important that you understand if it's embedded heavily, it's a sick patient. Don't try to take it out. But it has to be a good size valve to start with. Because all valves to start with, and what you don't is open the chest and have a problem again. I rather do a 19 surgical valve, and then you can do a valve in valve later again at few years time.
Yes, thank you. Case by case discussion and lifetime management. Thank you.
May I, Dr. Parker?
Yeah.
I think it's a great idea for us to share of the reoperation for these TAVR patients. I'm just out a question about the mitral valve. Is there any possibility for us when we perform the TAVI, if we put too deep, there's some damage to the mitral valve? So when we just remove out this TAVI valve, is there a possibility for us just when we damage the mitral valve, we need to do the mitral valve repair or replacement? Dr. Patrick, please. Thank you.
So I think there are cases reported that if you implant Evolut R very deep, there is anterior mitral perforation. So there is two scenarios where if I have to operate that patient, I may have to take the core valve or Evolut R out and then replace both the valves. It's very important. Many times when there is a sapien valve also in the aortic and I have to do a mitral procedure, when we surgeons, we retract the aorta, you can damage the valve. So you have to just keep that in mind also. So those are some other indications for TAVR explant.
Okay, thank you. Thank you so much.
So Dr. Bapat, do you have experience to explain the patient after valve in valve?
Yes, unfortunately, yes. So we have done explants for both aortic valve in valves and mitral valve in valves also. The good thing, if there is a good thing about valve in valve is the TAVR device doesn't come in contact with the annulus because it's inside the surgical frame. So to be honest, it's actually simpler in terms of taking it out. So you just get the TAVR device out first. The only difference is in the mitral valve in valve. In the mitral valve, we flare the sapien like this, so that in LV. So it's very, very important that when the surgeons cut out the sutures of the surgical mitral, not to. So what we do is in the mitral valve in valve, I've done now 3 cases. I always crush the sapien, take it out first, and then I remove the surgical valve. It's just better because you don't damage anything while pulling it out.
Okay, thank you. If there's no any questions, I would like to move on the next talk. Thank you, Dr. Bapat, for your excellent talk.
Thank you very much, and I'm sorry I'm going to miss the rest of the session. And have a good meeting. Bye-bye.
Thank you. Thank you. So the next speaker is Dr. Dida Park. Dr. Park is from Assam Medical University, Korea, and he is also the co-chair of TCT-AP and deputy editor of JACC Asia. And he is also a very famous interventional cardiologist and a very well-renowned TAVR expert as well. And today his topic is deep dive lecture on ADAPT-TAVR trial, optimal antithrombotic strategy after TAVR. Dr. Park, please.
Okay, thank you. So thank you inviting this wonderful. I'm going to talking about the recent presented ADAPT-TAVR trial edoxaban versus DAPT for leaflet thrombosis and cerebral thromboembolism after TAVR procedure. And this trial is funded in Daiichi Sankyo. So, and the subclinical leaflet thrombosis after TAVR, there are many publications, what is known, what is unknown. And we know leaflet thrombosis is not rare, it's common, 10% up to 30%. And we know oral anticoagulation can reduce the leaflet thrombosis based on many observational data. However, we still don't know there is a direct causal relationship of leaflet thrombosis with the cerebral thromboembolism. Finally, we don't know oral anticoagulation can reduce leaflet thrombosis related to cerebral thromboembolism. That is the rationale of our TAVR trial. So, addition before and the 10-30% leaflet thrombosis and the several studies shows could be associated increased risk of cerebral thromboembolism, stroke, or TIA. Also, some available random trial tested NOAC-based strategy is more effective than conventional strategy for prevention of replete thrombosis or thromboembolic risk in patients with or without oral anticoagulation indication. So our ADAPT-TAVR has two important objectives. One is investigate the effect of edoxaban compared to DAPT for prevention of replete thrombosis and potential risk of cerebral thromboembolism, neurological or neurocognitive dysfunction in patients without OH indication. Secondary objective is to determine the causal association of replete thrombosis with cerebral thromboembolism and neurological neurocognitive dysfunction. So trial is targeted to include 220 patients without OH indication. Randomization, two groups is NOAC versus DAPT. DAPT was a default recommended strategy at initiation of this trial. We have a mandatory evaluation of 6 months cardiac CT and the serial MRI and serial neurological function test. So our indication is symptomatic AS has successful TAVR. Key exclusion is any established indication for anticoagulation like atrial fibrillation or any absolute indication for DAPT like ACS or recent PCI. Also, our study is required CT imaging mandatory and severe renal insufficiency patient was excluded. Primary and 6 months follow-up CT four-dimensional volume rendered CT scan. Secondary outcome is the presence and number and volume of a new cerebral lesion on brain MRI and serial change of neurological neurocognitive assessment, NIH stroke scale, modified Rankin scale, Montreal cognitive assessment. Also evaluated the safety and efficacy and echocardiographic parameter. So our study included 5 centers in 3 countries, the 2 centers in Korea, and the 2 centers in Taipei, and 1 center in Hong Kong. And we used the independent COREB ASAN imaging matrix, imaging COREB, and the expert and neurological imagingist and the expert and the cardiac imagingist analyzed the whole imaging. So, and the sample size was based on the NOAC, the 3% is replete thrombosis, and the 15% in DAPT was based on SAVORY and recovery registry, and on the basis 80% statistical power, we assumed the 220 patients. We performed the main analysis is ITT and PP analysis. Our sample size also in the mid to demonstrate edoxaban would provide a 30% reduction number of new cerebral region on MRI. So, and our trial evaluated 69 patients, and finally 235 patients was randomization, and 115 in the edoxaban group, 120 in the DAPT group, and after exclusion of informed consent withdrawal during index hospitalization, finally 111 and 118 is included the ITT population. Also, and the overall patient with exclusion drug crossover, also less drug compliance less than 80%, 101 patient, 111 patient included PP protocol. So, and this is baseline characteristics, edoxaban versus DAPT group, mean age is 80, male is 40%, SDS mean risk score 3.1, 3.5, relatively low risk population, and on the basis of dose reduction criteria on edoxaban, and the use of low dose edoxaban is used 61% in edoxaban group, 40% used the full dose edoxaban, and the valve type is 90% balloon expandable valve, and the most of the cases conducted in the med anesthesia, transmural is 99%. So, and this is the completeness of imaging and neurological assessment, and the cardiac CT scan at 6 months performed 96%, brain MRI baseline performed immediate first TAVR, also 6 months follow-up. Overall, is a serial is conducted in 96%, NIH stroke scale 94%, modified Rankin scale 94%, Montreal cognitive dysfunction was measured 94%. So primary endpoint at 6 months for the CT scan in ITT population. DAPT group 18.4%, edoxaban group 9.8%. Risk difference is 8.5. However, p-value was a borderline 0.076. And in PP population, 9.1%, 9.1%, and the p-value was statistically significant. However, our trial was a random trial in the ITT should be considered first priority, and this interpretation in PP population should be interpreted in provisional. So, and the reduced leaflet motion, grade 3, 2.9%, 7.3%, in PP group 3.0%, 7.6%, is that there is no instance of a trend. And the interesting finding is MRI endpoint in ITT population, presence of a new cerebral region in serial MRI, and observed in 25% in edoxaban. That is 20%, absolutely no difference at all. Median number of total new region, median volume of total new region, absolutely no difference between two groups. Another important secondary outcome is the worsening of NIH stroke scale is found 5.0%. In the DAPT group is 3.7%, no difference at all. Worsening of a modified ranking scale is no difference. Worsening of a Montreal cognitive assessment is 30%, 22%, absolutely no difference. Another key secondary of our trial, we tried to evaluate the severity of the whole leaflet thrombosis, also extent of a new region on brain MRI. We evaluate the three different types in DWI, FLAIR, and GRI imaging. However, we didn't find any statistical significant association between severity of whole and the new cerebral region on serial brain MRI. This finding also consistent in the halt severity and decline of neurological assessment, NIH stroke scale, modified ranking scale, MoCA, absolutely no any correlation between two the observed phenomena. Clinical outcome, since our trial is the relative low number of patients, is overall event is quite low. Death is 2.7%, 1.7%. Stroke is 1.8, 1.7, and the MRI is lower, and the systemic thromboembolism is 2 patients, 0 patient. Overall bleeding event occurred 11.7%, 12.7%. There is no difference. Minor, major, life-threatening bleeding, also no difference at all. So, and limitation is our trial, open trial, potentially subject to attainment bias. Our trial that surrogate imaging endpoint, thus our study was underpowered to detect relevant difference in outcome. Follow-up period is relatively short, and the long-term effect of leaflet thrombosis on variable durability is unknown. Our finding cannot be directly applied in patients with OH indication like active patient. In conclusion, overall instance of leaflet thrombosis CT scan is less frequent, 9-point difference, risk ratio 0.53 with edoxaban therapy than with the DAPT. Although we did not reach statistical significance, overall new cerebral thromboembolism, brain MRI, new development of neurological, neurocognitive dysfunction, not difference at all. There is no causal association of leaflet thrombosis with a temporal related change of new cerebral thromboembolism and neurological endpoint. And this is published in Circulation simultaneously. Also, we remind that this is the Galileo trial. During Korea is written Dr. Rick Nishimura and David Holmes in the Mayo Clinic. After report of the Galileo trial, there was some discordant finding. Our initial inception, Galileo trial will succeed to reduce the leaflet thrombosis as well as overall clinical outcome. There is a discordant finding. Also, Dr. Nishimura remarked the CAST trial. This is done nearly 30 years ago. And the CAST trial, there is a misconception on ventricular premature beat after MI. And 30 years ago, and the VPC is RNT phenomenon could be some lesser in patient. And at the time, there is some trial to reduce the VPC using anti-arrhythmic agent. that could be considered VPC risk factor, sudden death, and cardiac death after MI. This is deja vu on replete thrombosis after TAVR. So this is a cast trial done 30 years ago, and randomization, placebo standard care versus active anti-arrhythmic drug. This overall clinical outcome was statistically significantly poor with the active treatment of anti-arrhythmic agent. That was confirmed also Galileo trial and some consecutive trial. I think the replete thrombosis problem clinically not much problematic, and there was some Wei-Hsian vein phenomenon. If the clinically significant, if you change the anticoagulation, we can resolve easily. So, and the clinical implication, this is my last slide. Subclinical replete thrombosis has not been proven to affect clinical outcome for patient TAVR. And this imaging phenomenon should not dictate routine antithrombotic strategy for its prevention at the TAVR. The absence of evidence temporal-related adverse clinical event, this imaging detected replete thrombosis does not support routine imaging screening test for detection this phenomenon at the TAVR. Also, imaging-guided antithrombotic strategy in case without hemodynamic or clinical significance. Thank you for your attention.
Thank you, Dr. Parr, for your excellent talk to compare the DAPT and NOAC treatment after the TAVR patients. And any question or comment from our panelists?
Thank you for Dr. Park's excellent talk.
May I just ask a question for the Dr. Parker?
Yeah.
Okay.
Please.
Yeah, I just wonder, is there any possibilities for us to revaluation the warfarins for the anticoagulation? We can still use the warfarin for the anticoagulation. Thank you.
So there is some loss of connection and the internet. Is you mean the warfarin?
Yes, yeah, we are surgeons, so we still like the warfarin. So
absolutely, so, you know, so and the warfarin is the guideline recommendation to be, and nowadays we just use warfarin comparator in patient with you know, the atrial fibrillation like Envisage TAVI trial. Also, the Atlantis trial used the comparator warfarin, but in the TAVR case, and we don't use the warfarin, but I think the remaining RCT does not evaluate the warfarin after TAVR procedure. And so, and nowadays the recommendation is just without AFib or anticoagulation indication, just to use the single antipress therapy would be okay. And in patient with AFib and the NOAC or warfarin would be is a good option. There was is updated guide.
No routine use of warfarin. Okay.
Yeah.
Okay. Thank you. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
May I ask a question?
Okay,
yes,
Kentaro.
Okay, thank you very much, DW, for your fantastic talk, and really congratulate on your great success. And I would like to ask you a question. And actually, I also think that the liver thrombosis should be bystander, especially in the patient with the very high old age. And what do you think of the impact of the liver thrombosis on the valve durability for the long-term follow-up, especially in younger patients? Because the indication is now shifting towards younger patient. And what is your current practice? What is your thought?
Yeah, I think the Kentaro's question is the most important question. That question also raised by the many is a panel in ACC late-breaking trial. So our key finding, we did not found any strong evidence of replete thrombosis and so cerebral thromboembolism risk, but we don't know yet is the replete thrombosis how can impact of the valve durability. I think the most intervention and cardiac surgeon and cardiologists concerned about that. We don't know yet. So I think we are now planning in the 5-year follow-up of ADAPT-TAVR trial. Also, we require more large size trial how valve leaflet thrombosis can impact the valve durability. That is still unmet need field, and we require is further data. That is the most important question.
Thank you very much.
Congratulations. Yeah, congratulations. And looking forward to long-term follow-up. Thank you.
Thank you. Thank you. Great.
Okay, Dr. Chen.
I have a question.
Yeah, please.
Okay. Thank Dr. Parks for the excellent talk. And would you please tell us about your daily practice about strategy of NOAC use or dual NAPR use? Which one you prefer? Or what is your strategy to choose these two strategies in your daily practice?
So and the daily practice, I think that is the same in the world. Many centers is last year, and the European valve guideline and the US valve guideline is updated. In patient without OAC indication, without AFib, single antiplatelet therapy or aspirin is recommended. That is our updated practice. Also in patient with AFib, OAC indication, and the recommendations, the NOAC or warfarin. In the most of the cases, we treat the oral and NOAC is like edoxaban or rivaroxaban and efixaban. Thank you.
Okay, thank you, Dr. Park, for your excellent talk, and we'll move on to the next topic. Thank you, thank you. So the next two speakers will be introduced by Dr. Tsai Chien-Sung. Dr. Tsai, please.
Okay. Everybody, good morning. I'm Dr. Tsai Chien-Sung from Tsai General Hospital. It's my honor and pleasure, invited by Zhang General Hospital, to share the next two speakers. The first speaker will be Professor Gilbert Tang from the United States. I briefly introduce Professor Gilbert Tang. He got an MD from the University of Toronto. And now he is the surgical director of the structural heart program at the Mount Sinai Health System. He have over 1,000 cases of TAVR and mitral valve clip, and with very excellent outcome. Now he's very famous in the world. Now today he give us our talk. The topic is transcatheter mitral valve replacement, Intrepid. Please, Professor Tang.
Thank you very much. Can you see my screen?
Yes.
Okay, great. Well, thank you very much. I'm going to be talking about the Intrepid TMVR system. Here are my disclosures. So the Intrepid technology has come a long way. You can see that here, the inner stent is a 27mm bovine pericardial valve. And you can see that it conforms to the outer stent anchors without leaflet capture. It's a symmetric valve, so there's no need to rotationally align. There's been now transapical and transfemoral delivery, but this one does not require any guide wire in the left ventricle. And there are currently 2 valves already in clinical trial, and there's a 3rd valve coming in development. So you can see that this clinical experience now over 350 cases around the world with 6-year follow-up and 50+ transfemoral cases so far in terms of perform around the world. Sorry, I think the program crashed. Let me share again. Apologize. So you can see that the clinical program for the Intrepid TMVR has started almost 10 years ago. And you can see that now currently in 2022, we now have the transfemoral and the transapical systems available in the Apollo single arm. And the future is going to be not just the European study, but also potential randomized trial. So in the phase 1, you can see we have a lot of learning that was already accumulated. Over 200 patients have been already performed in high extreme risk patients. These are all done transapically, and certainly there have been quite a bit of long-term follow-up now. You can see that 1 year, in terms of the clinical, certainly the mortality at that time with early experience was quite high, of almost 27%. There was also high rate of intervention, bleeding, and stroke as well. You can see that the 2-year follow-up so far, the mortality is around 38%. So not dissimilar to the coax population, if you remember the mortality after mitral clip. We also learned that pre-operation optimization is highly important, not just heart failure consultation, but you also want to start them on maybe some inotropes or diuresis before the procedure to optimize the condition before undergoing the TMVR. And also at this time, because of transapical access, apical management is critical, not just in the hemostasis, but also hasten removing the sheath to minimize bleeding and trauma to the apex. And finally, need to have multiple involvement, specialty involvement on discharging the patient. The other thing we learned is that the screen failure at the time earlier was quite high, and these are some of the common reasons for screen failure, is that LVOT obstruction, the annulus may be too small, too big for the new valves. There's also a MAC that were too severe. There's also volume issue in terms of too big or too small. A lot of these patients may not have severe enough MR, and also they may have severe TR, precluding them from the trial. And you can see that here, only about half of them were presented to the committee, and only a little bit over half were ultimately approved for the procedure. Because of that, we actually developed a very novel way to evaluate neo-LVOT. You can see that was published in JACC Intervention. Essentially, rather than look at just one snapshot of the cardiac cycle, which is end systole, we look across the entire phase of from early to mid to late systole. So only if you fail the screening at early systole will you actually be excluded in the trial. And as a result of that, we have included and improved the screen acceptance rate. So you can also see that the valve is very predictable in terms of deployment, and you can see sustained MR reduction at 2 years with almost MR elimination, not just reduction. And you can see this is a valve that was performed 5 years ago and is still functioning well. So the current Apollo pivotal trial has undergone some changes based on the approval of MitraClip in secondary MR in the United States. So you can see now that these patients are typically unsuitable for transcatheter mitral repair or surgery. And you can see that on the left side, the patients typically have primary, secondary MR, and you can see this is the primary endpoint. And you can see also we now have a MAC cohort in patients who are not good surgical candidates and undergoing TMVR. So far in terms of Apollo trials, there have been over 65 sites activated, over 1,000 patients consented, and 200 plus patients approved. And you can see that in terms of the MAC cohort as well, rather than just pure moderate severe MR, patients with moderate MR, mitral stenosis, and presence of MAC can also be approved. Sorry again. My computer has not been very good with the PowerPoint. So you can see now this is the transfemoral system. It's still 35 French, so it's quite large. Next generation is 29 French. It is actually very easy to use. It's very similar to the MitraClip system, very steerable, and you can see that there's no guide where the land pressure goes, so minimizing the trauma. It's a single stage pacing deployment. And you can see this series has just been published in JACC, and you can see that they've been compared to transapical cohort, there have been no mortality, no strokes. There are some bleeding events that occur, but now they've been mostly resolved. You can see again the sustained reduction in mitral regurgitation at 30 days is essentially no, none trace MR, an improvement in L9HA class. And currently, this is now the default system that going to be used in the Apollo trial. And you can see that in terms of global expansion, that's going to be including United States and US in terms of and Canada in terms of the trial sites, and then there'll be a separate study in Europe as well, and I'm sure it'll be coming to Asia in the near future. So I'm just going to show you one case in the interest of time and go through the details of how the procedure is done. So this is a 71-year-old female with an STS score of 3.3%, and the valve select was a 42 Intrepid. You can see the number of comorbidities, but essentially it's a secondary MR, and you can see that there are no other risk factors You can see that here, EF was down 37%, mild RV dysfunction, trivial TR. You can see the right high calf number with moderate pulmonary hypertension. This is initial transthoracic echo showing EF of 37% with dilated LV. And then you can see the SOQ echoes with moderate, you can see moderate severe MR, secondary in nature. You can see the mechanism of MR as well. It's a classic type 3B with posterior leaflet restriction. So what we typically screen in terms of these TEEs to look at the four-chamber, we look at the fossa height in terms of transeptal access. You have to be at least 4 centimeters or higher, just like with mitral clips. So we do a very standardized views, including the bicombinatorial explain the LVOT, which you saw earlier. CT screening is an important part of this process, as you know. So you can see this patient is 26% oversized by perimeter to a 42 Intrepid valve. And you can see that the neo-LVOT predicted is wide open, so there's no need to go through an in-depth analysis. We also look at ventricular assessment of how deep the apex is to the annulus in terms of where the valve can be accommodated with the delivery system. You can see we look at the aortic mitral angle. In terms of left atrial assessment, we look at this is a very key number, 64.5. It has to be at least 49 or 53 millimeters, so that you can actually steer the system from the atrium down to the mitral annulus. We also look at the distribution of papillary muscles. The high riding pap muscle may potentially interfere with the device, so that needs to be taken into consideration, especially in patients with primary MR and normal ejection fraction. We, of course, look at the femoral, iliac, and IVC diameters. It has to be sufficient. You can see that typically, even though you're a little bit less than ratio of 1, we would accept it. Certainly more than 1 would have to be considered with caution. However, this typically changes quite a bit with volume hydration, so we are not really overly concerned about these numbers unless it's really falling out of window, meaning the veins are too small. So first of all, this is a femoral venous cut down from the right side. The left side would typically put an arterial venous sheath just in case of coronary pulmonary bypass or emergency support, and we will use the left femoral vein also for ASD closure. This is basically the steps involved. I can tell you that this is a very reproducible procedure. So I have come up with essentially 35 steps for Intrepid deployment with transfemoral approach. It's very much now going to be adopted in other centers as well. Now, access is critically important. You can see that here we use 3 sets of mattress sutures, and the center one where the access will happen, we actually use a diamond-shaped pledgeted sutures to allow hemostasis. And I can tell you that we've done 5-6 cases so far, and has been no vascular complication or bleeding involved using this approach. So you can see that this is a safe cross transeptal system, the balloon tip transeptal system, because you have to be very accurately puncture the septum to gain enough height to be able to steer the device. And you can see that here with this, it's been pretty much very safe. You never really cause a pericardial effusion with this system. And you can see that in this particular case, you have a 4.2 centimeter in height, and we always pre-balloon the septum to allow the sheath to cross, and typically we use a 14 by 40 balloon. And you can see that here, once you advance the delivery system across, we typically before that would use dilators to stretch the vein, and also then we use the 37 pre-curve delivery sheath across, and you have to make sure you're 2 centimeter into left atrium before withdrawing the dilator, and also have to be careful not to entrap any air. So once you deliver the catheter through the sheath, you have to have at least 5.5 centimeters into the left atrium before you can retract the sheath so that the brim will be housed, and also the steerable guide can be in the left atrium. Otherwise, you'll make the procedure more difficult. So you can see that now the valve is now crossing across the mitral annulus, the capsule. So during this time, actually, the hemodynamics are quite stable. However, you have to be careful not to impinge on an anterior leaflet because that can cause hemodynamic instability. So you can actually clock the guide to gain height. And then you can see that here, the brim can be start expanded once you actually have enough height. But if you are concerned about the height being brought on, you have to be ready to deploy the valve under rapid pacing and whole ventilation. And you can see that here, the valve being deployed with rapid pacing, and there are really no issues, a very straightforward deployment. After the valve is deployed, you do have to retrieve the entire delivery system back in the left atrium. So you have to take your time to avoid any interaction with the valve. So you can see that here, you can just deliver the valve back in the left atrium. It's like trying to drive a car parallel park in a very small space. You have to take your time and be patient so that you don't bump into the other cars. So this is the final fluoroscopic view of the device. You can see that here, really no PVL, trace MR, very well expanded, no mitral valve gradient, no LVOT gradient. In fact, the EF in this patient improved. This is the post-op CT. You can see the valve is well expanded. In fact, if you look at neo LVOT, it's significantly bigger than what you predicted initially. This is interesting. You can see that here, after TMVL with elimination of MR for the transfemoral approach, you see that there's early emptying of the ventricle after the replacement, but also early filling. So the ventricle looks like it'll be more efficient, and you can see that here on the 4D reconstruction that is improved LV emptying and relaxation after the MR elimination. This is 30-day result. You can see here, no MR, no issues at all with the valve. So the next generation is going to be 29 French transfemoral system with 3 different sizes. You can see here, it's going to be smaller system, so we suspect it'll be able to do it percutaneously rather than venous cut down. So in summary, I think the TMVR with the Intrepid system has really evolved now from transapical to transfemoral. It's really a simple and predictable procedure. There have been well over 350 global implants being done, and you can see that it's near elimination of MR and it's sustained. The sizing and neo LVOT clearance still are limiting factors in terms of allowing us to screen more patients. Apollo trial right now, evaluating patients, we can be entire spectrum, primary, secondary MR, and also in MAC as well. And finally, the 29 French system will likely improve steerability with better LVOT clearance and also more sizes available to treat more patients. I'd like to thank you very much for the honor to present here.
Okay, thank you for Professor Tang. Any question from the audience and the panelists?
Can I ask a question?
Okay, please.
Okay, thank you very much, Gilbert, for your fantastic talk, and I'm so much excited. And so what do you think is the future indication of TMVR? Because you are also doing mitral valve surgery. And what do you think is the future indication of TMVR? And we have to use the both procedure for the optimal results for the patient.
Yeah, that's a great question. As you know, mitral clip is a very safe procedure. Everyone's very familiar with it. It's a low profile. There's no need for anticoagulation, so it's very attractive to patients. The major limitation, as you know, is that there are patients who come back with recurrent MR, and really you don't have much option because either you cause stenosis, you cannot put another clip, or you might need to take the patient to the operating room to address the mitral issue. I think patients who have secondary MR with reasonable renal function, you can do a CT to evaluate these patients. I would consider them for TMVR because you can eliminate the MR as long as they are okay to undergo, to receive anticoagulation. And the majority of these patients are already on some kind of anticoagulation anyway because of AFib. So I think in my mind now, we look at patients with secondary MR, if they have big ventricles that we think will have no neo LVOT issues. And these patients typically we would need at least 2 to 3 clips. And you and I both know as clip operators that 1 clip is obviously very straightforward and you can get a great result. But once you talk about 2 to 3 clips, it gets more complex. And so those patients, we would rather consider this device, at least in terms of screening. And we advise the patient that we might potentially eliminate the MR, especially now it's transfemoral, it's no longer transapical. It's much more attractive to patients, but also to our cardiologists as well. They like to hear that we're doing transfemoral. And these patients do very well. They get out of bed the next day, they go home in 3 to 4 days, rather than if you do transapical, at least in our experience in the past, they have been needing to stay in a week, they look more debilitated.
Thank you. What do you think of the primary MR?
So primary MR, yes. So if a very challenging anatomy for clip and you have a high surgical risk, we would definitely consider them for also TMVR. The issue is that most of these patients have normal ventricles, and so the LVOT becomes an issue in terms of clearance. But yeah, so let's say it's a complex commissural clip or multiple jets like Barlow's type valves, or maybe the leaflets are too short for clip or Pascal, I guess, then we consider them for TMVR. But it's definitely not as many patients as we would like to include because of the LVOT issue.
Thank you.
Okay, thank you.
I have one question.
Dr. Xu, please.
Yeah. Thank you, Dr. Gilbert Tang. Thanks for your informative talk, and congratulations to your excellent work. And I have one comment about regarding to the issue of the near LVOT is limited to our inclusion patients. So maybe I have one opinion to the manufacturer that this can design a symmetric stem frame of the maybe the outflow tract inside the LV. So maybe we can have the indicator marker, so we can rotate a symmetric stem frame and to avoid the compression of the near LVOT. That is my opinion.
Yeah, no, that's a great point. So as you know, there are other devices in development that are asymmetric to improve near LVOT clearance. The Tendyne valve is one of them. The other devices also have been put the valve more atrial. So rather more ventricular, you occupy the ventricular side and compress the LVOT. They put it more atrially so you can have more clearance. So that there are some devices in development who are designed that way. So example, I think the Edwards EOS, or it used to be called Evoke or Cardiac Q, is trying to be designed a little more atrial. But remember, each device anchors differently. So the Edwards device anchor more by the leaflet, so you have to visualize the leaflets. The beauty of the Medtronic device is that you get anchored by the annulus. So basically, you pick 3 out of 4 landmarks on the bicommissural view and LVOT view. As long as they are aligned coaxially, you can deploy with confidence that you will not have a problem. So it's actually very simple in concept and procedure.
Thank you. Thank you for your information. Thank you.
Okay, thank you, Professor Xu. Any other question? Please.
Thank you for Dr. Tang's excellent talk. I have a question about medication after your mitral valve prosthesis implementation. What do you prefer? You use dual type agent or just as anticoagulant like NOAC or other strategy?
Yeah, so because it's part of the clinical trial, we are required to put the patient on baby aspirin and also Coumadin for a period of 6 months with iron out 2 to 3. So after that, then they go back to their normal medication regimen. If they're on a DOAC or NOAC, they go back to that. Or if that's on baby aspirin, they go back to the baby aspirin. We don't know the longer term consequence in terms of valve thrombosis, with this protocol. But this is what we have right now. And so the patient had to agree to at least for 6 months of warfarin.
Okay, thank you. I have a simple question for Professor Tang. For your experience in the clinical trial, are there the same outcome for mitral valve stenosis case and the mitral valve regurgitation case? And are there have the same outcome for your study?
Yeah, so that's a great question because the mitral stenosis patients are still not included into the trial other than in the MAC cohort, so they have to at least moderate MR and then mitral stenosis. So that was still early in that experience. We just did actually one of our first cases with the Intrepid system, and it actually performs very well. One thing you have to be careful is that the mitral stenosis leaflet are not impinging on the stent frame because it's a self-expanding valve. So you might end up, if you don't get that radial force, the valve may be a little elliptical rather than circular to maintain the function. So you might have a bit more mitral regurgitation. But at least certainly the valve performs very well even in those cases. And also other devices like the Tendyne have also published experience with the mitral stenosis and MAC as well. But that's kind of the area. We have not done much rheumatic mitral stenosis because these valves might have a risk of migration because there's not much is factor leaflets to try to anchor based on this technology. So we're still learning on that.
Okay, thank you. Yeah, because the time limitation, we thank you so much for Professor Tang, your excellent talk. We proceeded to the final talk of section, this section. Thank you so much. Thank you. The final speaker will be Professor Xiangbin Pan from China. He is the director of Structural Heart Disease Center of Fuwai Hospital. He will give us talk. Please, the photo shift to the Professor Xiangbin Pan. And his topic is a complementary trend of mitral valve intervention in China. Please, Professor Pan.
Ladies and gentlemen, it's a great pleasure to give the presentation about contemporary trends of mitral valve interventions in China. I'm Dr. Pan from National Center for Cardiovascular Disease, Chinese Academy of Medical Science, Fuwai Hospital. In recent years, interventional treatment of mitral valve insufficiency has become a new hotspot in the field of interventional treatment for structural heart disease. All major medical device manufacturers around the world have developed their own mitral valve interventional products, which are under different stages of clinical trials. And I will review the development progress of mitral valve interventional device in 2021. As we all know, the interventional repair technique of the mitral valve can be divided into three parts: annuloplasty, leaflet repair, and artificial cordon repair. In terms of annuloplasty, Carimon, developed by Cardiac Dimension, has released 5-year follow-up of its small-scale trial. Results show that the 5-year survival rate was 56.2%, and the mitral valve jet area decreased by 34 to 41 over 1 year after operation. There is also a large sample of random controlled study underway, aka the EMPOWER trial, which intends to compare Caroline and guideline-directed heart failure medication in heart failure patients with mitral regurgitation. The study intends to enroll 300 patients in 75 heart centers across the United States, Canada, Europe, and Australia. The principal investigator of the trial is from Cleveland Clinic Heart Center. The trial is expected to end in 2024. And Caroline is currently considered as one of the most promising products in the field of indirect mitral annuloplasty and might be used in the future minimal invasive mitral valvoplasty surgery, together with transcatheter edge repair or cordon repair devices. The indirect mitral annuloplasty Arto device developed by NVRX company was designed to reduce the annular diameter by implanting a fixation device in the atrial septal wall, as well as the great cardiac vein under the annulus of the mitral valve. By decreasing the distance between the two fixation devices, the anterior and posterior distance of the mitral valve will be shortened. The research carried out is called the MAVERICK study, which means the mitral valve repair clinical trial. Is also a trial designed for CE mark. This is a prospective single group study. 45 patients were enrolled. Primary outcome measure was 30-day adverse event, 30-day adverse event, and mitral regurgitation improvement and device successful rate. And MAE include the death, stroke, myocardial infarction, precardial tampon, renal injury, and etc. The 1-year mortality rate was 17.8%. Mitral regurgitation level of 3+ and 4+ decreased from 67 to 8 at 1 year after intervention. Cardiac function class 3 to 4 dropped from 69% to 22% at 1 year follow-up. The successful rate of the device was 100%. The safety and effectiveness have been recognized, and it is expected to receive CE mark in the near future.
The direct mitral annuloplasty ring cardio band developed the idler left sense is an adjustable polymer forming band. The annular can be adjusted by implanting multiple anchors in the posterior annulus. Cardio band obtained CE mark in 2015, but related research was stopped after 1 year. Follow-up result was published in 2019. After that, Edward left science shifted the cardio band to the field of tricuspid valvoplasty and carried out several studies. The 2-year result of tricuspid valvoplasty published in 2021 showed this great potential in tricuspid annuloplasty. The mitral annuloplasty ring, IRIS, developed by Boston Scientific, has a semi-rigid adjustable ring with a nickel titanium alloy frame, which is placed on the atrial surface of the mitral valve annulus through multiple anchors. But after 20 cases of a feasibility study, no relevant research has been published. And such result from the clinical trial website indicate only one study is still in progress and no further information has been updated. In terms of valve leaflet repair device, MitraClip is undoubtedly the most successful. It has developed rapidly in the field of DMR treatment. There are more than 10,000 cases of MitraClip implanted in the United States every year. At the same time, the improvement of device is also ongoing. From NTR XTR system to the G4 system, the types of the clamps has also increased to 4 kinds. However, in the field of IFMR treatment, in view of the difference between the corpus and the mitral MR study, the effectiveness of MitraClip for the treatment of functional mitral regurgitation needs further research and exploration. The Pascal device developed by Edward left sense is also based on transcatheter edge-to-edge repair technique. It can achieve independent clamping of the anterior and posterior leaflets. Pascal has been used in degenerative mitral regurgitation and functional mitral regurgitation research and have achieved excellent results similar to MitraClip. The 1 year and 2 year survival rate was 91.2% and 80.3% respectively. And all patients' mitral valve function is under grade 2 regurgitation and 1 year follow-up, which further proves the advantage of edge-to-edge repair as a single technique in field of interventional therapy for mitral regurgitation. NeoCord system is the first artificial cordon implantation device that has obtained the CE mark as early as 2013. After long-term research, its target patients group has changed from high-risk mitral regurgitation patients who are not suitable for surgery to mitral regurgitation patients who are in early stage of the disease, while no significant left ventricular remodeling and left ventricular dilation has developed. It can be found from the clinical trial website that NeoCord has carried out comparative research which with surgical mitral valvoplasty surgery on a large-scale patients with development of minimal invasive mitral valve annuloplasty technique. It is possible that NeoCord might be used in the field of minimal invasive mitral valvoplasty in surgery. Harpoon is also a transapical mitral valve cordon implantation device, which has already obtained CE mark and is currently undergoing post-marketing safety and effectiveness research. But compared to NeoCord, Harpoon's related research is still in the early stage. Now let's review the development of the domestic mitral valve intervention device. The first one is the MitraClip. Since the first post-marketing operation, which was launched in January 2021, in-full mitral clip operations has been carried out in 20 heart centers across 14 provinces in China. As of October 20, 2021, the case number of mitral clip operations has reached 122, and the device successful rate has reached 98%. Reviewing the characteristics of the patient population, elderly patients and degenerative change are the most common population and etiology. The most commonly used clip is XDR, and more than half of the patients only need to implant one clip. The data analysis from the patient, the data analysis of the patient in Fuai Hospital from January to June shows that a total of 38 operations have been completed. There were 24 males and 12 females with a median age of 71 years and a median SDS score of 8.38. The degree of the mitral regurgitation after operation was significantly improved, and there was no significant stenosis after operation. At present, another relative mature domestic transapical transact-to-act repair device is the valve clamp. This device has not yet obtained FDA approval and is still under clinical trials. The enrollment of 110 high-risk DMR patients with surgical procedure has been completed, and the research result will be released soon. There's also the Dragonfly system, a domestic TR device via femoral vein, which is similar to mitral clip. The clinical trial is currently enrolling patients. In addition, there's a transfemoral TR device made by Hsien-Li Medical Corporation, which is currently under development. The animal experiment verification has been completed, and the first in-man research has been applied. In 2021, the domestic artificial tendon implantation device, Mitral Stitch, has completed its clinical trial. This is the first domestic device that can achieve both tendon repair and transcatheter act-to-act repair at the same time. And its research result will be released soon. In terms of interventional valve replacement, the domestic MISOS and the MitraFix valve has completed its clinical trial. This is the first domestic device that can achieve both. In terms of interventional and interventional valve replacement, the domestic MISOS and the MitraFix valve replacement device has been approved for clinical trial. The patients have begun to enroll. At the same time, there are still a large number of interventional mitral valve devices that have not yet entered clinical trials, including this TR device called Clip-2 Edge. This mitral valve anastomosis ring called mitral ring, which is similar to the cardioband, and transcatheter mitral valve replacement system called mitral sub, etc. And I believe that a large number of related devices will complete clinical trials and enter clinical application in the near future. And that's all. Thanks.
Okay, thank you. Excellent talk of Professor Pan. Any question for the audience and the panelists? Okay, Professor Pan, I have one question. Is about so many new products in the China market, but from the animal study to the clinical service in the current product, what is you think is the best outcome in the mitral valve replacement or repair from your personal experience?
Sorry, sir. Sorry for the poor network connection. I didn't hear your question clearly.
Can you hear?
Yeah.
Okay. From your personal experience, so many products about the mitral valve replacement or repair, percutaneous or the open procedure in the China market, from the animal study to the clinical practice. For your personal experience, which product is the best one in your clinical performance?
For now, it's still the mitral clip system.
Okay, and but for your mitral clip system, is any different from the now we use in the clinical service in the market about the China product? Any different or any special in for your product?
Actually, most of the product is copied from the mitral clip system, and some products it still lack of the basic functions. Still, most of the product is still under clinical trial. It haven't made the market yet.
Okay, thank you so much. Any question from the audience and panelists? Dr. Li?
Dr. Li, Dr. Pan, thank you for your informative talk. So what's the main strategy to choose the different device at your hospital? I mean, you also have a percutaneous mitral clip and some transapical mitral stitch. So how to basic classify in what situation you choose the stitch and in what situation you choose the clip for your patient?
Well, thank you for the question. In Fuai Hospital, the only available merchant the device is still the mitral clip. All the domestic device, no matter is repair or replacement, is still under clinical trials. And for now, most of the clinical trials has closed from the Fuai Hospital Center. So now the only choice we have is still the mitral clip device.
Okay, thank you. Any other question?
So may I ask another question about the if in your hospital, if the surgical repair, I mean the recurred mitral regurgitation, so what's your is the percutaneous device still useful in such patient? I mean, if the patient already have a ring on the mitral position, and what's about your strategy to do the mitral clip? Is some contraindication? I mean, have the possibility of a mitral stenosis after a mitral clip. So, is there any contraindication for mitral clip in patient with recurrent mitral regurgitation after surgical repair?
Thank you for the question. Actually, we haven't tried the mitral clip in the ring, because most of the ring in Fuai used is about like the size of the ring is 32 to 34, which makes it's hard for the mitral clip to implant. For the result might be stenosis.
Okay, thank you. Any other question? Professor Park from Korea, do you any question for the Professor Pan?
Okay, I don't have a further question.
Okay, thank you so much. Okay, if no more question, thank you so much for Professor Xiangbin Pan US and talk and share about the experience in China. Thank you so much. Thank you. And this section will be closed here. And thank you so much for all the moderator and the panelists and the audience. Thank you so much. Bye bye. Bye bye.
Bye. Thank you. Thank you.
Thank you. Bye bye.
Hey.
哎，谢宝教授。
哎，李教授你好。
你好，你好。
永在教授。
好，那这个 session 我们现在就开始吧，好不好？高教授在吗？
有。
哦，好，
很在。
那个教授，你要不要先开场？
是吗？
对。
Okay. So, welcome to join the next session of 222 Taipei Valve Summit. I am Professor Gao Hsien-Li from National Taiwan University Hospital. Today, my joint moderators are Dr. Tsao Tien-Ping and Dr. Xiangbin. And also we have panelists, Dr. Zhang, Gejun, Dr. Luo Jianfang.
Hello. Hi, nice to meet you.
Good to see you. Yeah. And Dr. Zhang Zhengmin, Dr. Ying-Hsiang, Dr. Jung-Cheng, Dr. Shi Zhiyuan, and Dr. Ying-Hsiang. I believe all of us are online. And we will see 3 live cases, 2 mitral and 1 TAVR. Dr. Tsao, are you online?
Dr. Tsao will be here because he's doing surgery, and will be here later. And I think this is a Chinese section. Maybe we can use the Chinese.
Sure, OK. 那没问题，我们讲中文就方便多了哈。
讲中文可以，
好的。
高教授，好久不见啊！
是王院长你好，好久不见，别来无恙。
这个很好，这新冠搞得我们都不能见面哈。
是啊，没问题。
那高教授麻烦介绍王院长的团队，还有等一下宪宝要先帮我们介绍 mitral 的这个录播的 case 这样。
好的。那我们第一个 case 呢是会由浙大2院的王建安王院长呢来领导为我们演示一个2间半的这个治疗。那么我想王院长我们大家都非常熟哈，都是老朋友了，尤其是在结构性这一块的话，王院长可以说是先行者，经验非常的多。那么同时呢也有很多精彩的手术。那我想就请王院长为我们来介绍一下团队以及这个病例的情况，谢谢。
这样吧，那个我的团队呢有刘宪宝的主任和我一起完成的这个 case 啊。那个我想由刘主任来介绍，我呢就关键时刻补充一点，或者我 summary 一下都可以。刘主任，您介绍。
好，王老师。那么因为我们还是为了保证这个大会能够顺利的进行啊，所以呢我们提前把它录好了，所以呢我就放一下我们录播视频，等会有问题随时可以停下来，因为王书记也在，我们都在，随时可以来进行沟通和交流。尊敬的主席、各位专家、各位同道，大家好。首先非常感谢殷伟贤教授的邀请，给我们这个机会跟大家一起来分享经导管圆对圆这个技术，使用 Dragonfly 分享病例。下面我代表我的老师王坚安教授，也代表我们团队跟大家来做一个汇报。那么今天我给大家带来2个录播病例，都是使用 Dragonfly 系统的。这个系统呢在设计上应该说在理念上和 MitraClip 和 Pascal 系统是一样的，都是圆对圆的技术。它确实也吸收了 G4 系统和 Pascal 最新的一些设计的一些理念，同时再加以一个创新。那我们可以看到它在设计在外面的手柄上啊，在这个 stabilizer 上，它把大鞘、中鞘和夹子输送系统都做了一个相应的一个固定，做了一个螺旋钮，而且呢它都可以做到精准的一个调控。另外呢在大鞘、中鞘整个我们可以看到它有方向性，同时在转动上它都有一定的角度的要求，而且都是一格一格，它可以做到一格一格打，而且都可以显示打了多少。同时我们在调弯的时候它也有度数，就无论是大鞘还是中鞘调了多少弯，在这个度数上也可以显示啊。所以也就是我们心里很清楚大概调了多少弯，调了多少度啊，所以都可以做到一个精准的控制。在这个夹子上呢，它可以 那个有4个型号，长的、短的、宽的和窄的。同时我们可以看到它有一个也是有一个叫 spacer 的一个这个设计，它叫做 filler， 那么也可以做到无极自锁的一个功能啊。所以说它的这个功能上面应该说是代表了最先进的一些理念和方向。那同时呢，它具有以下的几个特点。第一个呢，它是能够独立抓捕的，那么它可以前叶后叶一起抓捕，也可以分开抓捕。同时有一个 filler 的一个设计，所以它可以做到叫做无极自锁，也就是它夹的合的角度可以做到45度、30度，甚至更小都可以啊。所以这也是设计的一个特点。另外呢，它有4个的型号，所以应该说在使用起来应该说还是非常的一个方便。同时呢，它也可以做到一个连续的一个测压啊，这就是这个中国的这个首款圆对圆的筋骨静脉途径的一个设计，由德进公司研发。那我们中心呢，在王书记的带领之下，我们也参与了体外模型啊、动物试验啊，包括 film 研究，包括现在也是领导全国多中心的一个临床研究。所以呢，我们也应用超过100例的一个经验，所以从中有一些新的体会。那第一例患者是我们一年多以前做的一个 case， 这个呢是一个比较经典的一个 DMR。这个患者是67岁的一个老年男性，症状比较重，那么合并有这个直肠癌啊，包括尿毒症啊等等，所以这个临床情况比较严重。那么 STS score 评分也是比较高，16%。那么这个对于这样的一个病人来讲，外科手术的风险会比较高一些。那从这个经胸超声来看，这个病人的 EF 值是受到一定的影响，心脏的大小还可以，但是严重的二尖瓣的一个反流，大 P2 的一个突锤，你看这个反流的面积是 0.77 个平方厘米，反流容积是70个毫升。那这个病人 A2 和 P2 都比较长，都超过了2个厘米，瓣口的面积是 7.7 个平方厘米啊，所以我们可以看到反流量非常的大。我们也做了一个这个食道超声的一个筛查，所以我们看到这里这个大 P2 啊，反流是非常的大。从不同的角度看，那应该说这样的病人是适合做圆对圆的一个技术。这是心电图的一个表现，是一个心房颤动快速率。所以对于这样的一个病人，我们做的一个策略，术前我们根据产品的特点、病人解剖学的特点，我们准备是用1个或者2个长宽的夹子在 P2 上面。所以有时候呢，我们确实对于这样的病变，有时候确实有时候很难讲。有时候我们觉得说1个夹子够了，可能不行，要2个夹子。有时候准备用2个夹子吧，可能1个夹子一下去就够了。所以这个病人我们当时初始是希望能够有一个夹子夹在中间，就能够解决他的问题啊，这是我们策略。在我们这个房间隔穿刺的高度上，我们希望也是 4.0 到 4.5 左右的这样的一个高度来进行处理。那王书记带领我们团队啊，所以应该说当时做其实真的很不容易，因为我们是疫情的关系，因为我们包括国外的一些专家也不能到现场来进行指导，因为我们在2013年和14年我们是做了13例的 mitral clip， 所以这么长时间过去了，实际上很多都已经忘记掉了。开展这个 film 研究，所以也是感谢我们这个 Scott Lim 教授，包括林一贤教授在线上指导我们一步一步的去做啊，所以呢，应该说这个很艰辛，但最后的结果都还是不错啊。所以对于房间隔穿刺，应该说跟 mitral clip 是一样，我们希望能够穿的稍微偏高一点，这个呢还偏厚一点点。那我们要量一量这个深度高度是多少。那我们可以看到量的高度，我们希望是 4.0 到 4.5 之间，这个是我们术前定下来的策略。所以我们沿着半环拉一条线，这个穿刺点拉一个平行线，所以这里呢大概是 4.1 个厘米啊，应该说基本是达到了我们的需求。所以这样子我们就可以继续往前穿。那么当我们定位定好以后呢，我们常规在我们中心是在达到短轴面垂直的穿过去。所以有时候虽然说这个位置好了，有时候你斜过来穿过去，方向也不一样。所以我们希望是垂直的房间隔往前穿，这样的这个相当于我们说这个大鞘一个 alignment， 这样的话对于后续我们夹直镜也会更好一点。当我们这个穿刺房间隔以后，我们把导丝放到左上肺静脉，然后把我们这个防这个穿刺鞘放到左上肺静脉，然后呢我们会交换这个导丝，超硬导丝到里边，然后呢我们把这个大鞘的系统，它是24个 F 大鞘的系统，我们穿过房间隔送到左房侧，这个时候呢我们也可以在3维超声的引导之下看得非常的清楚。再后呢，我们退出这个内心和导丝的这个时候呢，我们要注意排气，气不要进去啊。这些操作能够 mitral clip 都是一样的。那接下来以后呢，我们就是进这个夹子的输送系统啊。夹子输送系统呢也是一样，它这个呢跟 mitral clip 不一样，它没有一个方向性的要求，它只要直接把这个垂直着往前面送就行，不需要 blue to blue。之后呢，我们这里就一步步进去以后呢，当然我们进的过程当中也是要注意整个系统的一个排气，这个是非常的重要啊。那我们可以在超声引导下，也可以在射线辅助下去做啊。那么这个也是在食道超声的引导之下，一步一步的啊，我们把这个夹子输送系统给输送进去。这样的话呢，我们也可以在输送的过程当中，可以稍微调一点点这个中鞘，所以这个跟 mitral clip 有点不太一样。mitral clip 呢希望 straddle 以后再去打弯，这个 dragonfly 呢可以大鞘先打到5度，中鞘呢就是出去一定以后呢，这个边打弯边往下走，这也是它是允许的，所以这样呢可以降低我们这个调弯的一个难度。那接下来其实操作跟 mitral clip 类似啊，就是掌握这个几个要素，把我们这个夹子，我们一定是第一个放在脱垂最明显的位置，就反流量最大的位置，第一个位置要准确。第二个呢，我们这个方向 orientation 要准确。第三个呢，就行进的方向，就 trajectory 也很重要，也要把它弄准确啊。所以呢，首先我们是把位置大概放好位置以后呢，这个我们就先打开夹子，因为有时候这个夹子的方向不一样啊，你调了其他东西也没用，所以我们把夹子打开以后，再把方向调好，再然后我们去调其他的一些按钮，包括 M 键啊，包括前后啊等等。所以这个夹子我们可以看到，因为说刚好是放到反流最多的地方。那么刚开始我们尝试着，我们希望能够从中间下去啊，这个当然我们前面也是做了一个 trajectory 啊 ，trajectory 方向也是好的。然后呢，我们夹子在120度左右，从心房面进入到心室面。然后呢，我们到心室面以后，这个时候呢，我们还要再看一下这个 orientation。有时候呢，我们在心房面调好了以后，到心室面以后啊，它可能还会转。所以这个病人呢，应该说心房面调好以后到心室面方向还是不错的。我们只是做了一点点的微调，所以我们不建议在心室面过多的转动。在心室面过多转动以后呢，就完全有可能会缠绕腱索。之后当我们打开夹子呢，我们可以再打开一点，120度可以打开到150度，稍微多打开一点以后，那么再轻轻往回拉，我们可以看到前叶和后叶都已经坐落到这个夹子的壁上。然后呢，对于脱垂的病人，我们也希望能够多往上拉一点，把脱垂面多加一点。所以这个时候你看我们王书记是往后打了一点点，我们再往上拉，你看可以看到这个脱垂面啊，脱垂的长度也非常长，脱垂的面也很宽啊。所以这个时候你可以看到我们两个夹子下去，前叶是夹的很多了，但是这个后叶啊感觉没夹住，因为它摆动的幅度很大，后叶没夹住。所以这个时候呢，我们可以考虑单边夹臂啊，就是前叶不要去动它，这个把这个后叶拉起来。你看这个就光是后叶拉起来，就拉起来以后，那么后叶你看再把它放下去，这次还是没夹住，所以这个时候呢，我们再把它拉起来，再放，所以这个时候我们就夹住了。在夹住了以后，我们可以看到，实际上我们可以看到夹了一部分，就后面那个地方啊，还是有很多的脱垂面在那里摆动啊，因为它脱垂面太大了。 所以这个时候呢，我们王书记决定先关起来先看。那关起来看以后呢，我们就可以发现确实摆动是明显小下来了。再让我们查看这个反流，但我们可以看到两边反流其实都有，两边都还有反流在，这样就达不到我们的要求。对于脱垂的病人来讲，我们希望是把两边的脱垂全部都夹掉，对吧？你不然有残余的脱垂啊，到时候随着时间的延长，就算结合效果好，后续结果也不一定会很好。所以从这个三维超声来看，我们也可以看到后叶这个地方啊，实际上还是这个脱垂面还是蛮大的啊，残余脱垂面蛮大的。所以呢，我们当时决定把夹子打开，打开以后呢，希望能够夹住更多的后叶啊。所以这个时候呢，我们把夹子打开，把 grip 拉起来，拉起来以后呢，那我们就再往后转一点点。那当然这个因为有时候这个方向啊，它可能就会改变，所以说呢，我们也可以把它翻转，翻转以后到达左房面，到达左房面以后再重新进行调整，我们再调整好方向，再然后重新来进行一个夹臂啊。所以这个方向调好以后，那我们在120度左右从新房面往新丝面去，就重复我们刚刚的那个步骤，无非就是我们想把后叶抓得更多一点。所以这个时候呢，我们夹子可以打得更大一点，往后叶呢转向后叶转得更多一点，能够有时候呢就是这么长的脱垂面，你只有让它打折了，把它夹进去，它才能夹得更多啊。所以这个时候你看，我们把前叶先夹住，前叶夹住以后，再往后多打一点点，再然后呢把这个夹子那个后叶放下去以后，你看，因为这个时候我们更加靠后了，把这个夹子顶牢根部了，再然后夹下去，所以我们可以看到这次明显的后叶的夹的幅度，夹的那个长度就比前面多啊。所以这个明显你看前叶和后叶夹的就更紧了。这样我们可以看到，在现在目前看起来，它最主要是从 lateral 这侧，你看我们可以看到残余脱垂最主要从 lateral 这一侧来的。那么接下来就是一个夹子放了以后，因为我们这个时候估计一个夹子搞不定，像这样的病人脱垂面太大了，所以我们也会决定在评估好了以后，我们会把这个夹子放掉，再重新再放第二个。所以这个时候呢，我们要做一个完整的评估。第一个我们要看残余脱垂有还是没有，在哪里。第二个呢，看反流就到底是两边都有还是靠向于一边，还要看压差怎么样，还要看这个肺静脉的血流怎么样啊，所以要做一个完整的评估在里边。那从这里看，整个夹子还是比较的稳定啊，就我们可以看到这个桥啊，前叶和后叶这个组织桥应该都还是比较的完整。那从反流里边看，那我们可以看到 media 这侧反流很少，最主要还是集中在这个 lateral 这一侧。而且从这个压力阶差来看，我们可以看到这个压力阶差大概是4，那当然4我们觉得已经偏高了，但我们看到形态是很尖的，所以呢它这个压差还受到了一个反流的一个影响啊，但是可能就是反流也会引起对压差产生影响。所以这个时候呢，我们就把第一个夹子给释放掉，释放掉以后呢，我们准备放第二个夹子。那么尤其是你看，我们第一个夹子放完以后再评估压差，到了5了，对吧？那到了5了以后，是不是说压差你放第二个夹子，是不是压差就会更大了呢？是不是就不敢放了？所以综合考虑，我们当时判断是因为这个是由于这个反流引起的压差。那放第二个夹子跟第一个夹子应该是不一样，我们把这个射线把第一个夹子打成一条线，是让那两个臂重叠在一起。然后呢，我们第二个夹子下去的时候呢，要贴牢第一个夹子下去，对吧？而且呢，这个时候夹子是不能打开的，这个夹子是闭牢了进去的，贴牢进去，使两个夹子尽可能靠近，中间最好不要有太多的间隙。如果有间隙的话呢，你到时候中间两个夹子中间会有产生一些空隙。所以这个时候我们下的时候要很小心，在射线和超声共同辅助之下，我们也不能够很暴力的没有看清楚就往里边走，这样的话呢，也有可能引起前面这个夹子的一些撕脱。那下去以后，夹臂本身来讲会比第一个夹子容易多啊。 当然这个时候呢，就我们千万不要有一些方向的一些改变，你方向改变，这个时候再去调整，非常的不好。所以这个病人呢，我们下去以后呢，确实方向感觉是跟原来比就是一点点啊，就是说我们需要顺时针稍微转一点点，稍微微调一下呢，应该是问题不大啊。所以呢，我们就很小心的微调了一点点，顺时针转了一点点，两个夹子看起来也靠得很近。那包括我们射线里边看，这个时候夹子的方向跟我们下去的方向略微有一点点不一样啊。所以从心侧面、心房面去看，夹子的位置都还非常的不错。所以这个时候呢，接下来就是我们要把这个夹子慢慢的拉回来，我们开始要准备这个夹臂了。对，夹子呢，我们这个时候呢也打开到150度左右。那这个时候呢，我们可以看到前叶后叶都坐落在了一边，往后转一点点，再到同时夹臂，所以这次夹臂比前面会轻松很多啊。这夹起来以后，我们要释放一些张力，张力要释放一点点，再到把它夹紧。所以从这里看，就我们可以看到，明显可以看到前叶和后叶夹的就比较多了，反流我们可以看到就只剩下一丁点，再到残余的脱垂，应该说也没有残余的脱垂，反流量就变成了少量，所以应该是达到了我们预期的目的。而且两个夹子的方向应该也是非常的一致啊，这我们叫做比翼双飞啊，这个夹子方向也非常的好。那评估其实跟前面是一样，无非就是残余脱垂有没有，反流有没有，压差怎么样，那么肺静脉血流怎么样，做一个综合的评估，包括两个半月里边夹进去 insertion 是多少，夹子稳不稳定，组织桥怎么样，所以综合来判断。所以我们看看这个病人，你看从这里看残余脱垂也看不到，对吧？两个夹子也是很平行，那无论是从心房面、心室面看，都是还是不错的。最后我们可以看到这个反流就只剩下一些少量的一个反流了。那么我从这个超声评估了以后，达到了比较好的一个状态，所以呢，我们就决定释放。这个时候呢，我们也一定要来关注压差啊。就前面我们说压差，第一个夹子放完以后是5个毫米汞柱，那么2个放完以后会是多少？2个放完以后，反而就变成了3个毫米汞柱了。所以这个反过来说明我们前面判断的是对的，也就是那个压差是由于反流引起的，而不是狭窄引起的。因为本身这个病人术前他的瓣口的面积是7.7个平方厘米啊。这样呢，我们也从不同的角度看这个夹子的方向，所以从不同角度看两个方向都是很平行的、很一致的，也不会说因为夹子之间有扭转或者夹子是有分开，导致一些夹子中间的反流。所以评估完了以后，接下来我们就释放第2个。那最后这是我们最后的一个结果，应该说还是非常的不错啊。这肺静脉血流也跟术前比有明显的一个改善。再接下来就是我们缝合。我们做股静脉缝合的时候，我们有时候要注意，有时候呢我们这个鞘管还在里边就去八字缝合，容易缝到动脉。所以现在我们中心是常规是先轻轻压一压退出来，再然后在没有管子的情况做八字缝合，这样就会比较安全。那这个病人应该说术中即刻效果很好。那么到这个出院过2天出院的时候，我们可以看到心胸超声也不错啊，包括压差也只有2个毫米一个汞柱。那么到术后现在有1年的随访，也是达到了比较好的一个结果。所以应该说对于这个今天这个展示的对于 DMR 来讲，这 Dragonfly 还是有明显的优势啊。所以包括它长的、宽的，对于很大的一个脱垂很宽很长，都能够比较好的来解决。那最近呢，我们 DMR 已经在去年就已经完成临床研究， FMR 是最近才刚刚启动。对于 FMR 来讲，因为前期我们知道 COAPT 研究的入学的标准非常严，所以我们做 FMR 来讲也是完全参考这个 COAPT 严格的要求，所以入选就会很慢。那我们中心到现在为止入组了大概7例 FMR 的病人，那在操作的流程上面、患者的评估上面、病人的管理上面跟 DMR 有很多的不一样。那今天再来跟大家分享这个 FMR 的一个病例。这个患者是66岁，症状呢也是很多啊，曾经呢有心梗的病史，血管呢都已经再通，那么心电图的表现呢也没有完左，而且呢经过优化药物治疗以后，症状还反复。所以对于这样的一个病人来讲，我们评估以后，这个病人有经导管源对源修复的一个指征。超声来看，心脏是大的， 包括 EF 值是低的，再然后我们看反流量也非常的大啊，这个前后叶的长度应该说还可以，半孔的面积还好，所以呢就是这个反流量很大啊。那么对于这样的一个病人来讲，那我们说原队员有适应症，那这是那个 QRS， 这个是窦性心律心电图的一个表现啊。所以策略上来讲，我们会有一些不一样。那我们希望呢能够用一个短的宽的，因为 FMRI 本身它的半环扩大会导致前后叶之间的张力之间就会比较大，所以这个时候你用长宽可能不一定会能达到我们的效果，所以短宽是比较好的选择啊。所以这个病人我们采取的策略是短宽，穿刺的高度呢反正也是 4.0 左右到 4.5 都 OK。 所以呢我们可以看到在穿刺实际上跟前面都一样，这个我们就可以略过去啊。这个操作流程上面没有什么特别，最关键是在策略上有一些不一样。但根据我们的体会，那应该说这个 FMR 操作其实比 DMR 就某种程度上来讲还会更难一些，因为我们用的是短宽的一个夹子，所以短宽的夹子有时候因为太短了以后会导致就我们夹臂的时候啊就没有那么好夹。这些都是跟前面操作都是一模一样的一个流程啊，这个我们就过去，包括我们说调弯 trajectory 等等都是一样。那一般来说我们对于 FMR 来讲，我们也是根据反流的位置啊，所以呢这个时候呢我们也会会把它放到2区，但有时候根据反流的位置呢适当会偏向于2区、3区或者1区。在这里呢就是我们想提一点很重要的一点，就是这个夹子这个 alignment 很重要，就我们前面说的几个要素以外，第一个是位置 orientation trajectory 这个以外，还有就是我们夹子打开了以后的这个夹子打开了以后一个同轴性，也就是夹子是打开是这样打开的还是这样打开的，跟我这个二尖瓣前叶和后叶闭合的角度之间，这个 alignment 很重要。如果这个角度好，我们兜上来一下子就把它夹住了，如果角度不好，可能前叶和后叶之间它不平衡，夹起来也会很困难啊。所以这个就是对于尤其是对于前叶和后叶长度不匹配的时候，一个很长一个很短，所以这个时候操作起来会更加的难。所以这个病人我们还是把它放在了这个2区，等到打开以后调夹子的这个 orientation。 那这个病人呢比较特殊，我们前面的心房面都调得好好的，再然后呢我们就下到心室面，在下到心室面以后呢就发现这个病人的角度就变了。那我们可以看到啊，这个你看这个对合圆前后叶对合圆在这里，夹子这个方向应该说这两个方向之间 alignment 还是不错的，还是比较有利于去夹合去夹臂的。之后呢我们把这个夹子调好位置以后呢，我们把它伸到这个心室面，在下到心室面以后你可以看到就是发现这个转动，就匣子旋转的非常大，而且这样呢我们反复试，再让我们发现这个太大了以后呢，我们就把它翻转，翻转以后呢就往心房面再拉，拉完以后呢重新调整。那这里呢有2个因素，第一个因素呢就是可能我们的心房面转的太多了，叫交往过正，因为在心房面转好了转多了，但实际上我们这个在这个松这个不断的调整这个夹子的时候啊，实际上这个我们距离不够大，所以导致它整个转起来张力没有完全的送到里边去，这是一个因素。第二个因素呢，就下面的结构啊，这个病人实际上我们看到后叶就在我们夹臂的区域有一个明显的腱索，所以腱索有时候它也会不断的去顶这个夹子，也会导致它这个方向的改变啊。所以这个病人我们在调夹子的方向上调了3、4次，最后我们这是第2次也是不行，重新又拉到心房面又来过，反复多次。所以这里我们的体会是，宁可刚开始麻烦一点，也不要等夹子缠住了以后再麻烦。所以我们一定把这个夹子方向各方面调好了，我们再开始夹臂啊。所以有时候我们前期会花的时间会比较长，但希望后续夹臂，因为夹臂以后呢可能对半叶会造成损伤，不要反复的去夹臂，夹了1次就希望能成功，就算调也是微调，所以这样就会比较好。所以这个病人最后我们是把方向都调的比较好了，你看在下面我们适当的做了一点点微调，而且避开了那根腱索，所以夹子调好方向以后再往回夹。那夹的时候呢，实际上对于 FMR 来讲会碰到难度， 因为有时候我们说心脏比较大，瓣环比较大，两个半叶之间有一定的 gap， 我们选的又是短夹子，所以有时候很难夹。所以这个病人我们刚开始尝试是同时夹壁，你看根本就夹不住，根本就不给你夹壁，夹不住，所以这样就会很痛苦啊。所以这个用短夹子在 FMR 当中，这个是比较常见的现象。所以到后来我们没办法了，夹不住怎么办呢？夹不住以后呢，我们就想着就看看能不能就分开夹壁。那分开夹壁呢，就是我们先把这个前叶夹住，因为前叶最好夹了。前叶夹住，因为摆动比较大，我们希望夹住前叶以后呢，再把它兜到这个后叶里边去，把后叶兜住了以后，再把后叶夹住。这是刚开始我们的想法。但有时候这个理想很丰满，这个现实很骨感，这个有时候就很难做得到。所以我们尝试了几下，不行，做不得。你根本就不可能把这个后叶给兜住。后叶你看，从这个后叶看起来很薄，而且这个后叶呢又很短，所以这样根本不行。所以到后来我们只能放弃，只能把这个放弃，先夹前叶再夹后叶。所以到后来呢，我们就尝试换过来。那我们把前叶放开，那我们只能先去夹后叶。那相对来讲呢，后叶你说去夹它呢，应该相对来讲会容易一些啊。我们单夹一叶，把这个夹子呢再往下送一点点。这个时候呢，我们再往后捞过去，把夹子呢略微关的稍微小一点点啊，这样呢我们可以宁可你看就是把后叶可以把它夹到根部为止。好，这个后叶我们可以看到后叶下去了，下去以后呢，这个时候呢我们可以适当的再往下走一点点，也可以往前稍微靠一点点。但这个时候呢，你看夹着这个前叶它根本就上不去，那你怎么办？你看它一直在摆动，所以呢我们中心王书记我们一直商量如何把这个夹住。所以因为幸好它是可以单边夹壁，所以我们就叫跳夹。你看就当这个前叶刚好往上跳到这个夹子上的时候，我们一下子就数牢，对吧？就是上下上下，刚好数牢，当这个夹子往上在这个夹子上的时候，我们一下子把前面这个放下去，所以我们把它跳夹。这样呢跳夹了以后确实把前叶夹进去了，夹进去呢也感觉挺稳定，所以这个时候呢我们也在超声指导之下就慢慢的把这个夹子给关起来啊。那关起来以后呢，确实发现还是不错，因为这个夹子确实你可以看到后叶夹的也够多，前叶夹的也很稳定，能够达到我们的一个需求。而且我们可以看到用短夹子夹完以后，这个虽然是 FMR， 就比我们想象中的要好很多。我们觉得哎呀这个可能效果没那么好，可能也有可能会用2个夹子，最后发现1个夹子出乎我们的意料，夹子非常好。而且我们从 glass view 里边来看，因为 glass view 看这个反流是一点点反流都看得很清楚，最后就发现这个反流几乎没有。而且从这个压差来看，压差只有1个毫米汞柱啊，所以最后这样的结果应该是非常理想的一个结果。所以应该说这个 Dragonfly 它做 FMR 用短夹子也有它明显的优势啊，因为它短的宽的，用宽的相对来讲可以略微多夹一点点，而且呢用1个夹子不需要用2个夹子，因为有时候对 FMR 来讲用2个夹子反而不利，因为你说1个夹子就能改变前叶和后叶，包括整体的一个瓣膜的张力，你另外放个夹子进去以后，你张力改变了，反而到时候可能会引起新的反流出来，反流可能从一边挤到另外一边，或者2个之间有问题啊。所以说通过这2个例子啊，那应该说我们这个 Dragonfly 系统在于 FMR 和 DMR 当中都会取得比较好的一个疗效，这是最终的一个结果。好的，这个就是我今天的汇报，大家有问题我们可以做一个现场的一个沟通和交流。好，谢谢大家。
先宝跟王书记这2个 case 应该是非常精彩。好，我不知道线上各位嘉宾有没有什么讨论的点，谢谢。Hsien-Li
对，这2个 case 确实很精彩，这也是我第一次看到我们这个国产的这个 Dragonfly 它实际上的一个操作那我是不是可以请这个罗教授还有王院长跟我们讲一讲，就是说就这2个病例来讲的话Dragonfly 它有什么样一个特别的优势？那么反过来讲呢，如果说是使用 Mitral Clip 的话，可能会碰到什么样的情况会比较难处置的？
谢谢殷教授，谢谢高教授。这个我代表我的老师来回答一下，因为我觉得首先从这个 FMR 来讲，这个 FMR 因为如果说用 Mitral Clip 的话，它就不能做到单边的夹壁，所以做不到单边夹壁呢，我觉得就会比较难，除非你就换长夹子，就用那个 XTR。但用 XTR 对于功能性反流来讲，我觉得不是太好的选择，因为它本身这个半叶这些张力比较高，所以你用长夹子的话，容易对这个半叶张力更高，就容易有一些这个对半叶的一些损伤。那对于这个第一个病例 DMR 来讲呢，因为我们现在目前大陆它这个没有 G4 系统，它只有 XTR 或者 NTR， 它没有宽的夹子，所以我觉得这个 Dragonfly 呢，它有4个型号，用宽的，你也想这个病人脱垂面非常宽，而且它这个脱垂的高度也很高，用2个长加宽的夹子就能够解决它的问题。所以我觉得就是主要是在一些型号啊、单边夹壁啊，在这方面我觉得可能比 Mitral Clip 目前这个在中国市场上的可能会有优势。但如果是 G4 进来了，那实际上我相信的这个功能方面又一样，它无非就是在操作上面更加可控一点，就一步一步。对于新手来讲，就是可以它可控性更好一点，因为 Mitral Clip 就是高手做可能会好一点，随心所欲，因为尤其是这个配合，你有时候2个手啊之间要配合的很好才可以。但这个 Dragonfly 呢，你就一步一步调，慢慢做，是不着急，主要是这样。
谢谢非常详细的介绍。
感觉上好像跟 G4 或者是 Pascal 比较优势会比较相近嘛，就是阿宝的 G4 的 Mitral Clip， 它也是可以单边夹，不过单边夹唯一的问题就是你那个 twist 的那个程度不能够太大，你那个torsion太大的话，反而把它整个解剖半叶的解剖又改变了，然后又可能有新的反流。那不过我完全同意刚刚先宝讲的，就是先宝教授讲的，就是你用太长的夹子，在 functional MR tension 是真的很大，因为我们以前有经验，就是夹了下来都很好，结果后来就是纵向的在它的边上面这样撕开，所以那个就非常非常难收拾了。所以这个是我们自己的经验。另外就想请教，在 FMR 你主要的问题还是出在左室嘛？左室如果持续扩大，你们有没有随访说有这些问题的？就是左室它还是 remodeling positive 的 remodeling， 最后造成这个反流又复发的。
谢谢殷教授这个问题。应该说我们实事求是讲，我们的经验不足啊，因为用这个夹子来做啊，实际上我们现在做的还是比较少。我们是2013年、14年做的一些 FMR 的病例，我们也随访了，确实对于功能性反流来讲，刚开始效果挺好。那如果说对于药物反应敏感，如果说我们夹子夹了，这个病人血压也升高了，给我们药物调整空间了，这样的病人效果非常好。但如果夹子夹了以后，这样的病人如果说血压还是没有很高，药物调整还不上去，继续的 remodeling， 他后续这个反流还是会出来。但因为我们现在这个总体的例数还是不是特别多，所以我想未来还是会累积更多的经验。但确实我觉得关键是夹子能不能给这个患者争取一些空间，就尤其是增加药物种类、增加药物剂量的空间来改善心肌重构，我觉得这才是最关键的。
是的，谢谢。其他炯昭教授、还有施志远教授、还有Ying-Hsiang教授有没有什么问题？
有个问题想请教。
施教授，
很恭喜这个王院长团队哈，我看非常成功的2个案例哈。那我对这个国产的产品是有一点不太了解，是说他刚刚有提到它有个特点，它有个 filler 哈。那我想这个 filler 它的作用是什么？因为好像在刚刚的这个过程里，我没有特别的听到这样子。
OK， 这个 filler 呢，实际上跟 Pascal 那个 spacer 的原理是差不多的。那从整个设计的初衷里边看，它其实也是主要中间增加了一个阻挡的东西以后呢，第一个可以降低对这个半叶牵张的一个张力，第二个通过这个 filler 以后，再加上它整个设计呢，它可以做到这个夹合的角度可控，就是我这个不一定说非得夹到一定要全部夹壁为止，那个可以夹到30度、40度，有时候我们用2个夹子，半口面积比较小的，我第2个夹子就可以给它稍微松开一点点，这个压差就可以从6降到4或者降到5等等。我看王书记这个现在在线上讲补充一下。
刚才 刚才有点事情，他那个无机治所就是刚才那个刘向宝主任也补充了，就是说你可以保持一定角度，45度以内都可以，也可以完全消失，让它完全没有。所以它跟概念上跟 spacer 是不一样的，它叫 filler， 它不叫 spacer， 它就是可以夹紧，完全让它消失，或者这样，它不会松掉的。你把它分离，它不会说松弹开来了啊，不会，只要没有关闭不全就行。没有关闭不全的话呢，这样又保护半夜不会夹伤。另外一个呢，也可能有时候不会狭窄，反而。这个全口翻译系统还是很有特色的。这个还有一个呢，我觉得它的那个传输系统也比较概念上比较简单。它一个大鞘可以前后左右，一个中鞘也是前后左右，然后送夹子的那个 CTS， 那当然就是往前送可以旋转，就它这个相互之间的关系比较简单。还有一个呢，特别是你初学者，你没有完全 override 的时候，它也可以打掉，还可以打不少弯，你不要担心它会有太大，你打点弯嘛，你再给它 override 一点，所以就对初学者来讲 override 就比较容易，所以操作系统还是它操作系统机械化程度比较大，不会像有的系统就是来回靠人这么拉弄啊，这样它就不会这样。刚才当然讲到这个 FMR 的时候呢，我们也是有经验体会的，特别是这个对它的 mechanism 和 anatomy 要有个 understand very deeply， 你要很 understand in detail， otherwise 你可能就不一定会取得好的效果。所以刚开始我们对 FMR 也是加一个大的长宽的，一加以后反而旁边到处都露出来了。所以有的时候现目前看还是 Carpentier 3B 是比较适合的一个 FMR 的 indication。那个因为 H 的话，有的时候心房很大，把半宽拉大还是比较难的，所以呢 ，Carpentier 10B 呢，有的时候往往是短宽，刚才刘主任也介绍短宽的夹子，就是把后叶筋抓住，前叶的一部分夹住，就可以。行，谢谢大家。
谢谢。来，其他还有没有什么问题？是，
我想问一个问题。
是，
像刚刚提到说这个夹子夹住以后，那个 valve 的 tension， 在术中我们要怎么去评估那个 tension 到底是大还是小？有没有比较量化或者是 image 上的可以讨论？
对，这个 tension 呢，就是说你主要还是看你有没有，所以我们不断在释放张力，就是说你夹的时候，你不要往心房里头顶，如果你夹起来的时候往心房这顶起来了。就说明你的碳性很高了，这时候你就要慢慢的这个释放张力。当然你说把半叶两个拉得很紧，你只要是根部，你不是说你只要恰到好处的夹到它的这个在你的范围之内，夹的范围之内，你把它拉起来，那多半来讲你都是在你的碳性都是在你的里面，但是旁边不要过多的反流出来了，反而过多的反流出来了，那有的时候我们也会调整，把前叶少夹一点啊。或者把后叶少加一点啊，让它减少一点它的 tension， 这当中自己去感觉了。但是在整个这个 system 你要释放张力的时候，其中很重要的一点就是你夹上来的时候，有的时候因为你顶在上面夹，它这个时候它往上顶，这个时候张力比较高，你要往前转一点，让它沉下去。它的夹子的根部是不要超过这个半环水平，应该在半环中间或者下来一点，这样的张力就比较恰当。
我们的经验，那个夹的组织的多少也是有关系的啦。你夹太少也是会出事，夹太多那个tension就很大。
对，这个有的时候要体会一下。有的时候你感觉可能拉得太紧的时候，你就给它这边稍微少夹点，往那边移一点。
谢谢。
OK， Ying-Hsiang有问题吗？
我想问一下，就是说我们这些就是单边的。这样的夹跟 filter 这些器材改良，那我用想象的就是说我们的机械运作应该会更复杂，那不知道这个会不会带来就是我们的整体操作，或者说它的空间上或是整个 device 的 size 上面会有什么样的一些改变，还是单纯都只有好处而已？
你说是 independent grasp 先抓一边。
是，我是说，那这些器材它变得更复杂之后，那它有什么样的一些潜在的缺点，还是它都只有优点？
当然，我觉得如果是单侧这种功能加进去，我觉得我只看到优点。我当然它有的功能，比如说你单侧抓，你就一定要小心，你抓第二个时候，它可能已经 orientation 已经变了，这是我们时常变的，就是你本来没有这个功能，反正两个一起抓，当然你往往它 orientation 不容易变，你一个一拉，再往它拉过来的时候，它 orientation 变了，所以你要不断的在这个 sliding and fast 去看它的 orientation 怎么样。这个倒是说你没有这个功能，反正你两个一起抓的，一般来讲orientation不会变，但有些功能你是要注意它可能带来的另外一方面的不合理性。但对这一点来讲，肯定是方便的。你现在抓不住，两个手让你抓一页，这点来讲可以。但是它的另外带来的问题，可能你要考虑到，这个是器械本身所带来的一些问题。
好，是各位还有没有什么问题？好，那就没有的话，我们就接着下一个 case 了。今天有3个 case，
谢谢，
所以应该还不错。谢谢啊，王书记，你们真的是做得很精彩，而且大陆这个研发的沃土啊，这发展出来的，再加上你们的脑袋真的是不简单，非常好的器械。
向我们台湾的同事们学习。
谢谢，谢谢，
谢谢，
谢谢，谢谢。
导播，我们是不是放第2个 case 了？
英父，你可以听到吗？
是
OK，
好，我们看到了。我们欢迎达新教授也上来了哈。那这个 case 应该是一个 TAVR 的 case。那李医师，你要不要稍微简单介绍一下？在台上的是曹殿平曹主任跟李永在李教授。
把 slide 放开。放 slide。好。那个，这是一个86岁的女性，那因为这个近几个月来，她都是有呼吸困难的状况，她曾经有这个眩晕过跟晕倒1次，那 comorbidity 是高血压，然后高血脂，那 CTKD stage 是3到4之间 ，depend on 她的这个水分的状况。STS 是 2.5 ，Case Frailty Score 是0，然后他大概平常还可以走路，可是因为这几个月来 AS 的关系，所以他走路就是越来越困难。Hematocrit 是30，然后 Creatinine 是 1.7。下一张，下一张。那 Echo 太多了。Echo 的话 ，function 是好的 ，Pressure Gradient 是43/65，AVA 算起来是 0.5。好 ，MR 跟 TR 都是mild的。Next， 那在我们医院住院检查的时候呢，那么他的这个 EKG 呢有 paroxysmal atrial flutter fibrillation， 然后有 RVR 跟 SVR 的状况，而且 long pulse 有 3.5 秒，所以我们认为他这个是 tachybrady 的一个心状。那大部分的时间他都还是一个 sinus rhythm。Next， 我们做的 multi-slide CT 的话呢 ，systole 跟 diastole 是差不多的 ，parameter 是 77.7， 然后 parameter below 的 annulus 的 size 是 24.3，Netman 的话大概有14，然后 RCA 是12，3 masaba 有31，然后钙化是比较少，所以我们今天这个 case 要做一个钙化相对偏少的一个 aortic stenosis。Next。那么它这个 ST 的这个大小的话呢，是 ST 的大小是 26.4， 然后高度是19。那么 coplanar view 的话是这个 crossover rate 是 IO 19 ，code 19。那么这病人的 Midas 的 membrane surface 是 2.55， 然后他自己的 membrane surface 如果以 corner view 算起来的话是 11.5， 然后他的那个 iliofemoral 的话它是好的。好，那刚刚我们有做准备，这个术前的准备，然后能不能请曹主任帮我们讲？再下一张。
我们是先置放个 Sentinel， 现在我们大概几乎是 routine 会置放 Sentinel。那下一个，
我们看一下怎么放 Sentinel。
太快了，
目前已经上市了，台湾的各中心应该都开始慢慢放了啊。
好，那这个我们会把那个，我们是用那个 Choice PT Extra Support Wire，Next one，我们会用那个 pigtail 来当 guide， 那知道它的 in brachiocephalic artery 的那个 ostim 在哪里，那这时候把这个 proximal 的那个 filter 把它置放在近端的那个 innominate artery 的地方，这是那个 filter 把它置放开的一个状况。下一个我们可以回到第一个做 arch 的这个 angiography 吗？这个比较特别的哈，就是说我们刚开始都 approach 不上去，后来我们照个 view 发现这个有点像波脉的那个 arch。我们可以看到那个左边的 common carotid artery 几乎是从那个 innominate artery 出来的，所以我们后来就尽量下一个，当我们要 approach 这个左边的 common carotid artery 的时候呢，我们就把这个你看这个 tip 把它 curve 得很近，把它几乎 curve 到那个 innominate artery， 然后呢再 approach 这个左边的 common carotid artery， 那这时候把这个 articulation sheath 呢把它拉上来。把它卡上这个 carina， 我们把 distal filter 放上去，放到左边的 common carotid artery， 你可以看到，我们把它卡上去再把下一个，再把 distal filter 放上去，好 distal filter 得到左边的 common carotid artery， 那这时候我们就完成了 procedure， 那我们可以看到，你给它过那个 pigtail 看看。我们可以 check 那个 pigtail 会不会有跟这个 device 有任何 interaction？ 那这样看起来，我们在过 device 的时候应该是很顺利的，这样就没有任何 interaction， 所以这是不会影响的。那我们就再来做我们的 procedure 这样子。我们现在准备 cross valve， 这个 case 主要是它的那个 aortic annulus 的钙化非常少。那当然对于非常少的那个 aortic annulus 的那个 calcification 那个 valve 的选择，不知道各位专家有没有什么特别的 preference 或者有没有特别的 common？ 那我们今天是打算是选择用那个core valve 那不知道各位专家的意见。
好，各位专家不知道有没有讨论的点？建立。
李教授。
是王书记。
做得非常好。我想请教一下，像您这个 cerebral protect 是那个 Sentinel 吗
？Sentinel。
对，像你们用这个，我不知道台湾医保是怎么样情况。像这样情况，你们有什么 indication 吗？像这个病人钙化不太重，就是3月半，一般有没有什么 insurance 上面有没有什么 policy？
一般我们几乎做它现在如果因为是医保没有给付，所以一般我们如果是只要做这个 TAVR 会跟病人做一个说明。那病人如果愿意的话，我们在任何做 TAVR 的 procedure 我们都会放这个 Sentinel， 甚至做 Mitral 的话，现在我们也希望能够放这个 Sentinel 来做那个 cerebral protection。
还有一个，我看您这个起搏电极是不是专门为这个病人？他不是平时没有装起搏器吧？只是你们故意做一个 active 的 lead 来 protect， 是不是？
就要装起搏器的。
他这个不是他的 baseline 他有曾经发生过 complete big block， 所以他的 system 可能就不是很好了，所以我们就直接先装了。
好。
关于这个半夜的钙化比较少的情况，各位的经验不知道怎么样？会选比较大的瓣膜？那有没有在放置过程特殊的考量？各位教授有没有什么经验分享？
我就觉得说这个病人当然瓣的钙化是比较少，比我们一般看到的少一点，但是还是有了哦。那我不晓得你们选择的是Evolut R 还是 Pro？
这是
Pro 嘛因为 Pro 的话，它有多上的这个 SCR 等等这些，我是觉得说对于这个比较钙化少的病人，应该是很好的选择。那同时它也还是有一个调节释放就是调节回抓的这个机制在，所以我觉得选择 Evolut Pro 是一个很好的选择。
是，当然 Evolut Pro 的选择还有一个考量，就是因为现在可以做比较大家都讲究 cross overlapping。所以即使选大一点的瓣膜，压到传导组织的机会也会少一点。所以我们现在大概都例行的会量的 membrane septum 的长度了。 像这个 case 大概 membrane septum 长度在 annulus 以下是大概 2.55， 在整个的长度当然是蛮长的，可以到10，所以大概也不能放太深啊，因为放太深还是有机会去压到conduction system。那我们讨论这个 case 最主要是说，如果是一个没有很好的钙化 anchoring 的情况之下，大家经验会放多深？会不会刻意的放深一点，免得它弹出来？
我想，我们医院的话，操作大概还是原则上是不会 intentionally 太深。那当然在完全释放之前，我们会稍微等待一下时间，让它跟组织之间的 interaction 能够比较完整。
不要动手，别动啊！
我想请问一下，就是说这个 case 在已经有测量 membrane septum 的情况之下，不知道有没有预期，就是说我们认为可接受的最深深度可以到哪里？
我们一般认为这样子的深度用 Midas 这样算的话，大概就是3 mm 最多了，再深可能就会有事了。那 Cassowary 当然还有一个讲究的地方，就是它是从上往下放，不像我们过去都是先跨半了以后再从底下往开了以后再往上提，这是2个非常大的不同。那这样子的话，对 conduction system 的影响也会减少。
对，
我们大概就直接做不做 pre， 直接置放这个瓣膜。那我想这种钙化少的，其实2种瓣膜应该都是有人各有各的 preference 了哈。如果用 balloon expandable 的话，你可以 rapid pacing， 那瓣膜会很稳定，那慢慢释放，其实也不错。那这个的话，就像刚刚高 P 讲的，这个瓣膜我们可以 reusable， 可以再回收，可以再 reposition 然后可以不满意可以再重做，那这个是它的好处。所以这2个我想到都是一个可以选择的地方。那我们还是会按照这个alignment conventional alignment。那我想大家都知道，这个 flushing port 可能会朝着3点的方向，尽量保持这个 head marker 朝着 out curve， 那这样可以得到一个很好的这个 alignment 那对以后的当然 coronary issue 的话也会比较减少。我们可以看到这个 head marker 是朝着 out curve。那我们在 LAO 的这个方位我们可以看到 Sentinel 在那里几乎是没有什么 interaction， 所以是很 safe 的一个很 safe 的一个 procedure。来给我来，那到这个方位的时候 head marker 会朝这个也是朝着 out curve， 所以这个 alignment 算是 OK。我们再把它调到 cusp overlap 的一个角度。
这也不能放太深，因为它大部分是看。
那样。好。照个线好了。有吗？好。因为这个病人还有一个问题，就这个病人的 renal function 不是很好。所以其实选择这个瓣膜也会减少 contrast 的使用。那我们把这个这样通常都在这个 pigtail 的下1/3的地方我们就慢慢的 release， 让它慢慢的下去 release 了哈。
预备
第3个，先等一下，小推一下。
在这个角度，大家会发现呢 ，head marker 是 center front， 就是朝前面。
好 ，pacing 120哦，开始。我们还是做一些 control pacing， 让释放稍微稳定一点。可以快一点。好，这边可以快一点，好，让它到 no return 的地方。好，那我们这可以照个相。就好了，因为肾功能，我们直接到左边照 LAO 照那个 parallax， 我们比较喜欢用这个角度来做最后的 final release 的一个角度，这样可以 check 到左边的冠脉啊，开口没有受到影响，也可以看到深度，还可以吧？有点浅。
因为这个病人他本来就有 pacer 的置放的计划了，所以你现在的深度 OK 吗？
我们想说因为钙化少，我们还是再稍微回收一点，再让它深一点点。没关系，没关系，那没办法。往上拉一点，要不要？啊。没有再回来。回来看手回来。稍微按照那个来。
我想刚刚那个状态会弹起来。
对啊，非常险，我觉得。
所以钙化少还是有一点点的这种风险。
对，再下去一点。对，我们这可能再稍微深一点。
所以可以看他们在放，还是希望就是 top down 的方式了哈。那一般 Castle 是从 pigtail 的那个 loop 的中间，那你也可以从下1/3开始放。
对，好像在后座要顶一下哦，顶一下啊。这个位置可能比较好一点啊。
对，
比较原来深一点。好，来左边来。想好了 ，OK， 好，这边好比较多，那没关系了哈 ，OK， 好，那我们就
大概是4个 mm，
就 release 了哈，啊 ，pacing
把 tension release 掉
，release 了，
我们就 release 了，松掉好那个，我们 Safari 就给它完全 release， 没有什么 tension， 慢慢释放，
可以准备。
OK， 开了吧？没开呢。
还有一个还
够着。
这个角度看一下，应该是开了。
应该开了，对。
开了。
好，好，我们先把那个沙菲留着好了哈，稍微留着。对。好 ，T 看一下来，看起来好像那个，看起来好像没什么漏哈。
minimum
没什么漏，然后整个 security 也算你还可以。不知道各位有没有什么特别要 comment？ 是不是我们要再做 post type 或者这样你们可以接受？
现在的 QRS 还是窄的嘛，是不是？
对。
有一点 bundle branch block， 有一点，但是它是 sinus reason。
好，各位专家的意见。
你看，
我觉得它这个深度是非常的好。
是。
第二次调整过的这个位置是很好。那个人是觉得可能不需要再做 post dilatation。
拿出来好了。
因为他的腰身什么都应该都已经开了啦。
把它拿出来，然后没有，拿不出来。这样对吧？我知道意思啊，就换成，不然你照不好，你 centrally 给到这样，整个收了再照。
你现在
我们就把那个 Safari wire 收起来好了，我们就应该也不需要做那个 post style 了。那收完以后，我们再做个最后的 angel 看一下。
所以曹 Sir， 你们的习惯也是就不会在最后再量 gradient 哈，所以不会再放一个 pigtail 进去量。
现在都没量了。
你们都不会。
因为刚开始都还是有量，现在都没在量。
我们现在是因为还在做一个 hemodynamic 的一个 study 啦，所以我们 routine 还是会进去量。
是，谢谢。
那你们的经验就是说，在比方说hemodynamic 改变的情况之下，量出来的 AR index 可靠吗？还是 echo 比较可靠？
我们现在还是比较相信 AI index， 因为当然你晓得在台大我们目前是 minimal invasive， 所以通常不会有 T 啦。那我们通常就是看angio 跟 hemodynamic 跟 AI index， 我们比较相信 AI index。
是。
那我讲的 hemodynamic study 是我们有另外做一个，就是我们要跟生理所在做一个数值分析的研究，那么希望去寻求一些 parameter， 所以倒不是单纯的为了看 AI index 等等。对，不过我就说，我刚刚只是说，这个在最后 procedure 的时候 ，routine 上会不会同时再量一次 simultaneous pressure tracing？ 我想这个可能各中心的做法会不一样。
是。达新教授，你们在复旦还是例行的量吗？达新教授，量的哈。是。
因为我们通常还是用 T 比较多哈，那有时候我们还是会。就是用 T 直接量那个它的 gradient 这样子，AI index 就没得量了。
通常我们也会看舒张压了，跟 dichotic notch， 如果都很好，大概发生问题的机会也不大。
照个相啊。
Ready。量一下，可能给我们很多的一些信息啊，提供很多的信息。除了这个 gradient 以外，还有很多其他的信息。
是，
还好，没有还好，
基本上没有什么漏了。
没有，非常好啊。
是，我们也感觉这个 Pro 感觉上是漏的，真的是比较少。
是，
对，根据他们最近发表的，几乎 Moderate 上的很少。
对。
唯一的克星可能还是钙化太多了，像这个病人他少，然后又对称分布，这种一个 Pro 塞在里面塞得圆圆的，就结果就会很好。
我想这个看起来它的 implantation depth 有稍微深一点点，不过因为钙化少，这样其实算是还可以接受，并没有太多的probable leak， 所以我想我们大概就这样就把这个 procedure 就可能就结束，不知道各位满不满意？那我这样可能要把那个 Sentinel 收起来，
是我们是不是也看一看 Sentinel 收的？
那我先把那个 wire 从左边的 common carotid 再拉回来一点，然后把这个 filter 把 filter 收进来以后呢，把这个整个 curve 往下推到 aorta 的地方。那把它的 curve 恢复下来，恢复过来。因为这个 curve 刚弄得很大，所以大概最多只能到。如果一般的话是可以直接蛮直的一个 curve， 那这样下来。这时候把那个 proximal filter 然后收起来。
还没收哦。
对，等等。好，这样收起来啊。
OK，
好。
那这个跟你们之前在做 carotid 可能完全不太一样经验，就是捞到的东西其实也不多，可是小的 debris 是很有的了。
是，刚刚大家也有讨论过这个 Sentinel device， 因为就像刚刚殷主任解释的，台湾目前是自费啦，所以我们是目前还用的很少。Sentinel 当然它对于两边 carotid 的保护，但是它对于左边的 vertebral artery 还是没有保护到。对，然后再过来一个就是刚刚殷主任讲的，就是好像看以前的经验，好像 Sentinel 做完了以后，能够真正看到有收到什么东西的几率不是太大。当然可以把它想成是买一个保险，所以我想这个可能就是看各个病人的情况来决定。如果说主动脉上面真的斑块很多，非常粗糙毛糙的话，我想用 Sentinel 应该是很合理的一个想法。
我觉得袁院长，我觉得这个收这个东西还是真的必要。我确实收到过东西啊，钙化斑块，
收到过啊。
我可以在上面给你们看一下，展示一下。
我们就把这个 filter 把它剪开，应该还要 flush。不过就刚讲的一样，通常就是 micro particles， 肉眼可以看到的 microparticles， 但是比较明显的大的不多啊。我们做了应该有20-30例了，大概只有1-2次可以看到很明显的 particle。
那也是很厉害了，很多了。
我把这个冲洗完以后，把它倒在 filter。都是几乎是 very tiny 的。没有，真的看到有那种大的，像书上写的那其实那个 frequency 不高。但是如果真的是10几20个人能够弄到一个大块明显的，那应该就划得来。那这看起来还是有一点点的，这不过很小很小。对，大部分都可以看到，直接 direct vision 一下可以看到 particles， 但都是很 tiny 的，大概这样。好，不知道各位对这 case 有没有什么特别 comment 的地方？
高斌，你们做很多 neurological 的那个，还有 neural recognition 的这些 follow up 哈。
是。
根据你们的经验 ，TAVR 以后的情况，可不可以跟大家 share 一下？
我们看就是说做完了以后，因为整个 cerebral perfusion 改善了所以其实 neural cognition 确实是有进步。主要表现的还是在一些比较高的功能性的评估，所以如果我们单纯只是看像 modified ranking 啊这一些，可能看不太出来。但是如果给他做一些 tasking 比如说像对于一些短期记忆啊 execution 啊这一些，还是可以看得到有进步。
是。所以这个
是我以前院长你给我看，这是我以前收到的那个钙化斑块，能看到吗？
是。
是，真是。那是那个捞到了，肯定是对病人有很大的帮助。
赚了。
对，这个就是保险买对了。
因为真的也很难算计，像我们上礼拜做了一个，就是那个wire tester 夹在外面收不回来嘛哈，我们
这是我以前做的那个房颤那个病人
是
风德收的。
是，
那都收的非常非常多的这个水伤，非常多。
是，
我觉得值啊，做这个还是值的，
还是值得。
值
得。达新教授把那个相片送给我们，然后我们以后病情解释的时候可以拿出来。
好的，我发给你，我发给你啊。
好，谢谢。好，那这个病人大家不知道还有没有什么讨论的点？如果没有的话，我们就请达新教授是不是秀一个复旦中山的录播的 case？今年这个疫情还是把大家搞得不太方便哈，不然我们
文字呢？文字上来了吗？
还没有，
还没看到。
没有，我要放
好，文字上来了。
好。
文字你可以露个脸，开个麦克风。
文字送吧，让文字解说。
好。
我一直在的，刚才是没。
谢谢。
刚才是没打开摄像头。
是。
就找我机器了。
好，谢谢。那文字就秀你们的 case 吧。
好的，感谢殷教授的邀请啊，各位专家啊。中午好啊！今天来受到殷教授的邀请，我们来展示一例病例啊。这个是本来是我们病例都写好了，然后实时录播一个实时转播一个病例。结果呢，筛选的时候啊，因为这个是用一个新的器械，然后在筛选的时候呢，发现那个病人的瓣环太大，超出我们这个做了 CT， 超出我们这个瓣膜设计的这个要求，所以就不能进行实时的直播。不过呢，我们是做好了那个充分的预案啊，就是可能就想到的时候可能录播找不到病例的这个问题，然后我们之前就提前录播了一个病例，这个病例呢前一段时间录播了，从来也没有展示过，也是个新鲜出炉的一个病例。那么所用的器械呢也是一个 比较新颖的一个器械啊，叫做 Lucibet Plus 啊，3件半置换啊，3件半置换，这个是目前来说呢是全球龙座
我们看到了，
金血
继续
啊，龙座金血管的这个瓣膜应该来说呢，目前还是比较少了，在全球范围内，所以呢，这个器械呢，以及这个手术呢，还是具有一定的这个领先性啊，这个那么我们先来看病例的情况。那么这是一个77岁的男性啊，有这个3件半的一个关闭之前有房颤啊，有机械瓣，2件半机械瓣啊，置换过18年。然后呢，他是一个高危的患者，因为他已经做过1次手术，又高龄啊，他的 STS 评分跟 CRS 评分都是很高的。那么我们要用的瓣膜呢，就是 Lucibet Plus 啊，就这样一个器械啊。Lucibet Plus 呢，这个器械呢，它是在它的瓣膜啊，跟它的前一代产品 Lucibet 是一样的啊，有个心房的一个软盘，然后呢，这里有2个夹持件来夹制瓣叶，起到固定作用。这里呢有一个10间隔的一个铆定啊，10间隔的一个铆定件，这个可以贴靠在10间隔上，然后打钉，然后呢把这个瓣膜铆定在，就用10间隔拽住，然后再加在2个这个铆定件，这样3点。通过这个3点的固定力来固定这个瓣膜。那么用的这个鞘呢，就是这个新的啊，原来的鞘呢，原来1代的产品呢，它是经心房啊，经右心房植入，所以还是要有一个开胸啊小切口来做。那么现在新1代的产品呢，它是经颈静脉啊，从颈静脉这个弄一个划一个小伤口，然后呢穿刺啊进去做了啊，可以把原来的比较大的创伤进一步做到像接近于经皮的这个方式来做这个3件半置换。那么它瓣膜有40、50、55啊3个尺寸啊3个尺寸。那么因为我们筛的那个病人的瓣环已经超过他这个55了啊，将近60啊，这个很大，所以呢他就无法做这样的一个手术。那么它的这个输送鞘呢是有33F， 这个是33F 啊，外径35，所以它必须有一个引导鞘是36F， 这引导鞘的外径是36F， 内腔呢33F， 刚好来导引这个鞘管啊。那么术前呢必须做一个 CT 啊 ，CT 这个计划来一个呢就是选择多大型号的瓣膜，第二个呢来去寻找术中的这个头罩角度。术中来讲呢有2个重要的头罩角度，一个呢就是3件半环切线位啊，像这样把3件半环呢打成一个切线，这样呢我们术中在瓣膜的时候就可以观察到我们放的瓣膜是不是跟3件半环是同轴的啊，这个时候要来看瓣环有没有斜掉，有没有同轴。第二个呢是10间隔的冠状位啊，就是看看10间隔是不是正对着我们。那么10间隔的冠状位呢，它的意义在于这个我们在打10间隔铆钉的时候要使得呢这个10间隔的那个贴片铆钉跟它是贴合的好，贴得很好。那如果要观察它是不是贴得很好呢，那就要在这个体位上观察啊，观察。所以总之这2个体位是重要的一个体位。然后呢再测瓣环的大小呢来选多大的一个瓣膜。当然了还要去看这个角度，就是说我们从静脉进去了之后呢，这个系统跟它的这个角度是不是同轴。那么再回到这里，实际上这个系统它有几个功能，一个呢它是这个末端可以伸缩啊，可以伸缩；第二个呢可以调弯啊，可以调弯；第三呢可以旋转啊，就顺时针逆时针旋转。这样通过这样的三个动作呢来使得来定位我们的瓣膜，使得我们的瓣膜跟系统同轴。然后呢它这里面还有藏一个针啊，系统里面还藏一个针，可以进去打针把这个10间隔铆钉上去，所以它整个这个输送系统还是比较复杂的，按键挺多的啊。那么这个是病人呢，术前呢我们这一个是进行 CT 测量，而且呢我们呢刚才还漏讲了一个啊，还必须测量颈静脉啊，颈内静脉的这个粗细啊，看看这个入血管的粗细要满足要求啊。这一般来说呢，可能要12厘米啊，12毫米以上啊的11到12毫米以上，这样来满足我们33F 的36F 的这个鞘管的一个要求啊。 然后这个病人的各样的数据啊都在这里。之后呢，我们就选择了这个55的这个尺寸的这个大型号的瓣膜啊，55的尺寸啊，它的这个平均瓣环的这个也刚好是平均瓣环刚好是在55左右，然后选择了一个55号的这个瓣膜啊。那么这个是他心超的结果啊，是个极重度的3尖瓣的这个环瘤啊，可以看到术前看到它的3尖瓣环瘤量是非常大啊，然后右心房也是非常大，3尖瓣环也是非常大。像这样呢，要设计一款瓣膜能把它锚定住，还是挺有挑战的，因为瓣环实在是太大啊，心脏实在太大了啊，这是心超的这个情况。那是术前的这个这是术后的情况。那么后面就开始播放病例。周老师啊，
那个它这个瓣膜呢设计的理念呢，它是不是靠定向支撑力去铆定？它是靠这个一个加持键和这个铆定呢是相隔上，所以在它这个副作用呢，就是说出现传导组织啊对这个传导数的影响就比较小。那么这个开始的是文字里一边因为太长一边放一边那个开始的呢，就是在右心室照影调整按照这个角度把这个2个切线位给调整好。你一边放一边说吧，你说。
好的，我来说啊，您来补充啊。刚才一开始我们就进行右心室的造影啊，造影造了之后呢，我们就把那个体位找好，就时间隔了体位调好，然后呢放入一根导丝到这个肺动脉之后呢，就是把输送系统送过来。可以看到这里就我们有弄了一个切口啊，稍微还是外科2个教授帮忙这里弄了一个切口啊，缝了个荷包。然后呢，这个是一个固定台啊，这个固定台就在它就是我们就操作都在病人的这个头侧啊，头侧这里啊，这个是机器啊，这是 DSA 机器，我们在头侧有个固定架，把个系统固定在这里，固定得很稳啊，然后呢，在这个输送系统的按键上进行操作啊，真正操作，那这里固定架，这是线条颈动脉，然后呢就把输送系统送进来啊，送进这个右心室啊，现在要进行跨到右心室。那么整个手术呢是前麻下食道超松跟这个DSA 双重引导下啊，你看看我们这个3维食道心脏在这边引导，那么 DSA 在这里引导，双重引导下呢进行一个手术啊，手术是的，怎么？
这个是呢，
有听到声音吗？
听到声音，听到的啊，很清楚。这个现在就是调弯。对，这个对这个调弯，它这个鞘呢是36个 F 鞘，相当于12个毫米的粗。人的颈静脉呢一点问题没有。我做的当然我们这个经验也不是非常多，总共做了十几例的病人，没有一个病人呢这个颈静脉不能够进入这个36的鞘，都能够进入这个鞘。
好的，这个之后呢，我们进行调弯，进行调弯啊，进行调弯调整这个。然后呢，进行调整吸动系统的这个跟3尖瓣的这个同轴线啊，刚才是一个调弯动作啊，把系统调弯起来，然后同时把这个伸直，一个调弯一个伸直，2个动作，然后它还可以旋转呢就可以使得要么靠间隔跟远离间隔这样的运动。
这个呢就是很缓慢的把这个角度呢，大的角度要调到90度或者90度多一点。前面呢，这个前面那个头啊，它是个圆的，是活的，它有一定的弹性，所以呢，对视间隔呢，这个张力不是很大。如果你碰到对这个心室壁，如果碰到心室壁的时候呢，它就会跳动，所以我们也可以看到。这是个照影，看了一下它这个相对的位置。那我这时候呢，我们就操作这个把这个鞘管往回撤，就 unshoes 以后呢，它从前面的2个兔耳朵2个就夹持键夹着这个3节半前叶的那个键呢，它逐渐就张开来了。
这现在还在调整这个系统因为他刚才讲了3个动作还有第4个动作就是这个系统推拉，这个系统一拉，它就这个东西就平行的往上走就是平行的往上走。这个系统往里面推的话呢，这个轴它是平行的往下腔的方向走还有第4个维度的这个运动来控制这个鞘的这个定位。所以这个前面的定位呢，可能是花了比较长的时间。我们现在呢，可能就是我们感觉到位了，开始按细子要把瓣膜放出来了所以前面呢花了比较长的时间，一直在调这个输送系统的这个末端跟这个3节半环链的这个同轴线这个是花费比较长的时间。对，现在开始释放瓣你可以看到它这输送系统的这一段它是可以伸缩的你可以看到它保持这个轴向，但是导致这个弯度跟轴向不动，但是这个系还是往后退了，所以它这系统可以伸缩来释放瓣膜
这个瓣膜现在这个瓣膜逐渐打开来了，就是两个
夹持键我们俗称它兔耳朵2个兔耳朵
对。
用这2个兔耳朵呢，要去勾前半的半叶。
如果能够勾到半叶的时候呢，它这个耳朵它就会
就像这样会跳动，就像这样跳动
那
么 DSA 下我们看它的跳动，超松下来是看看它是不是靠在前叶上。那可以看到下面这个跳动的很明显，这个肯定是勾住半叶了。那么这个呢还不太明显，所以呢还要进行进一步的调整到它也是这样跳。我们继续调整这个瓣膜的位置跟深度。术中呢有一个猪尾巴在这里一直可以照应进行调整。我们可能觉得这个位置不满意，然后呢又要把它收起来要重新再调整。
这个是因为剪辑的原因，所以你觉得一下子就跳上去，实际上是非常缓慢的一个过程
好，这是又进行调整，可以看到这个也开始在跳了2个地方都有位置在跳动2个兔耳朵都在跳动。刚才这个位置跟那前面的位置有点变调，是因为我们 DSA 的角度调整了调整了角度，所以刚才在这个位置，现在这个位置实际上的位置是差不多，只是我们投射角度有点把它调掉了。这里再看一下 好，等到我们这个瓣膜接到2个夹持件、2个兔耳都勾住的时候呢，我们继续放瓣膜啊，继续放瓣膜，把这个心室面啊，瓣膜的心室面给它放出来啊，把瓣膜放出来。放出来之后呢，它这个瓣膜跟这个夹持件呢，就跟柱体瓣膜呢形成一个三明治结构啊，三明治结构把它给它夹住了啊，夹住了。啊，继续放之后呢，就把瓣膜心房片也放出来了，瓣膜心房片放出来。然后呢，这个瓣膜夹持件跟自身瓣膜支架之间呢，会把我们的瓣膜夹住，会夹住啊。但是呢，这个时候瓣膜没有完全释放啊，心房片出来了，心室的支架也出来了，但是呢，还在连着一部分的心房面的这个支架，它是还没释放。这时候呢，我们进行
瓣膜开始工作了，这个
对，瓣膜开始工作，然后但是我们进行检查确认，就是到了这个程度之后呢，它就不能再回收了啊。就刚才呢，这个心房片放出来之前呢，这瓣膜是还可以回收的，但是到了这个状态之后呢，瓣膜就不能回收了，只能调整位置了。我们刚才觉得瓣膜有点位置有点不同轴，所以再把这个系统再调一调，使得瓣膜斜过来，通流性更好。
一个可以斜过来，第二个呢，它瓣膜呢还可以转10度到15度这样，就瓣膜可以稍微做一点点旋转。
那可以看到超声
旋转，然后呢，瓣膜还可以往前进一点，这样子呢，让心房面呢就彻底跟这个整个这个心房面的瓣膜和它这个瓣膜以及心房壁呢贴得牢一点，这样子呢就不会有这个差异分流。这个操作起来实际上比较简单的。
这个到这个地步了，确认瓣膜位置好的时候呢，开始要打钉了，打钉子了啊！你可以看到要去打时间格的这个钉子了。你看一看，这里会伸出一个东西要去顶它，伸进去啊，伸进去顶住那个时间格的那个铆钉的这个盘啊，时间格的铆钉盘顶上去，然后呢，从这里要打出一个钉子，打钉子固定，好。可以看到打出这个3个爪子啊，这个3个爪子的钉子就把这个时间格的这个铆钉盘呢固定牢固的固定在时间格上，这样子这个瓣膜就稳了啊。靠住2个这个夹持件以及这个固定的钉子呢进行一个固定，然后一打完之后，它这个钉子跟这个系统呢，它都自动就脱钩了，然后我们就退系统。瓣膜打完钉子之后呢，我们把瓣膜最后释放啊，这里还连着，
后面有个旋钮，这个解开结束以后呢，像这个顺时针转，它就释放了。
这是这个最后一个释放。好，完全释放掉了，然后我们把系统出来，好，系统慢慢的退出来，这说出来的一定很当心啊，这个东西还是比较大的，不要把它刮掉，
就是可以慢慢回弯，慢慢回弯，让它自己轻轻的跳动，它就出来了。
可以看到时间格上的铆钉件把它固定得很好。
慢慢走，然后等会看造影图像。这个时候就收进去了。
最后这是最后再做一个造影啊，可以看到最后造影是，我再拉一下啊，最后一个造影。可以再看到位置很好啊，然后呢，几乎是没有半周漏的，几乎是没有半周漏。
下面呢有一丝这个半周漏，但这个病人 和这个术前比起来还是改善了非常多。那我们唯一怕的呢，就是一丝呢会溶血，但是呢，它这个都是腹膜的组织，所以它不会溶血。未来呢，它会逐渐应该会长好。那么这个呢，这个瓣膜呢，就是 Luxwell Plus 这么经颈静脉做的这么一款瓣膜。这种瓣膜呢，它颈静脉一个必要的条件呢，所以我们术前都要评估颈静脉呢一定要大于10个毫米以上。但是我专门做这个瓣膜的时候，当病人走到这个诊室里的时候，我就会看这个人颈外静脉突出，预估颈内静脉应该是没有问题的。所以实际上人的绝大部分的颈内静脉都没有问题。我们最初开始做的时候呢，都是这个外科未来教授呢帮我们把这个颈静脉分开来。实际上呢，打 Progla 呢，我相信也是可以的。事实上呢，那个加拿大的那个一个教授他已经做了8例，叫安森这个教授他已经用这个瓣膜做了8例，他全部是打2把 Progla， 做了，在这个叫 Poor Hospital。在加拿大做了8例，那么用 Progla 来打的。那我们现在呢，还是请魏教授呢帮我们这个切开来做。那实际上我们虽然做了10几例，但是实际上经验还是不足，还在摸索当中。一些常规呢，也是在不断的去摸索。这个整个的过程如果顺利的话，已经1个小时左右，跟那个做一台 TAVR 差不多，应该是还是。比较好的。关键问题呢，它这个设计的理念和一般的瓣膜呢，它是靠这个镜像支撑力去铆定，它不是，它主要是靠这个在时间格上打一个铆定件，和呢有2个加持件加持在这个前叶上，然后靠这2个这个情况去铆定。我们知道3尖瓣是所有瓣环实际上并没有非常明确的瓣环。所以靠镜像支撑力是不大可能的，包括2尖瓣也是一样，换瓣一样，你要靠这个镜像支撑力去这个瓣膜固定，这还是有问题的。院长，
是达英教授，我2个小问题一个就是说，比方说这个我们做这个 abstain anomaly 这种先天性的异常，你们有没有经验？它的这种是不是就可以这样解决？它就不用开刀了？先天性的这个三尖瓣往这个右使方向移位的这一种情况。第二个就是说，看起来你这整个 orientation 是最困难的一点，花了很多的时间。这个你进去的时候是不是有方向性？那最后一个小问题就是说，你这个用完以后抗栓的策略是怎么样？
院长这个问题都提到点子上去了，非常非常好的问题。我们在做的过程当中，非常非常就是那个定位，就是那个2个耳朵要刮到这个前叶，这点非常的重要。我们从这颈静脉呢往下走的时候呢，它走到心房里，大部分呢它会贴着这个房间隔，然后呢靠近是这样一个地方过去。所以呢，我们在定位这2个兔耳朵刮这个前叶的时候呢，就是有的时候就不容易完全刮住。第一个，第二个呢，我们有的人的前叶是大的，有的人前叶的隔叶大，3尖瓣说不完全一样，所以刮这个前叶的时候非常重要。那特别是3尖瓣前叶，它跟乳头肌它方向不一样，所以2个前叶的角度，这2个兔耳朵就是2个夹之间的角度，如果大了，它可能刮在这个剑手上，它不容易往下刮。所以如果刮得好呢，上面那个兔耳朵呢正好刮在前叶上，下面那个耳朵呢，如果是顶在游离壁上呢，它可能会把游离壁给顶破掉，有可能出现这种情况。所以呢，这个在这个定位这个呢非常非常的重要，所以也是我们经常考虑设计的问题。这大部分的瓣膜呢，这个时间也花在这个上面。如果说能够定位成功，这个瓣膜自动的几个旋钮往后转，它就像一个做 TAVR 一样，就非常的简便了，非常简便。另外一个呢，这阿布斯坦畸形呢，从理论上也应该可以做，但是我们没有尝试过，因为一款产品它这个设计，它倾注了这个设计的人员呢非常非常多的心血，有很多的资本投资了大量的钱，它并且呢没有任何一个瓣膜它能够包打天下，能够适合所有的病人，所以目前我们还是非常谨慎的在做这件事情，所以没有扩大这个生意症。
请教一下达兴教授，像术前在选病人的时候，要不要评估他那个右室的功能？有没有病人说在把 TR 完全关掉了以后，就有发生了一个急性的右心室衰这样子的情况？
非常好。所以呢，我们这个问题也是非常到点子上去的。术前我们一定要评估这个病人的这个右心室功能。如果右心室功能很差了，或者说肺动脉压力很高了，实际上对一些肺动脉高压的病人，这个三尖瓣的反流，它会缓解右心室的压力，它从某种程度上呢能缓解右心衰。如果呢肺动脉压力很高，右心室功能非常严重，实际上它这个右心室的储备功能也就没有了。没有右心室储备功能没有的这种病人，你给他换什么瓣膜，它也是没有用的。所以在我们术前一定要进行非常的评估，特别是这个右心室的功能和肺动脉的压力。
像您这个病人术前的话，大概肺动脉压多大？因为看起来他应该原来是一个二尖瓣的问题造成的问题，是不是三尖瓣还是因为有一点肺动脉高压造成的结果？
他这个呢，这个大部分的主动脉瓣病变和二尖瓣的病变呢，它晚期都会发生这个右心室扩大。然后呢，右心室扩大呢，对右心室本身来说呢，是一种缓解压力的一种方式。所以像这个二尖瓣反流的病人，他这个压力的高啊，它往往是一个长年累月的一个没有药物进行治疗，导致晚期越来越重。所以真正的这个比如说二尖瓣换瓣以后，这个出现这个肺动压力很高的病人，实际并不是很多。但是这些病人呢，时间长了以后呢，他会发生右心衰，会发生这个三尖瓣瓣环的扩大，然后出现重度的三尖瓣的反流。其原因呢，就是时间长了以后，这个整个右心室呢，逐渐一个缓慢的一个扩张的一个过程。所以像这种病人呢，早期我们可以用瓣环，用 K clip， 就是我们也是我们中心做的 K clip， 把它那个瓣环这个关小一点，反流也承担一点，这样子呢，对整个病人呢，这个右心衰竭呢可能会好一点。像这种病人，实际上我认为结合房间个照漏也是有好处的这房间个照漏就是房间个分流也是有好处的。所以我们一般现在定的这个肺动脉压力呢不超过60毫米汞柱。正常人如果急性的话，很少人的右心室能耐受60毫米汞柱以上。但是呢，在肺动脉高压的人呢，他右心室这个 remodeling， 他那个可能100多，他的压力可能跟那个左心相类似，他也能够活下去。原因呢，他这个长期缓慢代偿，得到了代偿以后呢，肺动脉高压这种病人也是能活下去的。
谢谢。
是，大家不知道还有没有其他问题？我们还有5分钟的时间。
如果这样，那我再问一个问题好了，不好意思Wei-Hsian。像刚刚的这个三尖瓣瓣膜的选病人，如果病人术前有放过节律器，特别是在右室有这个节律器的电线的话，是不是一个禁忌症？那么另外的话就是说，有没有病人这个在放完了以后，当我们把那个右室的猪尾巴拿出来的时候，有没有什么要特别注意的地方？
非常感谢这个好的问题。那么就是节律器就是 pacemaker 对吧？就是我们要叫起搏器。
起搏器对。
那么这个起搏器呢，它的导线呢，实际上呢也是一个三尖瓣导致三尖瓣反流的一个重要的原因。我们这个有放了起搏器的病人可以做这个瓣膜，这个不影响的。这个因为它本身就把这个压在后面的嘛。在这个瓣膜呢，一般的照引定位总共释放之前，我们就会把这个猪尾巴导管先撤到右心房，然后再把完全释放出来。就是在这个瓣膜完全释放之前，就把这个猪尾巴导管呢就会拿出来。
了解。
这瓣膜放好以后，然后呢再把这个猪尾巴导管再塞到这个心房里去，再从心室里，然后再重新进行照引。
明白。
现在实际上呢，三尖瓣的病人呢非常多。因为主动脉和二尖瓣病变的病人，他三尖瓣都会有问题，都会是继发性的。这大部分三尖瓣的病人呢，都是瓣环扩大，都是继发性的。而三尖瓣本身瓣膜有问题的人， 断裂啊，或者是连加改变还是非常少的，非常少。所以呢，大部分都是继发性的这个三尖瓣这个问题。三尖瓣目前这个对病人的影响，做病人呢，因为通过用一些药物，比如利尿药啊，这个控制啊，甚至文字把这个病人把这个用起搏器把这心室的节律调到80-90次，本来起搏病人他60次，你把它调到80-90次以后呢，三尖瓣反流就会减少啊。这个 CO 啊，就是反流的 CO 的比例就会减少，那么症状也会改善，所以病人就不愿意开刀。他这样一开刀的时候呢，三尖瓣有反流以后呢，整个右心房胀大的非常厉害，非常容易出血。你这个针缝了上去，针一拔，从线里面往外面冒血，所以呢，这种病人死亡率非常高的原因就是这个原因。大部分病人都有房颤，所以非常的麻烦。这导致呢，这个三尖瓣呢就是被遗忘的把毛发，实际上到年龄大了以后呢，也没有什么非常好的办法去治疗。那么这个 Lux valve 呢，我和这个 K clip 呢，这个瓣环成型和这个瓣膜置换呢，我认为目前还是能够做一点事情的，因为 Lux valve 呢，它这个本身理念，它和以前的三尖瓣置换，包括我们意外三尖瓣的置换，在上腔或者下腔放2个意外的瓣膜，它这个瓣膜的固定，它也是要靠这个镜像支撑力是固定的。那三尖瓣瓣环，你靠镜像支撑力固定，它瓣环越来越大，你根本没办法去弄这个事情。
对，
所以导致这个是非常的麻烦。
是。
那么 Lux valve 呢，它这个不是靠这个镜像支撑力去固定，所以呢，从这个理念上呢和以前也不一样。对比像一些反颤的病人、慢反颤的病人，他呢没有非常大的镜像支撑力，他呢可能对这个穿脑术，特别是新手，影响就比较小，可能这个安装起搏器的概率会多啊，会少，就是这个意思。非常感谢叶院长的邀请。
非常感谢，我真的觉得结构的发展在大陆上其实是真的是迎头赶上了，包括二尖瓣的设计、三尖瓣的设计，对我们过去其实是没有办法照顾到的一群病人，我们都是把他放弃的一群病人，给了他一些希望哈。我真的觉得我们两岸在这一方面其实还是可以有很多的交流跟讨论，那将来对病人能够提供更好的救治。那今天非常感谢大家参加这个 session 的 live 的讨论哈。那我们的好朋友们就是在这个疫情期间请多注意安全大家保重，谢谢啊，谢谢。
谢谢殷教授，
非常感谢，非常感谢，
谢谢
教授，
高教授，
谢谢
这个这几位教授的谢教授，我们希望疫情结束以后呢，我们能够面对面的互相的一起讨论，可以做一些创新研发。
是
如果你们感兴趣的话，我们也可以把我们的东西到你们那里去，一起可以去有合适的病人也可以救治一下。谢谢，再见。
谢谢，欢迎大家继续听啊。那我们下面 next will be a TAVR session. I see Dr. GD have been on the air, and the next talk will be delivered by Dr. Henry Treaty from Germany. His topic will be a 75-year-old with severe aortic stenosis and proximal aortic stenosis. That would be an issue, very hard issue regarding the concomitant aortic valve disease and coronary artery disease. Dr. Treaty, please.
Yes, first of all, thank you very much for the invitation to this great conference. I hope you can see my slides. Can you bring up my slides? I just shared my screen.
Yes, please. We can see that.
Oh, you can see it. I can't see the.
Not yet.
Not yet. Okay. So I shared my screen. Is there anything I can do? Maybe I can stop it once more and share it once more. Can you see it now? Or can the technicians bring it up?
有没有技术上的问题？ We
can clearly see it. We can clearly see it, Henrik.
Sorry.
You can see it. Okay. That's fantastic.
You see it.
Now you see it. Okay, fantastic.
You can start your talk now. Yeah, thank you.
So thanks again for inviting me. It's an interesting topic, actually. I was asked to start off with a case that we see quite regularly in our daily practice. A 75-year-old patient with severe aortic stenosis and concomitant coronary artery disease, at this time proximal LAD stenosis. So this is our case. First of all, these are my conflicts of interest. This is our case. We had a 75-year-old female patient, slightly obese, New York Heart Association class 3 with severe aortic stenosis and coronary artery disease, one vessel disease with LAD and diagonal branch stenosis. NT-proBNP was 950. She showed up with preserved LV function, had good femoral access. She was basically a very good candidate for everything you could do. She was also a tiny bit frail, but no significant comorbidities. This is her echo. So she had severe aortic stenosis with a mean gradient of 65, Vmax of 500, area of 0.8, V hypertrophy, preserved ejection fraction. So pretty standard tricuspid aortic stenosis case. And she also had coronary artery disease. You can see here, this was more or less a bifurcational lesion of the LAD and the diagonal branch. That, in our aspect, was quite significant stenosed. The RCA only showed ward irregularities as well as the RCX. So the only vessel involved was the LAD and the diagonal branch. So these are the options that you could go forward for now. You could do, of course, regular surgical aortic valve replacement and CABG. You could also do aortic valve replacement surgically followed by PCI, or you could do first PCI, then TAVI. You could do TAVI together with PCI, or you could do TAVI followed by PCI. So these are various options. And of course, it is up to the heart team to decide now what to do. And in order to get this decision done in kind of a systematic way, I think we should follow this systematic approach. First of all, we have, as in regular decisions between surgery and PCI, we have to look for the severity of the coronary artery disease. And that gives us a hint if we should go for a revasc or if it's potentially even possible to have a conservative management. And then if we decide to do something about the coronary artery disease, then of course we have to look for the complexity of the coronary artery disease. And that is, again, very similar to what we have in heart team discussions about CABG versus PCI. We have to look for the complexity of the disease and then decide if PCI is an option or if CABG has to be done, depending on the syntax score. If we then decide for TAVI, then, of course, we have also to decide about the timing of the revascularization. Should we do TAVI before, during, or after? Should we do PCI, before, during, or after TAVI? And then there are some procedural aspects, and we're going to talk about that later on too, in terms of how to do the TAVI, because, of course, in a patient with coronary artery disease, we have to make 100% sure that access to coronary ostia is preserved by using the correct valve and by using alignment techniques. There's some data out on the topic. First of all, we have the activation trial that compared patients with in the TAVI setting with coronary artery disease, PCI versus no PCI. And unfortunately, this trial was prematurely stopped due to slow recruitment, but at least for those patients who were included, the follow-up of 1 year, there was no difference in terms of mortality between patients who underwent PCI versus those who did not undergo PCI. Except for the case that there was a higher bleeding rate in the PCI group, of course, due to the anticoagulation or the platelet inhibition. So this trial gave us some hints, but not really good answers due to the premature withdrawal of patients. And then there are more trials now undergoing, and this is a good message that we can get data in the near future. So first of all, when we discuss about the possibilities and need for PCI, we have to find out how significant the stenosis are, because you could somehow argue that the first proximal stenosis in the coronary system is the aortic stenosis. So it's clear that aortic stenosis has an effect on the hemodynamics of coronary artery disease.
And therefore, we have the TAVI trial that now compares angiography-guided PCI with stenosis grade 50% plus towards physiology-guided PCI with FFR measurements to show, what are the measurements we have to take the decision. Then we have a comparable study on the surgical side, the FAVOR4 QVASC trial, that compares QFR-guided CABG versus angiography-guided CABG. So two similar trials, one on the interventional side, one on the surgical side. And we have the Notion 3 trial that then again gives us maybe answers about the assessment of revascularization in AS patients, comparing FFR-guided complete revasc with PCI versus conservative management. And there's a trial that I'm also looking forward to get the data, the TCW trial comparing FFR-guided PCI and TAVI with CABG and surgery. And when it comes to the complexity of the disease, that was one of the points we have to consider. Then, of course, we know that complete revascularization has a positive impact on longer-term outcome. This is not so much different in patients with aortic stenosis. We know that patients who have a higher syntax score have worse outcome if they are not completely revascularized. And this you can see on the outcome of patients who were left with residual syntax scores after treatment. Those who did best, of course, were the patients who had no coronary artery disease. But those who were left with a residual syntax score above 14 had much worse outcome compared to those who had residual syntax scores below 14. So it's again clear that if you do PCI, you should potentially do complete PCI, complete revascularization. And then when it comes to timing of PCI and TAVI, we don't have evidence from randomized trials, but there is some evidence from non-randomized studies. And of course, as you can imagine, there are some advantages for every treatment way. If you do PCI before, of course, you could have a straightforward coronary access because there's no TAVI stent in your way, but you have potentially a bit more complicated procedure because aortic stenosis has an impact on hemodynamics. There's also an increased bleeding risk later on for the TAVI procedure because you have patients on double platelet therapy. If you do it concomitant, then it's most times possible to do, but it's also a long procedure. It's more exposure to vascular complications and to renal injury due to the amount of contrast agent. And it could also be quite a prolonged intervention then. If you do PCI after TAVI, then you can have an accurate functional assessment of the disease severity. That's a big advantage if you do it this way. But then you have the TAVI stent in your way. It's maybe a more difficult procedure that may be compromised due to the stent in place. So there's advantages and disadvantages for all of these ways to go. We know from the ReAccess study that accessing the coronary ostia after TAVI is not always easy, and we'll not go too much into detail because Marco Bavanti wrote this paper, is just giving the talk right after mine, so he's going to go much more into detail here, but we know from his data that it's not always possible to cannulate the coronary ostia if a TAVI prosthesis is in place. It seems to be even more difficult on the right side than on the left side, and altogether 7.7% of patients were left with no possibility to access coronary ostia. And the predictors of unsuccessful coronary cannulation of the TAVI have been transcatheter sinus of Valsalva relation. Of course, the smaller the sinuses are, the more difficult it gets. And then the implant depth of the aortic valve and also the use of self-expanding supraannular valves may be a bit more complicated than balloon expanded, for example. We also know that this might be of clinical impact if we have patients who show up with acute need for PCI due to STEMI, for example. If you have such a situation where it's also about the door-to-balloon time, where it's really difficult to get proper results, if you have difficult access to coronary ostia, that there is a risk for patients if they have such a situation. And it's associated with poor clinical outcome that if you cannot get into the coronary ostia in an acute situation, that's of course clear, and we should have that in mind when we take decisions. Therefore, it's highly important that we make the life of the interventionalist as easy as possible by commissural alignment, and this has been done now in the majority of cases, I would say. it is quite obvious that if the stent commissures are in front of the corneostea, it's much more difficult to access them than if the valve is anatomically aligned. And there are techniques now for all the self-expanding valve types. We have the Evolute and the Accurate and the Portico to achieve this goal. So you have landmarks that you can follow, and in more than 90% of cases, it's usually possible to get commissural alignment with self-expanding techniques. And this is the way how we should nowadays implant these valves. This is again then proven by data from the Align Access study showing that coronary angiography in patients after TAVI was most difficult in those patients who had a supraannular self-expanding valve that was not commissurally aligned. There the rate of unfeasible access to coronaries was highest. So in summary, the selection of optimal treatment strategies is guided by severity and complexity of the coronary artery disease. It's all about the heart team to decide whether you do CABG or whether you do PCI, TAVI, or SAVR. The timing is something that we also have to look into if you do TAVI and PCI before, during, or after TAVI. And this depends, in my eyes, on hemodynamics, on the risk for renal injury, coronary accessibility, size of sinuses, and all this. It's really something that where the heart team has to go into detail. And PCI after TAVI can be challenging depending on the anatomical and valve-related factors that we just discussed. Therefore, we should implant every valve whenever possible, commissurally aligned, that we get the best access to coronary ostia. And just to let you know what we did in our patients, actually, in our heart team decisions, since there was also a strong wish of the patient to get TAVI, we went for a PCI first strategy because we had no doubts about the severity of the disease. And what we did is that we did a kind of bifurcation standing first of the diagonal branch, then of the LAD, and this is the final result, and it looks quite good in our eyes. And then afterwards we went for TAVI. We started with a balloon expansion, and then we implanted an M-size sinus accurate valve in proper position. We chose that valve because we thought in this particular anatomy it would have good results and would also leave coronary ostia well accessible. Here's how the valve is implanted. We did one post-ballooning, and then this is the final result of the post-ballooning. We had a look at echo for that PVL. Here, this is the final result, and in echo, it looks like this. So there's not much PVL, fortunately, and I'm sorry, I cannot let this run out. Okay, here we go. And here we also made a final confirmation that the left coronary ostium is accessible and shows good result of the PCI beforehand. So this was our case, but the overall discussion is of course complicated and needs a good and proper heart team in process. Thank you very much for your attention.
Yeah, thank you, Dr. Chidi. And we have many distinguished guests, moderators, speakers, and the panelists. Do you have any comments on Dr. Chidi's talk? I have a short question, may I? In TAVI and TAVI procedure, we are afraid of sequestration or further two-layer metals in front of the coronary. What's your solution currently in Germany? Balloon expandable valve in self-expandable valve, or a self-expandable one in the balloon expandable one, or vice versa? What's your strategy now?
Yeah, I have to say this is the most crucial point now, because we see now, or we're starting to see patients who come back with TAVI degeneration. And I fear that nobody has a perfect answer to that question right now, because we need to gather the experience. My personal opinion is that maybe using a balloon expander valve in a self-expanding valve is a better way to go, because having two large cages, one into the other, may be rather difficult. So we have a working group built, and Ole de Backer, who's also here co-moderator, as part of it. We try to find solutions for this problem, showing also a guide how to do it in terms of depth and sizing and everything. But it is a fairly difficult decision. And I think if we treat patients who have, due to their life expectancy and the comorbidities and everything, who have a proper chance to survive the durability of their valve, we have to answer that question by the first implant. So we have to make sure that doing the first implant, we have to have the second implant in mind and pick the valve that's best suited for also TAV and TAV situations afterwards. And that is a quite complicated situation. We will only learn from the future how that should be done in the perfect way.
Yeah, thank you. Okay.
Dr. Chidi,
yes.
How do you make your DEPT plan after PCI before the TAVI? Is there any possible that increase the blooding risk for TAVI if you do PCI before?
This is true. So when choosing this way, the way we did it, first PCI and then TAVI, then you have an increased risk of bleeding during the TAVI procedure because patients are still on double platelet therapy. In this particular case, we took the risk because we knew that this was not the easiest PCI with the bifurcation lesion. And we had no doubt that the severity of the coronary artery disease was needed revascularization. So this was high degree stenosis that had hemodynamic effects. So in another situation where the coronary artery disease would have not been this distinct, we would have potentially decided in a different way. But this is really very patient specific and should be done very individualized among the heart team.
Thank you. Thank you.
Okay, thank you. Let's move to the next talk, which will be delivered by Dr. Marco Bapendi, who published the REACCESS trial. He's really famous, I think. Okay, Dr. Bapendi, can you show us your slide and start the talk? Thank you.
Thank you very much for the invitation, from this kind of invitation. Can you look at the slides correctly?
Yes, please.
Perfect. Okay. So I'm sorry if I'm going to overlap with some of the concepts that have been raised by Edric, but I think it's worthwhile to discuss because they are really key issues in this field. So why achieving optimal future coronary access is very important in transcatheter valve replacement? I think there is a fact, and the fact is there is a strong association and correlation between coronary artery disease and severe aortic stenosis. So in terms of epidemiological data, we know that a significant proportion of patients undergoing TAVI, they actually have some degrees of coronary artery disease. So this is very important to underline. And we know that in these patients suffering from a coronary artery disease, the most relevant clinical presentation of coronary artery disease, which is acute coronary syndrome, might happen anytime, and they have same data that show that this is associated with poor prognosis. We know from current literature that the incidence of acute coronary syndrome after TAVI is about 4.7 to 10%. And we know also that because of their longer life expectancy, younger patients are more likely of having coronary events after TAVI. So this is basically the background why maintaining access to the coronaries is critical for long-time management of these patients. We know from the current literature also that it's important also to achieve a revascularization in patients presenting with acute coronary syndrome. As we saw in this study by Farouks, one of the predictors of in terms of outcomes, so the revascularization with PCI after acute coronary syndrome was one factor associated with the reduction of the risk of all-cause death. So it means that despite these patients are quite elderly patients, when presenting with a non-STEMI, particularly because this was all unstable angina, so it's very important to achieve revascularization in these patients. And as Hendrik showed before, we know also in the most relevant clinical presentation of coronary disease, which is STEMI, and this is a study comparing patients, TAVI patient versus non-TAVI patient. So the presence of a transcatheter valve inside has an impact in terms of door-to-balloon time, which was 33% longer, and in terms of PCI failure rate, which was 4-fold higher. And this, of course, was associated with increased risk of death, which was remarkably high at 1 year. So almost 1 in 3 patients died at 1 year in this clinical situation. But of course, there are some factors that could impact coronary access after transcatheter valve implantation. And some of them are just typical and just anatomical. So, pertains all the dimension and anatomy of the aortic root. So including the dimension of the sinotubular junction, the sinusate, the bulkiness of the leaflets, the sinusovalsalva width, and the coronary height. But some of them are correlated with operator variables, which are device and procedural factors. First of all, is commissural tab orientation, and second is ceiling-skid height, so typical of the valve and valve implantation depth. So when we're talking about TAVI platforms and its impact on coronary access, we might summarize as the presence of short frame versus long frame, the presence of open cells versus closed cells, and the presence of a valve with supraannular leaflets versus valves with intraannular leaflets. And we have to say that all these factors may have an impact on coronary access following TAVI, with short frame, open cells, intraannular leaflets, all factors that could reduce the risk of having any impediment to coronary access after TAVI. This observation is also supported by some data, and this is one meta-analysis collecting some case series and all some retrospective studies, which basically showed that the successful angiography of the left main and RCA was much higher when this was attempted after balloon expandable valve, so Edwards valve for both coronaries. So once again, underline the fact that the shorter the frame, the open the cells, the present intraannularity of the leaflets, so the higher the chance to obtain a coronary access. And this was basically also the background that pushed us to design the REACCESS study. In this study, we included all the TAVI platforms we used. We were able to collect at the end 300 patients undergoing implantation of Evolut valve, SAPIEN 3, and portico valve, very few numbers, and accurate neo valves. And we, as a primary endpoint, was the unsuccessful coronary cannulation after TAVI, which was attempted before also and after TAVI. And then as a secondary outcome, aortic root and CTI measurements and prosthesis implantation related factors associated with an ability to selectively cannulate coronary ostia after transcatheter valve implantation. So what were the main findings? Henrik showed this study. Now let's go deeper in this. So 7.7% of patients had an unsuccessful coronary cannulation following TAVI, but more importantly, 22 out of 23 cases of unsuccessful coronary cannulation were observed with the Evolut valve. So with the TAVI platforms, they're carrying all those features that we anticipated might have an impact on coronary cannulation. And the second message was that cannulation of RCA was much more challenging than cannulation of the left coronary artery. So with the 31% of patients with the semi-selective cannulation of RCA versus 12%. But I think one of the most important message of the paper, which was something that led us to improve our tailoring approach to the procedure in terms of coronary access, was the analysis of predictors. So first of all, not only the valve, which was significantly associated with the unsuccessful cannulation, but it's also how we size this valve. So when we oversize a lot of the sinus of Valsalva, so there is a lot, much less space to engage coronaries, but also how we implant the valve. And these studies show that the lower the implant, the higher the chance to achieve coronary cannulation. So this means that we don't need to aim at deep implantation, because also we know that this is associated with increased risk of conduction disturbances, but we have to tailor our approach to each patient, bearing this in mind that when we aim to ground zero, very high implant, we might have some chance to reduce the chance to obtain coronary access after TAVI. But this observation were also showed by the AMI-TAVI registry, basically summarizing that the presence on the long-term or longer stent frame THV were associated with an increased risk of coronary unsuccessful coronary cannulation after TAVI. What was one of the main limitation of the reaccess? It was that actually commissural alignment was not achieved, because this was designed in the area before we are doing systematic commissural alignment. As Edric showed, we know that today commissural alignment is feasible and reproducible with some TAVI platforms. Of course, the current devices are not achieved on that, and I'm sure that future technologies will increase the chance to obtain coronary access and successful coronary alignment, commissural alignment. But this is an important step forward in a tailored approach. And we know that also the presence of a commissural alignment increased the chance of having coronary cannulation after transcatheter valve implantation. So fourfold increase the risk of having unsuccessful coronary cannulation when the commissures are not aligned. And the last topic I want to discuss briefly is the fact that the reduced TAVI procedure. We know also that we always say that, okay, TAVI is a repeatable procedure. But of course, this is true, but it's not completely true, because sometimes we have to face with the commissures. And this is why it's important to obtain with the first valve a perfect commissural alignment, because basilica, which can be something that has to be done in case of repeat TAVI, is feasible only if the commissures are well aligned. So this is one important aspect. And when we're talking about coronary access after TAVI, it's very important to bear in mind also this aspect when you're implanting the first valve, because we know that particularly when we have a supraannular device like an Evolut device, we know that what we call the nail skirt, which is the leaflets folded up when you implanted a new valve, and the nail skirt usually lay above the plane or the origin of the coronary ostia. So when you considering this, the fact that you don't have any problems with the first valve, but this can be a big issue when you're implanting a second valve, because you're going to have the old leaflets folded up by creating basically a stent graft into the aortic root. And also is important a new concept, which is the distance between the sinotubular junction and the first valve, because of course you can see here when you don't have space between the frame, the stent frame, and the sinotubular junction, and you implant the valve inside, it's basically impossible to go through with catheters inside. So it's very important when you're selecting the first valve for the first patient to go and to consider this distance, because it's very important. And this is what we saw in this paper by Tsai, that when, in case of reduced TAVI, when the first valve is enabled as compared with the SAPIEN 3, in case of reduced TAVI procedure, you see that the impingement and the sinus of Valsalva of the coronaries and sinus of Valsalva sequestration was much higher with the Evolut as compared with SAPIEN valve. And this is once again the paper mentioned by Edric, where Ole made a great job by collecting these reduced TAVI procedures, in which when the first valve is an evolute, you may have at least 2 interfering factors in case of reduced TAVI, where in 65% of patients versus 17% of patients, let's say, in the case of sapien valve. So once again, underlying has the first implantation determine an important impact in terms of long-term span. So we might have solution for that. One of the solution in case of having a degenerated valve with a supraanal device is to implant a balloon expandable device by lower implant, so by creating a overhanging of the valve. But this is true when the first valve is not stenosed, so is a very important step. I just want to bring out a case of degenerated sapien, a degenerated accurate valve, in which we anticipated any issues with sinus valsalva sequestration. We basically implanted a valve lower than in a lower position with a new valve. Like this was a previous endocarditis, so the valve was not stenosed, but with the regurgitant degeneration. So you can see here the old valve functioning up, the new valve functioning down. So we have no sequestration of the sinus, and it was absolutely easy to obtain a coronary access in this case, as you can see here. Here we go. So in conclusion, we see that coronary artery disease is very prevalent within TAVI population, and lower risk and younger patients are of course likely to develop coronary events, especially with the progressive evolution of very existing new lesions of time. PCI after TAVI is not frequent. It is feasible, but associated with higher rates of unsuccess and complication compared with no TAVI setting. We know also that specific anatomical and THP patient interacting factors are associated with more challenging or even impossible coronary access after TAVI. So this has to be bear in mind in terms of when we select the first TAVI. And design of the implanted THV matters because these valves with short stent and open cells are proven to maintain more easy coronary access. Thank you for your attention.
Yeah. Thank you, Dr. Bapat, for your excellent review on this topic. Any comment from the panelists?
Marco, if I may, first of all, that was a great presentation, and you showed the dilemma that we are in, that we're using now cusp overlap techniques for the self-expanding supraannular valves to achieve the highest possible implant to reduce the number of pacemaker as much as possible. But then if you have a patient who has coronary artery disease, whether it's now a need for treatment or not, would you now, in a patient that has coronary artery disease, implant the valve intentionally lower, accepting a higher pacemaker risk, or how do you decide in these situations?
Yeah, Edric, you got the point. So I think patient selection in TAVI has become much more a mess than before, because while a few years ago we had to deal with mismatched pacemakers, which was quite easy. Now the blanket is much shorter, so where you cover somewhere, you basically expose somewhere else. So of course this is something that should be considered. So probably if you're going to deal with a very young patient with, for example, RBB, so increased risk of pacemaker implantation, probably I would go with a valve which can prevent the risk of coronary access. So by implanting probably a different type of valves as compared with evolute, for example, accurate may be an option, sapien may be also an option. Of course, I think that commissural alignment is key, because in case you want to preserve the coronaries, as you said, you have to bear in mind the second step, which is the reduced TAVI procedure. And Basilica, that we are seeing that it may be much more useful for reduced TAVI procedures. This can be done also if commissures are well aligned. So of course, this it happens that sometimes I'm implanting the valve, also an evolute valve, a little bit lower. For example, if the patient has a very low risk of pacemaker conduction disturbances, if the patient has already a pacemaker in, so I really don't need to go 10 millimeters down into the LDOT. but it's important to preserve the coronaries. So it's really a case-to-case approach, and you have to select not only the valve you're going to implant, but also how you want to implant in terms of implantation depth.
Okay, thank you very much. Let's move to the next talk. I would like to invite Dr. De Baker to chair the next two talks.
Okay, very good. So the next speaker is Dion Stubb about TAVR health economics and cost effectiveness. So please, Dion, the floor is yours.
Thanks. Thanks to the Taipei Valve Organising Committee. Pleasure to be here. I can't believe it's been a year since the last time I was on Zoom. Maybe next time in person would be fantastic. Is my slide, maybe just a nod if the slide's coming up, you can see it. Yeah, so moving a little bit away from the technical aspects of TAVI and then thinking about the cost implications. I think like most areas in medicine, it's important that considering cost effectiveness and cost implications of our choices is more and more important moving forward with an aging population and increasing stresses on our health systems. From my perspective, have grateful research support from our Australian-based National Heart Foundation, and then I work across the variety of the THV valve platforms. So just orientating people, I think doesn't matter where you work and what country, I think funding of health systems varies significantly across the world. Is complicated in every jurisdiction. We're lucky in Australia that we have a universal healthcare system, but it still has its significant complexities. Whilst we have a universal healthcare system which everybody can access, we also have a relatively strong private system, which people will take out private insurance on top of universal healthcare, and it's just a bit under half the population will have private insurance. A procedure like TAVI can be accessed in both private and public, and I'll show you towards the end some of the differences. And when we think about cost implications for procedures, again, it will vary region to region, but the themes are the same. So when we're thinking about new technologies, the efficacy of the new technology, both to the person, but then the implications to the health system and then to society as a whole is really important when you're trying to balance competing needs across the health system. And it doesn't matter whether we're thinking about cardiovascular medicine, oncology, hematology, as we develop new devices, new drugs, new techniques, understanding of cost effectiveness and implications are really important. We don't make our sole decisions based on that. But again, most of our decisions are based on what's best for our individual patient, but knowing where it fits into with regards to cost and benefit is important. At a very simple level, as a clinician, it's nice just to have a sense when you're looking at some of our cost effectiveness papers, how do we express this? This is a really simple way to think about the benefit, the cost impact versus health gain when we're thinking about new devices and medications. So where we can have a device or medicine that will provide a health benefit or a health loss, depending on what we're talking about, and then whether or not something is cost effective will depend on that balance between the new cost or the increased cost of the device versus the health gain. And various systems will set a threshold for what they consider acceptable. In Australia, most, like many systems around the world, will have a cost effectiveness threshold of about $50,000 or $100,000, depending on the system, for where we think if it falls beneath this 50,000 threshold for net health gain versus cost, then we will consider that to be a cost effective therapy. I suppose the ultimate therapy is a therapy that is cost dominant, i.e. you get a health gain and it actually provides cost savings, where you don't need to worry about a threshold, you're actually a cost dominant. And we'll talk about how in some respects TAVI is one of these wonderful procedures where we actually have net health gains as well as potential cost savings. So in terms of cost effectiveness for TAVI, we've done a series of analyses based on Australian health data, inputting international worldwide randomized controlled trials with then Australian inputs. Again, it's based on Australian costs, but the themes for the papers can be used across all systems. The exact numbers and the cost per procedure will clearly be local to Australia, but again, the ratios and themes comparing TAVI to surgery is similar. We used a very nice Markov model where we look at the procedure, in this case TAVI versus surgical aortic valve replacement, and then have our outcomes, which is a patient doing well and then a patient having issues such as mortality, stroke, bleeding, permanent pacemaker, etc. And then comparing how they go both at short-term and then longer-term outcomes. When it comes to TAVI, we've looked at low risk and intermediate risk. What's interesting is the potential bracket creep, where you higher risk or prohibitive high risk, which is where I think what all health systems struggle with, is where we actually are expanding the pool of patients than we previously would not have offered surgery to. So in terms of when we look at our analyses for the low risk paper, we took the two seminal low risk trials. Everyone will be familiar with these. Trials were presented now a few years ago. Both of them were, I think, well executed and had similarities that makes comparison across them interesting and potentially applicable to our low risk population. Both had very similar average ages, around 73, 74, low STS by definition. I think it's important we remember who was and were not in these trials, in particular when we're starting to think of low risk TAVI making decisions compared to surgical aortic valve replacement. It was tri-leaflet severe aortic stenosis that were anatomically suitable, and that there was some differences. We participated at my institution in the self-expanding platform, but there were clearly some differences and clear choices made for who went into these randomized trials. They had to have appropriate iliofemoral access and appropriate valvular anatomy, and then there were slight differences between the surgical and TAVI arms, but about 15% of patients would have concurrent coronary revascularization. That was often done separately or at the same time, depending on the institution. So again, you can't really compare different randomized trials against different populations. What's really interesting about the two seminal low-risk trials is that the ratio of benefit of TAVI compared to surgery was maintained. So whilst I think there are different populations in the balloon expandable partner trial versus the self-expanding Evolute trials, the ratio is really similar when we're comparing the differences between TAVI and surgical AVR, which makes, whilst we can't compare across the two trials, it does potentially mean that the themes of potential benefit of TAVI compared to surgery is maintained. So we saw significantly less death and stroke in both the self-expanding trial and the balloon expandable trial, significantly more pacemaker in the self-expanding platform compared to the balloon expandable. We've just heard a fantastic talk around coronary access, and then other results were similar. So it was these two large international trials that we then created our Markov model, put in our Australian-based cost. Again, the diagnostic workup, whether you're having TAVI or surgical AVR, is similar. You can make we were very conservative with all of our estimates. So whilst many patients undergoing surgery will still have a CT aorta, the cost for the CT was only inputted to the TAVI. And then we looked at the cost of the hospital stay. Again, very conservative, because patients in the low-risk trials went to ICU. Within our cost model, we included ICU costs. Like many countries around the world, we have next to 0 hours in ICU. So that we've looked at 2 years data now across 4 hospitals in Melbourne, and we have 0 total hours in ICU. That would be very similar with most patients undergoing a local anaesthetic procedure heading straight back to the coronary care ward. But for the Markov model, again, very conservative estimates. And so we can confidently say that even with these conservative estimates, our price estimations are reasonable. And so when we look at our low-risk data with Australian costs, it's clear that TAVI is slightly more expensive on day one of the procedure, but very quickly, so by the time the patient's discharged from hospital, and again, we were profoundly conservative with regards to our in-hospital stay. So we took the data straight out of the low-risk trials. again, where the hospital stays were probably longer than you would see now for most TAVI programs. And by the time the patients are discharged from hospital, both the balloon expandable TAVI patients and the self-expanding TAVI patients are both clearly cost effective, and in the self-expanding platform, cost dominant. The reason with the slight differences in Australia, there's a small but significant price difference between the two dominant TAVI platforms. I think like most cost effectiveness models, the models are exquisitely sensitive to the price of the THV prostheses. And so I think whilst I'll show you with conclusions that TAVI is clearly cost-effective procedure and potentially cost-dominant, it is very sensitive to the price. And so as we get more competition in the THV market, and we're already seeing price reduction, the themes of cost-effectiveness will be even more dramatic. So we perform sensitivity analyses, so looking at 10,000 different scenarios. So these are inputting all different scenarios. Patient gets a pacemaker, doesn't get a pacemaker, has a major bleeding event, doesn't, has a stroke, doesn't, etc. And so whether balloon or self-expanding, you can see more than almost 80 to 90% of scenarios, TAVI is considered cost-effective for both balloon and self-expanding. And so within the model, it's clearly cost effective, and you can see this is a whole series of sensitivity analyses where not only is TAVI cost effective, it's actually cost dominant, where you're having a procedure that's more efficacious and potentially cheaper. Other interesting analyses that we've just finished, and this is pending publication, is there's some emerging and conflicting data about what do we do with cerebral embolic protection. Again, this will be very hospital specific. We're still grappling with who and when to use these devices. We're using them infrequently. I think most Australian programs would vary between 5 to 20% of procedures would use cerebral protection. And again, we've done some work around cost effectiveness. The cost effectiveness of using a cerebral protection device in TAVI is essentially all determined by whether or not you believe the devices provide stroke protection. We've done some systematic review modeling and inputting both the randomized and observational series. Interestingly, our model didn't include the latest two large observational trials that came out without significantly protective results for cerebral protection. But looking at our model, and again, very sensitive to its impact size on stroke reduction, if you do believe there is a benefit of stroke reduction, then the device is highly likely to be cost effective. If that benefit is smaller, then the actual cost effectiveness of cerebral protection in TAVI would be significantly less. So clearly, I think TAVI is one of the rare advances in medicine where you have a procedure that's liked by patients in the fact that their recovery is profoundly quicker, quality of life's better, but it's also, we can say, leads to significantly less death, stroke, major bleeding, and this is across the risk spectrum. And then amazingly is both cost effective and even in a whole series of models cost dominant, where you're actually, if everybody in the system was receiving a TAVI compared to a surgical AVR, you would potentially be saving the entire health system significant costs. With regards to how TAVI is progressing in Australia, again, we've had frustrations compared to many parts of the world, in particular, comparing rates of TAVI to the United States and Europe, which shows that TAVI is far and away perform more than isolated surgical AVR. In Australia, that's, and again, this is now a year and a half, 2 years, but you'll still see whether we look in public or private, we're still well under 50% compared to surgical AVR. So more patients are having a surgical AVR for aortic stenosis. This is rapidly changing. Much of it's been around our regulatory system and approval. So we've had a few years now where we've had TAVI approved for high risk. Intermediate risk is now just over a year old. And then we're probably the last TAVI country in the world to have low risk finally approved, and that's coming literally a month away, which will make access across the country significantly better. So I think decisions around TAVI, we've just heard a wonderful talk from Marco around coronary access. So decisions moving forward, I don't think will be around the cost of the procedure, because definitely when we're looking at lower risk patients, compared to prohibitive risk, the cost implications are positive. I think it's going to be very much more around what is the best thing anatomically for our patient. I think most programs are moving away from risk. So we're less focused on the risk of the patient and much more focused on making good anatomical decisions, trying to picture what the next 10, 20, even potentially 30 years are going to be when we make decisions for potentially our younger patients with aortic valve disease. So when it comes to costs, we can clearly say that TAVI is both clinically efficacious, cost-effective, and potentially even cost-dominant. And really appreciate the opportunity to present to you all today.
Thank you, Dion. Thank you, Professor Stubb, for these data. Well, there's hardly any time left because I think we have to move on with the program. We're 6 minutes over time. But is it correct just to conclude that as costs can be expected to go down, the procedure by itself, the devices get cheaper, but also beside the procedure, also the whole hospitalization is typically, like in Copenhagen, 80% is going home the day after. We can expect a lot of cost reduction there. So what do you think? Is this going to a cost effectiveness, which is going to be more optimistic, or even because you said it was comparable to surgery, can it be expected that it's going to be superior to surgery?
Yeah, absolutely. In a whole series of models, it's already cost dominant, where it's both cheaper and more efficacious. And that was with incredibly conservative results that were based off the large randomized trials. And so, yes, as many programs have minimalistic TAVI with day 1, day 2 discharge, no ICU stays, and then the biggest impact will be on the cost of the devices. I think we can naturally expect them to fall, and yes, it will be profoundly more cost effective / cost dominant in the future.
Okay, thank you. I'm sorry we don't have more time. We really have to move on because there's further programs. So let me invite by now Dr. Wassim Boudari on, and his topic is how can calcium pose problems during TAVI procedures?
Thank you, Dr. De Baker, Dr. Tweedy, and Wei-Hsian, and the organizer of the Taipei Valve. Can you see my slide?
Yes.
Well.
Yes, we do.
Okay. Yes. So the topic given to me is to share my experience with the problem with calcium posted on the TAVI procedure. So I'm gonna kind of shy away from all the clinical evidence numbers and give you some food for thought. So I'm gonna divide my talk into 3 segments: the calcium around the aortic valve complex, which means supravalvular, the leaflet, annular, and the alveoli. The calcium in the aorta, whether it's a ascending aorta, arch, or the rest of the aorta, and the vascular access calcification. Okay, I'll start with the last part first. The vascular access complication, I think we all know that it often give us a problem, especially combined with the caliber of the vessels, and especially when it has stenosis, and also with circumferential calcification. They're sometimes very thin and can be missed or underestimated on the CT scan. And sometimes give us problem with self-expandable sheath as well. We do have some tools to overcome it, whether it's a dilator, balloon, in some country, but not in Thailand, with the lithotripsy. And if we can't overcome it, then we have to go to alternative access. And if that's still available, of course, and that would take away your best possible outcome for transfemoral TAVI. Let's look at one of our recent case from one of my colleagues. This is a patient with the femoral measurement like this picture. Basically, the left side it's slightly larger than the right. And the size is kind of borderline between 5-ish to 6-ish. The perimeter of the valve is 77 and the area is 465. The SOB is between 29 and 34. The operator elected to use the Hydra valve, size 30. For those who's not familiar with this particular valve, it's basically similar to the original core valve, with slightly different design on the top end. It comes in the capsule, and you desheath it and it comes out. It's supposed to be used in an 80 French sheath, but we've been using it long enough that sometimes the operator use it with the bare delivery system, similar to the Evolut inline sheath, but we never know how big it is. But I think the operator believed that this could overcome or get across this particular case. So we start with the 14 French sheath, and he believed that the bare delivery system is similar to the inline sheath of the Evolut system, which is 14 French equivalent, but the sheath got stuck right around here. And so the sheath was pulled. And then before anybody noticed anything, he put the bare delivery system in. As you can see here, the top of the sheath was torn and left in the iliac when he tried to remove the 14 French sheath. And the new delivery system kind of pushed it back in. And it gets stuck here somewhere. Then try to go back in with 14 French sheath. Couldn't go in. And then a smaller sheath, hopefully can get some device in and try to get that piece of torn sheath tip out. But nothing worked. And then after a long while, you see a dissection below the torn sheath. He decided to put the cover stent from here down to here. And then eventually it was clot off. And the attempt to recanalize the iliac failed. So after a few hours, he decided to stop the procedure. And the surgeon in the team had to do a fem-fem bypass. And then the patient was scheduled for an elective direct aortic TAVI, and that went uneventfully. So that's the example of how we can underestimate the combination of calcium and size, and also not knowing the device that we use that well. Now, back a few years ago, we were probably more humble in this when we see bad iliofemoral system, bad subclavian in terms of caliber and calcification. We just kind of go ahead with the direct aortic approach without even thinking about trying.
Dr. Wei-Hsian, just about 1 minute. You, for the sake of time, there's only 5 minutes left, okay? Okay,
yeah, sure. For the arch, we all know that we have a lot of calcification in the arch. We shouldn't force. We could gently twist and turn, change to stiff Y, and some people use the snare to pull it up from the wall. And then we can, alternative access is also, will take us away from a transfemoral approach. This is an interesting case that we faced recently. The patient has a small annulus, well, not that small, 75, perimeter of 36, but the STJ is quite small, smaller than the annulus. So they had to go with a self-expandable, afraid that the 26 sapien would be too big for the STJ. So you can see the ascending has a lot of calcification. So the TF Evolut number 29 was planned because the access was okay. Predilatation with the 20 mm balloon. And the valve stuck right above the ST junction. So you can see they also used the Sentinel device. So as you can see, the third picture is also the body Y. The Y was changed to Lunderquist. Inline sheath was changed to 20 French sheath, hopefully with more support. Safari to Lunderquist to body Y. They even changed from Evolut Pro to Evolut R, thinking that it might be a little slimmer. Nothing worked. He eventually did a transeptal puncture, go in the LV, make a loop, grab the wire, make a loop, and pull it. And eventually can pull the system down. And then eventually the valve can be deployed with fairly good outcome. And then interestingly, what we see on the sentinel is these pieces of large pieces of calcium. Okay, so alternatively, we probably, when we face with the access problem like this, the last part that we're not going to face with calcification is transapical. And for this particular patient with all access problem, including direct aortic access, then we have to go with the transapical. For the aortic valve calcification, I'm not going to go through the data, but we all know that whether it's at annulus, leaflets, ST junction, LVOT calcification, it depends on the total amount, location, and thickness, the distribution. As you can see on all these pictures, it will create complication, as we all know, annular rupture, leak, and then need for pacemaker. And then that influences our complex decision-making in terms of valve selection, whether it's a type of valve, self-expandable versus balloon expandable, or size, undersizing or oversizing, the pre or post dilatation or none, and then the positioning of the valve, and also whether we should still do TAVI. And that's the least modifiable TAVI. I'm going to skip this slide. We all know that the bicuspid with a lot of calcium sometimes pose you a great problem. But even with the day-to-day cases like these two cases, with two pieces of calcium like this extend into the LVOT, and then we normally go with a self-expandable when we have the calcium in the LVOT. And the patient has some limit budget, then the Evolut R is still available in Thailand with less expensive cost. So he went with the Evolut R, pre-dilatation with a small balloon, minor axis diameter, valve place, and then there are very minimal paravalvular leak, transient left bundle branch block, and then he went home on day 2. Okay. Similar case 3 years ago, same annular dimension, same calcium appearance, same LVOT calcification, no problem with the budget. So Evolut Pro was used, and then pre-dilatation was made, same pre-dilatation balloon. And then there's a significant leak. Post-dilatation was performed despite LVOT calcium, and then looked better after post-dilatation. Still some leak. On the echo, it's mild to moderate leak, but 3 years has passed, and then the leak remain unchanged, and so as the LV function and LV diameter. So how can calcium pose problems for the TAVI procedure? I think calcium perhaps the greatest enemy of achieving a perfect TAVI outcome or results. And all these calcification, from what I have mentioned, make us having to do a complex and careful planning for the procedure. And we have to have a backup and rescue knowledge and tools to overcome problems. And sometimes when optimal TAVI cannot be foreseen, I think surgical AVR should be considered. So at the end, we have to balance between ideal TAVI and safest TAVI, and then come up with the optimal TAVI for that particular patient. Thank you very much.
Thank you, Wei-Hsian. Very, very nice presentation from going from the access to the valve. And it's true, calcium can be a friend for TAVI because it anchors our TAVI valves. But of course, if there's an excess of calcium, we struggle with either stroke risk, vascular complication, or even nasty complications like annulus rupture or aortic dissection, etc. Yeah. So I think I do not necessarily want to introduce myself, but it's maybe good that, or Henrik, you can do the task.
Yes, I'm going to take over, Ole. You don't have to introduce yourself. And thank you very much for giving the opportunity to do so. So the next speaker will be our co-moderator, Ole de Bakker, interventional cardiologist from Copenhagen in Denmark. He's going to speak about hemodynamics and valve durability and lifetime management of patients with aortic stenosis. Ole, thank you.
Thank you, Henrik. Yeah, so when I got this topic, I was thinking, try to think out of the box and try to position it in its context. And I see it as follows. So I think if you look to TAVI, in the beginning, in the early days, we were mostly concerned about acute outcomes, just procedural success, making this patient-led even survive and come successfully out of the procedure. Also, a lot of focus on paravalvular leak, the gradient as well, pacemaker implantation. But now that we're moving to younger and lower risk patients, our focus also moves more to lifetime management, as these patients typically have a longer survival. And that's still a largely unstudied field. And there are some topics, interesting topics, which are now hot in research, I would say. It's commissural alignment, coronary access, as Marco Barbanti touched upon. And also in this title here, durability, that's still a kind of unanswered question. And then also treating the degenerated valve. So here, this topic was about valve hemodynamics. I also take commissural alignment in it, and then what is the effect on valve durability? Well, I can say, first of all, there's very limited data on this topic, so I will not come with a lot of data because there is simply not a lot of data already available, but I want to introduce a couple of concepts as well. So first of all, if I think about valve performance or valve hemodynamics, we cannot go beside first paravalvular leak. I just spent 30 seconds on this. We all know these different types of valves which are in Western Europe, for example, available. All these valves have come with external sealing skirts over the last couple of years with better performing results on the PVL level. So Sapien 3, for example, with the external sealing skirt, also the Evolut Pro and the Pro Plus. We have then these, even they call it active sealing skirts, as you can see in the Accurate Neo 2, and also in the new Navitor, which is the new generation Portico valve. These are kind of active skirts where in the diastole, actually these kind of small swallow nests, they fill with blood in the diastole and prevent or reduce the risk of PVL. But let's go further on the real topic here, that's gradient. So what we really want to see is the following. We really want, if we do TAVI, we want to go into single-digit mean gradients. Only then I consider my procedure really as a successful procedure. And you see that in quite some comparative studies comparing TAVI with TAVR, we see that TAVI is actually performing better than the surgical valves, most of the surgical valves. So this is, for example, from the Notion trial, which is even up to 8-year follow-up data from in Copenhagen, this is not only data from Copenhagen, but from the whole of the north of Europe, Scandinavia. And you see that systematically in TAVI, mean gradients have been below 10 millimeters mercury, whereas the mean gradient in surgical valves is typically slightly higher, and this also results in a smaller opening area for surgical valves. So this may indeed be a concern for valve durability because stress on the leaflets may be higher and these valves may degenerate quicker. And that's also what we saw in this Notion trial so far with 8-year follow-up data. We see actually that if we look to the VARC3 defined structural valve deterioration, so here you see the definition on the right-hand side to call it a structural valve deterioration, we see that this incidence is twice as high in the surgical valves as in the TAVI valves. So no signal at all that the TAVI valves would degenerate earlier than the surgical valves. I would even say the opposite. And this has also been confirmed. This was presented at ACC a couple of 2 months ago, I think, by Michael Reardon. And also there, this was from some pooled core valve evolute data comparing to the surgical pool. And also there, they could show that up to 5-year follow-up, which is already significant length of follow-up, I would say, they also saw less structural valve deterioration in the TAVI valves. And this was, of course, this is just to show you that these data are also commercially exploited by the company, of course. So going back to the differences then between the different THV types, there is indeed differences between the different TAVI valves. And here, this is a graph. This is a meta-analysis actually with several thousands of patients with 14 studies in this meta-analysis. And you clearly see that here the self-expanding valves are again performing better than the surgical valves, but also, and more importantly, that the self-expanding valves are also typically having better gradients or hemodynamics than the balloon expandable valves. that you can also clearly see here, even up to a follow-up of 5 years. There is a massive difference, I would say, in the gradients and the hemodynamics between self-expanding and balloon expandable valves. In order to understand this, it's of course important to look really into detail to how the design of how these valves are designed. And this is showing you in the recommended annulus position how, for example, a sapien is sitting, how an evolute is sitting, also how an accurate is sitting. And then you see that in this is the intra-annular position, but still, if we talk about transcatheter heart valves with supra-annular leaflet position, if you compare just in your hands an accurate valve and an evolute valve, you would think that maybe even the accurate valve has the highest supra-annular leaflet position. But as these valves are implanted nominal always at a 7 millimeter depth, actually this is the leaflet position is actually finds itself somewhere in between a sapien and a core valve evolute. We can, on the other hand, we can also say that the hemodynamics of an accurate valve is well known to be really great, even in the very small annuli. So probably this extremely high leaflet position of a core valve evolute is probably not absolutely necessarily. Probably in the future, in next generations, we can expect that this leaflet position can be pulled a little bit down with a couple of millimeters without paying a price for the gradient. And also, this I want to show you these two next slides in order to try to explain you why balloon expandable valves have worse hemodynamical outcomes than self-expanding valves. And it's important to know that, for example, the Navitor, this is also a self-expanding valve with an intra-annular leaflet position, but it's still this valve generates very good hemodynamic results, very low gradients, almost in all patients, mean gradients of below 10 millimeters mercury. So what is the explanation for the fact that both a sapien and a Navitor have intra-annular leaflet position, but that the Navitor has clearly better hemodynamics than the balloon expandable sapien? Well, this has all to do about where and how the commissural posts and the sutures are positioned. So here you can see with blue, I indicated where the commissural posts are positioned. And of course, because the sapien has this very short stent frame, it does not have the luxury of putting these commissural posts and the sutures higher up in the stent frame, where the stent frame is already expanding more towards the aortic wall. And that you can even clearly see here. I took these kind of pictures from a kind of a helicopter view, and then you see how much space these commissures and these sutures take within the opening area with the sapien. I even indicated it here. So you see that these commissural posts and sutures, they take quite a lot of space in a sapien, whereas in a Navitor, for example, where also the leaflets are positioned intra-annulally, but you see that the commissural posts, they are outside this opening area. So the effective opening area in a Navitor is larger than in a sapien. So they are similar to the other self-expanding valves like an accurate and the evolute, which has supra-annular leaflet position. So I think it's probably a misconception to talk about the difference between supra and intra-annular leaflet position. We should forget about this. We should talk about probably the difference between having the commissures and the sutures within the opening area or outside the opening area. And this is thanks to the fact that you have self-expanding technology, which has a taller stent frame, and having the luxury of having these sutures on a higher position and a little bit out of this opening area. Lastly, I want to touch upon commissural alignment. Has been hotly debated. Also, Marco Barbanti has talked about the importance of commissural alignment for coronary access, etc. Also, there is good evidence it has impact on, for example, the risk of central leak, as we've shown in a couple of patients. Also, there's good evidence in bench tests results that having your position, your valve, even if it's a surgical or a transcatheter heart valve with commissural misalignment, that the stress on the leaflets is higher, and that these leaflets are more likely to degenerate earlier. And this has also been proven in a paper which is just published 2 weeks ago by the group from Raj Makar from Cedars-Sinai, where they say that commissural alignment after balloon expandable TAVI is associated with improved hemodynamic outcomes. As you can see, if in these cases where there was misalignment, there was first of all a slightly higher risk of mild central leak, as we also have shown in Copenhagen. And also there was an increased risk of a relative aortic valve gradient increase. So again, showing that obtaining commissural alignment probably also has a good impact on the gradient and the hemodynamic performance of these valves. But of course, finally, I want to say everything is depending on the patient's longevity or the life expectancy of your patient. Now we're talking already of about 5 to 8 year follow-up. Of course, if you're treating an octogenarian patient, it's not that important. But the more younger patients we treat, the more we should be aware about our TAVI valve choice, also thinking of durability and maxing out the durability of this valve. And then finally, this is not really the topic of this presentation, but still, if you have a regenerated TAVI valve, you have to know how to treat these. And also, as also Henrik Trede already touched upon, there kind of a lot of studies or research consortiums thinking on how to tackle these regenerated TAVI valves. We have to understand a couple of important concepts, like what is the hemodynamics we can obtain if we put one valve in the other valve, TAVI valve in TAVI valve? What is neoskirt length? What is the leaflet overhang? We have to explain the community really well what this is and what the risks are and what to take into account when doing a TAVI in TAVI. So by this, I would like to conclude this presentation about valve hemodynamics and valve durability.
Thank you, Ole. That was a great overview. We are running a bit short of time, but still, I'd love to have a short comment and then a question. The comment is that it's interesting to see now that what we learned painfully in surgery is now also in the TAVI field, that not every valve is the same in terms of opening area, in terms of gradients. And in surgery we now know, and we carefully compare valve types, what valves have the best opening area compared to those who have lower ones, and try to pick those with the best area. And this we learned also in the phase of TAVI, because you showed us how important it is to look for this, and patient-prosthesis mismatch is now much more on the focus than it was before. And at least the PARTNER 3 trial has shown that with proper surgery, using larger valves, you can achieve even larger opening areas in surgery than you can achieve in TAVI. But the question would be, now we are a bit in a dilemma. We know that the best performing hemodynamic valves are the self-expanding supraannular position valves, so that seem to have even better durability. But then on the other hand, alongside this session, we learned that there may be difficulties when it comes to TAV and TAV afterwards. So how much does this now have, again, an impact on your choice of first valve?
Yeah, I mean, we have to do it with the valves we have nowadays, but and I know this is indeed a dilemma. You can maybe even see how important this coronary artery disease is for that patient. If you have a coronary angiogram where there's absolutely completely no atheromatosis even, you can maybe forget about this and maybe try to go for the valve that gives him the best valve durability. But if we take it out of this current devices we have, I think the companies are all moving to a kind of more similar kind of valve, where you will see that probably core valve, the core valve kind of types, they will lower their leaflets slightly lower, because they found out that they don't need this extreme height of leaflet position. Whereas maybe the balloon expandables, there will maybe come in a couple of years. There's even an Australian company, even a balloon expandable, where the frame is just a tiny bit longer, giving the chance and reducing, actually it's reducing also the sutures. So these commissures are taking much less space into the opening area. So I think that's a field where the balloon expandable valves has to work on. And then the leaflet position and the height is where the self-expanding valves has to work on. So these valves will probably evolve to more lookalikes in the near future, I think.
Yeah, that would be very interesting to see. So thanks again, Ole. In the interest of time, we have to move on. It's my great pleasure and honor to introduce Vinod Turani. Basically, Vinod does not need any introduction, because one of the most world-famous surgeons in the field, actually, who has done several studies and really took part in the process of developing this field. He's working at Piedmont in Atlanta, and he's giving his talk about alternative access in TAVR. Vinod.
Henrik, can you hear me okay?
Yes, very well.
Okay, great, thanks. I'm from Atlanta, but I'm in Poland right now. Hopefully the connection is good. Thank you very much for inviting me. These are my disclosures, a lot of research that we're doing, and I really enjoyed the last talks. We have a lot of interesting conversations to have. The topic that was given to me was TAVR access, and specifically for for alternative access. And this is something Hendrik and I did many years ago. And so now it still continues to be a part of what we do. So one of my roles in the United States is to co-lead the STS-ACC TVT registry. This is every single TAVR place in the United States is put into a registry. And this is our most recent publication that we had in 2020. And what we showed at that time, we just have up to 2019 data. You see that 95% of patients are transfemoral, predominantly with the core valve and the balloon expandable valve. And here you can see that all of the cases that we'll be talking about alternative access are really in that 5% range. So one of the big papers that we early showed was TA versus TAO. And what we showed in mortality is that overall the mortality was higher than it is for TF. This is 1 year. At that time, we showed that trans-aortic had a higher mortality than TA. And in 2007, when I started doing TAVI, these were our two options, and that was all we had. Now we have a lot more options. Transfemoral, I showed you, is 95%, and then the remaining transapical is, I think I've done one in the last 5 years. Transaortic, I haven't done one in the last 5 years. Transcarotid has become our go-to as our third procedure. Transsubclavian for some core valves. I'll show you some data on that. And this retrosternal has really fallen out of favor. And then transcaval has become our number 2 because most patients can go home the next day. So for us, it's transfemoral first, then transcaval, and then transcarotid. Just for subclavian access, we talk about that first a little bit. It's, a lot of times a core valve sheath is used. The minimum is 6 to 7 millimeters. Patent bypass, some people don't worry about that. I do. And so I generally haven't done it for that. And of course, aortic angle can be a little tough. This is just an example of a carotid cut down. It can be done. This is not one of my patients, but just from one of the publications. There have been some studies done from the UK TAVI registry showing the differences between it. Here you can see the survival, the highest with femoral, the next highest was with subclavian, with TA and TAO being similar and the worst outcomes. And so here you can see that, subclavian has early on, even the first 200 days does better, probably because of just the inherent diseases with peripheral vascular disease. You see that subclavian does a little bit worse. Here you can see another paper that looked at the different alternative access pathways. And again, a lot of these papers are, in my mind, somewhat historic now because we're doing so little of these patients. And you can see here, not a major difference between the three that from this meta-analysis. You can see stroke, again, a p-value of 0.74. Balloon expandable is really not done with subclavian. It's mainly the self-expanding valves. The suprasternal access, I personally have never done, but I know that some of my friends have done this. You can see what it looks like. Here you're coming through this just above the notch, almost like a thyroid incision from a surgeon's point of view. And both procedures have been done using this. And it was published early on in 2015. Andy Kaiser, who was in North Carolina at the time, is the one who invented this procedure. And they showed, for instance, the first 4 patients for this in this publication, again, from 2015. And overall, you can see the length of stay is 7 days, 7 days, 15 days, 6 days. And in one of our earlier talks, you heard most 80% of our TAVR patients now are going home on day 1. So I think that this is something that really has to be really well thought out of. And I think that will fall out of favor. Transcarotid, the first transcarotid done in the United States was by myself, Robert Guyton, when I was at Emory University in Atlanta. You can see we published that in 2012. And so it was which I actually learned from my European friends on at an EX meeting on how to do the transcarotid. And here you can see the one of our earliest cases that we did this with. At that time, the French sheath was 28 French. So I used a femoral artery shunt to be able to do a distal perfusion of the carotid because I did a clamp and open and then had to patch it. Of course, now I did one last week before I came to Poland. And there I just do a small needle stick and I'm able to move quite quickly. And you can see the incision is very nice and very small across the board. So there have been some multiple publications on this. The one concern that people have is a stroke rate of 5.7. My personal stroke rate has been 1 patient out of over 100. So less than a 1% stroke rate for me personally. And we do them with general anesthesia. Unlike a lot of the European access, they use a left carotid for their patients. I never use the left carotid. I always use the right carotid. And I think sometimes using the left carotid, you're taking the sheath and you're rubbing it into the greater curvature of the aorta, and you're taking it into the right carotid. So I do not use the left carotid based on some of this earlier data. I've always used the right carotid, and that allows really very little, it's almost zero, less than a 1% stroke rate in my hands for this. I would say that the popularity of transcaval is, I think, also important. Most people probably have not done a transcaval. And there were two institutions at that time. I was at Emory. There was one in Detroit, and then we were the second site in the U.S. to do this. And what you're doing is you're coming up the femoral vein, and then you're puncturing across the abdominal inferior vena cava into the abdominal aorta, and then you're able to, from a right femoral artery, using a 7 to 8 French sheath, you're able to snare the wire that's come across the IVC through the abdominal tissue into the aorta. And at that point, you're able to perform the entire procedure, and I'll show you more about this. But the physiology of the aortocaval shunt, you can see the retroperitoneal space. Here's the inferior vena cava. The aorta, your intuition is that this will bleed to death, but they do not. And so that's what kind of the thought process is. But you can see that the pressure is 80, the pressure is 5, pressure in the retroperitoneal space is about 10. And so what you get is a very quick venous decompression of this tissue. And so there's also a venous sink, and this is required to decompress the arterial hemorrhage. The hole in the IVC must not be occluded. If you close the caval hole, then that becomes a major problem. So you have to always understand that if you ever need a stent, you'll always stent the aorta, not the vena cava. I've had some colleagues who think the bleeding is coming from the cava, which led to, they stented the cava after a procedure, and the patient died relatively quickly. So I think that's very important to understand, that you can see when you pull the sheath out, blood goes right into the cava without a problem. So I think the baseline CT is very important. We really analyze these quite a bit. We find the area, you have to make sure that you're not too close to the renal artery, so that if you do have to put a stent in, then this becomes a problem to close the renal. So last week we did a transcaval, and we did have to stent the aorta, very small calcified aorta, and we were just placed a stent without a problem into it. And here you can see now, you have to find a calcium sparing window. Here you can see this catheter is coming up from the inferior vena cava. This pigtail is from the left femoral artery. So the pigtail is in the aorta. The catheter here, the IMA catheter, is in the inferior vena cava. You also, on the back table, what you're doing is you have a total of 3 wires. You have the microcatheter, you have a wire converter, and then you have the actual guide wire. So we use a stato wire, a piggyback, and a navicross. So there are 3 different kind of pathways that you require in order to do this. You hook it up to the bovie at the end of the wire after you've taken the sheath off, or the coating off, and then you use the cut button at 50. You don't use the coag, you use the cut, and that allows a puncture from the IVC into the aorta very cleanly. And a lot of times what you're able to do is base it on the spine processes, and that's how you make the decision. From the CT, you're able to pre-plan or where you would do the entire injection. So here you can see the wire tip is there, the piggyback is there, and the navicross is there. So 3 wires, a wire and 2 sheets are back to back to back. And here you can see the snare, which is coming from the left femoral artery. So there's the 6 to 8 French Lima, and sometimes you can use the RDC1. And here you can see if you have biplanar, it's sometimes easier, but with us in our cath lab, we do this under minimalist. We have no general anesthesia here. We're just doing this with local sedation. We don't have biplane, so we actually just move the gantry. But if you have biplane, it makes it a little bit easier for this part. You can see that you're moving the catheter back and forth to make sure you're perfectly in the middle of the snare. Your II has to almost be 180 degrees in order to do this. Now you can see the wire, you hit the bovie and you push the wire across. You can see the wire is going, and here you can see the snare is opened. And then what you do is you push the wire till you can feel the left side of the aorta. You can see this wire is going, and you can feel and tap the left side of the aorta. Once this was done, then you're able to snare it very effectively. And here you can see the snare has captured into it, and we'll telescope this into the actual sheath. And here you can see you've telescoped it in sheath. So now you have a wire, and then now what you're able to do is push with the snare at the same time, push with the wire, so that the snare, which has caught the wire, is going to go into the thoracic aorta. And so at that point, then you move your microcatheter, and then you move your sheath. And then once you've done that, you now have full communication, and then you're able to put your Lunderquist wire into the descending thoracic aorta. And commonly, this is just that we are, do about 550 sapien cases a year now in our hospital, and we generally use this sheath. We do dilate once with just a dilator, and then we bring the E sheath up. And here you can see just an example of the dilator going in and out. And so the dilator is coming from the right femoral vein into the abdominal aorta. And here you can see sometimes you get caught up. You can see the outline of the aorta. So you have to be careful on doing this. Sometimes you have to redilate if you don't push too hard. You can see we're going to take the sheath out and come back into it. So I think you just have to be careful on how you do this. The valve part is the easiest part. Here you can see a Sapien 3 23 millimeter is done, and you can see the result with this. On the way out, you get a 10-8 amplatz or ductal occluder is all that's really required. And here you can see the deployment. First we were very scared on how we did this, but now what we do is we really just pull the sheath all the way back. You can see that the sheath is here. You can see the disc of the 10-8 PDA device, and we're using an Agilis catheter. And so you just pull the sheath back. It doesn't cause any problems. Once you do that, you bring the disc to the right side of the aorta with the Agilis. You can see the pigtail catheter looks good. We've just made a little injection there to make sure everything looks okay. And then you back the Agilis out. And after you've backed the Agilis out, then you're able to completely release. And so here you can see the disc is right here. And now this shows a little bit of a shunt right here, and that's okay. It'll close. We've already given protamine, usually 20 followed by 20 of protamine. So it's usually 40 of protamine is given. And then what we're able to do is release this. Now, what we do, and you can barely see it, there's a coronary wire that we put in. It's right here. We put that wire in, so 014 wire, in order to, if we lose access or pull the disc through, that we always have access inside. And here now you can see the Agilis catheter is completely pushed back. The disc is the 10-8 PDA device is pushed forward, and then it is released. And so here you can see this patient has a little bit of a fistula. And if you're worried about that, then you can just quickly put a stent graft in. If not, then it usually closes on its own. And here you can see the final result after releasing. You can see that there's really no extravasation, and the PDA 10 device is nicely seated. There have been some complications, and you can see here this is an occlusion. This is a funneling effect. This is a cruciform type of effect, and this is full extravasation. So really different ways of looking at this. And here you can see a post-op day 4. When we were first doing this, we would CT everybody, but now we don't do that anymore. Most of our patients go home on day 1, but this is what it looks like on post-op day 4. So one of the earlier studies that we did when I was still back at Emory and Jack, where we kind of described this, and this was the earliest series really to look at this. You can see the mortality, STS mortality was 8.9, our actual was 4. And you can see that there were some vascular complications, but this is really the earliest experience. And now it's gotten where it's a routine case for us. TAVR will dominate with greater than 90% for the foreseeable future, maybe always, never 100%, but very close to it. Heart team should be fast on all non-TF access. Subclavian may provide less morbidity than TATAO, and this has really gone away now for the most part. I think for us, transcaval is procedure choice number 2 because we can do it with no anesthesia, and they go home usually the next day. And then transcarotid is our third form of TAVR access. Thank you very much for allowing me to give this presentation.
Yeah, thanks, Vinod. That was really a great talk. Just a short, quick question before we ask Dr. Yin if we have time for discussion at all, because the session ran out of time a bit. Do you have experience with transaxillary TAVI actually, so really puncturing and not cut down? Is that something you do?
We have not done that, but I know a lot of my friends, especially in Seattle, have done percutaneous axillary. For us, it's always been the pathway has been caval because it's still percutaneous. But I know that some of my friends have done that across the country. I have no experience with that. Have you done that, Hendrik, yet?
Yeah, I've done a couple of cases. I think it's quite good. It's a valid alternative, and since we have this, we stopped our cut downs subclavian, so that seems to be something to look into.
Yeah,
but Dr. Yin, do we have time for discussion, or do we have to move on because session time is over?
We can allow another 1 or 2 questions.
Hendrik, I have a question for Dr. De Backer, which I really enjoyed his presentation. And, that we've been more of a balloon expandable site. And, this reminds me of the conversations that we have in surgery with stented valves and stentless valves. It's almost the same conversation. Mm-hmm. And what we've seen in stentless valves in surgery, the subcoronary freestyle route, is that there was about a 5 to 6 millimeter benefit with stentless valves over stented valves. But in the United States, we almost never do stentless valves anymore. When we looked at 5-year mortality, there was no difference between a harder procedure, a stentless valve, versus an easier procedure, a stented valve. So I almost, and Hendrik may comment, but I'm almost seeing the same parallel that we're having in does 5 millimeters or 6 millimeter gradient really make a big difference at the end of the day?
Well, I would say still, they could definitely do a better job with, if you look to the sapien and you look from the top, these commissures and these sutures, they take just far too much space. And I know there are other companies working on this to have balloon expandable, also short frames with much less sutures. So there is a lot to gain there, I would say.
Yeah.
Yeah, and Vinod, one of the reasons why we don't use stentless valves so often anymore is also that they're not good targets for future TAV and SAV, right? So also we have to keep this in mind. And they usually didn't, despite the better hemodynamics, the long-term results haven't been as good as for proper stented valves. So that's another point. So it's a colorful picture, actually.
Yeah, just one question I have for Vinod. We also do transcaval, but I know from screening our patients for alternative access, so we also do 95% transfemoral. But if you have talk about these 5%, only 40% of them are actually suitable, eligible for transcaval. So that's something which has to be mentioned. Even if you take this as your second, you will still need for sure maybe 2 more other alternative access options.
Yeah, I think you're right about that. And so carotid is our third pathway. And if we don't do carotid, then we have done, in fact, I did 1 transapical, I've done over 300 transapicals, but I did one the other day because we had no option for anything. So I think you have to have at least 1 to 2 backups.
What we do now in Copenhagen, our second approach is really pushing with shockwave assisted transfemoral. We push it really far. Really circumferential calcifications, 3 millimeter lumen. You can do it successfully.
Yep, I agree with
and
that.
then the second one is percutaneous transaxillary. And if you compare percutaneous transaxillary, this you can do in 80% of patients needing an alternative access versus 40% with transcaval. I don't want to say I also like to do transcaval.
Have you done balloon expandable with a perc axillary?
Yeah, because you can easily do balloon expandable via transaxillary as well. Yeah. But great presentation.
It's not so easy, I have to say. It's much easier to use the Evolute transaxillary. So
True. Great. But it is possible. Yeah.
Thank you all. Thank you all. Thank you all the old friends and new friends to attend this meeting. I appreciate your attention. Thank you very much.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Good afternoon. And the next session is lab case 4. And we have moderators of Wei-Hsian Budari, he's from Thailand, and Dr. Lin Jiaxun from Taiwan, Taipei, Xinguang University Xinguang Hospital. And our panelists including Dr. Savan from Hong Kong, Dr. Toru Nagaruma from Japan, and Dr. Zheng Jinyi from Taiwan, and Dr. Shi Zhiyuan from Taiwan, Dr. Li Yi from China, and Dr. Luo Jianfang from China, and Dr. Ying-Hsiang from China. So we have live cases. And the first case is mitral transeptal mitral valve valve, which will be performed by our colleagues, but this case is finished earlier. So Dr. Li Tsai, we introduced the case and the whole procedure. Dr. Li Tsai, can you start your presentation?
So, do you see the slide and
yes.
Okay.
Yeah.
So the case is 83 years old female. She was noted dyspnea on exertion for 2 months. She received Edward SAV 31 millimeter in 2006, and now he come back for severe mitral prosthesis dysfunction and MR. She also received the CABG at that time to LAD and RCA, and years later, she received stenting to RCA and LA circumflex again because native vasoprogression. She had comorbidity of hypertension, hyperlipidemia, paroxysmal atrial fibrillation. STS score is 6.6, and the frailty score is independently. Hematocrit is 30, and the creatinine was 1.5. Here we can see transthoracic echocardiography. You can see here the mitral regurgitation is quite severe, and the eccentric jet over here. And I think this is caused by the deviate partial tearing. The mitral pressure gradient, the mean is 3, and the max is peak is 13. And we look closer. Here we can see the porcine valve is partial flared, so it causes the eccentric jet. The dysfunction of the porcine valve dysfunction is a flare type. It's quite common, and we have done several cases of the bovine. It's always stenotic type. So that's at this moment, this patient needs a new mitral valve. And the multi-site CT show here the coronary artery, the bypass graft to LAD, and the 2 RCA is okay, and it's still patent. The true ID for this Edward SAV 31 millimeter is 27 millimeter, and the height of the SAV is 20. And we also do the measurement of the mitral prosthesis. The average is 26 or 26.5 hours, such as just like the app show is ID is 27. So we plan to use the S3, and the 29 S3 have the height of 22.5, and with a skirt outside the sapien 3. The transfemoral sheath is 6 French, and the nominal area is around 649. So the neo-LVOT we measured is 490. Outer mitral angle is 116. We also check the atrial septum. The minimum requirement of the valve-in-valve transector is 40 millimeter, and in this case is 42.9. However, you can see here, because in the earlier year that we replace the mitral valve, usually cut the septum, use the transector approach. So the atrial septum is become smaller and thicker. The thickness is around 3 millimeter, and the puncture size is around from 5 millimeter to 6 millimeter. That's the way we can do it. And if we failed, we needed to use the 5 ICS anterior SLI for apical approach. We usually prepare for apical approach for the mitral valve involved, even it's transeptal one, because bailout procedure must think about that. So today's plan is use transeptal mitral valve replacement with Edward Zeppelin 3 29 millimeter with a full volume, and because of the septum is quite thick, we prepare the radio frequency transeptal puncture, and the bailout procedure is transapical one from 5 ICS, and the patient was injured from the left common femoral vein. Any problem or any question from the above cases? No? So we proceeded the procedure, and we insert Edward issues first, and then insert the BRK to prepare for the puncture. And when we prepare as a T is standby, we usually check the T for the by cover view. So you can see here that the transeptal one you need to puncture the septum posterior and inferior. So this area is very quite thick, and you can see the tension over the atrial septum. So that when we make sure that the position is around halfway of the new the old mitral valve. So we use the radio frequency. So when we puncture that, as the portions is inverted to LA, and then we change to the super stiff wire, 7 centimeter tip. Usually, we hope to press the wire to the RSPB, and you can see here the tip is soft, so that we can keep the position, and then we change the sheath with agility. Now we store the puncture sheath and the needle. Now, because we talked about earlier that in left side procedure, we usually insert the brain protection device, the Sentinel. In the beginning, we usually take autoangiography to check the innominate artery, left common carotid, and the left subclavian artery. Now we puncture the radial artery and insert the choice PT atrial support, and the Sentinel come in. Then the wire was inserted into the ascending artery. Usually we release the first one, and you. Now the first one is open. And curve the tip of the Sentinel. Then we advance the wire into the left common carotid artery. Because we have checked the angiography, so that we perf the carotid artery with the choice PT. Now the choice PT it come to the distal internal carotid artery, and then we store advance the Sentinel, the second number 2 button, and then let the system sitting in the carotid artery corona and advance the third part. So the net was opening at this point. Then keep the position in the ascending aorta to capture any clot or the depth from the valve. Now we start to change the Achilles caster into the LA, and because the whole thing is quite thick, and sometimes we might be injured to the atrial tissue or auricle. So we should check the auricle. You can see here is ridge. So always advance the system and check the T and prevent to injury the LAA. So in this case, the Achilles is too far away, so that we need to withdraw the Achilles caster. And at the same time, the TE was checked. The Achilles is still remain in the left atrial side. Now the Achilles can angle into the mitral valve, so we start to probe the mitral valve with a soft tip wire. So it takes some time, but it's always not too much time. And then the wire was in the left ventricle. So as we use the JR to replace the J-tip wire with the safari wire. Be careful for the safari wire, so the Achilles should be inserted the position into the mitral valve in the left ventricle, because the Achilles wire is quite stiff and sometimes push all things out from the left ventricle. So when you do this procedure, should be pay attention, and sometimes you need a snare to pull out the wire or the caster from the aorta, because there's a tendency pop out to the left atrium. Our previous cases, the wire was pop out into LAs several times. Now, in this case, the safari wire is pushed out. We can play again. The safari wire is have a curve, and it's always push the position to the upper part, so that you need to pay attention in this moment. And the safari is better than the Boston extra stiff, because the curve have some soft touch, so it can prevent injury to the apex when you push the wire or system into the LV apex. And the alignment of the safari wire is better than other wire or you handmade wire, because the trajectory is quite good in this moment. Now we use the PTA balloon to dilate the cetostomy, and at the same time, another assistant insert the temporal pacing wire into the right ventricle. Okay, here you can see the cetostomy balloon is 12 millimeter, and we slowly inflation the balloon. You can see the setting is over here as a waist, so we inflation. During this period, the whole thing is down in the septostomy, and we can make sure the stent can enter through the mitral valve, and it'll be smoothly. So at this moment, we did not deflate the valve deflate the balloon, and the valve is prepared. And before you crimp the valve, you should make sure the valve orientation is quite good, because the skirt should be in the atrial side, and the open area, the open frame should be in the LV. So that is the tip is the LV is the open cell, and the skirt is the lower part. Now the assistant is prepared above. So during the depression, the balloon, we usually push the partial inflated valve into the ventricle to check the pathways quite smoothly, and that we remove the balloon. Now the valve is ready. Please rename the E face down, because it's updated to the TAVI procedure. 29 millimeter TAVI H3 is quite heavy and large, and it got some resistance when you insert to the issues. However, you can gently push, or sometimes you need to pull the sheath a little bit. Or you can see here is some resistance, but you can elevate the valve gradually. So at this moment, the sheath should be pulled out a little bit, because the H3 is a transmissible one. You need to assemble the valve, and the sheath tip should be at the IVC at the delivery level, and then we unlock the sheath and pull the balloon back. So, but make sure the tip is quite straight, because you must aim the balloon at the place the balloon in the middle part, or you inflate the balloon and the stent is uneven. It causes the valve embolization. Now the valve is cross the septum, and you can see here quite smoothly. And you usually have some resistance when the tip or the valve enter cross the stent, all the mitral processes, because the whole system is quite bulky. So we pay attention and place the C-arm parallel to the lower end of the mitral processes. And you can see here that the mitral processes and the O3 tip is in the line. Now you can see when you push up the valve, and sometimes it's stuck over here, and you cross a point, and you can see it's hard to push in, and now it's crossed the mitral valve, and have some tendency into the left ventricle. So the subaru I have a very good advantage, because when the nostril into the apex is just curved in the middle part, do not injure the left ventricle apex. And at this moment, the TE should be checked the positive position. Now we adjust the valve to the mitral level. Usually, the H3 stent when you open it is 22.5 millimeter, and the stent height of this SAV is 20. So the valve cannot push too much into the left ventricle. And now we unlock the sheath and withdraw the pusher to the 3-dot marker, and make sure that the pusher should be far behind the 3-dot, because sometimes the balloon is still in sheath and the valve did not inflate completely. It caused the valve embolism. Now we have a test for the check the position is good. Now the tip of the SG is just around the mitral valve. Usually when we push in, the valve is more easier than we withdraw the valve. So remember, we dip the HN side a little bit more, and during the middle we can push a little bit. Or you can adjust the wheel to adjust the balloon and the valve system into the LV or LA. And when you communicate to your carriage, to remember to use the left ventricle or left atrium, do not use the forward or backward, because sometimes it got a misunderstanding when you dip in play or a valve and push in or pull out. Now we start the overdrive pacing and inflate the valve very slowly, because the alignment of the transcatheter one is not as better as the transapical one. So you can see the valve is have a outbreak interaction of the new valve. Now we inflate very slowly, and do not worry about the overdrive and the low blood pressure, because the heart usually recovered itself. Now pacing on, and the assistant watch the blood pressure below 60. Now the inflation and the valve will auto centering from the new valve and the older valve. At this moment, you should keep attention. The new valve tip should not exceed the old one. And now you make sure that everything is in a good position and totally inflate the valve. And the counter 1, 2, 3, 4, 5, and the deflate. Now the valve is in a good position. However, you cannot sure that the lower end is good or not, because you can see here it still have some angle in this part. So the assistant should angle the CR to let the positive parallel, and the frame is in a line, and everything is okay. And the position of the new valve is the 1090 position is quite good for this valve procedure. We usually do a post-dilation because some tissue still around the new valve, and sometimes the valve, the SG has a recoil. So from the ST generation, we usually post-dilate. So the SG, we also post-dilate the valve. And the shape of the new valve is quite good. And then the echocardiograph checked the new valve. There were no pulmonary leakage. The LVOT is somehow I think it's good. So we can retrieve the balloon and everything out. So the balloon and the wire is removed at the same time. And then the echocardiographer check the ST and everything. If everything is okay, so we just remove the wire, the system out, and even in the vein puncture, we also do the ProGuide procedure. Any comment from this mitral case?
Okay, thank you, Dr. Li, for your introduction. I think the mitral valve involved is still early phase in Taiwan, but I think it's a very good alternative to the patient with failed mitral prosthesis who cannot receive the repeat surgery. But for this case, I think the other important thing is the when you mount the valve, the skirt should be point upward. It's the opposite direction to the TAVI, and also the direction of the curve, because the transfemoral TAVI is curved to the left side, but this is curved to the right side. So the E marker should be face downward. I think Professor Yin is here, and he performed this case. Do you have any comment on this case, Professor Yin?
Well, this case have 2 points to discuss. The first is his septum is really thick, and we have to use a radio frequency needle to puncture the septum. Fortunately, it is well done. So the second is that the patient need a 29 valve, so we have to align the trajectory very well before we get the valve there. And we are lucky that everything goes smoothly and the final result was good. So Simon and Wei-Hsian, do you have any comment on this case?
Yes, thank you very much. Sorry, Dr. Wei-Hsian first.
Go ahead, Simon.
Okay, so it's a very nice illustration, and for the septum, I agree that sometimes we have difficulties crossing, so we also use the radio frequency needle, either the newer VersaCross or the Baylis original needle, and sometimes we need very prolonged dilatation or serial dilatation of the septum before we can get the valve through. And some occasions, even we think we have enough dilatation, and once the valve was there, we cannot pass through. We need some other maneuvers, for example, to cross from the other side for additional ballooning to cross the septum. So the case was shown in a very simple, straightforward case, but actually there's a lot of experience behind that in a center like Chien-Sung. We also learned a lot from the transapical experience as well. So I think nowadays we use exclusively transeptal. And I would like to ask to which moment at the procedure you would think, what about changing now to transapical? Is it the septal crossing part? Is it the angulation part? May I ask for the experience from Chien-Sung Hospital?
Yeah, we follow you. Nowadays, all the cases we attempt transeptal first. If it fails, in one case, it is really hard to cross the valve. And then we make a small puncture transapically, and then use the snare to snare the wire, and then we use a bilateral approach to establish a rail, and then the valve can push easily.
So, this is Wei-Hsian here. Have you had an incident where you don't have enough room or height in the left atrium to manipulate the valve down the mitral valve?
No, not yet. Not. We didn't encounter this kind of difficulties.
Okay.
I
think the left atrium, the septal should be 4 millimeter, just about the same with the mitral clip, because the 4 centimeter is when you tip down from the top is have a angle. However, we do a bilateral approach wise, the sector is just around 3.5. So it gets very hard to push the device. So as another case, we need the bilateral approach. I think that's the reason that sometimes some proctor or some implanter mentioned about the 4 centimeter. However, that they did not talk too much about why needed 4 centimeter.
So may I ask, if any occasion I learned from your techniques that for valve in-ring and round valve, we do flaring by second ballooning, or sometimes we use additional volume in the first dilatation to make sure it flares on both sides. So what is your experience on this?
Usually, if, as you can see in the first inflation, there is already a raise there. So we don't need additional volume anymore. But you can shape it with the second inflation. Yeah.
I think Xiamen University Hospital Professor Wang, they are ready to.
Okay, let's
present
move
the
to
case.
the second case. Please chair the case. Thank you, Dr. Tsao.
Thank you, Dr. Ying. Hi, Professor Wang.
Yeah, hello.
You are online.
Okay,
Here,
thank you.
We have
Professor Tsao.
Yeah, we have Professor In here and Dr. Wei-Hsian and Dr. Lin Jiaxun from Xinguang Hospital, Taiwan, and the moderators Dr. Simon Lin, Dr. Toru Nagaluma, and Dr. Zheng Jinyu from Taiwan, Shi Zhiyuan, Taiwan, and Dr. Luo Jianfang, Dr. Yuan-Yiqiang from China. So can you present your case?
Okay, thank you, Professor Tsao. It's our pleasure. It's our pleasure to be here to present this case this afternoon. Thank you for the Taipei WAV. Give us the opportunity. Here is our team. It's Professor Chen, Dr. Chen, Dr. Su, and Dr. Echo, and the nurse team here. It's our case. I would like to let Professor Wang Bing to introduce a brief history of these patients, please.
Okay, thank you. It's my honor here to introduce the live case from Xiangbin Cardiovascular Hospital, Xiangbin University. And this is a 64 years old gentleman, and his chief complaint is repeated dyspnea for 2 months. And the lab examination showed elevated NT-proBNP and the troponin T with a normal renal function. And the BP on admission is 18.6/42 millimeter mercury. So this is he also concurred with the coronary heart disease with the New York Heart Association 4 class, and the echo showed the higher pulmonary hypertension, and he has also has a history of the COPD and the old TB, and this is the brief summary of his medical history. And this is the ECG on admission show the sinus rhythm with the some STT change. And this is the echo. You can see the patient with impaired LV function with the EF was 69%, and with the enlarged LV dimension, and the dimension of the diastolic period is 52 millimeter mercury. And you can see the AV peak velocity was the 4.1 meter per second, and with mean free gradient about 40 millimeter mercury, and his speculed area of the aortic with 0.6 centimeter square. And this is the CT scan. You can see very impaired pulmonary image, pulmonary function. As this is X-ray. This is the angio before the procedure. You can see this distal LAD isolation, and a nominal range of the right RCA, and this the peripheral artery angiogram. And this is the STS score, and this gentleman, the risk of the mortality was the 6.3%, and with high-risk patients. This is a CTA evaluation for the TAVR procedure, and this is the annulus. You can see the parameter drive the diameter was 26.9 millimeter, and this the LOVT section, and S is the superannulus about the 30 millimeter above the annulus. You can see the oral shape of the aortic valve. And this is the STJ, and the diameter is about 62 millimeter. So this is the height of the left coronary and the right coronary. So this is the brief video of the aortic section. You can see a very calcified left lid of the non-coronary side left lid, and some confusion of the right and the left coronary left lid. And okay, and our strategy is 22 balloon.
So this is a CT scan of these patients. Because the patients the patients assumed to do the aortic valve transplant, aortic valve replacement, because patients suffer from acute pulmonary edema, and transfer to our team. And the patients with the IBP seems stable, because the patients 4 days ago put the IBP, everything's stable. So today we are going to do the TAVR for these patients. So any suggestion for these patients? We can show the X-ray. Because we do a CT and CT before, we didn't show the peripheral artery. Because the peripheral artery is relatively, it's okay. We use 20 sheets already inside now. We have a next picture. Yeah. Yeah, this is a co-plan of the aortic angiogram. The next, and this is a this is overlap, cusp overlap angiogram. Next, then we cross the wire. Next, yeah, next. Yeah, this is a pigtail in left ventricular. We measure the gradient is about 670 gradient. Here we are. We just finished. We stopped here. So, any suggestion from the chairman and panelist for this case?
There is a eccentric calcification there. What's your strategy to deal with this kind of calcification? And which valve are you going to use? And about the sizing, what size would be appropriate for this case?
Okay, I think it's very big calcified in the non-Wasava coronary there, and I think the annulus diameter, according to the annulus diameter, and you can see the valve from the CT. It seems rheumatic heart disease. It's a narrowing part is above the valve about 6 or 7 millimeter. You can say this is annulus. This is above.
This is annulus. Yeah.
Yes, it's annulus. 再往上来。
Okay.
一针一针 step by step, you can say. It's 再往上
2 millimeter above the annulus.
2 millimeter 再往上 Yeah, this is a 4. You can say here is a 6 millimeter, 8 millimeter.
8.5 millimeter.
Yeah. So the native valve is relatively higher compared with the annulus, and we are going to put a Taurus. It's a Taurus Elite. It's a domestic from China valve. Taurus Elite seems as a core valve. So we would like to use the 26 valve. This is a chart about the Taurus Elite.
So you are expecting to anchor supraannulally?
Yeah.
So any comment from the panelists?
I'm not familiar with valve, but it looked like a supraannular self-expandable like the core valve, the hydra valve. And I guess if you size it to the annulus, you would go bigger. But if you size it to the supraannular measurement, you can go with a smaller valve. But why 26, not 29?
Yes, if according to the annulus, we would like to use the 29. But I think it's size above the annulus, the 2, 3, 5, 4, 6. It's a very stenosis of the aortic valve and very thick the leaflets, and as well as the calcium. We consider maybe the 26. We put a -2 or -1 or -3 should be better for this valve, because the outskirt is only it's a 5. Outskirt is 5 millimeter. We would like to better to seal the leak. 26 should be okay if we put a higher about the valve.
Professor Wang, this is like a taper type the bicuspid aortic valve. If you want to do the post dilatation, I think the selection of the balloon is very critical. Yeah.
Yeah. I would like to use a balloon dilatation. I use the 22 balloon to do the pre-dilatation.
I noticed that the left coronary height is 12. Am I right?
Left
coronary height.
Yeah.
One being it's 12. Yeah.
Yeah.
So in bicuspid, the leaflet usually longer than the coronary height. So maybe a 26 is better, because we don't want to oversize too much.
Yes, Professor. This is one reason we choose 26, because the leaflets are higher than the coronary. The leaflets. We are going to give a balloon dilatation. Pace 准备起搏啊！好，现在血压100左右，起搏，快速180起搏，起搏，来了吗？起了，血压还没下来。停一下来，停一下，停一下，下，好好，可以了。起搏，起搏停了，起搏停，起搏停，好，起搏停。刚才 pacing 不是太好，来，没事，等血压下来我们就喷啊。来，重新开始准备起搏，准备看你的。血压再好，打，来打造影剂，打造影剂快 ，OK。OK， 然后进来，停起搏，起搏停。Yeah, we're waiting for the blood pressure back. 慢点，看眼单。If we use a balloon, we use a 22 balloon. You can see the 22 balloon seals the valve perfectly without any leak.
IVP 打开。
So theoretically, we use a 23 can also seal the leaflets. Show me the 那个什么，看一下来 balloon. We can see the a neck narrowing is just a height of the valve. So the native valve is very high. So we would like to use 26
I think 26 is okay, because the sinus is big enough. Even the calcium stand up, it will not occlude the coronary artery.
Yeah.
And I think the balloon seal the supraannulus plane is quite nicely. So use 26 should be fine.
We would like to use the cast our left view to implant the valve. Any suggestion for the height of the valve? Is 0 or -1, 2?
I think you have core issue. We don't learn much about the torus. What's the height of the valve of the torus?
The torus valve is relatively lower compared with Qiming, compared with Vita flow, compared with Venus. It's about 5 millimeter above the lower stand.
So, what's your plan to implant? The implantation test would be 3.
I would like to use a -1 to start because I would like to seal the
And how about the radial force of this valve?
Radial force is between the venous and Vita flow.
Yeah, because
maybe
you have heavy calcification there. So
yeah.
if the radial force not enough, you may need aggressive post dilatation.
Yeah. OK， 左前弦，大的，来左前弦，我们准备跨挖啊，来看看，来看好啊，钢丝还可以再往前一点点 ，OK，ready， 好 ，OK， 来回来，来。
So how about the commissural alignment? Do you have any tip and tricks for the commissural alignment of this device?
I would like to use this is a cross overlap view to implant. Use pigtail and calcify with because I don't think the patients have the if I put higher, I don't think the patients need to put a pacemaker. So I don't worry about this. Only what maybe the if I put the wire below the annulus 2 or 3, it may once the deflation. I'm worried about the valve stenosis can too deep. That's one. I would like to 给10照相机10就好。Yeah。
那个曹教授，这个瓣膜它不能没有去做那个 alignment 的这个功能，只能随机的。
OK， 好，谢谢。
来，一点点放啊。So 慢慢。
Does this valve have any advantage over any other self-expandable that you have?
Dr. Wang Bing, can you share what's the advantage of this?
Yes, I think the radial force of this valve maybe the same to the envelope
too high.
And the out score is about the length of the out score is 5 millimeter and the inter score is 10 millimeter, and the is belong to a intra annulus valve design. I think it's very
好，先等一下，来造影，起搏继续，准备造影。
We want tricuspid valve and maybe the coronary access rate.
慢点 ，slow, very slow.
I think this is
等一下 ，very slow.
This valve.
Very slow. 直接放到那个不能再放的位置。 不能回收的位置，放到不能回收的位置，放到不能回收，到了吗？还可以放，还可以再放，放到不能回收的位置，
再放，可以再走。
Is it recapturable?
Yeah, it's recapturable. 来，放到还能走吗？
可以再走一点点。
还能再回一点点吗？
可以再走一点点。
回到让瓣膜工作再回来一点，可以回吗？你们说话。
可以，
来，
可以
再
回，
回，再走一点点，放。
OK， 好 ，OK。
好，停到这不动。So it can recapturable. And now I think the valve is working. 来，准备造影哈 ，Andrew。Since yeah,
is quite high, yeah.
Yeah, quite high.
But I think
do the post dilatation. If you want to do the post dilatation, that would be a risk.
I like this position because
yeah, we don't have an idea about this valve, so up to you.
Okay, and we can see just minimal leak on. I think it's okay.
I think it's a very good position.
I think so.
For this type of valve.
I would like to put the pigtail out now. 这行。没有，这就行。来，我们就用这个角度释放啊，或者我们再看一个左前斜的 co-plan。Here's the co-plan. Co-plan.
LAO.
OK. Yeah. 可以了，来，准备好吗 ？OK. Ready? Go.
I think it's okay.
I think it's okay. 那再来那个
That's bad.
That's over them view. OK. 来，我把钢丝推一点点，然后给一点点顶的力量，慢慢释放啊！非常慢，起搏器给我开到130、140、150。好，慢慢释放，非常慢，非常慢。
王院长啊，这个时候要把导丝往后撤，导丝要撤。
我已经撤了很多，他的心尖部很靠前面，对，他的心尖很靠前面。
可能要往里面推一点，会不会张力比较大？
我再推，慢点释放，慢慢的推，
很好。
OK， 释放
，Good。
Very good position.
还有一边没解 ，OK， 解掉了 ，OK，very good，very
good。
来
，almost zero
来，钢丝进，进，小心 ，OK。哦，我刚听到罗主任的声音，罗院长的声音。
哎，你好，对，我一直在看你的表演，对。
罗院长，您觉得要不要 post die 啊？
我想先等一会儿造影看一下。我觉得给我的感觉的话，它应该不会有太大的 leak， 但是我呢也担心，因为它的这个瓣膜，是瓣上最底边到上有5个 mm， 它的缺点是，它的到5个 mm 以上那个地方比较硬，radial force 比较强，瓣下呢那块呢不是很强。那不是很强呢，它的优点是如果放的低，减少这个素质阻滞，但是它的缺点是，有可能会是个椭圆形或者什么。如果我们等一会儿看 echo 各方面，它的 valve 工作是个椭圆形或者这样，我有可能会给它一个后扩。来，我们说起来
gradient 是怎么样？等一下看 gradient。
我等一会儿看一下，好的。
It seems that there is still some waste there.
Yes.
I think so. Yes.
钢丝留住啊。
Maybe you can Angel to evaluate the risk of the coronary. Left.
You may stop the IVP, right?
Yes. 来IVP stop 可以来。现在 IVP 可以 stop。我们先造个 angiogram， 现在可以啊。准备好了吗？给。好，准备好了啊。也。打，哇， I think no leak. Mild. Echo 那个苏主任可以给我们一个 echo 看一看。The diastolic pressure is 64, 65. You can see the echo. Can you show me the echo for the audience? Yeah. It's a color from the central. I think the wire lead.
Very good.
苏主任可以给我个短轴看看那个瓣膜工作的状态。
Look at the cross section and see the stent platform as circular or still have some phase.
这是一个短轴的吧，苏主任？一个看的有一点太多干扰了，看看那个瓣口。So the question is, you want to post dilate or not?
I think it's still not elliptical in shape. So maybe I will post dilate it.
How about size of the balloon to post dilate? 22 or 23?
This is a 26 valve. And superannually, what's the measurement? I forgot the diameter.
And his minimal, the width dilate of the 26 valve is 23.
So maybe a 23 is okay.
Okay.
Okay. 开一个23的吧。Okay, we would like to use a 23 to post dilatation.
Yeah, I think the overall concept is to bring back the valve in its original shape without adding stretching to the annulus, causing extra trauma. And I think in bicuspid anatomy, usually I would try to use a smaller valve, but the trade-off is I worry about some mismatch, patient prosthesis mismatch, because usually those patients have a very dilated aortic root, and at least I would bring back the valve to its original size to have a good hemodynamics. But this is kind of cosmetic reason. But gradient is something I would look upon to. But for this valve, I don't know the behavior. But using a effort, I mean, not a too aggressive polarization would be my choice for this kind of scenarios.
So maybe we can evaluate the gradient by the echo first.
苏主任，你用个超声看看 gradient。快！
Yeah, I noticed that there's some systolic aliasing, so I'm worried about the gradient.
苏主任，你先 echo 测一下 gradient。快，球囊23，准备。我们打电话让工程关掉。那值哦 ，OK， 来我们看看。
8。
钢丝拽值。Yeah, this is a 23 balloon. 苏主任多少 ？gradient 多少
？8。
Gradient by the echo is 8. 苏主任你可以退一点。
That's the mean gradient. The peak gradient is 20 or something.
Peak gradient. 苏主任的 peak gradient 你测一下多少
？20.
Okay. I think we should balloon it, right?
OK， 把那个 X 线弄上去啊。
好。 IVP 已经停了是吧？好，准备我们再后扩哈。等一会儿要个好的快速起步，刚才180。OK，
至少180吧。
来，直接到180。不用打造影机这次啊，180起步，看着下来你再打。好，打，快点打。好，起搏停。
I think the shape is much better.
Yeah, I agree.
Looking, it's quite better looking.
一个人跑上去。
How about the echo?
来，赶紧 pigtail 给我上 ，pigtail 换过来。
让我看一下 echo。echo
再看一看。
You can manual the gradient directly with the pigtail.
Yeah, these two. That's it, huh?
That's it.
Okay. Okay, I use a picture to measure the gradient.
Okay, very good.
I use a C line to. Okay.
Almost zero.
这个是造影机。
来，那个转到我们那个超声来看血压来，2个。
看，把那个血动传过去。
血动力学传一下。
把那个压力曲线传过去。
压力曲线传一下。
Oh, 4.
It's great. 0.
I think it's
almost
great.
0.
Yeah. Perfect.
Yeah. And the ECG also looks very good. No conduction disturbance.
Yes. 苏志，你把那个撤掉来。
Yeah.
苏志，你把吃到超声车，我最后留一个最后的 final angio 给他。啊，那个刚才给我那个
锥形，
那个锥形给我。
锥形。
2.6 米。
So I would like to use a final angiogram to aortic angiogram. Yeah. 可以打15毫升，加一点。啊？
没断过，一直没断过。
可以。准备好了吗？没有断开过吧？
没有，一直在。
好了吗？准备好啊！打。
Very good.
I think this is the final angio result.
Looks very good.
Yeah,
I think it's great.
Yeah.
You can finish. Okay.
Any comment from the panelists?
I guess you can take the balloon pump out at this.
Yeah. We're going to take out the balloon pump, and I think the patients can benefit from this TAVI, because the previous not only the gradient stenosis but also the regurgitation of the aortic valve, and also the patients got a mild, moderate mitral valve regurgitation, maybe cause of a dilated airway. I think the mitral may be improved later. So I think the patients can good for the operation.
So I may have a question regarding the valve selection. How about the balloon expandable?
Sorry, I can't hear you clearly.
Can you hear? Can you hear me? 有谁的这个收音机的杂音在里边？
有些它上 normal sound. Okay, please.
Yeah, we can hear you.
Okay, can you hear me?
Yeah,
we can.
Okay,
yeah, regarding the valve selection, I just wondering which balloon, which valve is better for this case. Even right now, it's got a very good result. So if you use the balloon expandable, maybe have another result, maybe a little bit better. Maybe I just raise the question because I don't have a lot of experience for balloon expandable platform. So 我想殷教授或者其他王岩教授会有更多的经验。
I think Simon, you can answer this question. How about using balloon expandable valve in this one, in this particular patient?
But seeing this result, I will use this valve in this particular case because it works so well, and I need Professor Wang's team to do it if I have this anatomy with this valve. But stepping back, overall, I don't think a particular valve is now shown to be superior to other valves. But you use it not properly, then you will end up in problems. So for a balloon expandable valve, I also may use a smaller one. A smaller valve in case, because of the calcium, because of the anatomy, because of suprannular measurement, theoretically, a smaller valve will have less favorable hemodynamics. So on that sense, I will a little favorable on self-expandable system for severe aortic calcification and also bicuspid anatomy. But I'm sure if you use it properly with a self-expandable valve, with your balloon expandable valve, you also get very good results. But for these patients, 64 years of age, I would think about durability, and we need data to tell which kind of valve is better in terms of that. But for acute results or immediate recovery for the patient, I think both will work very well.
Thank you very much. Thank you. Yeah.
Yeah, I also think the self-expandable balloon expandable valve can suitable for these patients according to this anatomy. This is a Taurus elite valve. It's a domestic valve. The benefit of this valve is, I think is那个这个 Taurus 的这个它上面离冠状动脉的那个菱形的开口，相对别的都比较大一点。如果以后它再出现这个冠脉的问题的话，它可能处理冠脉起来会比其他的那个会方便一点，这也是一个有利的地方。
From the appearance of this valve, it looks like because the valve cell is quite big, it looks like a radial force not very strong. But from this case, I think it's amazing, and the results very good. Even there's a big calcium chunk, the valve can expand quite nicely. So it's very good. Congratulations of Professor Wang and your team. It's very good demonstration of this case.
Okay, thank you. Thank you.
Thank you.
Thank you for.
Thank you.
Yeah,
for
excellent.
the audience. Thank you.
Thank you. Bye bye.
Bye bye.
Thank you. Bye bye.
Thank you.
Okay, let's move to the next session. Is that the group A here?
Yes, I am here.
Oh, Ebha, long time no see. Every year we talk to each other saying that we want to see each other in person, but well, already for 2 years.
Yeah, that's right. But I tell you, I'm in China. I am in India right now, and it feels so good to be with our friends and colleagues in person again. Hopefully, Taiwan will open up at some point too, so we can see each other. But on the other hand, you know, it was a great honor for me to moderate the session together with you. But unfortunately, you had the same. Bapat had the same problem than I had, and they only allow us for 15 minutes or 20 minutes to stream. Otherwise, they're going to shut us off, and that's I wanted to let you know beforehand. So I apologize. It was not my intention, but at least I can give you my presentation, and hopefully hopefully you will like it.
We will.
Great, Eberhard.
Definitely.
Looking forward to it.
Okay, so how do I go? Oh, I can share the screen now, correct?
Yeah, you share the screen and start the talk. Yeah, thank you.
Okay, let me, I hope I, okay, can you see it?
Yeah, we can see it.
Perfect.
Thank you.
Okay, so again, thank you very much for having me. And I give this lecture TAF and TAF, and I slightly changed that to procedure planning and mitigating risk. And normally I give you my financial disclosures that are shown here. And this is an overview of my talk, like kind of a roadmap. I would like to start with lifetime management and durability, the frequency of transcatheter valve failures, the mechanism of failure, stenosis or regurgitation, options for surgical explantation, the explant registry, briefly, contemporary outcomes for TAF and TAF, and then step-by-step procedural considerations, preserving coronary access, and leaflet overhang, and then excessive leaflet disease. And if we have time, and if you want, I can give you a very nice case example of an S3 in core valve, 12-year-old core valve with coronary protection. You decide, and I hope I stay within the time. So let's start with lifetime management and durability, something that has been mentioned in the previous case, which is very important for all of us as we move TAVR into the younger generation. Similarly to bioprosthetic surgical valves, TAVR valves are subject to fail. We have to develop new strategies to manage the clinical realities later in their lives after TAVR. And redo TAVR and surgical intervention will be required for a subset of patients, and we will discuss that. Obviously now, we have a better way and a less invasive approach to deal with degenerated valves, both surgical valves and TAVR valves. And that is TAF and SAF and or TAF and TAF. And this is an important slide because we can discuss the sequences of aortic valve replacement during lifetime management. And a younger patient that is supposed to have an intervention, he has to decide together with a heart team, how do we start? Do we start with surgery? Do we start with TAVR? Or do we start with TAVR and then continue with TAVR? Each individual approach has its benefit and its risk. The most important part is that we balance age of implantation with THV durability. And the goal is actually minimize open heart procedures and avoid performing them when the patients are older and at higher risk. That should be our interest. So that's an important fact that we have to keep in mind. So what is the frequency of transcatheter valve failure? This is the European consensus document, bioprosthetic valve dysfunction, structural valve deterioration, SVD, non-structural thrombus, and endocarditis. We all know the VARC3 recommendations go into more details, but this is a good separation of how we look at BVD. This is something that is very interesting, comparing SAPIEN XT on the left side with S3 versus surgery. On the left side, we have the randomized trial, SAPIEN XT versus surgery, and you can see SAPIEN XT is inferior to surgery on bioprosthesis valve failure. On the right side is SAPIEN 3. This is not randomized. This is propensity matched. And here you can see, even though the numbers for the SAPIEN 3 are a little bit higher on BVD, but it's not statistically significant. So something happened between XT and S3. This is a little bit in contrast to core valve versus surgery. We all know the notion 8-year randomized trial beginning in Scandinavia many years ago, 8 years ago, with core valve first generation. And you can see core valve versus surgery is doing quite well, 7.3 versus 10.6 on bioprosthetic valve failure. the reintervention on TAVI, which Nicolas has discussed at TCT in a late breaker, also shows that core valve is at 2 years better than surgery. So there's an increasing number of TAV and TAV over time, but thank God the numbers are very low. 330,000 patients, and in 365 only, which is 0.11%, were identified as TAV and TAV procedures. So good, the numbers are low, but as could be expected, the numbers are increasing. The mechanism of failure, stenosis regurgitation, this is kind of important. Calcification, the pathology leading to degeneration, calcification, thrombus, or neointimal growth. Because depending on what we find in the degenerated valve, we have to be a little bit more aggressive or a little bit less aggressive. As we could imagine, calcification, you cannot compress. Thrombus and pannus, you can compress. So it's kind of important, those three are the pathologies. And if we look at the indication for TAVI explants early, then we can see early explants are often due to endocarditis and PVL, much less for structural valve degeneration here in green. So if we have an early explant of the valve dysfunction is usually caused by endocarditis or PVL. What are the options for surgical explantation? Let's briefly go into the explant registry numbers. And you can do this by either resect the TAVR valve or you resect the leaflets. Both options are there. Surgeons have to decide what's best. And here you can see the explant registry baseline findings, balloon expandable, fundamentally the SAPIEN family, and here on the self-expanding and mechanically expandable for the majority core valve, and Evolut and Evolut Pro, as could be expected because those two valves are the market leaders. And if we look now at the conclusions of the explant registry, it's interesting. You can see here on the acute or median time, 11.5 months. Balloon expandable and self-expandable, roughly 50-50. Indications for the acute explant, endocarditis, and valve functions, also roughly 50-50. Unfortunately, overall stroke rate 8.6% and mortality is 13.3% at 30 days. And 1 year, the numbers unfortunately go higher. So what is the contemporary outcome for TAV and TAV? And this is a slide that I owe to Vinny. The main concern for aortic valve and valve, both TAV and SAV or TAV and TAV. Here on the left side, TAV and SAV, patient prosthesis mismatch and coronary obstruction. Obviously, we're not discussing the left side, TAV and SAV, because our topic is TAV and TAV. Most important, avoid coronary obstruction. That's the most important thing. And here we see, with a focus on SAPIEN in TAVR, and TAV and TAV, we can see here the first of all, the redo TAVR is due to failed TAVR valves or failed procedures. And the incidence is very, very low, 0.2%. The gradient, the residual gradient are very low, very good, 13 and 11. And coronary flow obstruction, very important, also very low, 0.7 and 1.3. Mortality low, 1.4 and 5.5. Here you can see the gradients. Obviously, after successful TAV and TAV, the gradients are going down, and the gradients of the smaller valves, unfortunately, is still higher, but that all could be expected. So what are the solutions that we have for TAV and TAV? Depends on the initial THV type. You can see SAPIEN and Evolut, Evolut and Evolut, Evolut and SAPIEN, and SAPIEN and SAPIEN. This is the TVT registry of TAV and TAV patients, of these 365 patients. And here you can see the mean time from index TAVR implant to the TAV and TAV procedure is 4.1 plus minus 3.2 years. Primary failure mechanism was stenosis in the majority of cases, not regurgitation. And if the first valve was a balloon expandable valve, 50-50, second valve was either balloon expandable or self-expanding. If the first valve was a self-expanding valve, then 1/3, as expected and rightfully so, was self-expanding in self-expanding, and 2/3 balloon expandable in self-expanding. So this is important, and obviously the 30-day outcomes for TAV and TAV you can see here. Rehospitalization, PPM, stroke, and death were a little bit higher than normal. Now I come to step-by-step procedural considerations because it is important to preserve coronary access and to deal with leaflet overhang. And here it is very, very important that we avoid complications by good planning. An ounce of prevention is worth a pound of cure, rightfully so, in particular for TAV and TAV. So first of all, self-expanding is off-label. But you can use Evolut. In Evolut, when the first valve was migrating out, you snared it and you can put a second valve in. And when the patient has complete revascularization and you don't need coronary access because the coronaries are supplied by bypasses. Those are the two most important indications for Evolut in Evolut. Here you can see the self-expanding and self-expanding on the left side, as I said, off-label, versus balloon expandable, so SAPIEN in self-expanding core valve or actuate. There are pros and there are cons that you have to weigh. For the most part, as we see, we use a balloon expandable and self-expanding valves, reduced EOA, higher gradients, the downside, but most important for future interventions, you improve your coronary access and your sinus flow. Whatever you do and whatever you plan to do, preserve coronary access, avoid coronary compromise, ensure suitable SAPIEN 3 function, avoid deep implantation that may result in conduction disturbances or changes there. So here, this is important that you know the devices. Increase the neoskirt height and level of SAPIEN 3 implant. And in shaded blue, you can see what is the neoskirt. If you put the outflow of the SAPIEN at node 4, node 5, or node 6. Keep that in mind as we move along, because here you can see, depending on where you put the SAPIEN, you can engage with the coronaries and with the original leaflet of the core valve. And what you try to do is you try to pin the leaflets of core valve, and that for the most part you could do, when you place the SAPIEN in node 5 or 6. That's the best position for compromise pinning the leaflets of core valve and maintain coronary access. So if you look at the pre-procedural CTAs, the step 1, determine the appropriate SAPIEN 3 size. Quite obvious if you use, for example, here, 20 millimeter SAPIEN should be used in the 23 core valve, the 23 and the 26 core valve, 26 SAPIEN. This is basic numbers. Step 2, determine the height of the SAPIEN 3 inflow to the core valve inflow. And you can do this as a reference, place points under each sinus node at node 0, which serves actually as a reference for the implant. Then determine the coronary access. Obviously, this is very important for future interventions. And you should do this by scrolling to the level of each coronary ostium so you know exactly where the takeoff of the coronaries are, and then you can determine the height. And this is the table to determine the appropriate implantation depth, node 4, node 5, and node 6. Each individual has advantages and has disadvantages. The best compromise, actually, in general, is node 5, because you want to maintain a coronary access. And now, if you have extensive leaflet disease, obviously you have this method, the basilica. You slice the leaflet in order to maintain coronary access. Remember, however, you can resolve many things with basilica when you have a lesion that's amenable or a problem that's amenable to basilica. However, there are also situations that are not amenable to basilica, and you have to keep that in mind when the skirt is, for example, too high, or when you have calcium in front of the ostium. So with that, I can finish, or I don't know whether we have time, and if you're interested in looking at a case presentation, how shall we proceed?
No problem. Keep going on.
Okay.
Let's go for the case.
Okay, thank you very much, because I think it's a very interesting case, actually. So it's a step-by-step TAV and TAV with a SAPIEN 3 23 millimeter. Let's skip here the history. What is important on this slide is, number one, you can see it is basically stenosis. It's a stenosed core valve, degenerated core valve. And what you can see also is the immobility of the original leaflets. Here you can see the leaflets don't move. They're tenting. And also important for the deployment later on, usually the degeneration starts at the base of the leaflets with calcification. You can see this on the left side here. You can see here calcifications. That is important, as you will see as we move along. Those are important analyses, because here you can see the STJ, you can see the height of the coronaries, and how are the leaflets configuring in relation to the ostium of the coronaries. Coronary peripheral access is good, as you can see here. So then, and in this particular case, we did a TAV and TAV, SAPIEN 3 to 23 millimeter in the core valve. And in addition, like a little bit of a teaser for you, we did a mitral clip for MR, a tri-clip for tricuspid at the same time. We don't need to discuss that, but I'm going to show you briefly the outcome. Pre-procedural peak-to-peak gradient, 62 millimeter gradient, so it is a stenotic core valve. And here we prepare coronary protection, because remember, the height was 11, and not much to be said. We used in this case a multi-purpose, and we placed the stent and the wire in the proximal part of the LAD in case we need it. We also believe this is not an elective procedure, but it should be a bailout procedure in case we need to protect the coronaries, and then we keep stent and wire in place as we move along. And here, this is very important. You can see here the protection, and then you position. In this case, we position inflow over inflow. So 0, this is the node, and this is node 5. And you can see here, if we deploy, we come close to the ostium, but we have to keep the valve down. As soon as the valve moves up, we are compromising the ostium. I hope I can show this to you while we deploy. And when we come to the next video, I want you to pay attention, because what happens, and that's why I was telling that the calcification starts at the base of the leaflets. And if you don't deploy slowly with forward push, the valve will definitely move up. And you can see this in the next video, and observe here how I pushed the valve down, the catheter moves into the outer curvature. So let's move on. S3 in protection, and here, now it's deployed. Keep down, and here you can see now I push down, because the valve has a tendency to go up. And if you don't do that, you are in trouble, because then you get very, very close to the coronaries. So this is an important, and that's why I think this video is interesting. When you deploy a SAPIEN in a core valve, look where the calcium is, and then deploy, but deploy slowly with forward push, so the valve does not move up. check for residual gradient that was peak to peak was good. No residual gradient. We did the functional valve assessment, which was also good. And then the root shot, successful S3 in core valve and no coronary obstruction or a problem. We could re-access the coronaries. And now the teaser, the patient did have severe MR, and we decided at the same session to do a clip. And here we reduced the MR to mild, as you can see here. The lady was old. At the same is here massive tricuspid regurgitation. And we did also a clip in the tricuspid, reducing it to minimal and with a gradient of 2.6. So in all then, this was a successful 3-valve procedure. I hope you enjoyed it. I really miss you guys, and I hope that we can see each other soon in person, one way or the other. Thank you for your attention. And again, accept my apologies for not being able to moderate in 2 hours because these guys here cut me off. Thank you so much.
Thank you so much, Eberhard, and present us such an educational case.
Good. Thank you so much. If you have any questions, I'm fine. But if not,
any question
you can proceed.
from the panelists?
Eberhard, can I ask you a quick question? Thank you so much for your fascinating talk as always. So you nicely mentioned about the potential additional procedure of basilica in case of coronary obstruction concern. So I assume that performing basilica in case of the first valve was core valve or evolute would be somewhat difficult due to the superannular position of the leaflet. Have you ever had a chance to perform on core valve?
So this is a very, very important question, and thank you for doing that. Actually, we discussed basilica this morning here in India, and basilica is how can I say this best? You know, it is an interesting procedure, but it is still a fairly complex procedure. It's not so easy. You can show this on the diagrams, and you can show this because there are many things that you have to observe in basilica, and that's why if you do a basilica, you have to do some cases, and probably also with the proctor. That's why basilica is not very common, at least not very common in Europe. And in the United States, it really, really depends. And Sushil discussed his case. He himself has done maybe 15 only, but it's tedious. And I've done personally only 5. So I'm not a big expert, but I believe that, companies are working on devices, specific devices, Picardia on the shortcut, and others are in the pipeline, which is a little bit more amenable to the everyday operator. The most important thing, though, is what people I shouldn't say don't understand, but that you have to pay attention to is that you really cauterize the leaflets. Many patients, many operators are so excited when they're there, they rip and they tear. And as you probably heard at this year's TVT, one of the patients had a bad outcome because the operator did not wait to cauterize. He tore the valve, or the leaflet, the leaflet, and it flapped and ripped. So this is one thing. And the other thing is you should really start at the base of the leaflet. And that takes experience and it takes time. And as you rightfully mentioned, that's depending for supraannular valves more difficult than for intraannular valves. So basilica definitely is more difficult in core valve than in sapien and in intraannular valve, portico or actuate.
Thank you so much. It was so clear. Thank you.
Okay, thank you. Because the time limit, so we have to move to next talk.
Thank you, guys.
Thank you.
Be well.
Bye-bye.
Be well and stay safe, okay?
Stay safe, yes. Thank you.
Thank you.
Thank you. The next talk will be delivered by Dr. Ken Su. Can you show your slide? The topic will be TAVR alternative access. Thank you very much.
Thank you very much. Thank you, TAVI for the invitation. And it is my great honor to share with you the alternative access of TAVR. And in fact, it's actually a very big pressure to talk after Professor Gubi. So this is Kent from Prince of Wales Hospital and Chinese University of Hong Kong. So today I'm going to share our experience on TAVR alternative access. So we know that the TAVR access now is mainly performed over the transfemoral access because the contemporary TAVR device require mainly 14, at most up to 18 French delivery system. And the access is still one of the key steps to a successful procedure. And surgical cut down is rarely performed nowadays. Most of the access, even in alternative access, most of them were performed percutaneously. And with increasing experience and also improving device, most of the TAVR can be performed over the transfemoral access. In my personal experience, it's actually more than 95% of the procedure can be performed transfemorally. So when we're talking about alternative access, so the intrathoracic access nowadays is actually largely fading out, including the transaortic, transapical, or some of the earlier days, they perform transiliac access, and some experienced surgical centers also perform transsternal access. So, but these procedures, these access are largely fading out. So when we were, as a cardiologist, when we're talking about alternative access, we were referring to transaxillary or transsubclavian access, transcarotid access, or transcaval access mainly. So the reason why that the access that goes through the chest is actually fading out is because of the bad experience, also the bad outcomes that was illustrated in early data, because these access was actually associated with much higher inpatient mortality, more than 5%, and in most of the literature, whereas the other alternative access performed peripherally, the inpatient mortality is significantly lower. The different individual access, there's actually no head-to-head comparison. Currently, we only have meta-analysis generating, comparing different alternative access with baseline demographic being adjusted. So one of the highlights of these access is that theoretically we think subjectively and emotionally we think the transcarotid access would have higher stroke risk, but from the clinical data is actually not in the same case. The stroke risk in the contemporary series is actually comparable or lower than other alternative access, especially when comparing to percutaneous axillary access. So the stroke risk of percutaneous axillary access is shown to be higher than other alternative access. One of the reasons is actually because the posterior circulation is not protected from this access, and the transcaval access theoretically has the higher bleeding risk. However, in the latest data, the vascular complication rate is actually significantly lower when comparing to the early experience as shown in this table, which I would cover later. So as I mentioned, transcarotid data is actually quite favorable, especially on the 30-day stroke risk. When it's compared to transaxillary access, the stroke rate is actually significantly lower, of only 4.3 when compared to axillary subclavian of 6.4%. Whereas when we're comparing transcaval versus transaxillary access in the contemporary experience, you can see that the bleeding risk of both access is actually significantly higher than comparing to transfemoral access. The death rate is comparable, but significantly higher than transfemoral access. But one of the highlights is actually that the transaxillary access carries significantly higher stroke weight when compared to transfemoral and also transcaval access. So with these, actually some experienced centers advocating using the transcaval access over transaxillary access, and especially they prefer this access over other alternative access if they have the expertise and the surgeons doesn't prefer to go for the transcarotid access. So with these data, so we can see that in United States, the usage of transaxillary access is actually decreasing starting from year 2019, whereas of course at the same time the central access is actually fading out, whereas the transcarotid access with increasing surgeons participation is actually increasing since year 2019. So I'm going to cover these three access very briefly, one by one. So in transcarotid access is largely a surgical procedure apart from the toughest part. So it requires a surgical cut down. Surgeon has to cut open, expose the carotid artery, serial dilate after puncture, and then have to surgically repair the access. And this is one of our cases that the surgical wound is slightly bigger than usual, but this is the vertical incision. In some center, they actually perform a oblique type of incision. So the practical difference when comparing to transfemoral access is that the wound setup is significantly different. So we move the table control equipment table and also the radiation shield to the access site, whereas we try to move the X-ray screen opposite to the access site as possible. So as I mentioned, we require surgical exposure, and when we have sufficient surgical exposure, we then bring in the C-arm, and then we also try to minimize the big shift occluding the carotid access at the time of big shift occluding the access site as short as possible. So we cross the valve, and then we then insert the shift over the stiff wire and then perform the TAVR procedure. So this is our setup because our screen cannot move to the opposite side, so we try to move as possible, as favorable as possible. So it requires also a surgeon that try to control the carotid bleeding, if there is any, during the whole TAVR procedure, whereas the implanter will be on the ipsilateral side of the axis that we chose. So, so this is the 18 French shift. So if we're using the Annulus system, ergonomically it's actually not so favorable because we have to hang the Annulus system in the air when we're deploying the valve, whereas when we're using the Sapien system, because it's balloon expandable, so the implantation is more straightforward in the carotid access. So after we finish the TAVR procedure, so we actually would routinely do a compression angiogram to check whether the carotid access is having no bleeding and no dissection. So to finish the procedure. So as for the transaxillary access, is purely we perform it purely a percutaneous approach. So one of the highlight is that you would need to be familiar with the anatomy of the axillary subclavian artery. So to minimize the risk of brachial plexus injury and also reduce the risk of pneumothorax, we in general approach the axillary subclavian artery at the shunt 2 and 3, which is landmarked by the pectoralis minor. And we also need to note different side branch in case we want to avoid going across the side branch when we're getting the access. So routinely we put in a ipsilateral occlusive balloon that is size 1:1 to the access spot, and through the balloon we do a baseline DSA, and under both fluoroscopy and also ultrasound guidance, we get the access at the target zone, and then we preemptively put in tube close for the closure. The reason for having an occlusion balloon is that we want to minimize any bleeding when we're exchanging the shift, which will reduce the subsequent hematomal formation and also reduce the risk of nerve plexus injury. So as you can see in this scene, when we are inserting the sheath and also the dilator, we actually, before we are completely inserted sheath, we actually have the occlusion balloon inflated. When we're inserting it, we'll try to deflate. That maneuver will try to minimize any bleeding associated with sheath and also catheter exchange. So the TAVR procedure is just a routine. Of course, the challenge will depending on the aortic root angle. As we would know that in subclavian axillary, when we're using the Annulus system, there's a restriction of the horizontal, there's a limitation in horizontal aorta, but in general, it's still possible. So when we finish the TAVR procedure, when we're closing the wound, again, it's very important to do dry closure to minimize any hematomal formation. So the occlusion balloon is important. So you can see when we are removing the sheath, as one of the operators trying to tie down the percose, the other operator will inflate the occlusion balloon. And we again use the balloon central ligament for subsequent final DSH. So one of the very important thing is that when we're performing the alternative access, it's always important to have an exit strategy. So if there is any bleeding that is not controllable with simply balloon occlusion, you also have to be ready of an exit strategy. So of course, surgical repair is always an option, but before that, we also have to prepare a percutaneous approach. So in this case, it's rarely happen now, but nowadays, but still need to get prepared with a cover stand. So in this case, we prepare a self-expanding cover stand that is delivered over the ipsilateral radial artery axis, and that subsequently sealed the bleeding. So the highlight is that always has to get prepared an exit strategy when we are performing an alternative access. So finally, the transcatheter access. So probably most of us will hear the principle. So the transcatheter works is actually because the caval pressure is significantly lower than the retroperitoneal space. So when there is a opening in the aorta and also in the inferior vena cava that is very close to each other, the bleeding from the aorta is going to shunt into the inferior vena cava rather than going into the retroperitoneal space because of the pressure gradient. So the transcatheter access is mainly divided into 4 steps. So we cross by having the gear from the inferior vena cava go through the aorta and then snare the wire, and then we upgrade the wire into a lunticus and then advance the ship, complete the TAVR, and then finally close with a ductal occluder. So this is one of the case example. We have the Astado wire, which is electrified and then pushed from inferior vena cava to get across into the aorta, and then we snare the Astado wire and then get the whole system into the proximal descending aorta. And then we would deliver the microcatheter across from vena cava into the aorta, and then we upgrade into a straight tip lunticus wire. And through this lunticus wire, we advance the delivery sheath across from the vena cava into the aorta. And then subsequently, we complete the TAVR as usual. So the advantage of transcatheter access is that ergonomically is completely the same as a transfemoral TAVR. So it's usually, it's probably one of the most favorable ergonomically alternative access for interventional cardiologists because we're used to go from the femoral access. So after you complete the TAVR procedure, then the closure is actually the most challenging and the most important step. So we in general use an Annulus to deliver a ductal occluder. So the ductal occluder would try to oppose on the aortic wall, and then we unshift the ductal occluder. So the vena cava side, you don't have to close it with a occluder. So the occluder mainly cover the aortic entry. So this is the compression aortogram. So in this case, we perform a CT, and you can see if the ductal occluder is actually well opposed in the aortic wall, it's actually sealing very nicely. So, but again, when we're performing these kind of alternative access, the exit strategy is always very important. So we need to get prepared to different kind of bailout. So in case there is still bleeding after you deploy the ductal occluder, balloon occlusion is one of the starting strategy. Try to oppose the aortic disc better to have it conform to the aortic wall. And finally, of course, it's always important to have a bailout cover stent. So ovation eyelid limb extension is the most commonly used bailout strategy because probably is the smallest is the cover stent that has the smallest delivery system. So this is the final aortogram after a cover stent for this case. So to conclude, alternative access nowadays is still important for high volume TAVR center. And in my humble opinion, the best alternative access is the access that you are most familiar with. So you have to choose around transcarotid, transaccessory, or transcaval access. All of them are feasible, although they require different kind of expertise and also rely on different patients' anatomy. But most importantly is that even before you start these kind of alternative access, you need to know the access method. You also need to know the bailout before you start doing this. Thank you very much.
Thank you, Dr. So, for your informative and very outstanding talk, along with the video cases regarding the TAVR. But I think we are far beyond the schedule, and I think we'll have to move on to the next talk. So before starting the next talk, I would like to introduce the co-chair, Dr. Li Yong-Tsai, and the panelists, including Dr. Ke Hong-Yan from Taiwan, and Dr. Li Ying-Hsiang, also from Taiwan, and Dr. Ken So from Hong Kong, and Eric Chen from Hong Kong, and Dr. Yohei Ono from Japan. So the next speaker is Dr. Simon Lan. Dr. Simon Lan, I think, is very famous. He's an interventional cardiologist from the Division of Cardiology, Department of Medicine, Queen Mary Hospital, Hong Kong. Today, his talk is Cerebral Embolic Protection for TAVI Tours, Technique, and Clinical Updates. Dr. Lan, please.
Thank you very much for the kind introduction. I will keep this talk simple and easy to digest because it's a simple strategy, but it helps a lot of patients because we know stroke is a major worry that even we perform the procedure in a perfect manner. This is something that could usually be unpredictable. Stroke can also have a major impact to our patients' outcome. So we know the most famous one is the only one which is validated for protection is a sentinel embolic protection device. The first filter is positioned in the brachiocephalic artery, and it protects the right carotid artery and subclavian, and it makes a U-turn to deploy the distal filter and protect the left carotid artery. So before putting in the system, we need to prepare it properly. We don't want to stick dust and blood clots from our gloves onto the system. We need to be clean in terms of preparing the system. And we know there are limitations to the device because it filters more than 90%, but not 100, because it left the left vertebral artery not covered. So we still need to be very careful in performing our TAVI procedure and not to introduce emboli. We need our standard radial access techniques. We use transradial puncture sets. We need small sheaths, more favorable with a 5 and 6 radial sheath. Diagnostic catheter, we need coronary wire, which is long and could provide support like the Boston 0.014 guide wire, or the choice PT that it was demonstrated in the live case. And ultrasound is useful to establish the access we have difficult scenarios. Most of them are easy. You need some strategy to tackle, but the principle is not to use excessive force. For example, you have this patient who have a radial loop. If you just use excessive force to put in the device without doing a very careful manipulation, sometimes you end up in the vascular complications, although you have performed a very successful TAVI. So for this case, for example, you need a wire, you need to do some maneuver to strengthen the loop before you put in the device. Otherwise, you will end up into some unexpected bleeding. So another thing would be like this case, there are always accessory radial loops, radial access. You can see that in this case, we put in a wire, but unfortunately, the access is actually not the same at the same pathway. We need to identify this scenario carefully. Otherwise, we use excessive force to push through our device. We always end up into vascular complications. And the rest of this case is simple. This is a case with sapien and is uneventful. So we know we have to learn anatomy for radial access. We know we should be able to identify if they're radial loop, they're excessive tortuosity, or accessory radial artery, as illustrated in the case. When we encounter this scenario, we tried our best to tackle. But in case we really have difficulties, maybe you should give up the sentinel because you don't want to create new troubles. So we need to learn anatomy. And case 3 is some anatomy variation at the aortic arch. So this is a patient with aberrant right subclavian artery. The term is arterial lusoria. And with this case, you can see that there are 4 separate openings towards the neck vessels. And this would have posed some limitation to the device because it was not designed in this way. And sometimes we need some very careful manipulation. And in this case, we successfully put into 2 filters. But because of the access to the brain, the circulation, there are 4 separate openings. We could only protect 2. But sometimes this is a reality that we only try our best to cover the most and protect the patient in the best manner. In this case, we also consider putting in additional radial access from the left to put in a second sentinel device. But unfortunately, the anesthetists have put in the radial line at that juncture, and we don't want to be too complicated, especially you can see the aortic arch is so calcified. Because on the other hand, if you have much manipulation around that area, you also end up into embolization. So we always have to balance the risk and benefit. So we know a stroke by itself is not too high without the sentinel. Overall, we usually quote about 2 to 3%. And in those sentinel studies or embolic protection studies, because of the inclusion of imaging criteria and stringent assessment, picking up very minor stroke or subclinical stroke, it goes up to 5 to 9%, but clinically, we know it's about 2 to 4%. And we know that TAVI advances, complication declines, for example, mortality, vascular complications, bleeding, but stroke is something that is cannot be totally controlled in your hands. So Sentinel ID trial, we can see that debris capture under the microscope, we found 99% of TAVI patients, we have something to capture on the basket, and most of them will be more than 0.15 millimeter. So we don't know whether these things would end up into clinical significant stroke, but better to capture them before they go into the brain. Imaging study showing around 40 to 50% reduction in the new lesion volumes after TAVI, and you can see that on the left side, TAVI without protection end up with more extensive or larger area of embolization or new brain lesions on MRI. So putting up all the studies, it tends to tell you that cerebral embolic protection is better in case you want to protect the patient from stroke. And it has also been supported by multiple registries and 1-hour CTs. And especially moving to low intermediate risk group of patients, stroke prevention is even more important. We don't want to have debris go into the brain. We have to capture them as much as possible. And now there's a protected TAVI randomized control trial. The enrollment will be complete this year, and then it's a 1-to-1 randomization looking at the clinical outcomes pre and post procedure and at discharge. Lastly, with some pictures showing some of the captures that we got this year from our Sentinel. You can see this patient, 70 years of age, WAF and RAF. I mean, it's a WAF in trifecta procedure with sapien, and we captured something. Even it is a very straightforward procedure with current protection. In this case, we do pre-dilatation and followed by TAVI with Ilford Pro Plus, and we captured these two typical calcified materials on the basket. And this in the case, elderly, we captured something, sometimes a mixture, some reddish materials on top of some calcified debris. And this is a case of rheumatic AS. And instead of calcification, we captured some tissues in the basket. We suspect maybe a part of the fibrosis process and materials on the leaflets. So this in a case with mechanical heart valve flex street, also rheumatic patients with now is aortic involvement. We don't capture much, but a little bit fibrin over the basket. And sometimes we capture clots-like materials. And this is one of the biggest catch we have is type 0 bicuspid. We need some pre and post manipulation, one capture, and it ends up with this. So we're really grateful that this patient would have this filter put in place before it ends up in a clinical stroke. So lastly, with the considerations, we have to tell the patient there's still risk of stroke, although we put in the device. Sometimes they have to pay for a device. We don't want to have a false expectation. It will prevent stroke 100%, but it's kind of maximizing the protection. We need to educate anesthetists not to preserve the right radial for us in terms of setting A-line. We have to secure the right arm, especially now doing TAVI under local anesthesia. Otherwise, the patient will move the hands during the procedure and the basket will move. And especially nowadays, we have non-TAVI procedures, and we know we capture things. For example, the case we've shown this afternoon with the WAF and WAF mitral S3, I am sure that it would do benefit. But overall, we always remind ourselves, minimizing from embolic risk in the first place is most important. Minimizing manipulation, careful, choosing the devices, not to do aggressive manipulation, especially in calcified vessels, is more important than putting the device. But putting the device gives you extra safety margin. So thank you very much for your attention, and hope to see you again and again.
Okay, Dr. Lam, thank you for your talk. Very good talk. And any comment or question from our audience?
Simon, thanks so much for your great talk. One quick question. So if this device is available in your hands, would you place it in all patients or selected patients, such as valve-in-valve or bicuspid, as you shared your case?
Yes, this is a very good question. So from a study or from our experience, we could not be sure what are the predictive factors. We know about more manipulation or more calcified heart valve, they tend to emboli more. But out of our expectations, some very straightforward cases, even they end up with a lot of captures on the basket. So we really don't know, and so we use it for all patients. In case there's no financial difficulties, and in case there's some anatomical challenges or restrictions that we don't use this device, we use alternative embolic protection, for example, TriGuard device. We don't know the answer, but better to protect all patients in case it is feasible.
Okay, agree. Thanks.
Okay, because of time limitation, thank Dr. Lam for your excellent talk. And we move on to the next talk. The next speaker is Dr. Myung King Hong. Dr. Hong is the Professor of Medicine, Division of Cardiology, Department of Internal Medicine, Yonsei University, College of Medicine, and Severance Cardiovascular Hospital, South Korea. And his talk today is the valve sedation for TAVR patients, longevity and the durability. Dr. Hong, please.
Thank you, Mr. Chairman. I'm so happy to be a part of the Taipei Valve 2022. I'm going to talking about the valve selection for the TAVI patient, longevity and the durability. My disclosure, I will cover the following topic: clinical outcome, hemodynamics, coronary access, and finally, patient with a small annulus between a balloon versus a set expandable valve in my presentation. Recently, the TAVI registry data with the huge number of study population was reported in the major journal. First, French TAVI registry data, which was published in the Circulation 2020, they report that in-hospital mortality or more than moderate paravalvular leakage was significantly lower in the balloon expandable TAVI valve. It means Sapien balloon expandable valve is the better. Actually, this study was done with the propensity score matching, and the study period was between 2013 to 2015. It means the type of TAVI valve used in this study was the older generation. And the number of study population in this study was 3,900 in each group. Additionally, in this study also report that the all-cause mortality and the cardiovascular mortality at the 2-year follow-up was the more favorable in the balloon expandable valve compared to the self-expandable valve. Another registry data, French Administrative Hospital Discharge Database. This data was also published in the Circulation 2020 to evaluate the clinical outcome between Sapien 3 versus EVOLVE trial. As we know, these two types of stent was the currently used in the everyday clinical practice. They report that the all-cause mortality, cardiovascular mortality, and the rehospitalization for heart failure during 1 year is quite better in the balloon expandable TAVR valve in the Sapien valve. Based on this data, the author of this study suggests that there is a need for the large prospective randomized clinical trial to compare the between to a self-expandable valve versus balloon expandable valve to prove the result of the registry data. What about the random data? Random study, first one is the scope 1 randomized clinical trial. This result was published in the Lancet 2019. They evaluate non-inferiority of accurate narrow. This is the another type of a self-expandable valve versus Sapien 3. In this study, number of study population is 7,039 patients. The result of this study was the non-inferiority of the accurate narrow was not met. Actually, the evaluation was a composite endpoint was 1 month after the TAVI. The result is superior in the Sapien 3 rather than the accurate narrow. Another random study solved the TAVI trial. This study was also published in the European Heart Journal 2020. The primary endpoint, which include all-cause mortality, stroke, and the more than moderate paravalvular leakage and the permanent pacemaker, primary endpoint was equivalent between two groups. The number of study population was 438 patients, and the primary endpoint was the 1 month after the TAVI procedure. All random study between two groups are so far very short-term result. The next issue is hemodynamics. From the French tour registry data, everybody knows that the frequency of the more than moderate paravalvular leakage was observed in the 15 to the 16%. And the presence of the moderate paravalvular leakage was significantly associated the higher mortality. What is the independent predictor for the significant paravalvular leakage is to use the balloon expandable valve. In this kind of hemodynamic aspect, the balloon expandable valve is more favorable. What is the more long-term frequency of the moderate paravalvular leakage during a long-term follow-up? Patra trial, which used the balloon expandable valve, the incidence of the more than moderate paravalvular leakage at 5 years is 4%. From the Notion trial, which used the self-expandable valve, its frequency at 5 years was the 8%, numerically higher in the self-expandable valve. Another aspect of hemodynamics, mean pressure gradient across the TAVR valve, or mean valve area, effective orifice area, during a 5-year follow-up from the French 2 registry data, mean pressure gradient and the effective valve area remain stable during a 5-year. But the actually mean pressure gradient is numerically greater in the balloon expandable, and the effective valve area was smaller in the balloon expandable valve. The next issue is coronary access. From the partner 3 trial, which was evaluate the TAVI outcome in a low-risk patient, as we know, the clinical characteristics, patient age is 73 in both groups, TAVR and the surgical. It means a quite young patient. In both groups, the history of the coronary artery disease is around the 27 and 28. It means a sizable portion of a patient will undergo coronary angio or PCI after the TAVI in the future. 30% have a coronary access. Therefore, when we select the adequate TAVR valves selection, we have to think about the coronary access issue. Rose cut or commissural height and the larger open cell design is more make it easier to the coronary access. In this point of view, the SAPIEN 3 is more comfortable than the Evolut system. Final issue is a patient with a small annulus. This group is quite different in the Asian patient compared to the Western patient. This patient is actually consists of the quite considerable portion, and the 1/4 of the in our TAVI procedure, 25%. Why this is some specific patient group? When you look at the patient characteristics, mostly female elderly patient, and the body weight is around the middle 50, and the height is the 150, and the body surface area is 1.5. It means this patient group is an elderly female patient with a very small body stature. Due to a small body stature, there is intrinsically the height from the annulus to the coronary artery is shorter. Therefore, there is a more chance or possibility of a coronary artery occlusion during the TAVI procedure. This is the CT database. In our patient group with the 70 patient, mean aortic annular area is less than 400. Mean aortic annular perimeter is 70. When we do the TAVI procedure in this patient, we have to select the small size of it. In these cases, we have to think about the 2 things: risk of coronary artery occlusion during a procedure, and during a long-term follow-up, we think about the PPM. Fortunately, among the 70 patients, the coronary artery obstruction did not occur in our group between Evolut and the SAPIEN 3 group. Another aspect of the hemodynamic data, echocardiographic finding, effective orifice area. At the time of the discharge, the effective orifice area was significantly greater in patients with treated with Evolut compared to those treated with SAPIEN 3. And this kind of the effective orifice area was maintained at the 1 year. At the 1 year follow-up, still effective orifice area was greater in the Evolut treated patient compared to the SAPIEN 3 patient. What about the PPM, process patient mismatch? At the time of the discharge, the incidence of the severe PPM was observed in the SAPIEN 3 treated patient, 4%, none in the Evolut. What about the 1 year follow-up? None in the Evolut, but in the SAPIEN treated patient, the incidence of the severe PPM was observed in the 33%. This is observed in the very specific patient with a small size of it. This is the summary. Actually, this data was this opinion was published in the JAMA Cardiology 2021, and they described that factor to consider for valve selection: patient with a large annulus, patient with the horizontal aorta, and the possibility of the permanent pacemaker, or the possibility of a future PCI. This patient cases, the balloon expandable should be considered. In the other cases, patient with a dense annular or subannular calcium, or intolerant left ventricular pacing, it means a severe LV dysfunction, and the small iliofemoral artery size or significant peripheral artery disease, TAVR in the SAVR in case, finally, to avoid a severe PPM. In this kind of patient, self-expandable valve should be considered. However, the author of this study suggests that so far, given the lack of a large-scale head-to-head comparison between a different type of the TAVR valve, so far there is insufficient evidence to claim the superiority of one device to other type of devices. Ladies and gentlemen, I'd like to conclude that first, efficacy and the safety of the TAVR during a long-term follow-up have been proven. Second, RCT regarding the clinical and the hemodynamic outcome after the TAVR with a balloon versus a self-expandable valve are so far still limited. Thank you for your attention. Thank you.
Thank you, Dr. Hong, for your excellent talk. Is there any question or comment from our panelists? Dr. Li, do you have any?
Dr. Hong?
Yes,
do you think that the current design of the self-expanding valve is equal prevention parallel leakage as such a balloon expandable valve?
Sorry, I cannot hear it. Please.
When you use the current Evalua Pro, and it can prevent more moderate parallel leakage. However, in the trial, the balloon expandable valve, such as SAPIEN, is better than the core valve system. Do you think the Evalua Pro is the same as the balloon expandable valve, or the SAPIEN valve still better than the core valve system in moderate parallel leakage?
We know that when we use the self-expandable valve, is the major limitation is the more incidence of the paravalvular leakage and the permanent pacemaker. That is correct. But we have to think about the more specific cases, some complex lesion, as I presented, the small size of the patient, and some severe calcification and the poor LV dysfunction. So, and that kind of patient, so I strongly believe that the self-expandable is more powerful than the balloon expandable valve.
Dr. Hong, regarding the small annulus, what's your recommendation, and what kind of valve do you prefer?
Simple lesion, and I prefer the SAPIEN, and the complex lesion, high risk of it, is self-expandable. That is the common sense, and but as we are the physician, you know that we are more happy to treat the more high risk and the more difficult cases. At that time, I'm more happier that that simple lesion everybody fix it, but that is my point of view.
Thank you. So thank you, Dr. Fong, for your excellent talk. So we have another moderator, Dr. Dr. Yohei Ono. He's from Japan. Dr. Ono is the director of interventional cardiology. So he's also associate professor of Tokai University, Japan. Dr. Ono, would you like to chair the next
Sure.
speakers?
Sure. Thank you so much for your kind introduction. So let's move on to the next talk. So next talk is given by Dr. Boo-Hee Pohang from Korea. His talk would be Cusp Overlap Technique, the standard of case. Please start your presentation.
Okay, thank you, Chairman. My topic is cost overlap technique. And currently, TAVR toward minimalist approach. So we are taking the outpatient as same-day TAVR. And in extension of TAVR into low risk or younger patient has been in the current days. So if the extension of TAVR into low risk or younger patient, we have to solve the permanent pacemaker issue and the subclinical leaflet thrombosis issue and the durability issue. And in the low risk TAVR registry,
Dr. Huang? I think he lost the connection. Dr. Huang?
I can hear you.
Are you going to give a presentation with your slides or?
So, well, where was the connection was unlinked?
Can you turn on the speakers? Oh.
Can you share your slides, please?
Okay, I'm sure. So, can you see my slide?
We still cannot see the slides yet. Can it? Everybody others can see the slide? Not yet, right?
Yes, we cannot see it.
So if it seems to be difficult, okay, now it's coming. It should come.
Okay, can you see the slides?
Almost. It's sharing now. It's still the dark black screen, and let's see.
Okay, can I? Okay. No.
It's still not shared, I guess. Now yes. Please start.
Okay. So currently, TAVR toward minimalist approach is the current situation, and the extension of TAVR into low risk and to younger patients, we have to solve these problems like permanent pacemaker issue and subclinical leaflet thrombosis issue and the durability issue. In the low risk TAVR registry, new permanent pacemaker implantation rate was 4.8%. And the K-TAVI first cohort, new permanent pacemaker implantation rate was 5.6%.
I'm sorry, but your slide is not going forward, maybe. Can you go to the next slide? We only see the first page of your presentation.
And you can hear my voice?
Yes, we can hear your voice clearly, but the slide is fixed in the top page. Now we see the next slide with the physicians and the patient, maybe. Yeah, now we can see the slides. Yes, I guess we can restart, please.
Okay, so sorry for the problem. So I don't know what's the exact problem, but so permanent.
Maybe this connection is not so stable. So should we go to the next speaker first and come back again, or what's your idea? Okay, for the sake of time, let's go to the next slide and come back to you again. So I would like to introduce our next speaker, Professor Anna Sonia Petronio. We all know her very well. We are delighted to appreciate her talk. She will give us a talk, case-based TAVR complications and management. So Anna, please start.
Trying to be able to show my slides. You're not seeing my...
We are seeing your desktop right now.
Okay,
so,
okay. Finally, there we are. Okay. So first of all, thank you very much for the invitation. And it's many years I'm missing Taipei and Taiwan. I was there for quite a few times, and it was a very nice time to be there. But, you know, then the COVID area came, and now I'm very pleased to at least be able to see you on the computer. So they asked me to share cases for TAVI complications, and I saw the program. And I thought that some of the complications, like vascular complications, were already discussed before. And as has been already said, in the live stream now of the patient that they are younger, there is one of the complication that at least you don't have to cure, but you have to avoid, which is the coronary complications. Because the problem of coronary occlusion, it is getting more in detail, even if it is a very low %. You have already sourced a few cases and a few discussions with Edgar, but I will try to describe a few cases and how the flowchart of these complications can be avoided. Now, I immediately will go through the first one. This was a female of 82 years old with a severe aortic stenosis and was scheduled after angio-CT for TAVI. You can see here the CT, a very, I would say, little bunch of calcium in the annulus plane, and the area was a medium range with a derived diameter of 24. For an absence of important calcification in the LVOT and the sinojugular junction, we decided for a Sapien 326. And the only important bit was that the left coronary height was a little bit low, but quite good. Another important aspect of this patient was that the sino of Valsalva were quite small. So when we approximately calculated the possible VTC, it was more than 4 millimeters. It was not really, really, really very, very important. We also observed that there was a quite important calcification on the leaflets that was looking to the coronary ostia of the left main. So we said, well, we have, not a very, very low coronary artery. The VTG is quite acceptable. So we will go through the TAVI protecting only with a wire or not. We examined more in detail the calcification and the coronary ostia, and we saw that really it was not so high as the first calculations. So we really decided to wire the, we didn't decide to wire, sorry, the valve. So this is the expansion of the valve. Here you see the valve goes a little bit up like it usually does. You can see here the last image, and this is something important here. You see that the left main, it is open, a good flow, but there is the white appearance of that leaflet with the calcium exactly where we didn't want her to say. Now we know that most of the coronary occlusion are in the acute or in the few hours late. And when they are acute, you have the chance to try to position a wire in the left main, especially with short valves. But when the occlusion appears a few hours later, then there's a higher percent of a very bad prognosis. See if I'm able to go. So what we did, we decided to place a wire this time, but putting a stent on the left main. It was not a chimney reel technique, as you can see, because this time we were inside the valve. So we did a prolongation of the left main in the valve to avoid the closing of the left main with that leaflet. You see here the videos, the position. You can see that the stent goes approximately really close to the position valve, and here you have the last imaging. So this time it is not a chimney. This time it is a real, let's say, not resolve complication, but it is a prevent complication, because there was that imaging that could be more dangerous in the following hours. We know that if you protect these cases with a wire or with a chimney technique, you can have different situations. This is a paper published not more than 2 years ago, where you can see that with the chimney techniques and with both valves, you can have very few cases of stent thrombosis. But the important bit is that with the, especially in cases where there was only a protection of the wire, those were the cases where there was more chance of having coronary occlusion. These are very similar results to what we have seen with the previous paper of Darren Milot a few years ago, with a registry of around 70 chimney cases and protections of the wire. And here you can see that the cardiac death in patients where there was only a protection with the wire were higher than the ones with a stent. This is a second case, a male of 78 years old, this time with a previous valve, a surgical valve, which is a mitral flow, which is one of the two that is more dangerous for coronary occlusions, that had problems of failure, of degeneration of the valve, and was scheduled for TAVI. We selected this time a self-expanding valve. We generally treat valves in valves with the self-expanding valve, especially if the valves are small, for the reason of the risk of a patient prosthesis mismatch. And we asked ourselves again, did we need a protection of the coronary artery? And now look, what did the CT show to us? There was not an important VTG shortness, but there was a very, very high leaflets of the mitral flow. And you know that the mitral flow are built, the leaflets are built outside the castle of the valve, so they can easily be, during the inflation, projected straight in front of the left main. So this time you can see here that the VTZ was around 4, so it was quite short. And again, the leaflet was very high. So to prevent the occlusion of the coronary artery, we decided to perform a chimney. And this chimney technique, the way we do it, I'll show to you the case. We, of course, incannulate the left main. You see that the left main, it's really, really at 5 millimeters from the valve. This is the right coronary artery. And here, what we do, we place the stent before the expansion of the valve, and we generally inflate the stent before the complete expansion. And then what is important for you to see, it is the post-dilatation that always, it's quite compulsory in these cases. It is done together with the inflation of the left main. Why? Because the important bit to avoid stent thrombosis is to have the most important expansion of the stent, which is really even postulated even twice. And you can see here that in the inflation of the stent, you have to make sure that this part, it is possibly well expanded. And this is the result. And you can see here with the red arrow, the leaflet of the mitral flow that was exactly in very close, and it could have closed completely the left main. Now, this is the description of the technique to avoid the non-expansion of the valve. So if you postulate the valve, which you generally do, you must do like a, let's say, a kissing balloon together with the chimney. So you keep the balloon inside the stent without taking it away before you have done the post-dilatation. And this makes things very, very more sure. We have done a few IVUS imaging after the chimney, and we saw that the post-dilatation with a non-compliant balloon and a quite a stent with a quite high radial flows gives more opportunity to have a good result. At last, as a crescendo, I will show you this third case. This was a male of 77 years old with a freedom solo of 19. So the valve was small. It is a stentless valve. And you know that stentless valves, they are generally sold in a supraannular position, very, very close to the coronary arteries. So these valves have a very, very high possibility of coronary occlusion. We selected a self-expanding valve because it was also a very small valve. So we needed to reduce as possible the chance of patient-prosthesis mismatch. And with the stentless valve, you are not able to fracture the valve. So you need to have the less gradient you're able to have. But there was the problem of the coronary arteries. So we looked carefully, the CT, and here we had a mixture of problems. We had a stentless valve, a very, very low position of the coronary arteries, a very, very important calcification that went from the coronary artery to the senior tubular junction that could create an important not expansion of the valve for the chimney technique if we put our, attention only to the chimney technique. We decided that with this patient, with this very low VTC, and with this calcification, we could not perform only a chimney technique because the calcification was really, really very high. So we had a long discussion. We don't have a very important experience on the leaflets tear or cut, as it could be more opportune. But we decided that we had to do a mixture. We looked the height of the right coronary artery and decided that that was not so important. So we focused our mind on the left main and on the left leaflets. So we positioned the catheter with the TEE, which is something that we don't do normally with the TAVI. We do local anesthesia and sometimes sedation. So the patient was with GA, with the TE, which is very important to put the position of the wire in the correct position. And we, with the lasso in the LVOT, and as you can see here, we have the wire around, and here was the cut. And the cut, as you discussed before with Edgar, needs to be in the middle. First of all, there is more chance to do so with the surgical valves because the surgical valves in general are positioned with the proper commissure alignment as always surgeons do. But now we are getting close to them with the commissure alignment technique. So when you do this, you need to have your valve prepared and everything in place for to do the TAVI as quick as possible. You see the pigtail inside the ventricle for the immediate exchange with the stiff wire. After the leaflet laceration, we implanted the TAVI, but we decided to maintain a stent in the left coronary artery because the space that we had was so small that there was no possibility of being comfortable in performing only the laceration. We had a long discussion. There was a friend of mine, there was Mohammed Wahab with us, which has more experience of lacerating technique. And we performed then the post-dilatation together with the kissing technique. Then what we did is we decided that the stent from the chimney was not necessary, but we aimed to recannulate the coronary artery from the inside, because with the laceration, we were able to have enough time to incannulate the coronary artery from the inside to put the stent. So we exchanged the coronary catheters, and here you have, like the first case I show you, inflation of a stent that went like a bridge from the left main to the core valve, and made like a, let's say, a mental procedure, I would say, than a chimney technique. With this, we avoided to have a chimney that could have less expandable chunks here with this calcification, and with the chance of being able to recannulate the left main more easily. This patient was quite young, was 77 years old, and so we thought that that would be give more chance to this patient. Thank you for the attention. Any question?
Thank you so much for sharing your great cases. It was really striking. So can I have a quick question for the second case? You nicely show the case of chimney stenting. Sometimes in that position, considering the radial force, we consider to implant two stents at the same position. How would you consider this strategy? And in that specific case, how long would you give the patient the duration of dual antiplatelet therapy?
Well, very good question. I mean, there is the problem in these patients, like in general, the antithrombotic therapy, it's a big deal because they have more bleeding complication than thrombosis. And as I showed you with the paper of Palmieri, there was very little amount of thrombosis. So what we have seen in these years, we did quite a few, I can't tell you exactly the number of chimneys, but we had only a couple of patients that came back more for prolongation, complication of the coronary arteries than for the stent of the left main. What we are now learning is that it is useful to perform an IVUS, as I said, because the IVUS technique tells you exactly if you really need the second stent or not. I think that putting the second stent can create more complications than it should. So one stent, it is, I think it's really enough. What is important is the post-dilatation that needs to be done together and after the post-dilatation of the valve, especially if you have a valve-in-valve with a surgical valve and you need to do the fracture, which is something that sometimes is necessary, well, you need to post-dilatate after the fracture. Otherwise, the risk of having not an expansion of the valve is high.
Okay, thank you so much for your great comment. Any other specific questions and comments?
And I enjoy your talk very much. Is it feasible to do the chimney from the left main all the way in between the valve and the artery wall out of the valve?
Well, the second case I show you, it was out of the valve. It was a real chimney technique. Okay, so we had the coronary catheter that was placed inside the coronary artery before the expansion of the valve, because the chimney technique needs to be with the stent outside the valve between the aortic wall and the valve. Okay, so that is the traditional, and the second case was like that. The third case, that was not really a chimney and the first case, we decided to make like a prolongation of the left main. But of course, to do so, you need to make sure that you have enough time and enough success to do this, to incannulate the left main from the inside. Otherwise, all your effort can be lost in 1 minute.
So I mean, the second case is the balloon expandable valve. But if the second case is the self-expanding valve, you do the chimney the same way?
Yes, with the self-expandable valve, which is the most number of valve we use for the valve-in-valves. We use balloon expandable valve for other patients, but with the chimney techniques is exactly the same. Exactly the same.
Thank you. Thank you.
Okay.
Okay, so thank you so much. Let's go on to the next.
Well, goodbye anyway, and it was a pleasure to be with you today.
Same with us. Thank you so much.
Sonia.
Have a great day.
Bye.
Bye.
So I would like to introduce our next speaker, my great friend, Toru Naganuma from New Tokyo Hospital. He will give us a talk on TAV and SAV, while we request our cardiac surgeons for a SAVR. Toru.
Thank you, Yohei, and thank you very much for your invitation, Dr. Tsao and Dr. Ying. I already sent you my recorded presentation, so please start as scheduled.
Please show Dr. Naganuma's video.
Can the technical team work on this, or is anyone listening? Let's see. Maybe you need to give a live talk.
Okay. Okay, so let me find my presentation.
Wait.
Technical team, don't you have my presentation?
They can't find it. Oh, that's terrible. Do you have the presentation slide?
Yes, but I need a few minutes to find out. Okay. Because I hear the Boston guy already received my presentation, so I already made sure.
Should be somewhere. Okay.
Dr. Ying, would you like to start your presentation first? Conduction disturbance?
Or Dr. Huang?
Yeah.
Dr. Huang, are you ready?
Yeah, I think I'm ready.
Then maybe you can go first. Thank you.
Thank you.
Sorry for the technique error.
Okay, can you see my slide?
Yes.
Sorry for my connection problem. So my topic is cost overlap technique. So nowadays, we're doing minimalist TAVR. So in European or American nations, so they're trying same-day TAVR. And there are extension of TAVR into low risk and younger patients. As you know, even 65 years of age can do TAVR nowadays. And we have to solve these problems: permanent pacemaker issue and subclinical leafless thrombosis issue, and durability issue. In low risk TAVR registry, new permanent pacemaker implantation rate was 4.8%. And our Korean TAVI first cohort was 5.6%. And in Partner 3 trial, 1 year, TAVR 7.3%. In the Evolute low risk trial, 1 year, 19.4%. So there's still a relative high risk of permanent pacemaker after TAVR. So how to avoid new permanent pacemaker implantation? So there are clinical issues and anatomic issues and procedure and operator related issues. So we all know that anatomic, and we have to control about this procedure and operator related issues. So how to avoid new permanent pacemaker implantation? So RBBB is a very, very strong risk factor. So we have to accept the possibility. And the length of membranous septum is important. So we are using cost overlap technique. And NCC landing zone calcium volume is also important. So if siphon 3, we should avoid oversizing, and we should take the FLR, high implantation. And heavy calcification of annulus and LVOT, we should avoid oversizing and maybe choose smaller valve size. So this cost overlap technique surprisingly reduce permanent pacemaker rate of FLR. So as you can see in the traditional 3-cost view, turn and see the NCC and make the RCC and NCC overlapped. So we can see the exact deployment depths of the point of contact in the NCC. This is important because in the NCC area, there is this left bundle branch and AV node bundle. So this point is the very important part. And as you can see, cost overlap view shows greater visual separation between the basal annular plane and the conduction system between 3-cost coplanar or ADAO view. So this technique implantation starts with the slightly higher above the annulus in order to not touch the conduction system. And during the deployment, if deployment, the valve slowly descends almost automatically. Then after control the pacemaker to point of no recapture. Then after confirm depths and performance, we should release slowly and carefully. So in the Latin America, after the adoption of cost overlap technique, they've said that about effective permanent pacemaker was 5.7%. Show you my case. We started pre-ballooned and started cost overlap view just above the annulus. As you can see, the pigtail is just at the NCC level, and slowly implant the valve, and the valve goes slowly, almost automatically into the LVOT. Then we check the aerial frame parallel view and the aerial frame parallel view to see the depth. And if depth is satisfactory, then we deploy the valve. And this is the final angio. And I'll show you some other cases in our hospital. This case is 79 female. Perimeter was 83.7, and annulus diameter is 26.6, and we chose Evola Pro 34 millimeters, was 28% oversizing. As you can see in the cost overlap view, implant very slowly from above the annulus, and you can see that NCC site was zone 0. And after this shallow implantation, I pushed the delivery system very gently before the valve expands fully. So you can see if the delivery system is gently pushed, then we can make the valve at the exact point which I wanted. So you can see before pushing, after post-pushing, the delivery was very satisfactory, so finish the case. Another case was 81-year-old male with pre-CT review, was perimeter at 82.1, annulus diameter 25.7, and we chose Evo Plus 34 millimeters. And the 25 millimeter pre-balloon did not cross, so we pre-ballooned with peripheral balloon. And after ballooning it, and with pacing, we implanted very carefully with the cost overlap view. But as you can see, the NCC site was zone 0 or 1 millimeters. And after gentle pushing, the valve goes into about 3 or 4 millimeters. So after push delivery system, pre-post, the depth of the valve gets very exact to the point where I want it. So after checking, implanted the valve. So in our hospital, we do minimalist TAVI due to minimal short sedation, no need for anesthesiologist. And we do only one femoral puncture, pivotal inserted by radial approach. And we do LV wire pacing, so we need not a temporary pacemaker. Instead of 2 ProGlide, we use ProGlide and 1 femoral seal. And we are trying next day discharge after TAVI to this minimalist of TAVI. And after COT and push delivery technique in our hospital, before COT, self-expandable permanent pacemaker was about 14% to 1. And after crossover technique and push delivery technique, it has reduced to about 4.3%, dramatically decreased. So this is my take-home messages. To avoid new permanent pacemaker implantation after TAVR, we should identify anatomical risk factors for new permanent pacemaker implantation, like RBBB, membranous septum length, anti-calcium volume. And this cuss overlap technique can be used for minimizing risk of permanent pacemaker after self-expandable valve. We use it almost about 99%. And gentle pushing before the final valve release can be an option for optimal positioning in self-expandable valve. Thank you for your attention.
Yeah, thank you, Dr. Huang, for your excellent presentation. We have tried several cases of pushing at the final releasing stage, but we found that if the valve or the leaflet is heavily calcified, you should avoid this kind of attempt because the system may already, the valve may already been fixed by the calcification or calcium nodule, and even you push advance into the LV, but after the final release, you will go back to the original position. So in your cases, I noticed that there is not that much calcification in your case. So you can successfully do that, but not every case can finish in this way.
Yeah, I think that not every case can do, but in this technique can be used in relatively small calciums and implant with very shallow and make it to exact depths. But if there's a heavy calcification, then if push the device does not go and it moves with the aorta. So a very gentle pushing can be only done, I think.
Right. Thank you for your great comment. So let's move on to the next speaker. Toru, can we start?
Yeah, of course. So
let's see how the tech team.
Can you see this?
Yes, we can see the top slide. Yes.
Okay, so here they don't have my recorded presentation, so let me start my talk live. Okay, thank you very much for your invitation again. My talk is about our discussion with cardiac surgeons about TAVI in serve. What is the best server for future TAVI in serve? So he's Dr. Nakao, who is famous also in Taiwan. I hear he was invited to Chien-Sung Hospital to teach aortic surgeries. We are the buddies. So we have more than 100 TAVR cases and 120 TAVI cases per year. Let me show you our history at TAVI in serve in Japan. We started TAVI in serve in July 2018 with Evolut. And now it improved to Evolut Pro Plus, as you know. Then Sapien 3 became available for TAVI in serve in February 2020. As you know, second server is worse than Bab in terms of short-term mortality. But we, especially cardiac surgeons, have to know some important things. For example, we need 17 millimeter in sub-internal diameter at least for future TAVI sub. Unfortunately, some cardiac surgeons do not know this, especially when they work at non-TAVI centers. And similarly, small sub is associated with worse outcome after TAVI sub. PPM, patient process mismatch, is associated with worse outcome. And we know, especially in small Asian ladies, Evolute is better than Sapien Bab. Supra is better than intraannular design. This table shows data subsize in server population in Japan. As you can see, small valves such as 19 or 21 millimeter valves are used in 66% of cases. If we include 23 SAV, which is regarded as small valve in Europe and the US. In Japan, it's standard size, but it's small in Europe and the US. It's used in 91% of cases. Red change population. This data shows subsize in Babin population in Japan. Similarly, 19 or 21 millimeter SAV is used for 60% of cases. If we include 23 millimeter SAV, it's almost 90% of cases. What I want to say is small SAV is used for Japanese population, maybe the same in other Asian countries. This is our New Tokyo Hospital data. In about 30 Bab cases, the same, 19 to 23 millimeter SAV were implanted first in 69% of cases. So what we discussed with our cardiac surgeon is as follows. So simple interrupted suture and infraannular positioning of the surgical valve is better for future TAVI sub. Of course, it's case by case. And then if we treat narrow annulus and ST junction cases, we need to perform enlargement with fresh autologous pericardium. Later, I will show you a video. To perform good bioventol, we need to create composite graft composed with internal mounted bioprocesses with a larger valsalva graft, at least 5 millimeter more. So in nerve center, our cardiac surgeon, Dr. Nakao, believes Manojam method. This is not familiar with interventional cardiologist, is the best surgical option to perform root enlargement. He believes fresh autologous pericardium is the best material to perform this method. On this video, as you can see, he's now putting the pericardium, this one, like this. So the patient shows a larger root angle, which is horizontal aorta. We already know it's very difficult to deliver and implant Evolute. Let me show you our challenging case. We try to deliver 26 millimeter Evolute for a failed 23 millimeter SEP valve, but we couldn't deliver it. As you can see, this couldn't pass due to the presence of the stent post between right and non-coronary cusp of the SEP. We tried body balloon technique as a shoehorn like this, but it was not possible. And we tried the double wire technique, as I said, body balloon technique to make a shoehorn. I made a second curvature in the stiff wire, ran the kist, and we were almost giving up and starting to consider a non-TF approach. Finally, I made a manual loop snare like this, 8 French JR catheter with a 3 meter large focus wire, and then we could deliver the evoludar into the surgical valve. Finally, success. This is the most challenging case, I think. This patient had a history of ascending aortic replacement, and the cardiac surgeon used 2 pieces for this replacement. As you can see, CT shows severe bending like this. Because the surgical valve was very small, so we chose supraannular design evolute valve for this case, of course. From the beginning, I used single gooseneck wire, but we couldn't go, especially at the bending part. So I added the second gooseneck wire from left radial artery, so supported with double gooseneck wires, but still we couldn't go. So we switched to 20 millimeter Sapien 3. Of course, we don't want to implant a small Sapien valve into a small surgical valve, but anyway, we have to achieve surgical procedure success in this case. But finally, we could deliver, but we require to use 2 gooseneck wires like this. So this flex function was okay, but it was not enough to deliver the Sapien valve into surgical valve. This is the first time. I have more than 700 TAVI experience, but this is the first and the only case I used the snare neck, gooseneck snare wire to deliver Sapien valve. But anyway, we implanted Sapien valve inside the failed surgical valve, end up with procedure success. Another talk is PC after TAVI. As you know, this is the good case. Both 2 coronary arteries are coming from between the evolute commissures. It's a good corresponding, but it's in this case, both arteries are very close to the evolute commissures. It's not good, so-called severe overlap. So the most challenging case difficult to engage a guiding catheter after TAVI sub is if we implant a small sub at the supraannular position, we need to implant 23 millimeter evolute at the high position to achieve larger EOA. But if evolute commissures are in front of coronary ostium, it's a nightmare for future coronary access. Theoretically, Edwards in-space regilia valve is good for TAVI sub, but we know there are poor evidence yet. So in our center, we consider small mechanical valve for patient with small annulus, especially the patient is young. This paper from Japanese colleagues shows good outcome, even if the mechanical valve is small. So this is my summary slide about our discussion with cardiac surgeons. So please implant larger bioprocesses, at least more than 17 millimeter for a true ID. Please do not implant 19 millimeter bioprosthesis. Please note, Evolut is better than Sapien for TAVI sub in Asian ladies. Intraannular sub position is better than supraannular position for future coronary access after TAVI sub. Maybe low positioning at the right and left coronary cusps and high positioning at the non-coronary cusp. It is associated with better coaxiality between sub and TAV and coronary access. Please consider good design of ascending aortic replacement. Please avoid the horizontal feature. Poor evidence about TAVI in splits. Consider a mechanical valve for a small annulus case. Thank you very much. 谢谢.
Thank you, Toru, for sharing your insights. And I guess you covered most of the tips and tricks for TAV and SAV. So any kind of question or comments from the panelists? Time is kind of limiting. But...
2 cases in valve crossing using 18 or 20 balloon. And then when you deflate the valve partially, the valve can just slide as a wrapping, slide through the balloon and inside the LB. That's another method to do that.
Okay, so I had to choose a larger balloon.
A larger balloon.
Okay.
Sometimes like a cushion,
Like a cushion, thank you.
That's one nice strategy. Solution. Okay, so thank you, Toru.
Thank you.
Let's move on to the
maybe I should have
speaker.
A very short and talk.
State of the art lecture,
Dr.
please.
Huang already had a background introduction, so I'll just present some of our own data.
Okay, please start.
My slide. Photo slide. Dear friends, I would like to share some experience regarding the cost overlap in our center. As you know, PACER is very difficult to overcome with the self-expanding valve. There are many predictors of pacemaker implantation after TAVR, as mentioned before. And self-expanding valve implantation days and the short membrane septum are the most important ones. As shown in this slide, the membrane portion is located mostly between the RCC and the NCC. And when you put the valve inside, the compression of the conduction system may occur. This is especially true for the self-expanding valve when the anatomy is unfavorable with membrane septum and to the difference of membrane septum length and the implantation depth more than 3 millimeter or the presence of VOT calcification may increase the risk of pacemaker implantation. So it is thought that we should use a cast overlap technique to overcome this kind of difficulty because the cast overlap view can best can show the widest distance between the left bundle branch and the annular plane. So with the cross overlap technique in the optimized pro study, as you can see, the implantation test is about 3.3. And this can remarkably reduce the incidence of pacemaker implantation and the new onset of LBBB. And this is consistently demonstrated in several other studies showing that the PPI rate should be single digits. The other advantage of a cross overlap technique is that you will use IO core W, which is provide the lowest radiation dose to the operator. That's another advantage. During the past few years, we have done 114 cases with Evolut R or Pro. Of them, 17 cases have pre-existing pacemaker were excluded, and we identified 47 cases from January 2021 to March 2022 as the cross overlap group, and 50 of the patient were historical control group using the conventional approach. The aim of the study was to see the 30-day instance of our PPI and the LBBB, and we try to find are there any other independent predictor of PPI after TAVR. As you can see, the cross overlap method strongly recommend a top-down approach for deployment, because this can avoid the interaction of a flare, transcatheter end, and the conduction system. But however, we observe that there are small movement of the transcatheter valve after final release. I think in those who of you using the self-expanding valve, you can appreciate this kind of valve movement. However, with the use of cross overlap method, we can largely reduce the implantation deaths both on the NCC side and the LCC side, and also the difference between the membrane septum and the implantation deaths. The instance of PPI after TAVR have largely reduced to about 5%, although we do have 2 cases needing pacer 8 days after the implantation. And the new onset LBBB incidence was also largely reduced. As you can see, also about 10% of the patient have LBBB after TAVR. It was 20 or 25 with conventional method. Regarding the major determinant of a 30-day PPI after TAVR, we all know that membrane septum length and the implantation depth on the NCC side are important. However, we also identified that the implantation depth on the LCC side are also important. Why was that? This is because the membrane septum actually extend from the right coronary cusp to the left coronary cusp with the NCC in between. So if in some patients, actually the His bundle piercing the membrane septum between the NCC and the LCC will make this, if you implant the valve too deep on the LCC side, this will compress the conduction system and cause PPI after TAVR. And moreover, as you can see, there's marked variation of the location of the conduction system and the penetrating bundle of His related to the membrane septum. As you can see, there are 3 patients here, and the anatomy between the penetrating His bundle, the location of the His bundle, and the membrane septum are different. Do we have other evidence from the literature? We found a study showing that only the deepest edge of the prosthetic end was related to the new PPI after TAVR. That means the deepest implantation depth of the transcatheter valve determine the need of a new PPI after TAVR. So in cast overlap technique, you have to identify the implantation depth by the LAO view. If the implantation depth was good on both NCC side and the LCC side, then you can give a final release. And also, our team also identified that judge tension should be done in the LAO projection. As you can see, if there is tension on the outer curvature side, when you deploy the valve, after deployment, the valve will just goes up. So that's why I said don't push too much during the final releasing. If the tension was on the outer curvature side, this may happen. And this case, we are lucky that the valve end up at the zero implantation and it did not pop out. If the tension is on the lesser curvature side, as you can see, after the final release, the valve will have a downward displacement. So we must keep the tension free during final release, like this. And as you can see, the tension of the system cannot be appreciated very well from the IO quarter view. You have to identify the tension on the aerial view with the system in the center of the aorta. In this way, after the final release, there will be only minimal movement of the transcatheter valve. So in conclusion, cast overlap technique can significantly reduce the instance of permanent pacer implantation after TAVR. As we mentioned, you should minimize the depth of the device below both the NCC side and the LCC side, and adjust the tension of the system to minimize the movement after final release. I thank you for your attention.
Thank you, Professor Ying, for your great presentation, sharing tips and tricks of cusp overlap technique, including your own great data. Any comments and questions?
I am Eric Chen from Hong Kong. I am a lover of the cusp overlap technique, but as we move on to a top-down approach, starting the deployment high, in our early days of Evolut Pro Plus, we have encountered problems like non-uniform expansion of the valve when we start to deploy the valve high, and then we can end up having trouble with the infolding of the TAVR prosthesis if we are deploying high. And we did not know whether we should go lower or we should recapture the valve and pre-dilate again, or we just deploy the valve right away and then post-dilate. So have anyone encountered any similar problems with this?
Yes, we do have that kind of problem initially. So we start from the maybe lower third of the pigtail, or at the zero, start from the zero position at the annular plane. And that may reduce the instance of this kind of asymmetrical expansion.
Great. Any other comments or questions? So I guess we're over time, but overall, I guess we covered very important topics in this session, and we learned a lot. So thank you so much for the moderators and all the distinguished panelists, and we would like to close this session. Thank you.
Thank you. Thank you for your attention.
Thank you.
Thank you.
Hope to see you soon.
Thank you,
friends. Yeah, thank you. Okay, let's move to the next session, the Transcatheter technique. This session, we will have 4 lectures. The first one will be delivered by Dr. Maurizio Taramasso, who is a master in the field, and today he's gonna deliver a talk regarding transcatheter tricuspid valve repair, tailored treatment with TriClip G4 and advanced imaging. Dr. Taramasso, please.
Thank you very much for the invitation and for involving me, first of all, and also for the kind introduction. And I will try in the next few minutes to give you an overview on the last generation TriClip, which is the 4th generation TriClip, and what can be achieved in terms of result, and which are the ideal candidates to be treated from a clinical, imaging, and anatomical standpoint. These are my disclosure. And we know that actually there is a huge clinical need for less invasive treatment for the tricuspid regurgitation, because actually the prevalence of the tricuspid regurgitation in the overall population is extremely high, with only a minor percentage of patients being actually treated with surgical intervention. And this is due to the fact that surgical intervention is usually carried out with really high risk of morbidity and mortality, up to 40% in some series, especially if we treat patients which are, let's say, more advanced in the history of the disease. This is the reason why there is a growing interest in the transcatheter treatment of tricuspid regurgitation. And for the first time last year, the transcatheter intervention have been mentioned in the guideline, in the European one, with a level of evidence which is 2B, so quite weak yet, due to the fact that we are still at the beginning of the journey. We need to accumulate more data in order to upgrade this level of evidence. But for the first time, the transcatheter intervention has been mentioned to treat tricuspid regurgitation in valve guideline. This is not present, for example, in the US guideline. This is new in the European one. And the first device that got the CE mark approval, which was fully dedicated to the treatment of the tricuspid regurgitation, is the TriClip. The TriClip that now is available in the 4th generation, so the Gen 4, is a steerable system that allows the operator to perform transcatheter edge to edge of the tricuspid valve. The peculiarity of the system is that the catheter allows to get coaxial trajectory to the valve. So the catheter has been developed specifically for this reason, and the steering possibility that we have using the guiding and then the implant system allows in most of the time the operator to get perpendicular trajectory to the tricuspid valve, and this overcome one of the challenges of other devices. With regard to the implant is exactly the same as for the mitral. So the TriClip Gen 4 is exactly the same as the mitral Gen 4. We have 4 different configuration of implant. We have shorter device, so the NT configuration, which can be more narrow or wider, so the NTW, which is 2 millimeter wider. And then we have the longer configuration, which is the XT, that can be 4 millimeter wide or 6 millimeter wider, so the XTW. So we have 4 different devices that allows us to basically tailor the device to the anatomy of the patient. I have to say that at least in Europe, but also in US now is the case, the most used device is the XTW in more than 90% of the cases. So the long and large device, at least as a first device. And then for the second one, a more narrow could be used. But usually the first device is always the XTW. As for the mitral, the Gen 4 TriClip allows the operator also to capture the leaflet independently. This is not only important to capture one leaflet and then the other one that could be helpful if the gap between the leaflet is too big. But this is important also to optimize the capture. And this is done in, I would say, the majority of the cases. Even if we capture the leaflet simultaneously, then we can optimize separately the leaflet insertion by lifting one of the two gripper and then just improving the leaflet insertion without releasing both. And this is pretty much helpful. And as I will show you in a few slides, this is translating also in better outcome. Few words regarding the result. The most important result are the 2-year result of the Triluminate trial that have been presented a few months ago. And actually, if the patient are well selected, we can achieve consistent TR reduction in about 85% of the patients, so more than 1 degree of TR reduction. And this is sustained up to 2-year follow-up. So if we achieve acute reduction of TR, usually this is maintained up to 2 years. So this is pretty much satisfactory. And obviously, if we reduce TR, we also observe a clinical improvement, and the NIA class improve, and this is also maintained up to 2 years, as well as the functional capacity in terms of walking distance, as well as the reduction in hospitalization. There is a 50% reduction in heart failure hospitalization between before and after the treatment. So if we reduce TR, we can improve the clinical outcome of those patients. This is true, obviously, in the trial world. In the trial world, like in the Triluminate, we select basically really ideal candidate, so the one that we expect to get good result and good clinical improvement. But interestingly, this has been replicated also in the post-marketing registry. So also the patient that we treat every day without selecting them according to a core lab or steering committee. So if we learn how to select the patient, this therapy reproduce the trial result also in the real world practice. And here you see the result in the first 200 patients of the BRIGHT trial, which is the post-marketing European registry of the TriClip. Implant success was 98% with a device time of 78 minutes, slightly more than 2 clips per subject. I have to say that in the first 200 cases, most of them were treated with the old Gen 3, so without any the XTW and the independent capture. And this is the TR reduction that has been achieved in these first 200 patients. So again, if TR reduction is achieved, then this is maintained in a similar way to the Triluminate trial. And the safety profile, interestingly, is extremely, extremely high. If you consider those are all inoperable patients or high-risk patients, major adverse event at 30 days is only 1% with a cardiovascular mortality of 0.5%. And this is improving. The first 200 patients, as I told you, were treated mostly with Gen 3 clip. Once the Gen 4 clip have been introduced, so if you look the patient between 201 and 300, so the last 100 patients that have been included, you may see that the introduction of the Gen 4 actually improved the result. Single leaflet device attachment went down from 7% to 3%, and actually only one further case happens. So if we can optimize the leaflet insertion, we also optimize the results. No further mortality, no further event. So there is room for even improvement, and experienced operator and better device will make the difference. Few words regarding the device. The catheter is really similar to the mitral clip one. You may immediately notice that one steering knob has been moved from the clip delivery system to the guiding catheter, and this knob, which is the SL or lateral septal knob, which is the one here facing upstairs, allows the guiding catheter to steer far from the septum, and this is pretty much convenient to get coaxial trajectory to the tricuspid valve. Then there is the plus minus that allows us to adjust the high, and then the flex extend on the clip delivery system that we use in all cases to steer toward the tricuspid valve. So there are few key features for each TriClip procedure that are independent from the anatomy. These are fundamental to achieve procedural success in all cases. One is to get coaxial trajectory, and with the TriClip, we can achieve coaxial trajectory like you see here in, let's say, most of the cases, if not in all cases, by using FND, obviously, but also using S and L. S and L basically is making this job. If you are coming not coaxial to the valve, so if you are coming too much from the septum, by using L, you can adjust your trajectory and gain coaxiality. It's similar to the plus maneuver in mitral. When we are coming from the aorta, we use plus, and then with some adjustment, we correct coaxiality. Here is the same. If you are coming from the septum, we do L, and then we slightly move towards the septum again. You see now the coaxiality of the catheter is perfect. Second really important aspect is to be perpendicular to the line of coaptation, which is our target. In functional etiology, most of the time, we target the anteroseptal line of coaptation. We can use 3D or we can use short axis transgastric to check perpendicularity, but it is extremely important to be perpendicular to the line of coaptation. This is especially true in valve who has more than 3 leaflets, so in 4 leaflet or 5 leaflets scallop valve, where there are a lot of cleft-like indentation. If we do not respect perpendicularity of the clip arm to the line of coaptation, we open this indentation and we can induce distortion. It's probably easier in tricuspid than in mitral to induce distortion, so it's extremely important to check the perpendicularity. And here you see how it is in transgastric short axis. We want to be perpendicular to the, in this case, anteroseptal line of coaptation to respect the symmetry. And here you see another example. Here you are ready to go down and grasp. We are above the anteroseptal line of coaptation. You see that there is a cleft in the anterior leaflet, so it's extremely important to respect the symmetry. And then obviously the grasping, and in this regard, having the Gen 4 is making really a big step forward because we can optimize the grasping if you are not happy in a separate way. And as I showed you, having nice leaflet insertion and nice grasping is fundamental for the long-term durability. So together with the improved device, also the quality of the imaging is obviously important for the grasping. We need to see the leaflet. Imaging is another paramount aspect of this procedure. Here you see the leaflet insertion assessment. Usually this can be done really well in short axis transgastric. Also grasping can be done in short axis, but here you can see really that the leaflet are pulled towards the clip, and there are no doubt that we have a nice leaflet insertion. Obviously, whenever we have good leaflet insertion, we should also observe a reduction of TR. So we don't look only at the anatomy, we look also at the function. The color reduction is also something that tells us that we are grasping well the leaflet. Few words regarding patient selection. As I told you, patient selection is important to achieve good result. I will not spend too much time to go in detail, but for sure we have ideal candidate. We have candidates that are a bit more challenging, and then we are candidates that we should consider only in exceptional cases. And we always look at the anatomy, we look at the clinic, and then we look at the quality of the imaging. And now let's focus on the aspect, on the 3 aspects to identify the ideal candidate. Let's start from the anatomy. The ideal candidate has functional etiology from anatomical standpoint. So usually we like to treat and we are able to achieve a really good result in atrially driven functional TR, but also in ventricularly driven functional TR. We can also treat degenerative TR or pacemaker-induced TR in selected cases, but I think we may agree that the ideal candidate have functional etiology. Second aspect, the coaptation gap, the gap between the tip of the leaflet, which is usually measured in short axis transgastric, is one of the most important predictor of procedural success. So the bigger is the gap, the lower is the chance to reduce TR and to have good edge-to-edge repair. Here you see 2 examples in transgastric short axis. The first case has a huge gap between the leaflet. If you look at the millimeter of gap, here is definitely more than 1 centimeter. I would say about 15 millimeter in the anteroseptal line of coaptation with a huge gap in the central part of the valve. This is obviously not a good candidate. The second one is an ideal candidate. If you look at the gap between the anterior and the septal leaflet, this is probably 3 to 4 millimeter. Both of the patients have relevant TR. The first one is not a good candidate. The second one is an ideal candidate. The length of the leaflet is also really important. We need to have leaflets that are long enough, especially if we want to use the XT or XTW, as for the mitral. And then the location of the jet. The easiest patient to treat are the patient where the jet is located between the anteroseptal line of captation towards the center of the valve. This is the easiest location to treat. So etiology, coaptation gap, and location of the jet. From a clinical standpoint, basically we want to treat patients that are not too sick. So we want to treat ideally patients before that they have torrential TR. Otherwise, even if we reduce the regurgitation, the outcome are less good as if we treat the patient when they still have severe TR. The right ventricular function has obviously an impact. We are still learning how to really predict prognosis on the basis of RV function. There is not a real cutoff, but for sure we should look at the RV function as well as the pulmonary pressure. Probably the best way is to couple them. The ratio between right ventricular function and pulmonary pressure is probably more important than look at them separately. For sure, the patients with isolated precapillary pulmonary hypertension are not the ideal candidate. And then the presence of pacemaker lead. This does not represent a contraindication, but if there is a pacemaker lead, overall, we can say that we can do the case, but we should always look at the single anatomy to check the type of interaction between the lead and the leaflet. Here you see again one case, the first one where the leaflet is parallel to the valve and is keeping the septal leaflet open. So this is definitely not a good case. The jet is around the leaflet, is not anteroseptal. The second case is a good case. The leaflet it moves a lot between the center of the valve and the posteroseptal commissure, and the jet is mainly anteroseptal. So the second case is a case that we can treat. The first case is a case that most likely we are not going to achieve a good result. Last but not least, the quality of the imaging. The assessment of the quality of the imaging, so the presence of a good grasping view and the presence of a good transgastric short axis view are part of the screening. So if everything, all the rest is okay, but we don't see the leaflet, this is not an ideal candidate. So again, this is a grasping view, which is really nice. We see the leaflet really well. And this is a short axis view, transgastric. We want to have ideally both this view good enough before proceeding. And it's important to check that we have this view before candidate a patient. And this is my summary for patient selection. We should look at the anatomy, we should look at the clinic, but then we should also look at the quality of the imaging. And this is my last slide. I think from the data that we have so far, we can say that we can tailor the therapy with triclip 4 to the patient, achieving good clinical and echocardiographic outcome. And there is for sure room for improvement with the completion of the learning curve for the center that are just starting. Thank you for the attention.
Thank you. And in what kind of case do you think that repair is not going to work and that we must consider replacement?
It's a really good question, but probably all the cases that I showed you that were not ideal were cases for replacement, like when there is this huge gap between the leaflet with a central hole with a huge vena contracta torrential TR where you cannot approximate the leaflet. You may consider annuloplasty, but if the gap is too big, also annuloplasty is not going to perform extremely well. Those are cases where if the annulus is not too big, obviously, replacement should be considered as a first-line therapy. As well, if you have extremely bad imaging or interference between the lead, pacemaker lead and the leaflet, you should consider for replacement as a first strategy. And then obviously, once replacement will be more diffuse, we will learn better. Maybe at the end, it will be the first-line therapy for most of the patient, and only the patients that we cannot replace, we will repair. Could be the parameter could also change. We still have to see what will happen.
Okay, thank you very much, because we are out of time. And the second lecture, I would like to invite Y.Y. Lam to introduce the speaker.
Okay, the second talk will be given by Professor Ralph Stephen van Balleten, and he's going to talk about transcatheter mitral valve intervention, how to select patient for Tendine.
Thank you very much, Professor Lam. Thank you for the organizing committee to have me. And it's my great pleasure to talk about transcatheter mitral valve intervention, Tendine, the optimal patient selection. These are my potential conflicts. The goals for a successful mitral procedure, and we heard this already for tricuspid from Maurizio Torremasso, is that, like in the tricuspid, we want to achieve an MR grade 1+ or 0, a mean gradient of less than 5 millimeters mercury. And this is true for both repair and replacement, a low LA mean pressure, a 3D mitral valve area that exceeds 1.5 or even 2 or 2.5 centimeters square, if possible. A very durable result is important, and a high survival rate and low risk of the procedure. So I think these will be the goals that I will explain you with the current data on the Tendyne valve. So if we compare the repair, and actually we also have the G4 in the mitral position, of course, we have on the transcatheter mitral valve repair an extremely high procedural safety. In Germany, currently the 30-day mortalities at a mean age of 80 range between 1 and 2.5%. So this is extremely low and hard to beat. MR reduction is anatomy dependent and not always predictable. There is a limited interaction of edge-to-edge therapy with the native anatomy. We have as a plus a low thrombogenicity, but there may be a risk of MR recurrence during long term. What about replacement? So replacement with a focus on the Tendyne valve, we do have some procedural risks. So it's a higher risk procedure than a TEER procedure, but we have a high efficacy in terms of MR reduction. So one system may fit almost all pathologies, but there are, of course, some anatomic limitations. And the main limitation for TMVR and also for the Tendyne valve is LVOT obstruction and the interaction with the subvalvular apparatus. The lower the profile of a TMVR valve, the better. There may also be a slightly elevated risk of valve thrombosis. So the patient has to be able to at least be able to be guided under oral anticoagulation for the first 6 or 12 months. And of course, we just have limited data on 8-year implants in London at the Royal Brompton, but the number of those patients at long term, higher than 5 years, still is low. So we cannot predict durability yet. What about the anatomic assessment? Dating back from the Everest criteria, which is already 13 years ago by Ted Feldman, you see that we had some ideal patients decided on the green table for TEER. Nowadays in Europe, more than 70% of the patients are outside these criteria. But according to the anatomic features, there may be a difference in the freedom from reintervention for those patients, especially in lower experienced centers. But on the other hand, of course, we see huge improvements in imaging. And this is just the latest generation of anatomic and echo overlay in fluoroscopy that you see here. And this is an example of glass view where you can see both from the left atrial and ventricular side. The complexity of mitral valve anatomy shows that the majority of cases are rather non-complex, while 1/3 in the EXPAND and EXPAND G4 have been complex cases. The complex anatomy has a different outcome, as you can see here. So in complex anatomy, the possibility to reach an MR 1+ or less was 80%, while the same situation was on non-complex anatomies, 90%, and 97% achieved an MR of 2+ or less, which is suitable and outcome relevant for the patient. If we look into a large registry of the US, the TVT registry, you see in 3,000 patients that there was a survival benefit long on the year on 12 months for those patients achieving a 1+ or 2+ result. And you can also see this as a predictor for the 1-year mortality on the right-hand side. So it's important to have a good result. Of course, technical iterations, as shown by Maurizio on the tricuspid side, already improved this also for TEER. So as I said, these are our main goals, and we'll now look into the replacement possibility. The more complex the situation of the anatomy is, and also the more calcium and combined situations of stenosis and regurgitation we have, the less likely we find a suitability for TEER patients, and we have to go into replacement. And these are some examples. This is a patient with advanced severe primary MR, and you can see it's a multifocal two-segment prolapse situation of the anterior leaflet, but the leaflet is already massively destructed. So in these cases, of course, TEER has a limited value. The second situation is if you run a CT and you see that there is massive calcification or MAC, as in this case on the medial side, you see the sclerosis here of the circumflex artery going around the mitral valve, and you see the situation of a replacement in the aortic valve position. And if we look at the latest publications here by Paul, Saraja, and Stitchy, you see that we have a 30-day mortality in those patients that is elevated, also one-year mortality that is elevated compared to the other possibilities, but these patients also have an elevated risk at surgery. The final result is excellent, as you can see here. So even with calcification or primary disease, you can achieve a 0 MR and a very good function at a low gradient. That outcome is coupled to residual MR, has nicely been shown in Circulation by Saibal Kar last year. And this is the presentation at EuroPCR. And you can see that both groups, MR 0-1 and 2+, are close together. But if your patient suffers from a 3+ or 4+ regurgitation after the procedure, his outcome over 24 months is limited. This is also shown in the latest publication by our group. It's 35 centers internationally, published by Walid Ben Ali from the Montreal Heart Center. And you can see here that also the rate of 0 and 1+ MR after TMVR, mainly with Tendyne, was much higher than after M-TEER in bailout situations. So this is also a very important finding. This has been reflected in the European guidelines. And you see in the valve guidelines for the first time, TEER has been upgraded to a 2A indication, but now also replacement is mentioned with a 2B indication for the first time. So criteria favoring replacement are in primary MR, commercial MR, a small mitral valve area, but still exceeding 26 millimeters, mitral valve stenosis, calcification in the anticipated grasping zone, short posterior leaflets, MAC, multiple jets, Barlow's disease, and cleft and perforation. On secondary MR, it's a broad jet from commissure to commissure, severe leaflet tethering, especially of the posterior leaflet, atrial SMR, and less advanced ventricular failure. So typically the patient should have an ejection fraction of more than 30% for good outcome. Possibly also failed surgical and transcatheter repair, but this is still excluded by the indication in Europe. There has been a so-called red document by the Heart Valve Collaboratory, published by Scott Lim last year, looking for unsuitability for TEER for studies for TMVR. And this was published in Structural Heart last year. So we look at a patient with severe secondary MR that may not be suited, and you see this patient has an indentation posterior, a severely tethered posterior leaflet. He is standard post-endocarditis in 2019. He had a perioperative ischemic stroke, renal failure, and permanent atrial fibrillation. As you see, these two types of tethering and also of retraction and short leaflets, I show it here to you. The upper patient, as you can see, has a very retracted and very short posterior leaflet, so you're less likely to do a TEER on this patient, and also the interior leaflet is severely non-pliable, which causes high gradients and stenosis after an edge-to-edge repair. Other patients may include previous surgical or transcatheter replacement of the aortic valve and or calcifications. So what about the data? We have now the first longer-term Tendyne mitral valve data, which is a bioprosthetic valve. It's contoured to capture the mitral valve and to seal it highly. And these are the first 100 patients now with a 2-year follow-up of 50 patients, so half of these patients. Technical success was high. Procedural mortality was low, but there is a 1- and 2-year mortality that is significant, and the 30-day all-cause mortality was 6%. Here you see the Kaplan-Meier curve, and you can appreciate that estimated mortality at 1 year was 27%, estimated mortality at 2 years was 41% in a very sick population, as you can see here within this graph. On the other hand, what was achieved was that there was a very durable, complete elimination of mitral valve regurgitation. So you see we had ranges between 99 and 93% over a 2-year period in those patients. New York Heart Association classes was reversed very favorably from a 66% New York Heart Association class 3 or 4 to a 1 or 2 at 82% of the patients. And you can also see a sustained increase in the KCCQ for those patients. But as it is an apical procedure, you see that the KCCQ improvement is ongoing over time beyond 30 days. And what is very striking, and what we also see in some TEER patients, is that the heart failure hospitalization rates in the single arm registry type are almost put down by half. So this is a very favorable outcome. What about the larger real world registries? We published this year in January the first 109 patients after CE mark. And you can see that on-label use of the Tendyne valve was in 81 patients or 75%, but 25%, every fourth patient, had already an off-label or borderline indication, which was a mitral stenosis, a severe MAC. The system is indicated up to moderate MAC, and also a prior interventional or surgery. And you see that this can be ideal. It was excluded in Europe, actually, but you see here a Carillion device that failed over time in A. You see a detached mitral clip in B, where we add a TAVR procedure, where we could put in a Tendyne valve, and you see severe MAC in C as another indication for TMVR. So just to give you an outline, the Summit trial will evaluate this with a randomized cohort against MitraClip, a MAC cohort, and a non-repairable cohort, which becomes more and more important also in the Apollo trial with our transcatheter systems. Just some images of an implantation at the end for you to see. This is a real, true view of the wire in the right upper pulmonary valve. This is the implantation process, which is from the apex. We're going into the atrium. This is all echo steered, actually. Here are the ears of the device heading towards the aortic valve and a little lateral. You see the opening, and this is the complete function of the Tendyne valve in such a procedure. Typical procedures range from 20 minutes to 40 minutes, so it's a very fast procedure over time in experienced centers. What we can do, if the outflow tract is very narrow, we can do a lampoon technique, either by sutures or by snaring or by electricity. So we also use RF energy to cut into the interior leaflet if we have a very narrow outflow tract. And we published this already in 2019 in the European Heart Journal, as you can see here, and could overcome severe LVOT obstructions. This is a patient in MAC, as you can see here, severely impaired leaflet, severe regurgitation, severe calcification of the ring. And on the right-hand side, with a pre-existing TAVR prosthesis, you see that the valve is functioning perfectly without any PVL, and this implant took 35 minutes. So it is a fast possibility, especially to treat patients with combined disease of stenosis and regurgitation. And this is the control, as you can see here, no PVL, normalization of pulmonary valve flow. And on the right-hand side, I injected you some contrast in the left ventricle via the aorta, and you see there is no regurgitation either. So I come to the conclusion, TMVR, the optimal patient. TMVR is able to address both primary and secondary MR. TEER is an extremely safe and low-risk comparator to this therapy. Of course, MitraClip G4 is based on 150,000 implants, but in TMVR Tendyne, we already have more than 1,000 implantations, 600 commercially in Europe during the time course of 2 years. TMVR completely eliminates MR over the range of 2 to 8 years. Of course, the 8-year results are very limited. This is just a dozen patients. TMVR still is a more invasive procedure as it's transapical versus a transeptal procedure. No TEER and MAC are clear TMVR indications for the future. Patient selection will be influenced by the still higher mortality rate short term, but may be a benefit long term. Transapical access is available. Transfemoral access is about to come. Thank you very much for your kind attention.
Stefan, it's really a great talk. So how would you really select? I mean, based on the summit trial, there's a trial arm. So people eligible for MitraClip, they're comparing TMVR versus MitraClip. What do you think this can give you? Any insights? How would you select these particular group of patients?
As I said, I think there are clear contraindications to a positive outcome in TEER. And I think, as I said, MAC patients are untreatable with TEER. There are other situations where you have non-existing or highly tethered posterior leaflets, and then I would always go for TMVR. TMVR is in a part, especially with MAC, negative selection and has higher risk factors. If we look into surgical literature, treating MAC patients also means that we have to accept higher 30-day and 1-year mortalities. But over time, we may see a benefit. In the future, as 2 devices are now testing in MAC and single-arm trials, we will also see randomized trials in these cohorts, and we may see benefits. On the downside, I told you that the current concepts still need improvements on the LVOT clearance. LVOT still is a major screen out for TMVR and has to be recognized. All other problems in the range of 26 to about 48 millimeter sizes have been or are beginning to be excluded. So LVOT is the most important actually screening guide to select TMVR patients. You can treat all anatomies. If the anterior leaflet is too long, this with an experienced center and lampoon technique no longer is a contraindication. We on purpose lampoon these patients or do an electrocauter transeptally, actually without snaring. I simply use a steerable sheath and a multi-purpose catheter that seals and isolates my normal steel wire, and then I cut in the anterior leaflet. And doing this is a 2-minute procedure prior to tendon implantation, and you can do this transeptally in the same procedure that you implant the valve, and you already have your security wire in the right upper pulmonary valve, so you can implant the valve within 5 minutes. So there is no hemodynamic instability that is significant, and I think we will learn more and more about this.
Okay, thank you.
Okay, because of the time limit, so we will move to the next patient. Thank you, Dr. Nathan. And next one, we will invite Professor Kentaro from the United States Brain and Women Hospital. And his talk will be transeptal mitral valve involved TMVR. Please, Dr. Kentaro.
Well, thank you very much, Professor Yin and Chen, and all the organizers for inviting me today. It is a true honor to be presenting the transeptal valve-in-valve transcatheter mitral valve replacement. And Stefan sort of touched on some of the subjects that I'll be talking about. These are my disclosures. So TMVR in general in the United States has been growing substantially. However, it has hit a little bit of roadblock. It's not increasing as much after it hit about 1,400 cases per year. And it has to do with the 30-day mortality being relatively high. So the 30-day mortality is depicted in red here, but it's been around 6 to 7%. So it does carry a little bit of high risk compared to the TAVR procedure. So why are we talking about a transeptal transcatheter mitral valve replacement? It is because of the 2 pathways that we have. One is transeptal and the other one's transapical. The Tandine procedure that Stefan presented is transapical access. The mitral valve-in-valve in particular, when this was looked in the TVT registry in the United States, the transapical approach had higher all-cause mortality. So transeptal in general is much, much safer. And we all know this because of the experience with MitraClip and other procedures that are done through a transeptal approach. These are very, very minimally invasive for the patients. So when we do a mitral valve-in-valve replacement, the first thing you have to look at is the type of valve and the size. And of course, there's an app for that. My good friend, Dr. Vinny Bapat, has created this valve-in-valve mitral app. He actually has updated it recently with his new funding. So those of you who have not updated this app, please do so, because it comes with several new features, which I will be talking about in the future. So this is sort of the new outlook of the new app that he has updated. And one of the key features that he states in there is that the stent ID and the true IDs are two different things. The manufacturer of the valves can say that it's a 27 millimeter valve, but the true ID, which is the measurement from the inside of the post to the other side of the post, can be significantly smaller than what is said as a manufacturer size. So in general, the porcine valve true ID is about 2 millimeters less than the stent ID. And the bovine valves are usually 1 millimeter less from the stent ID. This is something good to remember. And of course, the biggest issue of mitral valve-in-valve is the LVOT obstruction. And this is due to the retained prosthetic post, because when the new valve opens, the old leaflet will be pushed by the new device and will occlude that LVOT, and that will become a problem. So what are the risk features for the LVOT obstruction? One is the depth of the implant. If it's deeper, it has a higher risk. If it flares further, it has higher risk. If the aortomitral angle is less, then these will be high risk feature. And also if you have a septal bulge, then that becomes a feature as well. So these are some of the high risk features. So if the aortomitral angle is less than 105 degrees, that's definitely a risk factor. You see a bulging septum, that's definitely a risk factor. And a deep implantation will be a risk factor in these cases. So what the CT scan allows us to do is to calculate the Neal LVOT. So you slice it in the area right around here, and that will give you what kind of opening you will have if that valve is implanted. And people have studied what the risk of this LVOT obstruction is. LVOT obstruction occurred in about 8% with mitral valve and ring. Little lower with mitral valve-in-valve due to the fact that the leaflets are shorter with a biprosthetic valve compared to the native anterior leaflet. And if you have the LVOT obstruction, the mortality is extremely high. It's 35%. Whereas if you don't have LVOT, the risk is 2.4%. So the key here is to avoid this LVOT obstruction, and we can predict it. This is a study from Cedars-Sinai. They looked at all the international series of mitral valve-in-valves that are being performed, and the cutoff for the LVOT obstruction that they saw was 1.7 square centimeters. So if you have an LVOT area less than 1.7 square centimeters, the risk of LVOT obstruction was extremely low, as you can see in this paper on blue, 0.6% overall. In valve-in-valve, if the Neal LVOT area was less than 1.7, there was no LVOT obstruction. So I'm going to showcase and describe, how these procedures are done in general. 65-year-old female with previous CABG had a mitral valve replacement with a 25 millimeter epic valve. This is a porcine bioprosthetic valve, which I'll be talking about the size. She is on dialysis, and she also had morbid obesity, and she had NYHA class 4 symptoms, so she can barely move. Her SDS score was 10.2% for mitral valve replacement. So I labeled her as a prohibitive risk for surgery, and we seek a transcatheter option. So this 25 millimeter epic valve, it has a stent ID of a 23 millimeter. And remember that this is the porcine valve. So the true ID of this valve is only 21 millimeters. So it's a very, very small valve. This is a preoperative transthoracic echocardiogram, and the mean gradient across the mitral valve was 15. So very, very significantly stenotic valve. EF was fine on both left and the right with no mitral regurgitation. This was a CT scan that calculated the Neal LVOT. Fortunately, in this case, the Neal LVOT was 3.1 centimeters. So going back to the previous slide, it was above 1.7. So we thought that the LVOT obstruction risk was extremely low in this particular case. So this is the first part of the procedure. Of course, all transceptor procedures start with a transeptal puncture. For this mitral valve and valve, we would like to see the ideal puncture height at about 2.5 to 4 centimeters. So if you go too high, then the catheter, the device system will aim towards the dome of the left atrium. You have to take a steep curve. So you want it to be somewhat lower than the mitral clip procedure. We aim for closer to 3 when we do these procedures. Little posterior, slightly inferior, but more towards the middle. The puncture site in terms of the posteriorness does not matter as much as a mitral clip procedure. Once you cross the valve, you go to 3D TEE. We use a steering sheath, Agilis, and you aim it towards a mitral valve. You cross with a pigtail without a wire so that you don't entangle any of the cords. And then you have a rigid wire. We use a safari wire, which is parked in the LV apex. Oftentimes, the loop facing down will work much, much better in terms of the curvature when we do these cases. Then the next step is to perform a balloon septostomy. In this particular case, we use 14 millimeter Armada balloon. You can see the waist, and then you want to confirm that the waist goes away after these balloon septostomies are performed. So this was the final deployment of the valve. We use a 23 millimeter Sapien 3. You can see the epic valve. Epic valve has very, very scant radio opaqueness. In this particular case, there was a core knot that was used, which makes it a little more easier to see. Couple tricks couple things that you have to do before you actually deploy the valve. When you load the valve of the Sapien 3 system, you have to load it in the IVC, so you have to pull back the sheath to allow the valve loading. And then you turn the whole system with the device and the sheath to allow the curvature to go towards the left. You have to remember that the TAVR system curves towards the left, whereas in these mitral valve and valve cases, you have to curve towards the right. So you want the Edwards logo down when we do these procedures. But one thing that we really want to focus here is that there is lack of coaxility in this case. We're constantly trying to inflate very slowly so that we can adjust so that this valve lies coaxial compared to the mitral prosthesis. So this is a post-deployment echo. The gradient was 8. It was okay. We were relatively happy, although there was a waste. And the patient was discharged on post-op day 2, but the patient returned after 1 year. And now with returning NYHA class 4 symptoms, and this was the TEE, and then now the mean gradient is 24. So now what do we do? So this case, we actually brought the patient back for a balloon valve fracturing. This is going to be a little bit of a long run, so you might bear with me. You will see it's not as brisk, but you will see this part of the arching flatten over time. It was relatively a long pacing run, but with a 24 millimeter true balloon, we were able to fracture the epic valve frame. But after we did that, we saw that there was relatively significant mitral regurgitation that was seen centrally. So we ended up placing another valve inside the old valve. This time, the gradient was 7, and patient has been doing well since this valve deployment. So this was reported as a case report as a first fracturing. And going back to the app, now it has a feature that states whether the valve is fracturable or not, and it actually gives you the size of the balloon that you should be using. So that's another aspect of the app that I want everybody to check out after this meeting. So I spoke a little bit about the coaxility. We were completely off of that epic valve. There are a couple techniques that you can do to gain the coaxility. The first technique is called a push-push. What we do is you push on the delivery system, and then you push on the apical wire. So what it does is that whereas it was canting, it will bring the valve towards the upper aspect on the fluoro and gain that coaxility a little bit. It does have a better alignment on the medial and lateral aspect. However, if you look at the AP side, it's still canted. So it's not perfect, but it does fix that medial-lateral coaxillity in terms of the push-push technique. Another technique that you can use is what we call a posterior deflection. So you want to keep the delivery system in the left atrium, but add a lot of flex as much as possible. In these cases, we typically do not use a lot of flex, but if you want to do the posterior deflection, you put a maximal flex, and then you rotate clockwise. What that will do is it creates sort of an S-curve in that left atrium and obtains the coaxillity. In this case, in this technique, it will also accomplish the AP coaxillity in addition to the lateral medial coaxillity. So these are some of the techniques that you can use. Last but not the least, there are several methods that you can treat LVOT obstruction. And I know that Stefan touched on this already about the lampoon technique. You can use a septal alcohol ablation procedurally, but now more and more people are doing the lampoon technique, which will lacerate the anterior leaflet of the mitral valve. For the native valves, you have to go through the septum in order to lacerate the valve. But for mitral valve and valve, what you can do is what the NIH guys call the tip-to-base lampoon. So you go across the septum, and then there's another catheter that goes through the aortic valve. You capture the wire from the aortic valve through the aortic valve in the LVOT, and you pull through from both the aortic side and the transeptal side. And this is only allowable because the mitral valve prosthetic ring that is around the valve protects it from cutting into that aortomitral curtain. So this is the actual procedure that we did in one of the cases. You can see that the patient already had a mitral valve and valve. And then we also performed a second aortic valve and valve, and we performed a mitral valve and valve. You can see that there's a wire coming from the septum through the agilis, and there's a wire that goes through the aortic side. My partner and I are pulling the wire sort of simultaneously in a balance, aiming towards the rim of the epic stem frame. And you can see that we're sort of pulling and tugging in a way, and it was relatively a long laceration time, but ultimately it went all the way into the edge of the epic valve. And then this was the end result. You can see sort of the laceration here and a flow through the laceration. This was a better view of that. You can see the V shape in one of the leaflets where we had cut. And this patient was a high LVOT obstruction risk, but after the lampoon technique, the valve was implanted, and the LVOT gradient across was only 6 at mean and 10 at max. So this procedure is very successful, and for mitral valve and valve cases with high LVOT obstruction risk, this is a very, very useful method. So I think these are some of the techniques that we can do to improve the outcomes of valve and valve transcatheter mitral valve replacement, and I think we're going to see more of a growth with the maturation of the technique. So thank you very much for giving me the opportunity to talk today.
Thank you, Dr. Kaneko. I have one question for Dr. Kaneko. Since you said that transeptal result is much better than transapical mitral valve and valve, so what prevents you choose the transeptal route instead? What would be the limitation of using the transeptal route?
I think almost all cases should be done through a transeptal approach, unless if there is a true contraindication for this particular procedure. Say, for instance, if the patient had previous ASD closure and the device does not allow you to access transeptal puncture, I think those cases, transapical procedure will be applied. And for whatever reason, if the transpuncture is not obtained at an ideal height, and which does not allow you to have the device steer down into the valve, I think that's another challenging case. But other than that, we have completely eliminated the transapical procedure. We hardly ever do them anymore.
Thank you. Any more questions? All right, thank you, Dr. Kaneko.
Thank you. The last talk will be delivered by Professor Wei-Hsian. Wei-Hsian is our good friend and the the last talk must be the best talk. So, YY, please start your talk, MitraClip, clinical updates, and G4 cases sharing, please.
No, I'm not sure this is the best talk. It's just after we go through the universe. So it's good time to land back to our hometown, Earth. Okay, so this is because TEER is something that we do quite routine these days. So I think at the end, it may be good to go through with you some of the clinical updates and just to share two of my cases, just to illustrate the beauty of G4 devices. So this is the system everybody knows, almighty MitraClip going through the transeptal and treat a lot of the patient having mitral regurgitation. So if you're looking at mitral regurgitation classification, this is known, Carpentier classification. Now what we have in terms of clinical data, basically coming from the randomized control trial, the FRS2, mostly these patients are having DMR around 74%, randomized against surgery. And then you have ventricular functional MR, the LV functions low, and you have some FRS2 patients, and also, of course, the very important COAPT mitral FR study, which actually revolutionized the management of patients having ventricular functional MR. But having said that, the big areas that still there's a lot of disappointment because we are seeing around 30% of our patients having chronic atrial fibrillation, severe atrial functional MR. Now we don't have very good quality clinical data to address this issue. I think one of the reasons why atrial functional MR is mostly understudied because it is not really a disease of ventricle, or it's not really a disease of the valve. It's a disease combined with arrhythmia, and it's also combined with one of the most difficult area in heart failure, that's HAPAT. So that's why it's very difficult really in this area for us to give clear answer. So how should we address this patient? In, let's say, this year, of course, from PCR, there are Italian centers. They try to pull up their TEER registry and looking at those so-called pure atrial functional MR patients, and they found some clinical benefits. I think it has to be like a concerted effort worldwide for people doing really TEER in atrial functional MR. So if we have like 1,000, 2,000 cases, maybe it will help us give us some insight how to select these patients for TEER therapy. But now it's not the right time to give you the right answer. So let's go through the basic clinical data we have with MitraClip. Comes from the FRS2 trial. This is a trial done more than 15 years ago. Basically, with 5 years follow-up, it shows similar results in terms of quality of life and mortality as compared to conventional surgery. I always said this is an unfair comparison because in surgical arm, if the surgical repair does not result in a very good result, the surgeon will replace the valve immediately. Unlike MitraClip, you have to observe the result for several months. If the patient doesn't have good result, they go back for surgery. So, and also the device at that time was a MitraClip Classic. That's very old device, and the TEE at that time is very poor. So I suspect if you repeat this trial once again, you might have different results. That's why we are anticipating the repair MR trial that I'm going to talk about briefly. This is a classical clip case. I think this is a very, while we are doing a lot of TEER cases, we always go back to look at these candidates. This is like a type A lesion in coronary intervention. We would expect this patient will have very good clinical outcome as well as durability. And this is the patient, I think this is very solid when you're talking about TEER future. So we should definitely select these patients for TEER, not for any other like TMVR, no way. TEER is definitely the choice if they are something very close to FRS criteria. central P2 pathology, very narrowed disease, very long posterior leaflet, and the mitral valve area is long enough. These are definitely tier candidates. And COAPT study, of course, I have to mention this trial because we have this pain of treating patients admitted in the past for recurrent heart failure. So this is one of my patients. He came in every year 4 or 5 times for heart failure. And it is because of this mitral clip therapy that actually saved him from going to the hospital. And he had a really improved quality of life. And it is not until COAPT study we have proved this therapy, in fact, not just reduce hospitalization, but also improve patient survival. And the number need to treat is only 5. So this is very important. Of course, in COAPT study, what we learned is we have to select our patient carefully, but it's like in any other fields in interventional cardiology. We doesn't want to select patients who really had very advanced disease. Like if you have a very calcified left main, severe triple, syntax score super high, I know that even I have successful PCI. This patient is not going to do well as those patients having low syntax score triple vessel disease. I think COAPT is just the same. If the ventricle is too sick, so the ventricle is too sick, or the right ventricle is too sick, or this patient in fact needs mechanical support, these patients likely in long-term wise may not do very well. But having said that, if the patient has severe MR, already optimized medical treatment, no option patient, I think the message is very clear. Even mitral clip will actually help in these patients, but not as the degree as those patients having lesser degree of LV impairment. So mitral clip actually underwent a 4th revolution. So you have mitral clip classic, mitral clip, and then they have this mitral clip NT, and then they comes with 3rd generation. I think 3rd generation is the major breakthrough because they have this greed. In fact, it's ambition of the company to make a bigger clip so they can treat more complex pathology, especially those people having DMR with very wide disease and also flail leaflet. And the EXPAND registry that present a few years ago by Scott Lim actually shows that with these patients having relatively flail disease, they are able to achieve reasonably good results. Of course, it's not as good as non-complex anatomy in terms of MR reduction to grade 1. In fact, less than grade 2 is similar, but less than grade 1, of course, for complex disease is less than optimal as compared to non-complex disease. But if you have MR less than grade 2, already the patients will experience very good in terms of symptoms relief. And of course, with the competitors, especially Pascal coming to the market, the mitral clip knows they have to push their advancement of device. That's the beauty of having really competitor. Like if you have Roger Federer and you have Rafael Nadal, then you're going to have very great competition, and all benefits comes to the audience and to our patients. So in this system, is actually coming with the idea is that you want to shorten the procedural time because you want to produce a wider clip. And if you're looking at, also they have this concept of independent grasping, which actually is a concept first described by the Pascal device. And this is the first case, I think, worldwide done by Cyborg that was 4 years ago. And this is a case having very wide prolapse, and he had difficulty of catching the posterior leaflet. Always the posterior leaflet try to roll in like this, and with independent grasping, CGA, he was actually able to grasp more of posterior leaflet. And again, because of this wider clip, it only takes him 1 clip to solve the problem. And this is in fact reflected in the EXPAND G4 registry presented last year in TCT. You see that because you don't need to put in so many clips. The procedural time actually shortened, and you can see most of the clips being put in clinically are those wide clips. So having a wide clip is really a big improvement in the clip device development. And also, if you look at the G4, I compare with the XTR, NTR, and the chance of you having MR less than 1 plus is slightly higher, although this is not a direct comparison, but at least this doesn't show this big clip actually cause you bad results, big and wide clip. And about this CGA, surprisingly, you see in clinical practice, the use of CGA is very limited. Only about 5% of the cases you need to use independent grasping, because we all suffer from that, especially when you are using big clip. If you using independent grasping, many a time you have to rotate your guide, so to swing your clip towards, let's say, posterior leaflet. By doing that, you are actually distorting the orientation, the clip orientation. And sometimes after release of the clip, you may cause twisting of the mitral valve, and then you ended up with more MR. So people are more realized with bigger clip, independent grasping. If you are using it too excessively, you can have adverse outcome. And so that's why it is, I think most speakers would say that, okay, this CGA, they don't call it independent grasping, they call it controlled gripper actuation. It's more for confirmation. So if you're not sure, after you grasp both leaflet, you release it again and then you try it. Release one arm without losing the clip position, and then you grasp it with that arm. And then you try to optimize sometimes a 1 or 2 millimeter leaflet or more, instead of really aggressively using independent grasping. And this is repair MR I mentioned because of the improvement in TE imaging, improvement of clip design, and with more operators experienced in this therapy. So I think it's like TAVR, we are moving to moderate surgical risk and to see head-to-head comparison. And so we are waiting the result of this trial. And so this is a brief summarization of the clinical data that we have for MitraClip for different types of MR. So for DMR, of course, high surgical risk in the guidelines. MitraClip is definitely green light. It's like traffic light. Red is still belongs to the surgical territory. But of course, the MR, repair MR trial may change the landscape. But for functional MR, I don't think surgery is really a good option. There's no randomized control trial whatsoever in surgical field that shows it actually improves survival. So I think for patient having ventricular functional MR, although here is yellow light, but for me, I tend to go for green for this functional ventricular functional MR. But atrial functional MR, as I said in the beginning, still is an area of unknown. So let's go for some cases. I'm going to show with you 2 cases, try to illustrate some points. This is the diagram I try to summarize myself on how to select, because you have now 4 clips and you have long clips and short clips. You have wide one and you have the short one. So this is the rationale I selecting these clips. I would usually select these clips based on the etiology, location of the jet, mitral valve area, the leaflet length, and also the MR jet width. So basically you can see that if it is more functional MR, I try to cause less tension on the leaflet, so I would choose a short clip. For patient having small central pathology, I would tend to go for maybe because there's more room there for caudal entanglement, I would go for the long clip. But if patient have small mitral valve area, of course, you tend to use a smaller clip. And if you have very long posterior leaflet length, then of course you can go for long clip. But with more experience, I'm sure every one of you will have your own algorithm. There's no right or wrong in particular right algorithm. This is just the process that you have to go through when you select the right clip for the right pathology. So this is my first case. This is a case with HOCM and also DMR. So this is an 83-year-old lady, had history of hypertrophic cardiomyopathy, quite severe. At the same time, this patient also had degenerative MR. So the surgical risk was not that high, but patient, after some intubation and prolonged hospitalization for other medical conditions, she became very frail. So the surgeon said, okay, you go for this TAVR therapy, because we know TAVR can treat DMR, we know TAVRs can treat HOCM by stabilizing SAM. So that's why we go for the mitral clip therapy. But her anatomy is actually quite complex. I'm showing you the anatomy. So this is a more commissural disease. So from here, you can see the X actually is a medial commissural prolapse and with flail. So the strategy here is, because this flail is actually quite long, there's very high chance you need 2 clips. And so this patient has adequate mitral valve area, so we know 2 clips should be okay. But in order to go to this small space, you need to stabilize the commissure with a small clip first, and then followed by a long clip. That's the strategy. So this is the strategy: small clip to go to a more narrow space in the commissure, and then the residual disease, I stabilize it with a relatively longer clip. This is what happens. So the first clip is NTW, small clip. We go to the commissure and we do the first grafts there. And after the first graft, what happens is that the MR becomes more severe. So, and then we figure out, because you already stabilized the prolapsing segment, there's no chance that there will be any MR coming from that region. And if you look carefully, actually the first clip induced SAM. So the SAM was not that bad, but after you clip the anterior leaflet, the SAM becomes more severe. So instead of just putting a clip immediately, you give fluid to the patient is more fluid, and then the MR actually decrease. So this is actually the SAM caused by the first mitral clip implantation. So we're going for the second clip as planned. So you see, this is a second clip. This time, this is XTR. I don't think any other parts in the world you use XTR, because at that time we still have some old stocks there. In Hong Kong, you still have some old guards XTR. So that's why we use XTR. Otherwise, if you use G4, then it would be something like XT or XTW. And so you see, after the second clip, there's no more SAM. We actually stabilized the anterior leaflet, and the MR actually is gone completely. So this is the final result with G4 here, NTW, and with XTR, and the patient's MR actually reduced from severe to very mild and without increase in mitral valve gradient. So the HOCM gradient actually improves from 80 to 30 after the procedure. So I'm showing you the second patient. So second patient is an atrial FMR. The patient also has very funny leaflet perforation. So this is, although relatively young patient, but she had multiple comorbidities, including diabetes, hypertension, ischemic stroke, obesity, and she had a supravalvular AS with previous SAVR